Welcome to another deep dive where we get to, well, dive deep into some pretty fascinating stuff.
Yeah, always fun to geek out a bit, right?
Right. Today, we're taking a look at trauma, specifically burns, and what happens when your body's kind of pushed to its limits by the environment.
So we're talking about those moments when things go a little haywire.
Exactly. We've got some excerpts from paramedic textbooks. They cover a whole lot. Everything from how your skin reacts to injuries to what happens when you get way too hot or way too cold.
Those paramedics definitely see it all, I bet.
They do. And you know what's crazy?
What's that?
Over 80% of deaths from burns actually happen in homes.
Wow. That really makes you think about how important prevention is. Simple things can make a huge difference, like checking your smoke detectors, being careful in the kitchen.
Absolutely, Sam. Okay, so let's start with the basics. We all know skin is our largest organ, but it's also our first line of defense, isn't it?
You got it. That's right. And it's way more complex than most people realize. I mean, it's got three main layers: the epidermis, the dermis, then the subcutaneous tissue.
3 layers. I usually just think of the part I can see.
Right, that's the epidermis, the outer layer we touch. But the dermis, that's where things get interesting. Blood vessels, nerve endings, sweat glands, hair follicles, it's all in there.
So it's like the support system for the epidermis.
Yeah, you could say that. Gives your skin strength, helps regulate your temperature, helps you feel things.
Wow. So what about the subcutaneous tissue? What's that do?
That's mostly fat, kind of like insulation, and it helps cushion your body too.
Okay, so our skin's working hard for us, even if we don't think about it. But what happens when something, messes with that protection, like a burn?
Well, that's when things get serious. Burns disrupt all those important functions we just talked about. Suddenly, they become a lot more than just a surface injury.
Right. I remember learning about first, second, and third-degree burns. Is that still how you guys classify them?
Not so much anymore. Now it's more about the depth. Superficial, partial thickness, full thickness.
So like a really bad sunburn, that would be superficial.
Exactly. Damages that top layer, the epidermis. Painful, but it heals.
But I imagine if it goes deeper, that's when it gets more complicated.
Definitely. A partial thickness burn, that gets into the dermis, part of it at least. Those are
Yeah.
the ones that blister.
Ouch, yeah, I've had those. And full thickness, that sounds really bad.
It is. It goes through all the layers of the skin. Can look leathery, might even be numb because the nerve endings are damaged.
So the treatment depends a lot on how deep the burn goes.
Absolutely. The depth, the size, where it is on the body, all of that factors in.
Okay, how do you even measure the size of a burn? I remember something called the rule of nines, is that right?
Yeah, we still use that. It's a way to quickly estimate what percentage of the body's burned. There's also the rule of palms, where the patient's palm is about 1% of their body surface area.
So those are more like initial estimates?
Right. More precise measurements happen at the hospital.
Okay, so you've got the depth, you've got the size. What else are you looking at when you see a burn?
The cause. Burns aren't all created equal. You've got thermal burns from things like flames, scalding hot liquids, contact with hot objects. Those are the most common ones.
Yeah, I can see how those happen a lot, especially in kitchens.
Exactly. And scald burns from hot liquids, those are especially common with little kids. So big reminder to be super careful in the kitchen.
Always. So what other types of burns are there?
Well, there are chemical burns,
Yeah.
acids, alkalis, all those corrosive materials. And those are tricky because they keep doing damage as long as they're touching the skin.
So getting that chemical off quickly is really important.
Oh, yeah, absolutely. Time is of the essence there. And then there are electrical burns. Those can be sneaky.
Geeky? How so?
Well, the entry and exit wounds, those might look small, but underneath, the damage can be massive. And you've got to worry about internal injuries, too, from the current passing through the body.
Wow, that's something I never would have thought about. What about radiation burns? Are those common?
Not as common, no, but they do happen. Sun exposure, medical treatments, things like that. And the tricky thing is, they might not show up right away. Could be days before you see the damage.
So even if someone doesn't have obvious burns after being exposed to radiation, they could still be in trouble.
Exactly. It's like a delayed reaction. Makes scene safety super important for us paramedics.
I bet. So it sounds like you guys are like detectives, piecing together all these clues to figure out what kind of burn it is and how serious it is.
Yeah, that's a great way to put it. Putting the puzzle together helps us decide what to do.
Speaking of doing, what are some of the first things you do when you arrive at a scene with a burn?
First things first, we got to stop the burning process. Flames. Put them out. Chemical burn. Flush it with lots of water, electrical, make sure the power's off before we even get close.
That makes perfect sense.
Well,
What about after you've stopped the burning?
then it's all about ABC's airway, breathing, circulation, make sure the patient is stable, no immediate life
Right,
threats.
priorities. And then you start treating the burn itself.
Exactly. We'll cool it down with cool water, not ice cold, and cover it with a clean dressing.
I imagine pain management is a big part of treating burns too.
Absolutely. Burns are incredibly painful. We can give pain meds to help with that. And we also have to watch out for shock.
Shock. Wait, isn't that something that happens with, like, heart attacks, not burns?
You'd think so, right? But burns can actually cause something called, well, burn shock. It's a complication, especially with larger burns.
So what is burn shock exactly?
It's a type of shock that happens when you burn a big chunk of your skin. Think of it like, well, your body's internal plumbing system springing a leak.
A leak?
Yeah, fluid leaks out of the damaged tissue, evaporates into the air. That fluid loss messes with your blood volume, makes it harder for your heart to do its job.
Okay, so you're losing fluid. That makes sense. But I thought you said there were two types of shock associated with burns.
Right. So that first one, that's hypovolemic shock, the fluid loss. The other type is distributive shock, and that one's all about where the fluid goes.
There the fluid goes.
Yeah, the burn messes up your blood vessels, makes them leaky. So instead of staying inside where it belongs, the fluid leaks out into the spaces between tissues. You get swelling, what we call edema.
So with burn shock, you've got fluid leaking out and fluid going where it shouldn't be.
Exactly. And that double whammy can really wreak havoc on your body. Your heart, lungs, kidneys, even your brain can be affected.
That sounds pretty terrifying. How do you know if someone is going into burn shock, and what do you do about it?
The early signs, those can be subtle. Faster heart rate, breathing gets quicker, skin's pale and clammy. As it gets worse, blood pressure drops, maybe confusion, even passing out.
So what's the treatment?
Get them to a burn center fast. They can give IV fluids to replace what's been lost and support the blood pressure.
This is all really fascinating, but wow, I had no idea burns were so complicated.
They definitely are. And we haven't even talked about inhalation burns, which can be just as dangerous.
Wait, inhalation burns. So it's not just the skin that can get burned.
Nope. If you breathe in hot gases or smoke, you can burn your airway. That can cause coughing, wheezing, trouble breathing.
That sounds terrifying.
It can be. And then there's the risk of breathing in toxic gases, especially carbon monoxide.
Oh, right, carbon monoxide. Isn't that called the silent killer because you can't see it or smell it?
Exactly. And it can be deadly even at low levels. It basically stops your blood from carrying oxygen like it should.
So even if someone doesn't have obvious burns after a fire, you still have to worry about carbon monoxide poisoning.
Absolutely. That's why we always check for it after any fire. Better safe than sorry.
This is all great information, but honestly, it's a little overwhelming.
I get it. But the key is to be prepared, know what to do in case of an emergency, and that's what we're here to help with.
Okay, that makes me feel a little better. So what are some practical things we can do to be more prepared for burns, before they even happen?
Well, we'll dive into specifics later, but for now, the biggest thing is just awareness. The more you understand about how your body reacts to trauma, the better prepared you'll be to react effectively.
Knowledge is power, right?
You got it. Stay tuned, and we'll explore some real-life scenarios and give you some actionable tips that could actually help you save a life.
Maybe even our own.
Exactly.
Welcome back to our deep dive. We've been exploring how our bodies react to trauma, and wow, there's a lot to learn about burns.
Right. And we've only just scratched the surface.
True. But burns aren't the only danger out there. What about those emergencies that pop up when we're dealing with, extreme temperatures?
You're talking about heat and cold emergencies. Those can be tricky too.
Exactly. One of the textbooks mentioned how good our bodies are at regulating temperature, but I'm guessing there are limits, right?
Oh yeah, definitely limits. Our bodies are pretty amazing. I mean, keeping that internal temperature stable, even when it's crazy hot or freezing outside. But push too far in either direction and, well, things can go wrong.
So let's talk heat. What happens when our bodies get too hot for too long?
Well, think about what happens when you're working out on a scorching day. You start sweating, right?
Yeah, for sure.
That's your body trying to cool down. But if you're out in that heat for a while, especially if you're not drinking enough, your body starts to struggle.
And that's when you can get heat exhaustion.
Bingo. Heat exhaustion, it's like your body waving a big red flag.
Saying, help, I'm overheating.
Exactly.
So what are the signs of heat exhaustion? What should we be watching out for?
Well, you'll be sweating a lot for sure. Probably feeling weak, dizzy, maybe nauseous, muscle cramps, could even feel faint.
Sounds pretty miserable.
Oh, it is. And your skin might get cool and clammy. It's like your body's trying to dump as much heat as possible through sweat, but it's losing the battle.
So what do you do if you think someone's got heat exhaustion?
Get them out of the heat, pronto, shade, loosen clothing, start getting fluids in them.
Water, sports drinks.
Either one works. Electrolytes can be helpful, but plain water's fine too. The important thing is to cool down and rest.
So heat exhaustion is serious, but it sounds like you can recover if you catch it early enough.
Yeah, but the thing is, if you don't catch it, it can turn into heat stroke. And that's a whole other ballgame.
Heat stroke, that sounds scary.
It is. Heat stroke, that's when your body's cooling system just gives up. The internal thermostat breaks down, so to speak.
So you stop sweating.
Yep. Your skin will be hot and dry, your core temperature skyrockets, you can get confused, have seizures, even slip into a coma. It's life-threatening.
Definitely sounds like a 911 situation.
Oh yeah, without a doubt. Call 911 and start cooling that person down any way you can. Shade, remove clothing, cool compresses, even a cool bath if you can.
So knowing the difference between heat exhaustion and heat stroke, that's really important.
Huge difference. Heat exhaustion, that's your warning. Pay attention and you'll probably be fine. Heat stroke, that's a full-blown emergency.
Okay, good to know. So we've covered the hot side of things. Let's switch gears, talk about what happens when we get too cold.
Okay, so just like we've got ways to cool down, we've also got ways to warm up. Shivering, that's a big one.
Yeah, I hate shivering, but I guess it's good that your body's doing something to fight the cold.
Exactly. Those muscles are working hard to generate some heat. And your blood vessels, they constrict, which helps keep your vital organs warm.
So shivering is a good sign, right?
To a point, yeah. It means your body's still fighting. But as your temperature drops, that shivering might stop. And that's when things can get more serious, moving into hypothermia.
Right, hypothermia. I remember something about the umbles being a warning sign.
Ah, yes. The umbles, stumbles, mumbles, fumbles, and grumbles. If you see someone having trouble with those, especially out in the cold, that's a sign their body temperature's dropping.
So, like, stumbling means they're having trouble walking.
Right. Yep. Coordination and balance go out the window as you get colder. Mumbling, that's slurred speech. Stumbling, they can't use their hands right. And grumbling, well, they're just not happy campers.
That's a good way to remember it. What else should we be looking for with hypothermia?
As it gets worse, breathing and heart rate slow down, they get weaker. Eventually, they could lose consciousness. And in really severe cases, they might seem lifeless. No pulse, no breathing.
Sounds like every second counts.
Yeah.
What do you do if you think someone's got hypothermia?
Get them warm, fast, out of the cold, into a warm place. Take off any wet clothes, wrap them in blankets. If they're awake and can swallow, give them warm fluids. Nothing with alcohol, though. And call 911.
Okay, so with hypothermia, time is really of the essence.
Absolutely. The sooner you can warm them up, the better their chances.
We've talked about the dangers of being too hot and too cold. But what about, like, injuries that are specific to cold weather, like frostbite?
Frostbite, yeah, that's another serious one. It happens when skin and the tissue underneath are exposed to freezing temps. Basically, ice crystals form inside, blood flow gets messed up, and you get damage.
So it's kind of like a burn, but from cold instead of heat.
Good analogy. And like burns, you've got different levels of severity. Superficial frostbite, that's just the outer layers of skin. Deep frostbite, that can get into muscles, tendons, even bone.
What does frostbite look like? How do you know if someone has it?
Well, the skin will be white or maybe grayish yellow. Feels hard, kind of waxy, might be numb or tingly, and it can be really painful.
So what do you do for frostbite?
Same as with hypothermia, get them out of the cold into a warm place. You can rewarm the area with warm water, not hot. Never use direct heat like a hairdryer. That makes things worse.
And I guess you shouldn't rub the area either, right?
No rubbing. That can cause more damage. Just be gentle.
And if it seems serious, get medical attention.
Definitely. The sooner the better.
So we've covered burns, heat emergencies, cold injuries. Anything else we should be thinking about when it comes to these environmental emergencies?
Well, we haven't talked about drowning yet. That's a big one. And it's not always as dramatic as you see in movies.
Yeah, you always hear about it being a silent killer.
Exactly. It can happen fast and it can be quiet. No splashing, no yelling, just gone.
That's terrifying.
Uh-huh.
What are some things people should know about drowning?
First off, drowning's not just about being underwater. It's about not being able to breathe because you're submerged. And it can happen anywhere. A bathtub, a pool, a lake, the ocean. Doesn't matter.
Makes sense. I remember reading about the mammalian diving reflex, How does that work?
Ah, that's a cool one. It's this automatic response when your face hits cold water, your heart rate slows way down, blood vessels in your arms and legs constrict, and all the blood flow goes to your brain and heart.
So it's like survival mode for cold water.
Yeah, you could say that. Helps conserve oxygen, can buy you some time. But the tricky thing is, it can also make it harder to tell if someone's drowning.
Because they might look calm.
Exactly. That's why I gotta pay attention to other signs. Weak cough, vomiting, maybe frothy stuff around the mouth.
Okay, so a calm person in the water isn't always a safe person. Good to know. This has been an incredible deep dive into, well, all kinds of emergencies. I'm learning so much about how our bodies react, but also about how to be more prepared.
And that's the goal, right? Awareness and preparedness. We'll keep going in the next part, explore some real life scenarios, and give you those practical tips we promised.
Sounds good. I can't wait to hear more. Welcome back to the deep dive. We've been through a lot, haven't we? Burns, heat, cold, all those situations where, well, things can get pretty intense.
Yeah, it's been a wild ride, but I think it's all about, being prepared. Knowledge is power, like they say.
Absolutely. The more you know, the better you can handle things when they go wrong. So let's shift gears a little. What are some practical things we can do, to be more prepared for all this?
Okay, good question. Let's start with burns. Remember we talked about how most burn deaths happen at home?
Yeah, kind of scary when you think about it.
It is. So prevention is key. Simple stuff, really. Like in the kitchen.
The kitchen, yeah. I've had a few close calls myself.
It happens. Just being mindful can prevent a lot of accidents. Turn those pot handles in, keep hot stuff away from the edges of counters, use the back burners when you can.
And never leave anything cooking unattended.
Exactly. And then there are the basics. Smoke detectors, fire extinguishers. You got to make sure those are working.
Yeah, I know they're important, but are there, specific things to check?
For sure. Test your smoke detectors every month. It's a small thing, but it could save your life. And replace those batteries once a year, at least. Oh, and don't forget to vacuum them. Gets rid of dust and stuff that can clog them up.
I never thought about vacuuming them. Good tip. What about fire extinguishers?
Make sure you've got one on each level of your house and that everyone knows how to use it. You don't want to be figuring that out in the middle of a fire.
Definitely not. Okay, what about those environmental emergencies? We talked a lot about heat exhaustion and heat stroke. Any tips for staying safe when it's super hot out?
Hydration, hydration, hydration. That's the big one. Drink plenty of fluids, even if you don't feel thirsty.
What about, sports drinks versus plain water? Does it matter?
Water is always best. Sports drinks can be helpful if you're losing a lot of electrolytes, but plain water is what your body really needs.
Okay, water it is. What about clothing? Does that make a difference?
Oh, yeah. Light colors, loose-fitting clothes helps reflect the sun and lets your body breathe.
And a hat, right?
Yes. Wide-brimmed hat and sunglasses to protect your face and eyes.
Okay, good to know. So flipping the script, what about staying safe when it's freezing out? Any tips for avoiding hypothermia and frostbite?
Layers, 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 that's the key. Multiple layers trap heat better than one big, bulky thing. And don't forget those extremities. Hat, gloves, warm socks, those are essential.
It seems like planning ahead is really important too, especially if you're going somewhere remote.
Absolutely. Always check the weather forecast before you head out, and be ready for things to change. If you're hiking or camping, tell someone where you're going and when you'll be back.
Good advice. What about if you're out on the water? Swimming, boating, fishing, all that.
Life jacket. No matter what, wear a life jacket. Even if you're a strong swimmer, it's just not worth the risk.
I never go out on a boat without one.
Good. And never swim alone. Always have a buddy. And be aware of the water temperature. Cold water can suck the heat right out of you.
And we can't forget about that mammalian diving reflex. Tricks your body into thinking it's okay.
Right. A calm person in the water isn't always safe. Look for those other signs, remember.
The weak cough, vomiting, all that. Got it.
Good.
Well, this deep dive has definitely been intense.
Yeah.
But so informative. I feel like I've got a whole new appreciation for, well, how much our bodies can handle, but also how important it is to be prepared.
Me too. And remember, this is just the tip of the iceberg. Take a first aid class, learn more about specific dangers in your area, and most importantly, share what you've learned with others.
Yeah, we can all help each other stay safe. Knowledge is power, right? Thanks for joining us on this deep dive into the science of survival.
Rob.
We hope you've learned a lot and feel more prepared for whatever comes your way. Stay safe out there.
Stay curious.
All right, ready to dive deep. Today, it's all about the cardiovascular system.
The heart, blood vessels, The whole circulatory shebang.
We've got some really interesting sources lined up. We've got excerpts from a medical textbook really focused on heart rhythms and ECGs.
And I've brought some insights from a presentation about handling cardiac emergencies, from a paramedic's perspective.
So if you've ever wanted to understand how your heart works, what can go wrong, and how those paramedics basically become superheroes on the scene.
This deep dive is for you.
For sure. The source material describes the heart as this, like, tireless pump.
Yeah, it's constantly working.
It moves, get this, 7,000 to 9,000 liters of blood every single day.
That's incredible.
That's like more than a giant hot tub, right?
It is.
All of that happening in something just a bit bigger than our fist.
It really is a biological marvel. And you can actually get a sense of way it is if you place your hand just slightly left of center on your chest.
Right.
That's where your heart is nestled. You can even feel your heartbeat if you press gently.
Oh, yeah.
That's what's called the point of maximal impulse.
I can feel it.
Can you?
Yeah. So this pump, though, is a bit more complex than it sounds. It's like two pumps in one, right?
Exactly. The right side of the heart handles what we call pulmonary circulation.
Mhm.
That's sending blood to the lungs to pick up oxygen. Relatively low pressure system.
Okay.
But the left side, that's where the heavy lifting happens. That's responsible for systemic circulation.
Hmm.
That pumps that oxygen-rich blood throughout your entire body.
Ah, okay. So that explains why they say the left ventricle is the strongest chamber, right?
Exactly.
It's the one that has to propel blood all the way to our toes.
It does.
Wow. The source material really emphasizes the importance of the coronary arteries, too. Why are those so crucial?
Well, because those arteries supply the heart muscle itself with the oxygen-rich blood it needs to function.
Ah, okay.
Any blockage in those coronary arteries, that spells trouble. Big trouble. That makes sense.
Yeah.
So we've got this powerful two-sided pump working all the time, but how does it actually beat? The source material says the heart has its own electrical system.
It does.
It's like no external wiring required.
No.
It's wild, like a perfectly synchronized electrical symphony happening inside us.
A symphony, that's a great analogy. And what's so fascinating is that when we see an ECG readout, those peaks and valleys, those represent specific electrical events in the heart.
Oh, okay. So it's not just like a bunch of random blips on a screen.
Not at all. Each wave tells a story.
Wow.
The SA node, tiny cluster of cells in the right atrium, acts as the conductor, setting the heart's rhythm,
Huh.
generates the impulses that trigger the contractions.
What happens if the SA node has a problem, like our heart's conductor?
Well, thankfully, there are other areas in the heart that can take over as pacemaker if the SA node falters.
Oh, okay.
But they might not be as efficient.
Okay.
Think of it like backup generators kicking in.
Gotcha. Okay. So let's talk about those electrical signals themselves. The source material uses these terms depolarization and repolarization.
Yeah.
So they sound kind of intimidating,
Yeah, I can see that.
but I'm guessing they're not as complex as they sound.
You're right. They're describing the movement of ions like sodium, potassium, calcium across the membranes of heart muscle cells. It's this movement that creates the electrical signals. Depolarization is like flipping a switch, triggering the muscle to contract, and then repolarization is the reset, getting it ready for the next beat.
So like a constant flow of charged particles creating these electrical impulses that keep our hearts ticking.
Exactly. And those impulses are what we see on the ECG, like, for example, the P wave. That shows the atria contracting.
Okay.
The QRS complex, that represents the ventricles contracting. And then the T wave, that indicates the ventricles repolarizing, getting ready for the next beat.
So the ECG is basically translating the heart's electrical language, right?
It is.
What happens when that rhythm, that electrical symphony gets disrupted? That's when we get what are called dysrhythmias.
Right.
And some can be harmless, others are really dangerous.
That's true. They're like glitches in the rhythm, and their severity can range widely.
Yeah. The source material lists quite a few types of dysrhythmias.
It does.
Let's try to unpack a few. So like sinus bradycardia, for instance.
Okay. Sinus bradycardia simply means a slower than usual heart rate, but it's got a regular rhythm.
Yeah.
Athletes, for example, often have sinus bradycardia. Their hearts are so efficient. But in other cases, it can be a sign of a problem.
So slow heartbeat isn't always a bad thing,
Right.
but it's worth paying attention to. What about atrial fibrillation?
Atrial fibrillation.
Yeah, the source material makes it sound like a bit of a chaotic dance party in the atria.
That's one way to put it. The atria, they quiver instead of contracting smoothly. It's surprisingly common, especially as we age.
So those little chambers are going haywire.
Yeah.
Then there's a ventricular tachycardia.
Ventricular tachycardia.
That one sounds a bit scarier.
Yeah, and it is. It's a rapid heartbeat that originates in the ventricles. It's dangerous because the heart can't pump blood effectively at that speed, requires immediate attention.
And finally, the one we often see in, like, movies, ventricular fibrillation.
Ventricular fibrillation.
Yeah, that's the one where they yell clear and
Yeah.
shock the patient, right? Yeah.
Exactly. That's where the electrical activity is completely chaotic.
Wow.
The heart isn't pumping blood effectively. Life or death situation, defibrillation is crucial.
So this brings us to, the heroes of the hour, paramedics.
Hmm.
They're often the first line of defense in those heart-stopping emergencies. They not only have to assess the situation super quickly,
They do.
they also rely heavily on ECGs, right?
Absolutely. And we're not just talking about basic heart rate monitoring. We're talking 12-lead ECG.
Hmm.
Gives a really comprehensive view of the heart's electrical activity
Oh, wow.
from multiple angles.
So, like, instead of one viewpoint, they're getting, like, a 360-degree perspective.
Exactly. Each lead provides unique information, allowing them to identify specific patterns like, a STEMI, for instance,
Right.
which indicates a major artery blockage, a heart attack in progress, helps them make quick decisions, get the patient to the right hospital fast.
So it's not just reading squiggly lines. They're, like, analyzing these complex patterns to make these life-saving judgments.
That's right.
This time is muscle concept really starts to make sense.
It does.
The faster they act, the less damage to the heart.
Absolutely.
But we shouldn't forget, not all heart problems are these sudden dramatic emergencies, are they?
That's an important point. Things like atherosclerosis, that buildup of plaque in the arteries that can develop silently over time, lead to serious problems down the road.
Yeah. Atherosclerosis is a major player in a lot of heart conditions, isn't it?
It is.
And it's not just the heart, it's arteries throughout the body, right?
That's right. It can affect arteries anywhere. For example, when it affects the arteries in the legs, it's called peripheral artery disease, PAD.
PAD. And the source material mentioned that one common symptom of that is, like, leg pain when walking.
That's right. Because the arteries are narrowed, those leg muscles aren't getting enough oxygen-rich blood, especially when you're active.
So it's kind of like that time is muscle concept, but for the legs.
Exactly.
And blood clots, too. Those can be pretty dangerous.
Indeed. A blood clot that forms in the veins, often in the legs, that's called a deep vein thrombosis, or DVT. If that clot breaks loose and travels to the lungs, it can cause a pulmonary embolism.
It's like a ticking time bomb. And then there's aortic dissection, which sounds terrifying.
Yeah. Aortic dissection is a tear in the aorta, that main artery carrying blood from the heart. Extremely serious. Requires immediate attention.
So we've covered, like, a whole range of potential problems.
Yeah.
From that silent buildup of plaque
Yes.
to those sudden dramatic emergencies. But the source material doesn't just focus on the negative, does it? It talks about the progress in cardiology.
Absolutely. There are so many new discoveries and treatments emerging all the time.
It's exciting.
It is.
And I think that's something we're going to get into a lot more in the next part of our deep dive.
We will.
But I'm curious, before we move on, what stood out to you from all this information so far?
What really struck me is just how intricate the heart's electrical system is. It's remarkable how it all works together to create that rhythmic beat. But it's also kind of unnerving to think how easily that rhythm can be disrupted.
Yeah. What really stood out to me is that most heart attacks are triggered by a sudden plaque rupture. Not just the buildup of plaque, but when it actually ruptures.
Right.
So what does that tell you about the importance of managing risk factors for atherosclerosis, even if you feel healthy?
It's a powerful reminder that we can't be complacent, even if we feel fine.
Exactly.
Yeah.
And we'll delve deeper into all of that in the next part of our deep dive.
We will. Welcome back to our deep dive into all things cardiovascular. Last time, we explored the heart's anatomy, those electrical rhythms. Those are pretty fascinating.
They are.
But as you've learned, sometimes those rhythms get disrupted. And that's when things can get serious.
For sure.
So this time, let's shift our focus to, well, those heart-stopping moments. Cardiac emergencies.
Okay, yeah. This is the stuff of, like, medical dramas, right?
Right.
Someone clutches their chest, collapses, everyone yells, "Call 911."
Exactly.
What's actually happening in those critical moments?
Well, in many cases, it's sudden cardiac arrest. The heart's electrical system goes haywire, usually because of ventricular fibrillation, that chaotic rhythm we talked about.
Right.
And when that happens, the heart just stops pumping blood effectively.
So it's not just, like, a slowed heartbeat. It's a complete stop.
Yeah.
Like the heart's not doing its job at all.
That's why they call it an arrest. Everything comes to a screeching halt.
Yeah.
It's life-threatening. Absolutely.
It sounds terrifying.
It is, because without that constant blood flow, the brain and other vital organs, they're deprived of oxygen, they start shutting down, and it happens really quickly.
So every second counts.
Every second. That's why the source material really emphasizes those first few minutes. Having a plan.
What is that plan?
Well, the cornerstone of that plan is CPR, cardiopulmonary resuscitation.
Okay, CPR.
Those chest compressions, they're literally a lifeline, manually pumping blood to the brain and those other organs while we try to get the heart started again.
Buying us time.
Exactly, precious time. But even with effective CPR, the heart won't just magically start beating again on its own.
Right, so that's where defibrillation comes in, that dramatic scene where they yell, "Clear!" and they shock the patient.
Exactly, that's it. Defibrillation, it delivers a controlled electrical shock to the heart. It's like hitting a reset button, trying to stop that chaotic ventricular fibrillation, give the heart a chance to get back to a normal rhythm.
The source material really highlighted the combination of like early CPR, high quality CPR, and then that prompt defibrillation. Those two things together are key to survival.
Absolutely. They work together to maximize the chances of a positive outcome.
Wow. But even when the heart restarts, the work isn't over, right?
Oh, no, not at all. There's a whole range of advanced life support measures, ACLS, that paramedics use to stabilize the patient.
So it's like this carefully choreographed medical ballet.
It really is.
Every step is crucial. What are some of those advanced measures? The source material mentioned a few medications that paramedics will use. Like, what do those drugs do?
Well, they target different things. Epinephrine, for example, that helps increase the heart rate and blood pressure.
Okay.
Amiodarone, it's an antiarrhythmic drug that aims to stabilize the heart rhythm.
Okay.
And aspirin, that helps to prevent blood clots, which is really critical in these situations.
So it's like this pharmacological toolkit to support the heart.
It is.
Give it a fighting chance. Pretty amazing, isn't it, that these medications combined with the CPR defibrillation can bring people back?
Yeah, sometimes literally from the brink. But even with all these advancements, I'm sure there's still a lot we don't know about cardiac emergencies.
There's always more to learn, right?
Oh, right. But one thing that is becoming really clear is the importance of, well, early recognition and action.
Okay, yeah.
Bystanders who know CPR, who can use an AED, that automated external defibrillator, they can make a life or death difference.
So it's not just about medical professionals. It's about empowering anyone to be part of the solution.
Absolutely.
And the source material did say that early defibrillation is crucial. Why is that?
Because every minute that passes without defibrillation, the chances of survival decrease, and significantly. Early defibrillation, ideally within the first few minutes, that's associated with the highest survival rates.
Wow, those minutes really do matter.
Yeah.
So let's say someone survives a cardiac arrest. What happens next? The source material mentioned transporting them to a specialized cardiac catheterization lab. Why is that so important?
Because in many cases, the underlying cause of that arrest is a blocked coronary artery.
A heart attack.
A heart attack in progress, exactly. And a cardiac cath lab, well, that's equipped to perform procedures like angioplasty. That's where they use a tiny balloon to open up the blocked artery, restore blood flow to the heart.
So paramedics play this crucial role, not only in stabilizing the patient, but also in, figuring out what the root of the problem is.
They do.
They're like medical detectives.
They are. Constantly gathering information, making judgments based on symptoms, medical history, and of course that 12-lead ECG.
That can reveal a lot.
It can.
They have to process so much in such a high-pressure environment.
They do.
It's incredible.
It is.
But what happens after the patient reaches the hospital? Is the danger over then?
Well, not necessarily. Even after that immediate crisis is over, there's a long road to recovery.
Okay.
The focus then shifts to preventing further damage, managing any underlying conditions, reducing the risk of anything happening again in the future. This might involve medications, lifestyle changes, ongoing monitoring.
Sounds like a long journey.
It can be. But with the right support, the right care, people can recover and go on to lead really fulfilling lives.
It's inspiring how far cardiology has come, really.
It is. We've made remarkable progress in understanding treating cardiovascular disease.
Yeah.
But prevention is always the best medicine.
I agree. It's about empowering ourselves, taking those proactive steps to protect our heart health. And that brings us to a thought-provoking question for you, our listeners. We focused a lot on the dramatic emergencies, but the source material also highlights a range of more chronic conditions. One of the most common is hypertension,
High blood pressure.
often called the silent killer.
It is.
Why do you think it's so important to be aware of this, even if you don't have any obvious symptoms?
It's a great question, and we'll delve into that and the broader spectrum of cardiovascular disease, those latest advancements in treatment and prevention, next time.
Welcome back, deep divers. We're in the final part of our exploration of the cardiovascular system.
The grand finale.
We've covered so much, from the heart structure, those electrical rhythms, to those intense emergencies, the heroes who respond, but we've just scratched the surface. There's always more to uncover. In this last part, let's go deeper into specific heart conditions,
Okay, sounds good.
explore what makes them tick,
All right.
and how the latest research is shaping our understanding and treatments.
It's a field that never stands still, that's for sure.
Constantly evolving.
Yeah.
What I find captivating about cardiology is we're always uncovering new insights into how the heart works, what can go wrong. It's like this never-ending puzzle.
And researchers are always finding those new pieces.
Exactly.
Yeah.
Let's start with something we hear about all the time. Heart attacks.
Okay.
We know they're serious, but what exactly is a heart attack? What's going on, like, at the cellular level?
So a heart attack, medically, it's called a myocardial infarction.
Myocardial infarction.
Happens when a part of the heart muscle doesn't get enough oxygen-rich blood. This lack of blood flow, usually it's because of a blockage in one of those coronary arteries.
Right.
And that can damage, even kill those heart muscle cells.
So it's like a traffic jam in the heart's blood supply.
Yeah, good analogy.
And those cells downstream are being starved.
Exactly.
And the source material mentioned that the most common cause of these blockages is atherosclerosis. Can you break down that process a little more?
Atherosclerosis, it's the buildup of plaque, cholesterol, fats, all those substances inside the artery walls.
Right.
Over time, this plaque, it hardens, narrows the arteries, restricts blood flow. But here's the thing. Most heart attacks aren't triggered by a slow narrowing.
Really?
Yeah, they're often caused by a sudden event.
Okay.
Plaque rupture.
Wait, so it's not just the plaque being there, it's the plaque breaking apart.
Precisely. These plaques can become vulnerable, and when they rupture, it triggers this whole cascade of events. The body tries to contain the damage, forms a blood clot at the site of the rupture.
Right.
But that clot, it can quickly block the entire artery,
Oh, wow.
cutting off the blood flow to that heart muscle downstream.
Like a sudden earthquake in the heart's plumbing.
That's a good way to put it.
So if someone's having a heart attack, what kind of symptoms should they be looking out for?
Chest pain is the most common.
Okay.
But it's not always that classic crushing pain you see in movies.
Right.
It can range from tightness, pressure, to a burning sensation. And it's not always limited to the left side of the chest either. It can spread to the back, the neck, jaw, even down the arms.
Interesting. So a lot of variation in how that chest pain actually presents.
There is.
Are there any other signs that might go along with it?
Yeah, shortness of breath, nausea, vomiting, sweating, lightheadedness, a feeling of impending doom. Those are common too. And it's worth noting, women often experience different symptoms than men. They might have what we call atypical symptoms,
Okay.
like fatigue, back pain, jaw pain. That can sometimes delay diagnosis.
So really important to pay attention to any unusual symptoms, especially if they come on suddenly or
Absolutely.
if they involve any kind of chest discomfort.
Better safe than sorry.
Let's talk more about the ECG.
Okay.
We know it's essential for diagnosing heart attacks, but how does it actually help doctors, pinpoint the problem?
Well, remember how we talked about that 12-lead ECG providing multiple views of the heart's electrical activity?
Yeah.
By analyzing the patterns across all those leads, doctors can identify which coronary artery is blocked
Wow.
and roughly where that blockage is located.
So it's like a map of the heart's electrical system.
It is.
And by reading those signals, they can trace it back.
Exactly.
And what about those stemmas, those ST segment elevations?
Right.
How do those fit in?
A STEMI that tells us a major coronary artery is completely blocked, and a significant portion of the heart muscle is in danger.
Oh, wow.
It's a red alert on the ECG, means immediate intervention is needed.
Life or death.
Exactly.
And that's where those paramedics play such a critical role.
Absolutely. They're trained to recognize that pattern on the ECG and get things moving fast.
Get that patient to the right hospital.
Exactly. Time is muscle in a STEMI. The faster they can open up that blockage, the better the chances are.
Amazing.
Yeah.
But not all heart attacks are STEMIs, are they?
No, you're right.
What about the NSTEMIs, the non-ST elevation myocardial infarctions?
Right. And STEMIs. They typically involve a partial blockage.
Okay.
So they might not cause as much ST segment elevation on the ECG,
Okay.
but they're still serious, absolutely require attention.
So it's like a less severe traffic jam, but still enough to cause damage.
Yeah, that's a good way to think about it.
What are the treatment options for heart attacks then? Both STEMIs and STEMIs.
Well, the goal is to restore blood flow as quickly as possible.
Okay.
For STEMIs, this usually means emergency angioplasty,
Right.
where they insert a catheter, a tiny balloon, to open up the artery. For NSTEMIs, the approach might involve medications, to thin the blood, prevent clots, relieve that chest pain, and angioplasty if needed.
So really the key is getting that blood flowing freely again.
It is. Early detection, early treatment.
Let's shift gears a bit. Talk about dysrhythmias, those irregular heartbeats.
Right, dysrhythmias, they're basically irregularities in the heart's rhythm.
Right.
They can range from, harmless skipped beats to really serious problems like a racing heart that can't pump blood efficiently.
Yeah, it's like the heart's rhythm section has gone a bit offbeat.
Yeah, I like that.
And sometimes those offbeats can be dangerous.
They can.
What are some of the things that can cause dysrhythmias?
Oh, the list is long. Coronary artery disease, heart valve problems, electrolyte imbalances, high blood pressure, thyroid disease, certain medications, caffeine, alcohol, smoking, stress. Even just getting older increases the risk.
Wow. So many things can throw the heart's rhythm off. What kind of symptoms should people be aware of?
Well, some people experience palpitations, that fluttering sensation in the chest, or a racing heartbeat. Others might feel lightheaded, dizzy, short of breath.
Okay.
And in severe cases, they can lead to fainting, heart failure, even sudden cardiac arrest.
So a real mixed bag of symptoms.
Yeah.
How are dysrhythmias diagnosed and treated then?
The ECG is the gold standard for diagnosis. It shows us the heart's electrical activity in real time.
Right.
Treatment really depends on the type and the severity.
Okay.
Some might not require any treatment at all. Others might be managed with medications, lifestyle changes, or procedures like cardioversion or ablation.
So very personalized.
It is.
There's one dysrhythmia in particular that I want to touch on. Atrial fibrillation, AFib. The source material really highlighted that as the most common type.
It's very common.
Can you tell us more about it?
Sure. In atrial fibrillation, the heart's upper chambers, the atria, they quiver chaotically
Okay.
instead of contracting smoothly. And this irregular rhythm, well, it prevents the heart from pumping blood effectively.
Right.
Leads to fatigue, shortness of breath, chest pain, and it can even increase the risk of stroke.
Stroke. That sounds serious. Why would AFib increase that risk?
Because the atria aren't contracting properly, blood can pool in those chambers.
Oh.
And that increases the risk of clots forming. If a clot breaks loose and travels to the brain, it can block a blood vessel there, cause a stroke.
So AFib is a double threat.
It is. Affects the heart's pumping ability and increases stroke risk.
Early detection, treatment, really important. What are the treatment options for AFib?
Treatment might involve medications to control that heart rate and rhythm,
Okay.
blood thinners to prevent those clots,
Right.
and in some cases, procedures like cardioversion or ablation to try to restore that normal rhythm.
This has been an incredible journey. We've explored the heart, delved into those emergencies, uncovered so much about heart conditions.
It has been quite the deep dive.
But before we wrap up, I want to come back to something we've touched on throughout: prevention.
Absolutely. While we can't control everything about our heart health, we can make choices that significantly reduce our risk.
So it's about taking ownership, right?
It is.
And it doesn't have to be overwhelming. Even small changes in diet, exercise, stress management, not smoking, those can make a big difference.
Every step towards a healthier lifestyle is a step towards a healthier heart.
Well said. That wraps up our deep dive into the cardiovascular system. We've covered a lot, but this is just the start of your exploration.
It is.
Keep learning, keep questioning, and keep taking good care of that amazing heart of yours.
Keep diving deep.
Welcome to the deep dive.
Oh.
Today, we're going to be stepping into the world of paramedics.
Oh, yeah.
We've got excerpts from some of their actual training materials, all about clinical decisions and how they assess patients.
Yeah, it's going to be a wild ride.
I'm ready for it. So we're going to figure out how paramedics approach a scene,
Right.
make split-second decisions, and figure out what's going on with a patient,
Yeah,
all under pressure.
exactly.
So whether you're thinking about a medical career or just wondering what happens, When those sirens are blaring, this one's for you.
And maybe we can even, bust some myths along the way.
Oh, absolutely. We're going to talk about the zebra cases.
Oh, yeah.
Paramedics watch out for.
The zebras.
That's rare conditions that can really throw a wrench in the works.
Yeah, those are the interesting ones.
But first, let's get back to basics.
Okay.
What are the cornerstones of effective paramedic practice?
So these are the principles that guide everything they do. First up is gathering information,
Okay.
evaluating it, and putting it all together.
Okay.
Sounds simple, but think about trying to get a clear story
Right.
from someone who's in pain, scared, maybe not even speaking your language.
Yeah, that's not your average doctor's office visit.
Right, exactly.
These are high-stakes situations.
high stakes, exactly.
So they're dealing with people who are maybe confused, maybe they have dementia, maybe they're under the influence, maybe they just can't communicate clearly.
Right.
They've got all these challenges.
All the time.
So it's like piecing together a puzzle, but with missing pieces.
Yeah,
And you got to be quick about it.
you got it.
And you can't just rely on the patient's words.
Right.
You might have to get information from bystanders, look for clues at the scene, even check for medical alert bracelets. So you're kind of being a detective as much as a medic.
That's a good way to put it.
The materials actually share this anecdote about a patient
Oh.
with what seemed like a simple sprained ankle.
Okay.
But then they immediately demanded morphine.
Now that's a red flag.
Right. What's going on here?
Yeah, exactly.
Is this someone who's just seeking drugs, or is there an injury
Right.
that they're not seeing? Or maybe the patient is a doctor themselves
Mm-hmm.
and knows,
Have the low pain tolerance?
has a low pain tolerance or whatever. Yeah.
Exactly.
So it highlights how important it is
right.
to consider all the possibilities.
All the possibilities, yeah.
So even if they do get information, paramedics can't just take it at face value.
Right.
They're constantly evaluating, looking for inconsistencies, and trying to really refine their understanding of what's going on.
Exactly.
So that leads us to the second cornerstone,
Okay.
developing and implementing a patient care plan.
Right.
So they have established medical guidelines,
Yeah.
but they also have to adapt to situations that don't fit neatly into a textbook.
Absolutely.
So it's this balance between following protocol and knowing when to kind of go off script. Right? When is it okay to deviate?
Yeah.
And the materials really emphasize documentation in those cases.
Yes.
So especially when they deviate from the standard procedures, it's that whole, if you didn't write it down, it didn't happen thing.
Right.
But with, potentially life-saving consequences.
Yeah. High stakes.
Okay, that makes sense.
Yep.
So what's the third cornerstone?
Judgment and independent decision making.
Ooh, this is where it gets intense.
This is where it gets really intense.
We're talking life or death decisions here.
Coffin. Yes.
So how do they handle that pressure?
So their training really emphasizes critical thinking and adaptability.
Okay.
Interestingly, medical directives often use the word consider, which gives them some leeway to exercise their professional judgment.
So it acknowledges that real-world scenarios aren't always black and white.
Right.
There's that gray area where experience and intuition come into play.
Exactly.
So they have to assess the situation,
Yeah.
weigh the risks and benefits, and then just confidently make a decision.
That's right.
Which brings us to that fourth cornerstone,
Okay.
thinking under pressure.
Yeah.
So it's not just about knowing the medical stuff, it's about applying it
Right.
when every second counts.
Exactly.
The materials talk about psychomotor skills,
Mm-hmm.
being able to coordinate your actions with your mental processing, even in a chaotic environment.
It's a vital skill.
So picture this.
Yeah.
A multi-car accident, injured people everywhere,
Oh, yeah.
sirens blaring, maybe even hazardous materials.
Right.
That's the kind of scene that paramedics are walking into.
Absolutely. And they need to rapidly absorb information,
All right.
stay calm, make accurate decisions, all under that immense pressure.
So their ability to think clearly and act decisively can often be the difference between life and death.
That's the job.
Okay, starting to sweat just thinking about it.
Yeah, it's a tough job.
So we've covered the four cornerstones,
Uh-huh.
but how do paramedics actually decide who needs care first when they arrive at a scene like that? What's the system?
So they use what we call a triage model
Okay.
to categorize patients based on the severity of their condition.
So it's like a ranking system, but for emergencies.
Yeah, exactly.
Okay.
So imagine like 4 main groups.
Mhm.
You got those with critical life-threatening conditions
Okay.
requiring immediate care.
Okay.
Then you have patients with serious but not immediately life-threatening conditions.
Okay.
Then you have those with minor injuries, often called the walking wounded.
The walking wounded, yeah.
And sadly, those who are deceased
Yeah.
or have injuries that are incompatible with life.
Okay, that makes sense.
Yeah,
But I'm guessing it's not always clear-cut.
right.
What if someone has what seemed like a minor injury, but it turns out to be more serious?
That's where experience and a deep understanding of potential complications comes in.
Right.
A simple cut could become infected,
Right.
or a sprained ankle could be masking a fracture.
You don't know
You don't know.
until you look closer.
Exactly. Paramedics are trained to assess those risks and intervene early.
So it's not just about treating what you see, it's about anticipating what could happen.
That's a good way to put it.
Yeah.
Early intervention is key.
Okay.
Now, are you ready to dive into the fascinating world of critical thinking
Bring it on.
and clinical decision-making in paramedic practice?
I'm ready to solve some medical mysteries.
Perfect. So the materials actually outline 5 steps
Okay.
that paramedics use to approach each call with a critical eye.
Right.
It all starts with what we call concept formation,
Okay.
where they gather initial information from the scene.
Okay.
So are there safety hazards? What's the overall situation? Is this a traumatic injury or a medical illness?
Got it.
Then they move on and observe the patient,
Mhm.
their appearance, level of consciousness, and even their mood.
Wait, their mood. Why is that important?
A patient's emotional state can be a valuable clue.
Really?
Does it match the situation? For example, someone who is laughing uncontrollably after a car accident
Oh, wow.
might have a head injury or be in shock.
Oh, okay.
It's a red flag that something's not right.
So even someone's emotions can be a vital sign.
Exactly. And that's the beauty of critical thinking. It's
Yeah.
about connecting those seemingly unrelated dots
Right.
and looking for patterns that might not be obvious at first glance.
Okay, so concept formation is about gathering those initial clues.
Yep.
What happens next?
Next is data interpretation.
Okay.
This is where paramedics analyze all that information
Mhm.
using their knowledge of anatomy, physiology, and how diseases work.
So they're trying to make sense of it all.
You're trying to make sense of the data and avoid bias.
Right, so it's not just about going with your gut. It's about using your training
Absolutely.
and experience to objectively evaluate the evidence.
That's a good way to put it.
The materials actually emphasize that even seemingly non-emergent calls can be valuable learning opportunities.
Right.
Each call helps refine those skills and build the knowledge for the next one.
Exactly.
Because you never know when something might be more serious than it seems.
You never know.
So they've gathered the clues, they've interpreted the data. What's next?
Applying principles.
Okay.
This is where they take all that interpreted data
Mhm.
and develop a working diagnosis, their initial impression of what's going on.
Okay.
And they also consider other possibilities
Mhm.
known as a differential diagnosis.
So they're saying, okay, based on what we know, we think it's this.
Right.
But it could also be these other things.
Exactly.
So it's like narrowing down the suspects in a case.
It is. And it's important to note that a definitive diagnosis often happens later in the hospital setting.
Okay.
But paramedics are working to get as clear a picture as possible so they can provide the appropriate care right away.
So we've got concept formation, data interpretation, and application of principles.
Mm-hmm.
What are the last 2 steps in this whole critical thinking process?
The 4th step is what we call reflection and action, which is all about thinking while doing.
Yeah.
Paramedics are constantly monitoring how those interventions are working and adjusting the plan as needed.
Okay.
So if a treatment isn't having the desired effect, they go back to that differential diagnosis.
Right.
Consider other options.
So they're not just blindly following a protocol, they're thinking the whole time.
They're thinking the whole time.
What's that final step?
It's called reflection on action.
Okay.
Even after the call ends,
Yeah.
paramedics take time to reflect on their performance,
Right.
analyze any mistakes, and identify areas for improvement.
So they're always striving to do better.
They're always striving to provide the best possible care.
Wow, that's a level of dedication I really admire.
Yeah, they're dedicated professionals.
So we talked about the mental side of things,
Mhm.
but now I'm curious about how paramedics actually approach a scene.
Yay,
It sounds like there's a whole detective element to that as well.
there is. You're absolutely right.
So before they even approach the patient, they're already reading the scene for clues.
Like Sherlock Holmes.
So what are they looking for? It's not just about finding the patient, right?
No, not at all.
Okay.
The materials call this scene assessment,
Okay.
and it's crucial.
So what's involved in that?
First and foremost are what we call routine precautions.
Okay.
They have a great saying, you can't help anyone if you become a patient yourself.
Okay, point taken, safety first.
Exactly. Depending on the call information, paramedics might wear gloves,
Yeah.
eye protection, masks,
Okay.
helmets, maybe even a high-visibility vest.
Right.
It all depends on the potential hazards they might face.
So PPE is like their detective's toolkit.
Yeah, you could say that.
What else are they looking for in this initial assessment?
Next is scene safety.
Okay.
They need to ensure the safety of themselves, their team, the patient, and any bystanders.
Got it.
And we're talking about a whole range of hazards.
Okay.
Unstable vehicles and downed power lines to hazardous materials. And potential crime scenes.
Wow. So it's not just about medical emergencies. They've got to be prepared for anything.
Yeah, you ought to be prepared for anything.
Once they've taken precautions
Yeah.
and addressed any immediate safety concerns,
Right.
they try to determine the mechanism of injury.
If it's a trauma case.
Okay, if it's a trauma case, or the nature of illness if it's a medical case.
Exactly.
So they're figuring out basically what happened here.
That's it.
But couldn't a trauma also involve a medical issue? Like, what if someone had a heart attack
Yeah, that's a great point.
while driving and then crashed their car?
You're thinking like a paramedic already.
Oh,
Those lines can be blurred.
okay.
The materials give an example of someone having a seizure while driving,
Okay,
which then causes a car accident.
right,
So the seizure would be the nature of illness,
right.
and the crash would be the mechanism of injury,
Okay,
leading to potential injuries on top of the medical emergency.
that's complex.
It is.
I can see why they need those strong critical thinking skills.
It highlights why thorough assessment is so vital.
Yeah,
They need to consider all those possibilities
Right.
and avoid getting tunnel vision on one aspect of the situation.
okay, so they've taken precautions, assessed the scene for safety,
Yep.
and figured out what might have happened.
Yeah.
What comes next?
Next, they determine how many patients there are and if they need to call for backup.
Okay,
Things like more ambulances, fire department, police, maybe even a hazmat team.
right.
They're constantly evaluating the situation and deciding if they need to call in the cavalry.
Okay, so they've got the big picture.
Yeah.
Now let's talk about how they assess the patient.
Okay.
What's the very first thing they do?
So the initial assessment is all about identifying and managing those life-threatening problems. This is where the ABCs come in.
Ah, yes, the ABCs of life support.
Airway, breathing, and circulation.
Got it.
So they're trying to answer the questions. Is this person sick? How sick are they? Are they injured? How badly? It's all about quickly figuring out how serious the situation is.
Got it. So they're not wasting any time.
No time to waste.
What are they actually doing during this initial assessment?
It's a systematic approach, but it happens fast.
Okay.
So they assess several key areas.
Mhm.
First is mental status and neurological function.
Okay.
And one of the quickest ways to assess this is using the AVPU process.
AVPU, break that down for me.
So it stands for alert, verbal, pain, unresponsive.
Okay.
Basically, they're determining the patient's level of consciousness.
Right.
Are they awake and aware?
Mm-hmm.
Do they respond to voice?
Okay.
Do they only respond to pain?
Got it.
Or are they completely unresponsive?
Okay. Makes sense.
So it's a quick way to gauge how serious things are.
Right.
They also use the Glasgow Coma Scale,
Okay.
or GCS, which is a more detailed way to assess neurological function.
What does that involve?
It assigns a score based on things like eye-opening verbal response
Okay.
and motor response.
Yeah.
And the key here is that they don't just look at the overall score.
Okay.
They break it down to understand the specific responses.
Right. So it's like a code they're deciphering
It is.
to understand what's going on in the brain.
Exactly.
So that's mental status.
Yep.
What comes next in those ABCs?
Next is the airway.
Okay, the A.
They're focused on two main questions. Is the airway open and clear?
Mm-hmm.
And will it stay that way?
Got it.
So they're listening for sounds that might indicate a problem.
Like snoring.
Yeah, snoring could mean the tongue is blocking the airway,
Okay.
or gurgling if there's fluid buildup.
Got it.
And they're also thinking about the possibility of a spinal injury,
Right.
which would change how they open the airway.
Right.
If there's a spinal concern, they'll use what's called a modified jaw thrust maneuver.
Okay.
If not, they can use the head tilt chin lift.
So even something as simple as opening the airway has different techniques
It does.
depending on the situation. And if the airway is blocked by something, they would suction it out.
they would.
Like if it was blocked by vomit or blood or something.
Exactly. They might also use a device called an airway adjunct
Okay.
to help keep the airway open.
Got it. So they've made sure the airway is clear. What's next?
Next is breathing, the B in ABCs.
Okay.
They're assessing the rate, rhythm, and volume of breathing.
So it's not just about whether the chest is rising and falling, it's the quality of those breaths.
It's about the quality, exactly.
Okay.
They're also looking for signs of respiratory distress.
Okay.
Things like using those accessory muscles in the neck and chest to help them breathe.
Right.
Retractions where the skin seems to sink in between the ribs when they breathe.
Yeah.
Or flaring of the nostrils.
Got it. So they're using their eyes and their ears to assess the breathing.
All their senses.
What's the final piece of the initial assessment?
Circulation.
The C.
The C in ABCs.
Got it.
They're checking the pulse for the rate, rhythm, and quality.
Mm.
And they're also assessing the skin.
What are they looking for with the skin?
They're checking the color, temperature, and moisture.
Okay.
So pale, cool, or clammy skin could indicate a problem with circulation.
So basically they're making sure blood is flowing throughout the body.
Exactly.
So they've done the mental status check, airway, breathing, circulation.
Yep.
What happens after all that?
The final step of that initial assessment is identifying priority patients, those who need immediate, rapid transport to the hospital.
So how do they decide who gets transported first?
So there are a number of factors they consider.
Okay.
Things like unresponsiveness, difficulty breathing, uncontrolled bleeding, severe pain, chest pain that could signal a heart attack,
Right.
suspected stroke, multi-system trauma.
Wow, that's a lot to keep track of.
It is, but paramedics are trained to recognize those red flags quickly.
Okay.
They also consider what's called an apparent life-threatening event, which is basically a combination of symptoms
Right.
that can be very alarming, especially in infants and children.
So they're looking for any sign that the patient is in immediate danger
Exactly.
and needs to get to a hospital ASAP.
That's it.
So this initial assessment is really crucial.
It is.
It allows them to quickly identify and manage life-threatening problems and make those tough decisions about who needs to be transported first.
Right. It's the foundation for everything that follows.
It sounds like a lot to do in a short amount of time.
It is, but we're just getting started.
Oh boy, here we go.
After the initial assessment, they move on to a more focused history and physical exam.
Okay, so let's talk about that, but first.
Yeah.
Okay, so we're back and ready to dive into the focused history and physical exam.
All right.
So after that initial assessment where they're really focused on those immediate life threats, paramedics shift to a more targeted approach, right?
That's right.
It's like tailoring it to the specific patient and situation.
Exactly. The approach is going to vary depending on whether it's a responsive medical patient,
Okay.
an unresponsive medical patient, or a trauma patient. Let's start with those responsive medical patients.
Sounds good. What are the key elements of assessment for that group?
For responsive medical patients, paramedics gather detailed information about what's going on.
Okay.
You know, the chief complaint, as we call it.
Right.
They often use mnemonics like OPQRST to help guide their questioning.
Okay, I remember hearing about those mnemonics, but refresh my memory.
Sure.
What does OPQRST stand for?
It stands for onset, provocation palliation, quality, region radiation referral, severity, and time.
Okay, so it's like a way to understand the story of the problem.
Exactly.
Right, like when did it start? What makes it better? What makes it worse? What does it feel like? Where is it? How bad is it? How long has it been going on? All those key questions.
They'll also gather what's called a sample history.
Yes, another helpful mnemonic.
Another mnemonic. Okay, what does sample stand for?
Sign symptoms, allergies, medications, past medical history, last oral intake, and events leading up to the problem. So they're gathering clues about the patient's past,
Right.
as well as their present situation.
Precisely. And all this information helps guide that focused physical exam,
Okay.
which they'll tailor to the specific complaints and what they found in that initial assessment.
Makes sense. But what about when the patient is unresponsive?
Right.
That seems way more challenging.
It definitely is. When a patient can't communicate,
You're right.
paramedics have to rely more heavily on other clues,
Okay.
things they find at the scene, information from bystanders, and a very thorough head-to-toe exam
Okay.
to try and piece together what's going on.
So they're searching for anything that might explain why this person is unresponsive.
Exactly.
So looking for signs of trauma, maybe drug paraphernalia, medical alert bracelets, really anything that might shed light on the situation.
Yep. And they'll use their diagnostic tools, too. Things like a blood sugar check,
Right.
getting vital signs.
To help narrow down the possibility.
Exactly.
It's like they're putting together a puzzle, but without all the pieces.
It is. It can be a real challenge.
Okay, now let's switch gears and talk about trauma patients.
Okay.
So these are the folks who have experienced some kind of physical injury.
Right. Right. Trauma patients can have either isolated injuries
Cool.
or what we call multi-system trauma.
So isolated injuries are more straightforward, like a broken arm or a sprained ankle.
Exactly. But multi-system trauma means there are injuries to multiple body systems.
Right.
Which makes things a lot more complicated.
So in those cases, paramedics really have to figure out which injuries are the most life-threatening
Absolutely.
and prioritize their treatment.
It's all about prioritizing, and here's where it gets really tricky.
Okay.
They have to be careful not to get tunnel vision on a really dramatic injury,
Okay.
like a compound fracture where the bone is sticking out.
Right. It looks really bad.
It might look really bad,
Right.
but it might not be the most urgent problem.
Yeah.
They could miss something less obvious, like internal bleeding or a spinal injury.
So sometimes those less dramatic-looking injuries can actually be more dangerous.
It happens. That's why they have protocols for certain mechanisms of injury
Okay.
that always trigger a rapid trauma assessment.
So things like falls from a significant height, being ejected from a vehicle,
Those are big ones.
or even if another passenger in the same car died.
Exactly. Those are red flags that something serious could be going on.
It's like their spidey sense starts tingling,
Uh-huh. Yeah, you could say that.
and they go into high alert mode.
That rapid trauma assessment is a head-to-toe evaluation
Okay.
that's designed to catch any life-threatening injuries
Right.
that they might have missed in that initial assessment.
Got it.
So they're systematically checking the head, neck, chest, abdomen, pelvis, extremities, and back.
Wow, they're really thorough.
Looking for fractures, dislocations, bleeding, tenderness, deformity, and any signs of neurological problem.
Okay, so they're really covering all their bases.
They are.
What happens after that focused history and physical exam?
Well, the assessment process doesn't end there.
Right.
Paramedics are actually doing what we call ongoing assessment.
Okay.
Throughout the entire call, from the moment they arrive on scene,
Mm-hmm.
all the way to handing the patient off at the hospital.
So it's like constantly checking your GPS during a road trip.
That's a great analogy.
You're always making adjustments based on traffic and conditions.
Exactly. They're reassessing the ABCs,
Okay.
taking those vital signs again and again,
Mm.
listening to breath sounds, watching how the patient's responding to treatments,
Right.
looking for any trends or changes in their condition.
So it's all about making sure the patient is stable
Absolutely.
and responding to treatment.
And making adjustments as needed.
Okay, the materials actually use a mnemonic for this.
They do.
The 6 R's of critical thinking during a call.
Yep, that's a good one.
Okay, I love a good mnemonic.
Uh-huh.
What are the 6 R's?
Read the scene, read the patient, react, reevaluate, revise the plan, and review your performance.
Okay, let's break those down.
Okay.
Read the scene. We already talked about that.
Mm-hmm.
It's about checking for hazards, looking for clues, getting a sense of what happened.
I just
Read
going
the
to like
patient is about those nonverbal clues.
Yep.
Observing their appearance, their level of consciousness, their behavior.
Uh-huh.
So it's like they're reading between the lines of what the patient is saying.
Or even if they can't say anything.
Right.
That's
So it's like a medical version of being a human lie detector.
Uh-huh. You could say that.
How about react?
So that's about putting all that assessment into action,
Okay.
prioritizing interventions, addressing those life threats, starting
So
treatment.
that's where the rubber meets the road.
Exactly.
Then reevaluate.
So it's about not getting complacent,
Okay.
continuously monitoring the patient's response to the treatment,
Mm-hmm.
looking for any changes, making sure the interventions are actually working.
So they're constantly checking and rechecking,
Mhm. All the time.
making sure they're on the right track.
That's right.
What about revise the plan?
That's about being flexible.
Okay.
Emergencies are dynamic, things change,
Mm-hmm.
so they need to adapt.
Right.
Maybe their initial plan isn't working, so they have to switch gears,
Okay.
be ready to adjust on the fly.
So they're thinking on their feet the whole time.
They are.
And what about that final R? Review your performance. Yeah.
So that's the step that really shows their commitment to excellence.
Right.
Even after the call is over,
Mm-hmm.
paramedics take time to reflect on what happened, analyze their actions, think about what they could have done better.
Always learning, always improving.
It's all about continuous improvement.
That's really impressive.
It is.
They're not just focused on the immediate situation. They're always looking for ways to grow and do even better next time.
That's the sign of a true professional.
So now let's dive into those specific techniques they use during a physical exam
Okay.
to gather more information about a patient. Okay, we're back, ready to learn about those hands-on techniques that paramedics use during a physical exam.
Yeah, it's like they're medical detectives gathering evidence.
Exactly.
So the materials outline 4 main techniques:
Okay.
inspection, palpation, percussion, and auscultation.
Okay, let's break those down.
Okay.
Inspection, that's just looking at the patient, right?
Right. It's about taking in their overall appearance,
Okay.
looking for signs of distress, obvious injuries, anything that seems out of the ordinary.
Okay, so they're using their eyes to gather those clues.
Exactly.
What about palpation?
Palpation is about using their hands to feel for things,
Okay.
checking for tenderness, any deformities, masses,
Mm-hmm.
feeling the quality of the pulse, noticing if any organs feel enlarged.
So they're using their sense of touch to get a better understanding of what's going on.
Uh-huh.
Okay, what about percussion?
Percussion is a technique where they gently tap on different parts of the body.
Like tapping on a wall to see if it's hollow or solid.
Exactly. It helps them evaluate the density of the structures underneath. Different sounds mean different things,
Right.
and it can give them clues about what's happening inside.
That's fascinating.
Yeah.
And lastly, what is auscultation?
Auscultation is all about listening.
Oh,
Using a stethoscope to hear the sounds the body is making.
Right.
They're listening to breath sounds, heart sounds, bowel sounds. Basically using their ears to assess how those different organs are functioning.
So they're really using all their senses, sight, touch,
I
sound,
love them.
to gather information.
Yep,
It's amazing how much they can learn just from a physical exam.
it is.
So now let's take that head-to-toe tour and talk about some of the key things they're assessing.
Okay.
For each body system, let's start with the skin.
The skin, the body's largest organ.
It can tell us a lot.
It can.
So what are paramedics looking for when they're assessing the skin?
They're paying attention to color, moisture, temperature,
Okay.
and looking for any marks or abnormalities, what we call lesions.
Okay, so let's break that down. What can those things tell them?
So skin color can give clues about circulation.
Okay.
Pale skin might indicate poor blood flow, while blue or cyanotic skin means there's not enough oxygen getting to the tissues.
Okay.
Moisture tells them about hydration. Is the skin dry or clammy?
Right.
Temperature can indicate fever or even shock.
So they're getting a sense of how well the body is functioning just from looking at the skin.
Exactly.
And then there's those lesions.
Right. Lesions are any marks on the skin, cuts, bruises,
Great.
rashes, sores. They can be signs of all sorts of things. Trauma,
Right.
infection, allergic reaction, you name it.
So even something as simple as a rash can be a clue.
Absolutely.
Okay, next stop on our head-to-toe tour is the head, eyes, ears, nose, and throat.
Heat, for short.
Got it.
Mm.
What are the key things paramedics are looking for in that region?
So with the head, they're checking for any signs of injury, deformities,
Okay.
bruises, scrapes, punctures, burns, tenderness, cuts, swelling.
Wow.
Yeah. They'll also be on the lookout for signs of increased pressure inside the skull,
Right.
especially in babies.
So they're really scrutinizing the head for any indication that something's wrong.
Yep.
What about the eyes?
So they'll assess vision,
Okay.
check the size and reactivity of the pupils, and look for any signs of trauma, infection, or foreign bodies.
Wait, how did they check vision out in the field?
Oh yeah, good question.
It's not like they're carrying around those eye charts, are they?
No, no, they're not.
Okay.
They'll improvise, maybe have the patient read something like a street sign or a license plate.
Okay, that's clever.
Yeah.
So they're making do with what they have.
Right.
What about the ears?
They'll check for any signs of injury, infection,
Okay.
drainage from the ears. They're also looking for what's called battle sign,
Okay.
which is bruising behind the ears, which can be a sign of skull fracture.
Okay, that's one I'll remember. Battle sign. What about the nose?
So they'll make sure the airway is clear through the nose, check for any bleeding, and also see if the septum, that's the cartilage that divides the nostrils,
Right.
is straight or deviated.
Interesting. So it's not just about whether they can breathe through their nose.
Nope.
They're looking for other clues.
Other clues, that's right.
What about the throat?
They'll be checking the throat for signs of obstruction, infection, or swelling.
Okay.
They'll also look at the uvula,
Okay.
that little teardrop-shaped thing that hangs down at the back of the throat.
Right. The uvula, what can that tell them?
If the uvula is swollen or off to one side,
Okay.
it can be a sign of a problem with the nerves that control those throat muscles.
Oh, wow.
And that could indicate something serious like a stroke.
So they're gathering clues from all those different parts of the HEAT exam.
They
What comes next?
Next is the neck and cervical spine.
Okay.
They'll be checking for any signs of injury, swelling, tenderness, or deformities.
Right.
And they'll also be checking for something called jugular vein distension, or JVD.
JVD, what's that?
It just means the veins in the neck are bulging,
Okay.
which can be a sign that the heart isn't pumping blood effectively.
So it's a clue that something might be wrong with the heart.
Exactly. And of course, they're carefully assessing the cervical spine
Right, those bones in the neck.
to rule out any fractures or dislocations, especially if there was any trauma.
Because a neck injury can be incredibly serious.
It can.
So they looked at the HEAT, the neck, and cervical spine.
Mm-hmm.
What's next?
Next up is the chest and lungs.
Okay.
Time to assess the respiratory system.
So they'll be looking for any signs of breathing problems?
Exactly. They'll inspect the chest, looking for any signs of injury, deformities, or if one side is moving differently than the other.
Right.
And of course, they're checking the rate, rhythm, and effort of breathing.
So looking for any signs of respiratory distress.
Yes. Things like rapid or shallow breathing, struggling to breathe,
Right.
using those accessory muscles to help them breathe. They'll also use a stethoscope to listen to breath sounds, making sure air is moving in and out properly,
Right.
listening for any abnormal sounds.
Like what kinds of abnormal sounds?
Things like wheezing,
Okay.
which can indicate narrowed airways, or crackles, which could mean there's fluid in the lungs.
Okay.
And they're listening for stridor.
Mhm.
That's a high-pitched sound that can indicate an upper airway obstruction.
Right.
And rubs, which can signal inflammation.
Wow. So by listening to your breathing, paramedics can hear clues about what might be happening inside your lungs.
Pretty amazing, right?
It is. Okay, what's next after the chest and lungs?
Next is the cardiovascular system,
Okay.
the heart and blood vessels.
So they'll be checking for signs of good circulation and heart function.
Exactly. So they'll check the pulse, how fast it is,
Mhm.
the rhythm, how strong it feels, and take the blood pressure.
Right.
They'll also use the stethoscope to listen to heart sounds,
Mhm.
making sure the heart is beating regularly, listening for any murmurs or extra sounds that might indicate a problem.
I've always heard those lub-dub sounds.
Yeah, the lub-dub.
What else are they listening for?
So those lub-dub sounds are the closing of the heart valves,
Okay.
and they should sound a certain way.
Right.
Murmurs sound like a whooshing or swishing.
Okay.
It can mean that there's turbulent blood flow in the heart,
Got it.
maybe because of a valve problem.
Yeah.
Extra heart sounds can indicate problems with the heart muscle or how well the heart is filling with blood.
So they're really listening for any irregularities in the heart's rhythm and function.
Absolutely.
What's after the cardiovascular system?
Next stop is the abdomen.
Okay, so now we're getting into the digestive system.
Right. To make it easier to assess, the abdomen is divided into 4 sections.
Okay.
Upper right, upper left, lower right, and lower left.
Got it.
They'll use all 4 examination techniques: inspection, auscultation, percussion, and palpation.
Right.
To get a good understanding of what's going on.
So let's go through those one by one.
Okay.
What are they looking for when they inspect the abdomen?
They're checking for any swelling or bloating, what we call distension,
Okay.
any masses they can see, pulsations or discoloration.
Mm-hmm.
They're also looking for scars, stretch marks, or anything else that looks unusual.
So they're visually scanning the abdomen for any red flags.
Yeah.
Okay, then what about auscultation?
Auscultation is when they use the stethoscope to listen for bowel sounds.
You got
Those gurgling noises your intestines make as food and fluid move through them.
Yeah.
So they want to hear those sounds, but the frequency and quality can tell them a lot.
it. Okay, so what are they listening for?
So really loud and frequent bowel sounds can indicate increased activity,
Okay.
maybe diarrhea or gastroenteritis.
Mm-hmm.
But if the sounds are quiet or absent, it could mean things have slowed down,
Right.
possibly because of constipation and obstruction or even inflammation.
So they're listening for the right amount of gurgling, basically.
Haha, you could say that.
What about percussion?
Percussion is tapping on the abdomen to see what kind of sound it makes. A drum-like sound means there's gas in the intestines, which is normal.
Right.
A dull sound could mean there's fluid or solid mass.
So percussion helps them differentiate between gas, fluid, and solid organs.
That's right.
Okay, what about palpation?
Palpation is when they gently press on the abdomen
Okay.
to feel for tenderness, guarding, rigidity, or any masses.
What do those things tell them?
So tenderness just means it hurts when they press there.
Okay.
Guarding is when the patient tenses up their abdominal muscles, which can be voluntary or involuntary,
Okay.
and it can mean there's pain.
Yeah.
Rigidity is when those muscles are involuntarily tense.
Hmm.
It can be a sign of a serious problem, like appendicitis or peritonitis.
Got it.
And of course, they're feeling for any masses, which could be tumors, cysts, hernias, things like that.
So they're really getting a good feel for what's going on in there.
They are.
Okay, what's next on our journey through the body?
Next is the musculoskeletal system.
Okay.
The bones, muscles, and joints.
So now we're talking about the framework of the body
Right.
and how it moves.
Right, so they'll visually inspect, looking for any signs of injury,
Okay.
deformity, swelling, or discoloration.
Mm-hmm.
And then they'll assess range of motion. Can the patient move their joints freely?
Right.
They'll check muscle strength and joint stability, too.
So they're looking for any limitations in movement or function.
That's right.
What are some of the common injuries they might find?
So you've got the classics. Fractures, sprains, strains, dislocations, and contusions.
Okay, break those down for me.
All right, a fracture is just a broken bone.
Right.
A sprain is a stretched or torn ligament, those tough bands of tissue that connect bones to each other.
Oh, yeah.
A strain is a stretched or torn muscle or tendon,
Mm-hmm.
and tendons connect muscles to bones.
Okay.
A dislocation is when a bone pops out of its joint,
Right.
and a contusion is just a fancy word for a bruise.
Okay. Those all make sense.
Okay.
So what's the final stop on our head-to-toe assessment tour?
The nervous system, the brain, spinal cord, and all those nerves that run throughout the body.
So this is the control center of the body. How do they assess that?
So they assess mental status, cranial nerve function,
Go ahead.
motor function, and sensory function.
Okay, we already talked about mental status earlier.
We did.
What about those cranial nerves?
So there are 12 pairs of cranial nerves
Right.
that control all sorts of things in the head and neck.
Okay.
Things like eye movement, facial expressions, smell, taste, hearing, and balance.
Wow.
So paramedics can assess those nerves by testing things like pupil reactivity,
Okay.
eye movements, facial symmetry, hearing, and swallowing.
It's amazing how much those nerves control.
It is.
What about motor function?
Motor function is all about movement.
Okay.
They'll check muscle strength and coordination, maybe have the patient squeeze their hands, lift their legs,
Right.
or push against resistance.
So they're looking for any weakness or paralysis.
Exactly.
What about sensory function?
Sensory function is about the senses. Can the patient feel different sensations?
Right.
So they might touch the patient with something sharp or dull.
Okay.
Check if they can feel temperature differences or test their ability to feel vibrations.
So checking for any numbness or tingling.
That's right.
So they've completed their head-to-toe assessment. They've got a good understanding of the patient's condition.
Mm-hmm.
What happens next?
Well, that depends on what they found.
Right.
They might start treatment right away, maybe giving medications,
Okay.
immobilizing injuries, or preparing the patient for transport to the hospital.
Right.
The goal is to stabilize the patient and get them the definitive care they need.
And they're constantly reassessing, reevaluating, making sure that plan is still the best course of action.
All the time.
This deep dive has given me a whole new level of respect for the work that paramedics do.
Yeah, it's an amazing job.
It's incredible how much knowledge they have and how quickly they have to think and act, all under pressure.
It's a tough job.
So we talked about the cornerstones of paramedic practice.
Yep.
How they triage patients, the 5 steps they use to think critically on every call.
Uh-huh.
We covered scene assessment, the initial ABC check, that in-depth physical exam, even those 6 R's that guide ongoing assessment.
You've been paying attention.
Well, it's also fascinating. I'm still curious about one thing, though. Remember those zebras you mentioned at the beginning?
Ah, yes, the zebras.
Yeah.
It all goes back to that saying in medicine. When you hear hoofbeats, think horses, not zebras.
Right.
It's a reminder that the most common conditions are, well, the most common.
Okay.
Paramedics are trained to rule out those likely explanations first.
So zebras are those rare conditions that they need to be aware of,
Yeah.
even though they don't see them very often.
It's exactly. They have to be able to think outside the box.
Right.
Even when things seem pretty straightforward.
Can you give us some examples of what kinds of zebras a paramedic might encounter?
Sure. It could be something like a rare genetic disorder,
Okay.
or maybe a common illness that's presenting in an unusual way. For instance, someone might have symptoms that seem like a heart attack, but it turns out to be a pulmonary embolism, a blood clot in the lungs.
Oh, wow.
Or they might have abdominal pain that looks like appendicitis,
Right.
but it's actually something called mesenteric ischemia,
Okay.
which is a blocked blood vessel in the intestines.
So it's like a medical mystery where they have to use their detective skills to figure out what's really going on.
You got it. And that's part of what makes paramedicine so challenging and rewarding.
Well, this has been an incredible journey into the world of paramedics.
It has.
I have such a deeper appreciation for what they do now.
They're amazing.
It's clear that they need that special blend of knowledge,
Yeah.
skills, and critical thinking to handle whatever comes their way.
They're truly on the front lines of healthcare.
Hmm.
And their ability to think quickly and make those tough decisions can be the difference between life and death.
It's amazing. Now, you have a good understanding of how paramedics use their critical thinking skills and those physical assessment techniques to provide that life-saving care.
Right.
But here's something to think about.
Okay.
Those skills aren't just for medical professionals.
That's a good point.
How could you apply those same principles of observation, assessment,
Mm-hmm.
and decision-making in your own life?
Yeah. Think about that.
It's something to ponder.
It is.
Thanks for joining us on this deep dive into the world of paramedics.
Hey, everyone, and welcome to a deep dive into a topic that I think will resonate with pretty much all of us at some point, caring for those with special healthcare needs.
It's something that touches everyone, really.
We're going deep into 3 chapters from a medical textbook,
Oh, wow.
all about geriatrics, special needs patients, and how to handle those really tricky situations, emergencies, when someone has a chronic illness.
Right.
And, don't worry, this isn't going to be just dry medical jargon.
Yeah.
We found some seriously fascinating insights.
Oh, yeah, definitely.
And practical tips, too. No matter if you're a caregiver yourself
Mm-hmm.
or you work in healthcare,
Right.
or maybe you just find this whole topic interesting, which I think a lot of people do.
It's definitely relevant these days. And honestly, the sheer number of seniors is exploding right now. Did you know that by 2030, nearly a quarter of Canadians are going to be over 65?
Wow, that's a lot of people.
It is. And, this huge demographic shift, it means a lot more people are going to need specialized care. And we're also seeing this massive rise in home health care.
Right.
People prefer it. Often, it's a lot more practical.
Mm-hmm.
But think about it from a paramedic's perspective. They're trained for that, controlled hospital environment.
Yeah.
And now, all of a sudden, they're thrown into these really diverse home settings,
Right.
each with their own unique challenges. It's a lot to handle.
That's so true. I actually never thought about it like that. They're going from this very specific setting into who knows what.
Yeah, exactly.
Yeah.
Exactly. It's like entering a whole new world. And, I think one of the biggest challenges they face is just wrapping their heads around how the aging body works differently.
Hmm.
It's almost like this domino effect,
Okay.
As one system starts to decline, it can kind of trigger problems in other systems. And that makes diagnosis and treatment so much more complex.
Like how a creaky knee can throw off your balance and then lead to a bunch of other problems.
Precisely. It's all connected. For instance, did you know that as we age, the heart actually gets bigger,
Really?
but weaker?
Oh, wow. So it's working harder, but it's not as efficient.
Exactly. It's counterintuitive, right? And the brain actually shrinks.
What's that? Crinks.
Yeah, it shrinks. But, it can still retain amazing function. It's pretty incredible.
That is wild. It's amazing how the body adapts, even as we age.
It is.
But I guess there's some downsides to those adaptations too, right?
Oh, absolutely. One really interesting one is that older adults, sometimes they won't even develop a fever when they get an infection,
Oh, wow.
which makes it way harder to detect,
Right, especially with all this care being provided at home now.
Exactly.
Speaking of home care, the sheer variety of chronic conditions that paramedics are running into in those settings, it's kind of mind-boggling. I mean, COPD, cystic fibrosis, heart problems, dementia, the list just goes on and on.
It really does.
Yeah.
And, that's where understanding the supporting equipment in a home healthcare setting becomes so crucial. We're talking oxygen tanks, ventilators, tracheostomy tubes, feeding tubes. It can literally be like a mini hospital in someone's living room.
It's not just medical knowledge. You need to be, tech savvy, too.
You got it. Paramedics need to know how to use all these machines,
Mm-hmm.
what the safety issues are, how to transport everything safely. One example is that you've got to be really careful not to mess with a home ventilator settings unless it's like a true emergency.
Oh, wow.
And then there's this whole double bag system for anything contaminated.
Right.
Just one example of how specialized this whole area is.
Wow. It's amazing how much goes into just providing care at home.
Hmm.
Now, earlier we were talking about something called the GMS Diamond.
Mm-hmm. The GMS Diamond.
It sounds kind of mysterious.
It's not a secret society or anything,
Okay.
but it's an amazing tool for assessing older patients. So GEMS stands for Geriatric, Environment, Medical, and Social. 4 really key areas paramedics need to consider.
So it's almost like a checklist to make sure they're looking at the whole picture, not just the symptom that's right in front of them.
Exactly.
Yeah.
Exactly. So geriatric, that reminds us that, older adults, they might not show symptoms in the typical way.
Right, right.
Then environment, that makes us think about the home itself. Is it safe?
Right.
Is it supportive? Is the temperature controlled? Things we take for granted can be really crucial.
Like if the home is cluttered, it could be a fall risk.
Exactly,
Yeah.
exactly. The medical, that part really emphasizes the importance of a thorough history
Yeah,
because, older adults are often on a lot of medications, what we call polypharmacy,
right.
and they might downplay their symptoms, thinking, oh, this is just part of getting old.
Makes sense. It's like, oh, this is just what happens when you're this age.
Exactly.
So really careful observation and clear communication are so important in those cases.
Absolutely. Absolutely. And finally, you have social. That reminds us to look at their support network.
Yeah.
Are they isolated? Is there any risk of elder abuse?
Yeah.
It's sensitive,
Yeah.
but it's crucial.
Right. The GMS diamond, it really seems to go beyond just treating the immediate symptom.
Mm-hmm.
It's about understanding the patient's whole situation. And that kind of leads us perfectly into another key part of special needs care, communication, especially when you're dealing with sensory or communication impairments. We're talking about everything from hearing loss
Right.
to vision impairment to speech impediments to paralysis. I can only imagine, like, patients would be a superpower in those situations.
It absolutely is.
Yeah.
Paramedics need to be so adaptable, utilizing writing tools, maybe involving interpreters
Right.
or family members, and just always communicating clearly, patiently.
Right.
And, sometimes those clues, they aren't obvious. For example, if someone's pronunciation is a bit off, it could be a sign of hearing loss.
Right. Not just confusion.
Exactly.
Wow, you have to be really tuned into those subtle cues.
You do.
And speaking of needing, like, extra sensitivity, let's talk about bariatric patients. I mean, providing care for them, I imagine it presents some unique challenges.
Oh, absolutely. Sensitivity and respect are so important. And then you have specific medical things to consider, like Pickwickian syndrome.
Pickwickian syndrome, what is that?
Well, think about it this way. Excess weight, especially around the chest and neck, it makes breathing harder.
Right, right, right.
And this can lead to sleep apnea. That's where your breathing repeatedly stops and starts while you're sleeping.
Okay.
And when your breathing is constantly interrupted like that, it throws off the balance of oxygen and carbon dioxide in your blood. And that's where Pickwickian syndrome comes in.
Wow. That's fascinating, but also kind of scary. It's not just about the weight.
It's not.
It's these serious health complications
Exactly.
that can go with it. What about moving bariatric patients safely? Are there any, like, special techniques involved there?
Always.
Yeah.
And communication is key. We always ask the patient how they prefer to be moved. We never, ever lift by a single limb, use the proper equipment. And we are super mindful of pressure points. It's about, respecting their dignity while also ensuring their safety.
It should be the guiding principle for all healthcare, really, no matter the situation, treating everyone with dignity and respect. And that kind of brings us to a topic that, it's a difficult one, but it's often part of healthcare, navigating the end-of-life journey, especially when it's happening at home.
It's challenging, but it's an essential part of care. And I think it's really important that we all understand the difference between a DNR order and simply not providing care.
Okay.
Even with a DNR, paramedics are still there to help,
Right.
to make sure that the patient's needs are met for comfort, for dignity.
So it's not about stopping all treatment.
It's not.
It's about making that shift
Yes.
to ensuring a peaceful and comfortable passing. Now, I imagine there are some thorny ethical considerations that come up.
Oh, absolutely. Especially with families involved. What are your thoughts on transporting a patient against a family's wishes
Oh, that's complex.
when a DNR is in place?
It's such a complex question, and honestly, there are no easy answers. It's really about striking that balance, between respecting the patient's wishes, which is what that DNR is all about, and then you have to factor in the family's distress, their understandable desire to do everything possible.
Right.
It's a situation that really calls for clear communication, empathy, and a deep understanding of the rules around end-of-life care.
It's not just about procedures. It's about navigating these really intense emotions
It is.
and ethical dilemmas. Well, this has already been so insightful, but I think this is a good spot for us to pause.
I agree. There's a lot to think about. When we come back, we're going to dive into some specific conditions and the unique challenges they present. Stay tuned.
Sounds good.
Mm.
Welcome back. Let's delve into some more specific conditions that paramedics and caregivers often encounter, shall we?
Okay.
I think a good place to start would be abnormal airway conditions.
Okay.
This area is particularly fascinating to me because it really highlights how, like, a chronic illness
Mm-hmm.
can suddenly become a life or death situation.
Yeah.
You know?
Right. It's easy to forget that what might be just a minor annoyance for some people
Exactly.
can be a huge deal for others.
Exactly. Take COPD, for instance,
Yeah.
or cystic fibrosis, or even obesity.
Right.
These conditions, they make breathing difficult on a good day. But then something like a simple fever or an infection can really tip someone over the edge.
Yeah, that makes sense.
Imagine you're already working so hard just to breathe, and then you get hit with something extra. It's like running a marathon with, like, a weighted vest on.
Yeah.
And then someone suddenly adds another 10 pounds. It's just too much.
Okay. That's a powerful image. It really gets the point across.
Yes.
You mentioned equipment like oxygen systems and ventilators earlier. It seems like knowing how to use those things
Mm-hmm.
would be critical in these situations.
Absolutely crucial. I
Yeah.
mean, these devices, they can literally be lifesavers.
Right.
But they also add this whole extra layer of complexity for paramedics.
Right.
You
Yeah.
have to be able to assess the equipment, troubleshoot any problems,
Mm.
make sure everything's transported safely. Did you know that there's actually a type of ventilator called a negative pressure ventilator
Okay.
that it actually mimics the body's natural breathing rhythm?
Wow, that's pretty incredible. It sounds so much gentler than those big, bulky ones you see in hospitals.
It is, and it doesn't require those really invasive procedures
Yeah.
like intubation,
Right.
which can be a huge advantage for some patients.
Yeah.
It's a great example of how technology is evolving to meet these complex needs.
Yeah. It makes you realize just how much paramedics need to know these days.
They do.
It's way beyond basic first aid, that's for sure.
Oh, absolutely. Now, let's talk about invasive airways for a minute.
Okay.
So these are procedures like tracheostomies and laryngectomies.
Right. I remember reading about those.
Yeah, where they actually create an opening in the neck to help with breathing.
Right. And the source material actually mentioned different types of tracheostomy tubes.
Oh, yeah, absolutely.
Even within one procedure, it's like a whole world of variation.
It is. Think about drinking straws, right?
Yeah.
They come in all these different sizes for a reason. Well, tracheostomy tubes, it's kind of the same idea. You've got different sizes and types,
Right.
and paramedics have to know how to work with each one.
So it's not just about knowing the procedure itself, but also understanding all the nuances of the equipment that goes along with it.
Exactly.
Yeah.
You also have to know about potential problems. Like a tracheostomy tube, it can get dislodged or blocked,
Right.
which is super
Me
dangerous.
too.
Paramedics need to know how to suction the airway, exchange the tubes, or even replace a tracheostomy tube with a standard tracheal tube if they have to.
Wow. That sounds like a high-pressure situation.
Right.
Requires a lot of quick thinking and expertise.
It does. It does. Okay, let's switch gears a little bit and talk about chronic cardiovascular disease.
Okay. Yeah.
Heart issues affect so many people, especially as we get older.
It's one of the leading causes of death and disability, isn't it?
It is. It is. Worldwide, in fact.
Yeah.
And a lot of these patients, they need ongoing care at home. So paramedics might encounter people with pacemakers,
Mm-hmm.
defibrillators, or even long-term venous access devices for medications. It's really important for them to understand how all these devices work
Yeah.
and how to manage any potential problems.
That's right. The source material said that heart failure is one of the most common reasons that older adults end up back in the hospital.
It's true. It's a condition that needs careful monitoring and management. But the good news is there are effective treatments. It just often involves, a bunch of medications, maybe some lifestyle changes, sometimes even surgery.
Yeah.
It depends.
It really highlights how interconnected everything is.
It does.
All the systems in the body.
It does.
And it's not just the heart.
Mm-hmm.
Chronic illness, it can affect so many different parts of the body.
Well, it can.
Like the digestive system and the urinary system.
Absolutely.
Yeah.
Paramedics might come across patients with feeding tubes,
Right.
colostomy bags,
Mm-hmm.
or urinary catheters.
Mm-hmm.
And each of these devices, they come with their own set of potential complications.
Mm-hmm.
A feeding tube could get clogged.
Mm-hmm.
A colostomy bag could leak.
Right.
A catheter could lead to an infection. Can you imagine dealing with all that at home?
Must be really tough.
It is. It is. And the source material also mentioned something called adhesions, which It kind of sounds like something out of a science fiction movie.
It does. What are adhesions?
Well, they're basically scar tissue
Oh.
that can form after surgery or an infection. They're kind of like internal sticky spots that can actually cause blockages in the intestines.
So it's not just about the initial illness or injury, it's about these potential long-term effects too.
Exactly.
Yeah.
Exactly. It's a great point. It's like things we wouldn't even think about
Right.
can have a huge impact on someone's health,
Yeah, absolutely. And speaking of things that can have lasting effects, let's talk about wounds and infections for a minute.
Okay?
The source material really stressed how aging can make people so much more vulnerable to these things.
It's true. As we get older, our skin gets thinner, more fragile, and our immune systems aren't as strong as they used to be.
Right.
That makes us more susceptible to injuries and infections. I mean, even a small cut can become a major issue for someone with a weakened immune system.
Right, right. And I remember reading that things like nutrition, activity level, even certain medications, they can affect wound healing too.
Oh, absolutely. Absolutely. And here's a crucial point for caregivers especially. The absence of a fever
Okay.
doesn't necessarily mean there's no infection in an older adult.
Right, because their immune response might not be as strong.
Exactly. So they might not have those classic signs of inflammation.
So you really have to pay attention to all the other signs and symptoms,
Yeah, you do.
not just rely on a fever as an indicator. So what are some key things to look for when you're assessing a wound?
Well, the size is important,
Mm-hmm.
but also the appearance. Is there any drainage, swelling? What's the pain level like? And you want to be on the lookout for any signs of dehiscence.
Dehiscence, what's that?
It's basically when the edges of a wound separate.
Oh, okay.
It can be a sign that things aren't healing right. And then don't forget about drains. Those tubes they use to let fluid drain from a wound.
Right.
They could be simple open tubes or more complex closed systems. It really depends.
It's like a whole other level of wound care.
Yeah, it is. It is. And paramedics, they need to know how to assess these systems too.
Right.
We got to make sure the drain is working right, monitor that drainage for any changes,
Right.
Color, consistency, odor,
Right. Right.
a lot to keep track of.
It is. It is. Sounds like careful observation and documentation are really essential for ensuring that a wound heals properly.
Absolutely. Absolutely. And while we're on the topic of sensitive care, let's shift over to hospice and comfort care.
Okay.
It's not always an easy thing to talk about, but it's a really important part of healthcare.
Yeah, absolutely. It's about supporting people with terminal illnesses and their families and focusing on comfort and quality of life.
Exactly.
It's hard to talk about,
It is.
but it's a conversation that we can't shy away from.
We can't. Hospice care, it's really all about managing pain, easing symptoms,
Right.
respecting the patient's wishes, and helping them find peace and dignity at the end of their life. Even with a DNR order in place, paramedics are still there to provide comfort care. It's a really important distinction. It's not about withholding care.
Right, right,
It's about providing a different kind of care,
right.
focused on comfort.
And comfort often goes hand in hand with pain management, doesn't it?
Absolutely. Absolutely. Chronic pain, it's a huge challenge for so many people.
It is.
It affects their physical well-being,
Yeah,
but also their emotional and mental health.
you're right.
It's a really complex experience.
Yeah.
It's not just about the physical sensation of pain.
Right. And the source material actually talked about the different types of pain signals and all the different nerve fibers involved.
Yeah.
It's amazing how the body processes pain, really.
It is fascinating. And it highlights why there's no one-size-fits-all approach to pain management.
Yeah. Right.
We need to consider each individual, their unique needs, explore a whole range of options. Medication's one piece of the puzzle. But you also have non-pharmacological approaches like physical therapy, massage, acupuncture.
Even mindfulness.
So it's about finding that holistic approach,
It is.
not just masking the pain with medication.
Exactly. Speaking of specialized care, I was really surprised to learn how common home chemotherapy is becoming.
Yeah, it must be a huge adjustment for patients and their families.
It is. Chemo is no walk in the park.
Yeah.
And to be managing it all at home, that takes serious courage and support.
Yeah, it's not just about the physical side effects either, like the nausea, vomiting, hair loss, fatigue.
It's not.
You've got the emotional and psychological toll of living with cancer, too.
Absolutely. And the medications themselves, the source material mentioned that chemo often involves multiple drugs, some to actually fight the cancer, and others to help manage those awful side effects.
Right.
It's a lot to handle.
It is. And paramedics need to be aware of potential complications too, right?
They do. They might encounter patients with implanted ports or PICC lines for administering the chemo.
Right.
And these devices require really special care to prevent infection. It's critical.
It sounds like home chemo requires a whole team effort.
It does.
You know, the patient, their family, all the healthcare professionals working together.
It does. And let's not forget about another group with really unique needs, transplant recipients.
Right.
These are individuals who've gotten organ transplant.
Right.
It's like a second chance at life.
It is.
But it comes with its own challenges.
Of course. Of course.
Transplant recipients have to take these immunosuppressant medications.
Right. To stop their body from rejecting the new organ.
Exactly. But it also means they're much more likely to get infections. So paramedics have to be extra careful.
Right.
The source material really emphasized the importance of having all their medications and medical information ready,
Right.
just in case they need to be transported to the hospital.
So healthcare providers have that complete picture of the patient's history, especially their meds and any recent changes in their health. It's like having all the pieces of the puzzle so you can make the right decisions.
Exactly.
Mm-hmm.
And while we're talking about having all the pieces of the puzzle,
Mm-hmm.
we can't forget about the importance of psychosocial support.
Right.
Chronic illness and disability,
Mm.
they can be so emotionally and mentally draining.
It's not just the physical limitations. It's like adapting to a whole new way of life. It is. Coping with loss, dealing with all these big, heavy emotions.
That's true. Patients might experience grief, anxiety, depression, fear.
Mm-hmm.
The source material, it pointed out that adaptation is a process.
Right.
It's not like you just, flip a switch.
Right.
It takes time.
Right.
There are going to be ups and downs.
Right.
It's normal.
It's a good reminder that as healthcare providers, we need to look beyond just those physical symptoms.
We do.
And really address the whole person.
Yeah.
Their emotional well-being, their mental health, sometimes just listening, just offering a compassionate presence can make a huge difference.
It can.
Yeah.
And sometimes it might mean connecting them with other resources too, like counseling,
Right.
support groups,
Yeah.
other mental health services.
It's about recognizing that healthcare is about the whole person,
Yes.
not just the illness.
Exactly.
Now, before we move on, I want to just circle back to something we touched on earlier.
Okay.
End-of-life decisions.
Mhm.
It's a tough conversation,
It is.
but it's so important for people to have a say in their own care,
Absolutely.
especially as they're nearing the end of their lives.
Absolutely. It's about empowerment,
Mm.
respecting their autonomy. The source material mentioned a few legal documents,
Right.
like a durable power of attorney, a living will. These things can help make sure a person's wishes are followed.
Right. And of course, there's the DNR, which we talked about earlier. It's all about giving people control
It is.
over their own healthcare journey,
Yeah.
even in those really difficult circumstances.
It is. And it's not just about, signing the papers. It's about having those conversations with loved ones, with healthcare providers.
Right.
While you still can, it's about planning for the future,
Mm-hmm.
making sure your voice is heard.
Right. It's not about dwelling on death. It's about taking control
Exactly.
and making your wishes known.
Oh.
Okay, let's switch gears a little bit, talk about something that's always relevant in healthcare. Communicable diseases.
Okay.
So we're talking about things like the flu, COVID-19, even more serious infections like tuberculosis.
Right. It's a constant concern.
Yeah.
Especially when you're working with vulnerable populations.
Mm.
We have to be really careful. Follow all those infection control rules.
Right.
Protect ourselves and our patients.
Right. The source material said that paramedics should be on the lookout for certain clues.
Mm-hmm.
That might suggest a communicable disease,
Mm-hmm.
things like rashes, coughing, or even just a general appearance of being unwell.
Exactly. And, don't forget about the patient's health history.
Right.
Any recent travel,
Right.
their medications, all those things can give you valuable information.
It's a good reminder that infection control is everyone's responsibility,
It is.
not just something to think about in a hospital setting.
Well said. Well said.
Yeah.
You know what? I think that's a good place for us to pause for. Now, we've covered a lot of ground here,
We have.
from managing airways to navigating end-of-life care.
Mm-hmm.
In part 3, we'll wrap things up. We'll look at some very specific conditions
Okay.
and the unique challenges they present. Stay tuned.
It's been fascinating so far. Welcome back to our deep dive into the world of special needs care. We've covered a lot of ground already, from the aging body to the ins and outs of home health care. We even touched on some pretty sensitive topics like end of life decisions, but we're not quite done yet. We still have some really fascinating conditions to explore, each with their own unique challenges and triumphs too, of course. So are you ready to jump back in?
Let's do it.
Hmm.
Let's start with a condition that affects a significant number of people, especially children, cerebral palsy,
Right.
or
Sure.
CP.
Okay, I've heard of CP, but to be honest, my knowledge is pretty limited. Could you give us a quick overview?
Sure. CP is it's a neuromuscular disorder
Okay.
that basically affects muscle control and coordination. It's caused by damage to the brain, either during pregnancy, childbirth, or early childhood. And it's non-progressive, meaning it doesn't get worse over time.
So it's not a degenerative disease like some of the others we've talked about.
Exactly. But, the symptoms can really vary from person to person. Some people with CP might just have, like, mild muscle weakness
Right.
or some difficulty with balance, while others might experience more severe limitations. They might need assistive devices,
Yeah.
like wheelchairs or specialized communication tools.
So it's a pretty wide spectrum of challenges.
It is.
One thing I remember reading in the source material was a warning against assuming intellectual disability in someone with CP.
Oh, that's so important. Just because someone has trouble with movement or speech, it doesn't mean their cognitive abilities are affected at all. We really have to treat each person as an individual, recognizing their unique needs and abilities.
It's a good reminder to not make assumptions about someone's capabilities
Yeah.
based on, their physical appearance or
Yeah,
limitation.
exactly. And paramedics especially need to be super mindful of potential injuries, especially to the limbs.
Okay.
People with CP, they might have underdeveloped or weaker bones, making them more prone to fractures.
So extra care is needed when they're being transported or just, handled in general.
Absolutely. Okay, let's switch gears a bit. Talk about another condition, one that mainly affects the respiratory system, cystic fibrosis, or CF.
Okay, I've heard of CF,
Right.
but I don't really get what that mucus does, What's the big deal?
Well, imagine trying to breathe through a straw that's like constantly getting clogged up. That's kind of what it's like for people with CF. This thick, sticky mucus, it builds up in the lungs, and the digestive system, making it hard to breathe and digest food properly.
That sounds really, really tough. And the source material mentioned it also creates like a perfect environment for bacteria to grow.
Exactly.
Yeah.
That's why people with CF are so prone to getting infections, especially lung infections. They might have this persistent cough, shortness of breath, and they can even develop something called clubbing of the fingers.
Clubbing? I haven't heard of that.
It's when the fingertips get enlarged and rounded, sort of like a drumstick. It's actually a sign of long-term oxygen deprivation.
Wow, that's pretty incredible. It's like the body is trying to tell us what's going on.
It is. One of the biggest challenges with CF is preventing and treating those infections.
Hmm.
It often involves like really aggressive antibiotic therapy and a bunch of other strategies.
And is there a cure for CF?
Unfortunately not, no. But there have been incredible advances in treatment and how we manage it. Life expectancy for people with CF has increased dramatically.
That's good to hear.
It is. It often involves a combination of things. Medications,
Mm.
airway clearance techniques, to loosen up that mucus,
Yeah.
nutritional support, and sometimes a lung transplant.
That's encouraging. It shows how even without a cure, we can still, really improve people's lives.
Absolutely. Okay, let's move on to another condition. This one affects the central nervous system, multiple sclerosis, MS. It's an autoimmune disease. That basically disrupts the flow of signals between the brain and the body. Imagine your brain is trying to send the message to your leg to move, but the message gets all scrambled along the way.
So it's like a communication breakdown within the body.
Exactly. And the symptoms can be all over the place. Some people might just experience mild sensory stuff, tingling, numbness, while others might have much more severe issues, paralysis, vision problems.
And I think the source material mentioned there are different types of MS too, right?
That's right. The most common type is called relapsing remitting MS, where the symptoms kind of come and go,
Right.
like flare-ups. But then some people, they have a more progressive form of MS, where things just gradually get worse over time.
And is there a cure for MS?
Not yet, no. But there are medications that can help manage the symptoms and slow down how fast the disease progresses. Plus, there's a ton of research going on to try and better understand MS and develop new, more effective treatments.
That's really good news. It seems like research is always pushing the boundaries of what's possible in healthcare.
It is. It really is. Now, let's talk about a group of inherited muscle diseases.
Yeah.
Muscular dystrophy.
Hmm.
These conditions cause progressive muscle weakness and degeneration, eventually leading to, loss of mobility.
Yeah.
And in some cases, MD can even affect the heart and lungs.
Right. The source material mentioned that the symptoms might not be obvious at birth,
hmm
but they often emerge as a child grows and develops.
Exactly. Parents might notice delays in certain milestones, like crawling or walking, or they might see signs of weakness, like frequent falling, or having trouble climbing stairs. One of the challenges with MD is that there are so many different types, each with its own specific genetic cause and progression.
And is there a cure for muscular dystrophy?
Sadly, no, not yet. But there are treatments that can help manage the symptoms and, improve quality of life. Physical therapy can help maintain muscle strength and flexibility. Assistive devices can help with mobility. And certain medications can actually slow down the muscle damage.
So even without a cure, there's still ways to support people with MD and help them live fulfilling lives.
Absolutely. Okay, let's talk about a disease that used to be a major global threat, but is now mostly preventable thanks to vaccines. Poliomyelitis.
Polio, yeah, that's the one that can cause paralysis, right?
Right. It's a highly contagious viral infection that mainly affects young children. Before the polio vaccine, it caused so much fear and suffering. Imagine, whole communities gripped by the fear of this disease, not knowing who would be next.
That's a scary thought. I've seen pictures of those old iron lungs.
hmm
They used to help people breathe when polio paralyzed their respiratory muscles. It's hard to even imagine what those families went through.
It was a devastating time. But thankfully, thanks to the polio vaccine,
Mm-hmm.
which was introduced in the 1950s, cases have plummeted.
Mm.
The Americas haven't had a case of polio since 1994.
That's an amazing achievement. It just shows you how powerful vaccines can be in protecting public health.
Absolutely. And even though polio is now rare in a lot of the world, it still exists in some countries.
Right.
So vaccination is still super important to prevent it from coming back.
It's a good reminder that we can't get complacent.
We can't.
We got to keep pushing for global vaccination efforts
I do.
to protect everyone,
Everyone.
everywhere.
Couldn't agree more. Now let's talk about a condition that affects the spinal cord. Spina bifida. It's a birth defect. That happens when the spinal cord doesn't close completely during pregnancy.
So, like, part of the spinal cord is exposed?
It can be, yeah.
That sounds really serious.
It can be serious. Yeah, spina bifida can cause a whole bunch of different symptoms. Paralysis, problems with bowel and bladder control,
Mm-hmm.
learning disabilities. It really depends on, the location and size of the defect.
The source material also mentioned something about latex allergies
Oh, yeah.
being more common in people with spina bifida.
That's a really important point for paramedics to keep in mind. Even things that seem harmless, like latex gloves, can trigger a serious allergic reaction in some people.
It's another reminder to be aware of potential sensitivities, allergies,
Hmm.
especially when you're working with people with special needs.
Right. Now let's shift gears a little bit. Talk about traumatic brain injury. TBI. It's kind of a broad term that covers a whole range of injuries to the brain, from mild concussions
Mm-hmm.
to severe life-altering damage.
I know that TBIs can happen from, a blow to the head, like in a car accident or a fall. But the source material also mentioned that they can happen from just like a sudden jolt or shaking of the brain.
That's right.
It seems like there are a lot of ways to get this type of injury.
There are. And one of the tricky things about TBIs is that the symptoms can be really subtle.
Mm.
They might not show up right away.
Right.
It might be days or even weeks before the full effects are clear.
That's a little scary.
It is. It is. That's why it's so critical to get a really thorough history from the patient, their family, anyone who might have seen what happened. This can help, paramedics and other healthcare providers piece everything together and spot any potential red flags.
It's like a detective game sometimes.
It can be. Early detection and intervention are really key to minimizing the long-term effects of a TBI. Okay, let's talk about a condition that affects communication between nerves and muscles. Myasthenia gravis, MG. This is an autoimmune disease that causes muscle weakness and fatigue, especially after activity.
So the body's attacking itself, basically.
Exactly. The immune system, it attacks the connection points between the nerves and the muscles. disrupting the signals that tell the muscles to contract. This can lead to a lot of different symptoms: drooping eyelids, double vision, trouble swallowing, slurred speech, even breathing problems.
That sounds really, really debilitating. And are there any effective treatments for MG?
Yes, thankfully there are. Treatments might include medications to help improve nerve transmission, therapies to remove those harmful antibodies from the blood, and in some cases, even surgery to remove the thymus gland, which is part of the immune system.
So there's a multi-pronged approach, targeting different aspects of the disease.
Exactly. And now, as we wrap up our deep dive, I want to just take a moment to think about everything we've talked about. It's been quite a journey, hasn't it?
It really has. We've gone from understanding the basics of aging to, all the complexities of special needs care across all these different conditions. And it's really, opened my eyes to the importance of empathy, awareness, and just ongoing education in this field.
I couldn't agree more. As healthcare professionals, we have to be lifelong learners, always expanding our knowledge, our skills, so we can meet the needs of all our patients.
Right.
And as individuals, we can all do our part to create a more inclusive and supportive society for people with special needs.
It's about moving beyond just tolerating differences,
Right.
to really embracing them and celebrating the unique contributions that everyone brings to the table.
Beautifully said.
Yeah.
Remember, knowledge is power. The more we know about special needs, the better prepared we'll be to provide compassionate and effective care.
This has been a fantastic deep dive. I feel like I've learned so much, and I hope our listeners feel the same way.
Thanks for joining us on this journey. We'll be back with more deep dives soon. All right, let's dive in today. We're tackling EKGs.
EKGs.
Yeah, those little squiggles that tell us all about our hearts.
Yeah.
We've got a stack,
It's late.
medical textbooks, slide decks, the whole shebang.
Mm-hmm.
By the end of this deep dive,
Whole lot of information.
you're going to be fluent in EKG.
We're not turning you into cardiologists.
No. But
not
you'll
sad.
at least be able to, spot
Yeah,
those red flags.
Exactly. At least you'll understand what your doctor's talking about
Right.
when you see those squiggles
Exactly.
on the screen.
Okay, so EKGs, what are they really measuring? It's electrical signals, right?
Yeah.
What's the big deal about those?
Yeah. So at the most basic level, an EKG is really just capturing the electrical activity that makes your heart beat. It's
Okay.
like we're listening in on the heart's communication system.
Ah, interesting.
Every beat, every pulse you feel
Yeah.
starts with an electrical impulse. And what the EKG does is it takes those impulses and translates them into that visual graph
Right.
that we can then analyze.
So it's more than just is my heart beating fast or slow?
Yeah.
It's like the quality of those signals, right?
Yeah, it's about the quality, the timing,
Uh-huh.
the coordination of
Oh,
those electrical signals.
Okay. So when those signals are moving smoothly,
Exactly.
what does that tell us about the heart?
Well, think of it like a perfectly choreographed dance.
Okay.
The heart's electrical system has to be
Yeah.
perfectly timed and coordinated to make sure that
Right.
each chamber of the heart contracts in the right sequence,
All right.
and that pushes the blood
Yeah.
through the heart and out to the body.
Okay, so kind of like a chain reaction.
It is. It's a very precise chain reaction.
Yeah, that makes sense.
Yeah.
So let's break down this electrical dance. Our sources mention this thing called the SA node. What is that all about? Why is it so important?
The SA node, or the sinoatrial node,
Okay,
it's like the VIP of the heart's electrical system.
the VIP.
The VIP, yeah. It's often called the heart's natural pacemaker, and for good reason. This tiny cluster of cells,
Uh-huh.
it's located in the right atrium,
Right.
and it's what sets the rhythm for your heartbeat.
So it's like the conductor.
Yeah, it's the conductor of the heart's orchestra.
Got it. So the SA node kicks things off.
Yes.
And then how does that signal travel through the rest of the heart?
Okay, so the electrical impulse from the SA node
Yeah.
spreads through the atria first,
Okay.
causing them to contract.
Right.
That contraction pushes blood down into the ventricles.
Uh-huh.
The ventricles are the heart's main pumping chambers.
Okay.
Then that signal, it travels down to this other node
Right.
called the AV node.
AV node.
Yeah, or the atrioventricular node. Now, the AV node is kind of like a gatekeeper.
The gatekeeper.
It slows down the signal just a bit
it
before it gets relayed to the ventricles.
So it's like a pause.
Yeah, it's like a strategic pause.
Okay.
And that pause is crucial
Okay.
because it allows the ventricles time to fill up completely with blood
Right.
before they contract and pump.
So if I'm getting this right, it's like a relay race. SA node passes the baton to the AV node.
Exactly.
Data to make sure everyone's ready,
Yeah.
and then it's the ventricle's turn.
That's a great way to think about it.
Yeah, okay.
A very well-coordinated relay race.
And each of those steps, each handoff, is showing up
Absolutely.
as a different wave or bump
That's
on
right.
the EKG, right?
Yeah. Think of it as a secret code.
A secret code.
Cool.
Yeah.
That tells us exactly what's happening inside the heart.
Okay, so let's decode this. Let's start with the P wave. I always see that little bump at the beginning. What's its role?
The P wave, it might be small, but it's definitely not insignificant.
Okay.
It's the electrical signature of the atria contracting.
The atria. Okay.
Yeah, so as that electrical impulse spreads through the atria, it causes them to contract, pushing blood into the ventricles.
Right. The ventricles are waiting.
Exactly.
Okay, so P wave, atria are doing their thing.
Yeah.
Then comes that big spike, the QRS complex.
That's right.
That's got to be the ventricle.
You got it. That QRS complex is all about the ventricles.
Okay.
So when that electrical signal reaches the ventricles,
Yeah.
it causes them to contract powerfully.
Right.
And that's what propels blood out to the lungs and the rest of the body.
Okay, so that's the big pump, the main event.
It is. It's the main event.
And it makes sense that it's a bigger spike on the EKG because the ventricles are...
Exactly. They're much larger
Yeah.
and more powerful than the atria.
Right.
So they need a stronger
Yeah.
electrical signal.
Okay, that makes sense. So we have P wave is the atria,
Mhm.
QRS is those ventricles contracting.
Right?
Now there's that last little wave, the T wave.
Yeah, yes, the T wave. The T wave represents the electrical recovery
Okay.
or repolarization
Yeah,
of the
right.
ventricle.
So it's like they're relaxing,
They're relaxing, they're recharging,
recharging.
getting ready for the next beat.
Okay.
Makes sense.
It's their little break.
Got it. P wave, atria contract. QRS, ventricles contract. T wave, ventricles recover. But is it always this perfect, like, synchronized dance? Don't things ever get a little out of rhythm?
That's a great question, and it leads us to one of the most crucial parts of understanding EKGs, rhythm analysis.
Okay, rhythm analysis, what does that mean?
So not all hearts beat
Yeah.
in perfect time, right?
Yeah.
Sometimes those electrical signals, they get disrupted,
Uh-huh.
and that leads to what we call
Okay,
arrhythmias.
arrhythmias. Okay, so those are those irregular heartbeats.
Exactly.
Yeah.
And EKGs are really our main tool
Oh.
for detecting and classifying those arrhythmias.
Right, so by looking at the EKG, we can see if things are out of sync.
Exactly.
Okay, that makes sense. Well, I'm ready to get into the rhythm of things.
All right, let's do it.
Ah,
Let's explore those irregular patterns. And I'm especially curious about this phrase I've seen, regularly irregular. Like, how can something be both regular and irregular?
it sounds a bit paradoxical, doesn't it?
Yeah.
But regularly irregular describes a rhythm that's not perfectly even,
Uh-huh.
but it has a predictable pattern to its irregularity.
So it's not totally random?
Not totally random, no. It's like, think of a song with a syncopated beat.
Okay.
It's not a steady metronome tick, but there's a recurring motif
Right, I got you.
to the offbeats.
Okay, so give me an example. What would a regularly irregular rhythm look like in the real world?
Sure. So one common example is atrial fibrillation,
Atrial fibrillation.
or AFib.
AFib, okay.
In AFib, the atria, they quiver chaotically instead of contracting smoothly.
Oh, wow.
So that leads to these rapid and irregular impulses bombarding the AV node, remember the gatekeeper.
Right, right.
And so the resulting ventricular rhythm, it ends up being irregular,
Yeah.
but it often has this characteristic pattern.
Coach.
Like maybe a group of fast beats, followed by a pause, and then that pattern repeats.
Okay, so it's not just complete chaos.
No, there's a method to the madness.
Yeah, yeah. Okay, so that's regularly irregular. What about irregularly irregular? Is that just like completely random?
Pretty much. It's like pure chaos.
Okay.
It's like free jazz
Oh, wow.
with no predictable melody or rhythm.
That's kind of scary.
It can be. And that's why it's so important to pay attention to these patterns,
Right.
because the type of irregularity
Yeah.
can give us really important clues
Okay.
about the underlying cause
Uh-huh.
and the potential severity of the arrhythmia.
So like regularly irregular, that might be manageable. But if it's completely irregular,
Yeah, if it's irregularly irregular, it could indicate a more serious problem that
Right.
might require a more aggressive intervention.
okay, so it's all about understanding the pattern.
Exactly. It's all about those patterns.
Makes sense.
Yeah.
Now, our sources have a bunch of EKG strips. I feel like we need to put our detective hats on
Let's do it.
and try to figure out how to estimate heart rate
All
in
right.
these tracings. Game on.
Game on. Let's start with a simple one, the 6-second method.
Okay, 6-second method. What is that?
So you look at your EKG strip,
Yeah.
and you find a 6-second interval.
Okay, I see the markers.
You count the number of QRS complexes
Uh-huh.
within that 6-second interval,
Okay.
and then you multiply that number by 10,
All right.
and that gives you the heart rate.
Okay, so looking at this strip, I see about 9 QRS complexes within that 6-second marker.
Okay, so 9 times 10.
That's 90.
90 beats per minute.
Okay, that makes sense. And it's pretty quick and easy.
Yeah, it's a quick estimate.
But what if the rhythm isn't regular? Like if it's one of those, regularly irregular situations.
No, we might need a different method, like the sequence method.
Yeah.
But that only works for regular rhythms.
Okay, sequence method, let's try it. I'm finding a nice R wave, one that looks pretty regular.
Okay, good.
All right, got it. Now what?
Okay, so now you're going to count off these magic numbers.
Magic numbers.
300, 150, 100,
300, 150. How about
75, 60.
75, 60? Got it.
And you see where that next R wave falls.
Okay, looks like it's right around the 60 mark.
So that means the heart rate is 60 beats per minute?
60 beats per minute. Nailed it.
You're a natural.
But what about those super fast heart rates?
For those, we have the 1500 method.
1500, okay.
It's the most accurate, especially for really rapid rhythms.
All right, challenge accepted. Let's see, this one looks pretty fast.
Okay,
I'm counting those little boxes between the QRS complexes.
good.
Looks like about 13 small boxes.
Okay, so you take 1500 and divide it by 13.
Okay, I get about 115 beats per minute.
Perfect.
That is fast.
That is our rapid heart rate.
Okay, so we've got our 6-second method, our sequence method, and our 1500 method. We can handle any heart rate that comes our way.
You've mastered the basics.
Yeah, I'm feeling pretty confident. But we've been looking at single lead strips. I know there's this thing called a 12-lead EKG.
Yes, the 12-lead EKG.
It's like the next level, right?
It is. It's a much more comprehensive view.
It gives us more information.
Way more information. Think of it like this. Instead of just one camera,
Okay.
we now have 12 cameras.
12 cameras. Wow.
All capturing your heart's electrical activity from different angles.
Okay, so it's giving us like a 3D picture.
Exactly. A three-dimensional view of the heart's electrical activity.
That's incredible. But where are those cameras? Or I guess electrodes in this case. We have a diagram here.
Yeah, electrode placement.
It looks a little complicated.
It is precise, but it's not too complicated once you get the hang of it.
Okay, let's break it down.
All right, let's start with the limb leads.
Limb leads. Okay, so those are the ones that go on the arms and legs.
Exactly.
Fair.
So it's like we're creating a triangle
Uh.
with these leads.
Okay, so I see white lead goes on the right arm, black lead on the left arm, red lead on the left leg. What about that green one?
That green one is the ground lead.
The ground lead. What does that mean?
It's usually placed on the right leg, and it helps to minimize electrical interference.
So it's like the noise-canceling technology.
Exactly. It makes sure we get a nice, clean signal.
Oh, that's important.
It is very important.
Okay, limb leads. Got it. Now, for those chest leads, they look a bit more complicated.
They are a bit more specific in their placement.
I see V1 and V2 are placed near the sternum.
That's right.
Okay, so what's the exact placement?
So V1 is on the right side of the sternum in the fourth intercostal space.
Intercostal space. That's the space between the ribs, right?
Exactly, the space between the ribs.
Okay.
And then V2 is on the left side of the sternum,
Okay.
also in that fourth intercostal space.
So they're kind of mirroring each other.
They are?
Okay, got it.
Yeah.
What about V4? It looks like it's right below the nipple.
Well, technically, it's placed in the fifth intercostal space.
Okay.
At the midclavicular line.
The midclavicular line.
Yeah, that's an imaginary line that runs down from the middle of your clavicle.
From the collarbone. Okay, so we try to be as precise as possible.
We do, because even a slight misplacement can change the way those electrical signals are recorded.
That makes sense.
Yeah.
So V1 and V2 on either side of the sternum, V4 at that midclavicular line. Where do the rest go?
Okay, so V3 goes between V2 and V4.
Okay.
Also in the fifth intercostal space.
So we've got a little triangle forming there.
We do.
Okay, then V5 and V6, it looks like they go on the left side under the armpit area.
Almost. V5 is in the fifth intercostal space.
Fifth again.
At the anterior axillary line.
Anterior axillary line, another one of those imaginary lines.
Yeah, it runs straight down from the front of the armpit.
Okay.
And then V6 is also in that same intercostal space,
Okay.
but further back at the mid-axillary line, so a line running down from the middle of the armpit.
Got it. So much precision.
There is.
I'm starting to see how all these different placements give us that 3D perspective.
Exactly.
Okay, so we've got our limb leads, our chest leads.
Yeah, all 12 leads working together.
Working together.
to give us a comprehensive picture.
Okay, so consistency is key here.
Absolutely. Consistent lead placement is super important for getting an accurate EKG.
I can imagine, yeah.
If those electrodes are even slightly off, it can change
Yeah.
the way those signals are recorded.
And that could lead to, like, a misdiagnosis.
It could.
Okay, so we've got to be really careful.
Yes, precision is key.
Okay, so we've covered a lot. I think we've got a good foundation for understanding EKGs.
I think so too.
But now the real detective work begins.
Right.
We need to learn how to spot those patterns, those clues.
Absolutely.
That can point to some serious heart problems.
That's what we'll tackle next.
All right, I'm ready for the challenge.
Bring on the challenge.
I am. Okay, welcome back to our EKG adventure.
Back for more EKG.
We are. So we've decoded the basics.
Yeah.
We figured out P waves, QRS complexes, T waves,
Squiggles.
those squiggles. We can even estimate heart rate.
You're practically pros.
I know. But now it's time for the real detective work.
The real detective work.
Yeah, like how do we actually spot those EKG patterns?
Yeah. Yes.
That could mean,
Trouble.
trouble. I'm a little nervous, to be honest.
You're a little nervous, I understand.
Yeah, but I'm also kind of excited.
And a healthy mix.
Yeah.
Nerves and excitement.
Okay, so our sources keep mentioning ischemia, injury, infarction.
Right.
Can we, define those real quick, make sure we're all on the same page?
Of course. Let's imagine the heart as a bustling city
Okay, I like this.
with a network of coronary arteries.
Okay.
They're like the highways,
Okay.
constantly supplying oxygen-rich blood
Yeah.
to the heart muscle.
Okay, so the heart muscle is like the city.
Exactly, like the city's businesses and residents.
Okay.
Now, ischemia happens when there's a blockage in one of those highways. So blood flow is restricted.
So it's like a traffic jam.
It's like a traffic jam on a crucial route.
Okay.
And if that traffic jam persists,
Yeah.
those businesses and residents, they start to suffer.
Oh.
That's what we call injury.
Injury.
The heart muscle starts to get damaged because it's not getting enough oxygen.
Not good, not good.
And then the worst case scenario
Yeah.
is infarction, which is a heart attack.
Okay, heart attack.
In that case, a portion of the heart muscle actually dies.
So it's like those businesses in the city,
Exactly.
they just shut down.
They shut down permanently.
Wow, okay. That's pretty serious stuff.
It is serious.
So how do we see those different stages? Ischemia, injury, infarction.
Right.
How do we see those on the EKG? Are there like specific patterns?
There are, yeah. So we become EKG detectives.
Okay, like
And we carefully examine the tracing for clues. One of the most important areas we look at is the ST segment.
the ST segment.
Remember, that's the section of the EKG between the S wave, the
Yeah.
QRS complex, and the T wave.
Okay. Between the S and the T,
Exactly.
right, ST segment. What kind of changes should make us, worried?
Well, one of the most alarming signs
Oh.
is ST segment elevation.
ST segment elevation.
Yeah, it's literally a lifting of that segment
Okay.
above the baseline.
Okay, so it's higher than it should be.
Exactly. And that often indicates that a heart attack
Oh, wow.
is in progress.
So if we see ST segment elevation,
That's a red flag.
red flag, call 911.
Absolutely.
Okay, got it.
So what else should we be looking at in that ST segment?
Well, we also pay attention to ST segment depression.
Depression, so it's lower.
Yeah, it's a dipping of that segment below the baseline.
Okay.
Now, that can indicate ischemia,
It's ischemia, that's the
that restricted blood flow.
traffic jam.
Exactly, the traffic jam.
Okay.
And it definitely warrants further investigation.
Okay, so elevation or depression of the ST segment.
Both potential signs of trouble.
Got it. Now, what about the T wave?
The T wave,
Yeah, remember from last time? The ventricles are
recovering.
recovering, yeah.
You're recharging.
So can the T wave tell us anything about potential heart problems? It can, yeah. So T waves, think of them as the heart's way of saying,
Okay.
I'm recovering, I'm getting ready for the next beat.
Uh-huh.
But when those T waves become inverted, like flipped upside down,
Inverted, okay.
yeah, that can be a sign of ischemia or injury.
So it's like the heart is saying, hey, I'm not doing so well.
Exactly. It's a warning sign.
Not a good sign.
No.
Okay. Our sources also mention something called pathological Q waves.
Pathological Q waves.
What are those?
So those are deeper than normal Q waves.
Deeper, okay.
And they can develop
Uh-huh.
after a heart attack.
So it's like a scar
Yeah, think of it like a scar
That's right.
on the EKG, a lasting imprint
from the heart attack.
from the damage that occurred.
Okay, so we've got ST segment elevation,
Mhm.
ST segment depression,
Right.
T wave inversion, pathological Q waves, all bad news bears.
All potential signs of trouble.
Okay, anything else? Anything else we need to be on the lookout for?
Well, you're forgetting one crucial element.
Oh no, what am I forgetting?
Reciprocal changes.
Reciprocal changes. Okay, tell me more, because I don't think we talked about that last time.
So imagine you have a balloon,
Okay, a balloon.
and you squeeze one side of it.
Yeah.
What happens to the other side?
It bulges out.
It bulges out. It's a similar concept with the heart.
Oh, interesting.
So when there's ST segment elevation in one area due to a heart attack,
Okay,
we often see ST segment depression and T wave inversion
on the other side.
in the electrically opposite leads.
So it's like a mirror image.
Exactly. A mirror image, but with opposite changes.
Oh, wow. That's amazing how the heart does that.
It is. It's the heart's way of confirming
Affirming,
that a heart attack is happening.
like a double check system.
Exactly.
Right.
It tells us that this is a significant blockage
Okay.
affecting a large portion of the heart muscle.
Reciprocal changes. Okay. Got to remember that one. That's a big one. So it seems like we can learn a lot from the EKG.
We can.
Okay.
EKGs are powerful tools,
Yeah.
but it's important to remember that they're just one piece of the puzzle.
One piece of the puzzle.
We always have to consider the patient's symptoms,
Right.
their medical history, and other diagnostic tests
To get the whole picture.
to get the complete picture. Yeah.
So speaking of getting the full picture, I know that sometimes a standard 12-lead EKG
Yeah.
isn't enough. Is there such a thing as a 15-lead EKG?
There is. There is. A 12-lead EKG is great,
Yeah.
but sometimes we need a little bit more information.
Okay.
It's not routine,
Hmm.
but a 15-lead EKG can be really valuable when we suspect certain things.
Like what? What kind of situations would we need that extra information?
Well, sometimes we need a better look at the right ventricle
The right ventricle.
or the posterior wall of the heart.
Okay, remind me, where are those?
Okay, so let's think of the heart as a house.
All right, how?
The inferior wall is like the foundation,
Okay, the foundation.
and the right ventricle is one of the rooms on the ground floor.
Got it.
So if a heart attack affects that inferior wall,
Yeah.
sometimes it can also impact
Right, ventricle.
the right ventricle. Exactly.
So we need to check both the foundation and the room.
We do, and that's where the 15-lead EKG comes in.
Okay, so how do they get 15 leads? Do they add more electrodes?
It's not about adding more, it's more about strategic repositioning.
Oh, yeah.
So we take some of those precordial leads, specifically V4, V5, and V6,
Okay.
and we move them to the right side of the chest.
The right side of
And by doing that, we create new leads,
new leads.
V4R, V8, and V9,
Okay.
and those give us a clearer view of that right ventricle.
So we're just adjusting the camera angles.
Exactly, adjusting the camera angle.
Got it. So that's one reason to do a 15 lead. What's the other situation?
The other situation is when we're looking for a posterior MI.
Posterior MI, that's a heart attack.
That's a heart attack affecting the back wall of the heart.
So the back of the house.
Exactly.
Okay.
Now, the standard 12-lead EKG doesn't have leads that look directly at that posterior wall.
Right.
But by repositioning those precordial leads,
Like,
we can create leads V7, V8, and V9. Okay. And those give us an indirect view.
so it's like using mirrors to peek around corners.
Exactly.
It's really clever. What would we be looking for in those leads to, like, confirm a posterior MI?
So if we see ST segment depression in those leads,
Okay.
coupled with ST segment elevation in the leads that are looking at the opposite anterior wall,
The front.
the front,
Okay.
that strongly suggests a posterior MI.
Okay, so we've got our standard 12 lead for the overall picture,
Oh.
and then the 15 lead for those trickier cases.
Exactly, for those special situations.
I feel like I'm leveling up in my EKG knowledge.
You are.
But I also know that, with great power comes great responsibility,
That's true.
because we're learning about all these, like, warning signs on the EKG.
Yeah,
But I know there are other things that can mimic those patterns.
they can.
Like, it might look like a heart attack, but it's actually something else.
Exactly, and those are what we call STEMI mimics.
STEMI mimics.
Yeah, STEMI stands for
Repeatedly.
ST elevation myocardial infarction.
Right, a heart attack.
A heart attack, yeah. But there are a bunch of other conditions
Hmm.
that can cause similar EKG changes, even when there's no actual STEMI happening.
So it's like those optical illusions where you think you see one thing,
Yes.
but it's actually something totally different.
That's a great analogy. These STEMI mimics can be challenging,
I bet.
even for experienced cardiologists.
Okay, well, let's talk about some examples. Hit me with those EKG illusions.
Okay, let's start with bundle branch blocks, or BBBs.
Bundle branch blocks, BBBs.
Yeah. These are disruptions in the electrical pathways that carry those signals through the heart.
So it's like a detour or a roadblock on our electrical highway.
Exactly, a detour or a roadblock.
Okay. And how does that affect the EKG?
Well, it can cause the QRS complex. Remember that spike?
Yeah, ventricular contraction.
Yeah, it can cause that to widen abnormally.
Okay, so it's wider than it should be.
Exactly.
How do we know if that's a BBB or an actual heart attack?
There are some specific features that help differentiate them. For example, in a right bundle branch block, or RBBB,
RBB.
we often see this characteristic rabbit ears pattern in the QRS complex.
Rabbit ears.
Yeah, especially in lead V1.
I love it. Okay, so rabbit ears, RBBB. What about a left bundle branch block?
The left bundle branch block, or LBBB,
Can be
a little trickier.
Oh.
It can actually mask some of the typical EKG signs of a heart attack.
Oh, wow.
And it can also cause ST segment elevation.
It's not good.
It's not. It can be easily mistaken for a STEMI.
So it's all about looking really carefully at that QRS complex.
It is, yeah.
Okay, baby V's, got it. It's next.
Next up, we have benign early repolarization.
Benign, that sounds good.
It is good. It's harmless.
Okay.
It's actually quite common, especially in younger people.
Okay, so what does it look like on the EKG?
It often causes some subtle ST segment elevation.
Oh, but it's benign.
It's benign.
So how do we tell the difference?
Well, the shape of the ST elevation is one clue.
Okay.
In benign early repolarization, it tends to have this concave or scooped out shape.
Concave, like a smile.
Like a smile, exactly.
Oh,
In a true STEMI, that ST elevation is usually convex, more like a frown.
okay. Concave, happy. Convex, not so happy.
That's a good way to remember it.
Any other clues for benign early repolarization?
Yeah, look at the height of the T wave.
The T wave.
In benign early repolarization, that T wave is usually taller than the ST elevation.
So it's like it's trying to reassure us.
It is. It's like a little thumbs up
Okay, good.
saying everything's okay.
All right, I like that.
Yeah.
What else do we have?
Okay, let's move on to left ventricular hypertrophy, or LVH.
LVH.
Yeah. Hypertrophy means that the left
No,
ventricle...
big pumping chamber.
Exactly. It means it's gotten thicker.
Okay, thicker. Why would that happen?
Often it's due to chronic high blood pressure.
Okay.
So it's like the heart's been working out too much.
It's gotten swole.
It's gotten swole, yeah.
Okay, and that can cause problems.
It can, yeah. That thickening can cause some pretty dramatic changes on the EKG.
Like what?
Well, including ST segment elevation, that can mimic a heart attack.
Okay, so
Yeah.
how do we tell the difference between LVH and a true heart attack?
Well, one giveaway is the size of the QRS complexes.
Okay.
In LVH, they get really tall and wide. It's like
Right, yeah.
those electrical signals are shouting instead of talking.
So big, bold QRS complex.
Big and bold, yeah.
Yeah.
And we also pay attention to the location of that ST elevation.
Okay.
In LVH, it's usually most prominent in leads V1 and V2.
Okay.
In a true STEMI, we'd expect to see it in multiple leads.
So location is key.
Location is key.
Got it. Okay. What's next?
Next up, we have pericarditis.
Pericarditis. What is that?
So that's inflammation of the pericardium, the
What?
sac that surrounds the heart.
So it's like the heart's protective covering is irritated.
Exactly.
Okay. And why is that a problem?
Well, that inflammation can cause widespread ST segment elevation,
Uh-oh.
and that can be mistaken for a STEMI.
Oh, no. Okay, so how do we tell the difference?
Well, one clue is that in pericarditis, that ST elevation is usually present in most of the leads.
Okay, so it's more widespread.
It's widespread. And it also tends to have that concave or scooped out shape.
The smiley face?
Exactly, the smiley face.
Okay, good.
And the T waves are usually upright, not inverted.
Okay, so concave shape, upright T waves, pericarditis.
That's a good way to remember it.
Okay, what's next?
Okay, let's talk about Brugada syndrome.
Brugada syndrome. Okay, what is that?
So it's a less common condition,
Mhm.
but it's important to recognize because it can cause some really serious arrhythmias.
Arrhythmias, okay.
Yeah, those irregular heart rhythms.
Right, right.
And the scary thing about Brugada syndrome is
Yeah.
that those arrhythmias can be triggered by certain things,
Like what?
like certain medications or even a fever.
Oh, wow. So it's like there's this hidden vulnerability.
Exactly, a hidden vulnerability,
Uh-huh.
and then something triggers it.
Triggers it, yeah. Okay, so how does it look on the EKG?
So on the EKG, Brugada syndrome can cause ST segment elevation.
Uh-oh, again with the ST segment elevation.
Yeah, it can be tricky, but in Brugada syndrome,
Yeah.
it usually has this very distinctive shape.
Okay, what kind of shape?
It's called a saddleback or coved shape.
Saddleback, okay.
Yeah, and the T waves are often inverted in those same leads.
Okay, so a specific shape, and it's usually only in certain leads, right?
Right, usually just in leads V1, V2, and V3.
So we're looking for the saddleback shape in those specific leads.
Yeah.
Okay, what else do we need to know about?
Okay, let's talk about stress cardiomyopathy.
Stress cardiomyopathy. Is that what
Yeah.
they call broken heart syndrome?
It is, yeah. Sometimes it's called Takotsubo cardiomyopathy.
Takotsubo cardiomyopathy. Okay, so broken heart syndrome. What's going on there?
So it's a temporary condition
Capillary, okay.
where the heart muscle weakens,
Weekends,
and it's often triggered by extreme stress or grief.
like emotional stress.
Emotional stress, yeah.
Wow, the heart really can break.
It can, but the good news is it's
Mhm.
usually temporary. So how do we know it's not a real heart attack? Well, the clinical picture is key.
Okay.
The symptoms usually resolve quickly,
Okay.
and those EKG changes
Yeah.
typically go back to normal within a few days or weeks.
So it's dramatic, but it's not permanent.
Exactly.
Okay, good.
Yeah.
What other mimics do we have?
All right, how about persistent ST elevation after a myocardial infarction?
Persistent. So that means it's like hanging around.
It's hanging around even after the heart attack.
Oh, so it's like a lingering effect.
Exactly.
Okay, so why is that a problem?
Well, because sometimes that ST segment can stay elevated in the affected leads,
Yeah.
even though the heart muscle has healed.
So it looks like there's still a problem.
It does, and that's why knowing the patient's medical history
Right.
is so important.
Right, because if we know they had a heart attack in the past,
Exactly.
then we can expect to see those changes.
We can, yeah.
Okay, so it's like we know that that part of the house has been repaired,
Right.
but there might still be some signs of the old damage.
That's a good way to think about it.
All right. Any other mimics we need to cover?
Okay, let's shift gears a bit
Right.
and talk about electrolyte imbalances.
Electrolyte imbalances. Those are those things we get from sports drinks, right?
Those are the things in sports drinks.
Okay.
Yeah. Let's start with hyperkalemia.
Hyperkalemia. Does that mean too much potassium?
It does. It means too much potassium in the blood.
Okay. And how does that affect the heart? Potassium doesn't sound that dangerous.
Well, potassium is really important for the heart's electrical activity.
Okay.
But too much potassium can
Okay.
disrupt those signals,
Okay.
and that can lead to some significant EKG changes.
So what kind of changes are we talking about?
We might see tall, peaked T waves,
Okay.
flattened P waves, and a shortened QP interval.
A shortened QT interval. Okay.
Yeah, in really severe cases.
Yeah.
The EKG can even progress to this thing called a sine wave pattern.
A sine wave pattern.
It's a life-threatening situation.
Okay, so this is serious stuff.
It is, yeah.
Okay, but how does that mimic a heart attack?
Well, those peaked T waves
Mhm.
and the shortened QT interval,
Yeah.
they can create the illusion of ST segment elevation,
Even when there's no blockage.
even when there's no blockage.
Wow, so it's like a potassium-induced mirage?
Exactly.
Okay. Hyperkalemia. Got it. What's our last mimic?
All right, last but not least, we have Prinzmetal angina.
Prinzmetal angina. I haven't heard of that one.
It's a less common type of angina.
Okay. Angina. Chest pain.
Chest pain, right?
Yeah.
But Prinzmetal angina is caused by spasms in the coronary arteries.
So is that a blockage? It's like a
It's a spasm, yeah.
sudden tightening?
A sudden constriction.
Okay.
Like the arteries having a tantrum.
Okay, so why is that a problem? It sounds like it should be temporary.
Well, even though those spasms are temporary,
Yeah.
they still deprive the heart muscle of oxygen.
Just like a heart attack.
It's like a heart attack, yeah.
Okay. So how do we tell the difference between Prinzmetal angina and a real heart attack?
Well, a good medical history is key. Prinzmetal angina often happens at rest.
The rest. Okay.
Especially at night.
Okay.
And it's usually not triggered by physical activity.
Right.
Like classic angina.
So if someone's having chest pain at night,
Think Prinzmetal.
think Prinzmetal. Got it. What about the EKG? Are there any clues there?
Yeah, so the EKG changes in Prinzmetal angina, they tend to be transient.
Transient. That means they
They come and go
come and go.
as the spasms happen and resolve.
Okay.
And that ST elevation might have a different shape
Okay.
or involve different leads.
So the EKG is like a real-time monitor
It is.
of what's happening in those arteries.
Exactly.
Wow, that's amazing. So we've talked about a lot of mimics.
We have.
It seems like EKG interpretation is a real art form.
It is. It takes practice and experience.
Yeah. EKGs are amazing tools,
Powerful tools.
but they're not the only thing.
No, they're just one piece of the puzzle.
Right. We always need to consider the whole patient,
It's
their symptoms, their history, everything.
the whole picture.
The whole picture. Okay, so we've covered a ton in this part.
We have.
We've learned about the warning signs of
Right.
heart problems on EKGs.
Yeah.
And we've explored all these crazy STEMI mimics.
All those EKG illusions.
It's clear that interpreting EKGs
Yeah.
It's not simple.
It's not.
You really need to understand all those nuances.
You do. It's a complex skill.
I'm feeling pretty good about it.
But I'm glad.
I'm feeling more confident, but also I realize how complex this is.
And that's a good thing.
Yeah.
It's good to have a healthy respect for the complexity.
Okay, so we focused on EKGs in emergencies,
Yeah.
but I'm curious, what about, like, routine checkups?
Ah, yes?
How are EKGs used in everyday cardiology?
That's a great question, and that's what we'll explore next time.
All right. I'm excited to learn more about that.
It's fascinating stuff.
Yeah, it is. Welcome back to our EKG deep dive. We've come a long way
We have
from those basic squiggles.
the ABCs of EKGs.
I know. And then those, scary patterns.
Right, those red flags.
The red flags, yeah. And we even tackled those sneaky mimics.
The EKG illusions.
Oh, those mimics, they're tricky.
They are.
So we were talking about EKGs in emergencies.
Yeah, a lot of focus on
Yeah, like in the ER. But
emergencies.
I'm curious about, like, everyday cardiology.
Right.
What about those routine checkups?
Yeah. EKGs are incredibly versatile.
Okay.
They're not just for emergencies. They're used all the time.
Okay, so give me some examples. Like, how are they used in, just general cardiology practice?
Well, let's say you go for a routine checkup.
Okay.
Your doctor might order an EKG
Okay.
just as part of your overall cardiovascular assessment.
So it's like a baseline.
Exactly, a baseline snapshot
Okay.
of your heart's electrical activity.
Okay, so we can see if anything's, like, off.
Right. It can help detect subtle abnormalities that might not be obvious during a physical exam.
So things that we wouldn't even know about otherwise.
Exactly.
Okay, so that's in a, like, doctor's office setting. What about in the hospital?
Oh, EKGs are used constantly in hospitals.
Okay.
Think about someone who comes in with chest pain.
Okay.
One of the first tests they'll do is an EKG.
See if it's the heart.
Exactly, to help determine the cause of that pain.
Okay, so it helps rule things out.
Is it the heart? Is it something else?
Oh, right.
It's
Yeah.
really helpful for making those decisions quickly.
And I imagine in, like, the ICU,
Oh, absolutely.
those patients are probably hooked up to an EKG all the time.
Continuous EKG monitoring.
Okay, so we can see any changes.
Exactly. Any changes in heart rhythm, any problems, we see them right away.
Okay, that makes sense. And I imagine technology helps with all this.
Oh, yeah. Technology has revolutionized EKG interpretation.
Okay.
I mean, now we have these sophisticated computerized algorithms.
Algorithms.
Yeah, they can analyze the EKG
Okay.
and help identify potential abnormalities.
So they can, like, flag things for the doctor.
Exactly. They're like a second set of eyes.
Okay, that's pretty cool.
It is. It's super helpful, especially in those time-sensitive situations.
Right, when every second counts.
Every second counts.
Okay, but those algorithms, they're not perfect.
They're not perfect, no. They're tools to assist,
To assist.
not replace human expertise.
Right, so a doctor still needs to look at it.
Absolutely. Always.
Okay, good.
The doctor interprets the EKG in context.
Right, with the patient's whole history.
Exactly.
Okay, so it's a team effort,
It
technology, and the doctor.
perfect team together.
Okay, that's good to know. So what about the future of EKGs? Any cool things on the horizon?
Oh, there's some really exciting stuff happening.
Like what?
Well, imagine wearable devices
Wearable devices, okay.
that can continuously monitor your heart rhythm.
Like on your wrist.
Exactly, like a little EKG on your wrist.
Okay.
And it could pick up on subtle changes
Good
that you
info.
might not even notice.
Wow.
So it could alert you
Okay,
to potential problems
early on.
early on before they become serious.
That's amazing.
It's amazing, right? It could revolutionize how we manage heart conditions.
So we could, like, prevent problems before they even happen.
Exactly.
That's incredible. Okay, well, I think we've reached the end of our EKG deep dive.
I think so, yeah.
And I have to say, I feel a lot more comfortable with those
Goodness.
little squiggles.
I'm glad to hear that.
I know. We've gone from being, like, intimidated by them
Right.
to actually understanding what they're trying to tell us.
You've become fluent in EKG.
I know. And realizing how important they are
They are.
for, our heart health.
Absolutely. They're a window into the heart.
They are. So we covered a lot today. The basics, those red flags.
The mimics.
Oh, the mimics. And even, like, the future of EKG technology.
It's a fascinating field.
It is. A huge thank you to our expert
Oh, thank you for having me.
for sharing all of this knowledge.
Yeah, pleasure.
You've really helped us decode those EKG mysteries.
I'm glad I could help.
But remember, everyone,
Yes.
if you have any concerns about your heart, talk to your doctor.
Absolutely. They're your best resource.
They are. Okay, well, that's it for our EKG deep dive. Until next time.
Until next time.
Keep those heartbeats strong
Strong and steady.
and steady. Hey, everyone. Ready for a deep dive into something a little intense?
Intense is right.
Yeah, we're going to be talking all about bleeding and shock today.
That's right.
We've got some pretty heavy medical textbook chapters to get through.
But don't break it down.
Yeah, we're going to make it as interesting as possible.
I think people are really going to be surprised by some of this stuff.
I think so, too.
Yeah.
Like, I had no idea that losing just 1 liter of blood can, like, already start to cause some serious problems.
Yeah, that's right.
And that kids are even more vulnerable to blood loss just because they have less blood to begin with.
That's exactly right. And that's exactly why we're here.
To help everyone understand.
Yeah, to help everyone understand just how important this is.
Yeah.
Because, knowing how your cardiovascular system reacts to bleeding could honestly save a life.
Yeah, seriously.
And maybe even your own.
So, okay, let's not get ahead of ourselves.
Okay.
Let's start with the basics.
That's it.
How does this whole cardiovascular system actually work?
So think of it like a complex delivery system. Okay.
Your heart is this powerful engine pumping blood through a network of, like, highways?
Okay.
Your blood vessels?
Makes sense.
And the blood itself is like the delivery truck carrying oxygen and nutrients to every single cell in your body.
Okay, that's a good analogy. I like that.
Yeah.
So what happens when this system, like, springs a leak?
Well, the amazing thing is your body is, like, totally prepared for that.
What? Really?
Yeah. It has all these, like, built-in mechanisms to try and compensate for blood loss.
Wow.
So your heart will start pumping faster.
Okay.
Your blood vessels constrict to maintain pressure,
Okay.
and your body even releases hormones that help retain fluid.
It's like a whole emergency response team.
Exactly.
Just kicks into gear.
That's a great way to put it.
Immediately.
But here's where it gets tricky.
Okay.
These mechanisms, while, like, heroic in the short term,
Okay.
can actually backfire.
If the bleeding isn't controlled.
Exactly. It's like pushing that engine too hard for too long.
Oh,
Eventually, it's going to give out.
that makes sense. Yeah. And that's where the trauma triad of death comes in.
Yeah, that sounds pretty ominous. So what exactly is that?
So it's a combination of 3 deadly factors. Hypothermia sets in because the constricted blood vessels aren't delivering enough warmth.
Okay.
Then there's coagulopathy, which is where your blood struggles to clot properly.
Okay.
And finally, the buildup of waste products leads to acidosis,
Acidosis.
which throws your whole body's chemistry off balance.
Wow. Okay, so it's really a race against time then,
Yeah.
which is why knowing how to spot bleeding is so important.
Exactly. But our sources mention that it's not always easy, right? Like, blood loss can be tough to assess,
Yeah.
depending on where it's happening.
Oh, absolutely. So with external bleeding, what you see is what you get.
Right.
But internal bleeding is a whole other story.
Yeah, because you can't see it.
Yeah, it's like a hidden leak.
Right.
And the signs could be much more subtle.
So what should we be looking for?
So think about it this way. If blood is leaking internally, it has to go somewhere right. Yeah, that's true.
So you might see things like vomit that looks like coffee grounds, or very dark tarry stools.
Oh.
That's digested blood making its way
Oh,
out.
I see.
Or bright red blood in the stool, which would mean that the bleeding is lower down in the digestive tract.
Okay, that's definitely something you wouldn't want to ignore.
No, definitely not.
But let's go back to external bleeding for a second.
Yeah.
Like, how much blood loss is too much?
Well, the source material mentions that even losing just 1 liter of blood can cause some serious changes in your vital signs.
1 liter?
Yeah, that's about 2 standard soda bottles.
Wow.
Might not seem like a lot.
No.
But remember, your body relies on that blood volume to function properly.
Right, and you mentioned earlier that infants and children are especially vulnerable to blood loss.
Yes.
So why is that?
Well, think about it this way. If adults are like big trucks,
Okay.
kids are like little scooters.
Okay.
They just don't have the same carrying capacity.
Makes sense.
They have less blood volume to begin with. So even a seemingly small amount of blood loss
Can be a big deal.
can be proportionally much greater for them.
Wow, that puts things into perspective.
Right.
So what should we be watching for in children specifically?
It's all about being extra vigilant with kids.
Okay.
Any bleeding that doesn't stop quickly,
Okay.
or any signs of lethargy, confusion, or rapid breathing should be taken seriously.
Got it.
Don't hesitate to seek medical attention if you're at all worried.
Okay, good advice. So we've talked about bleeding both internal and external.
Right.
Now let's tackle the big one. Shock.
Okay.
What exactly is happening in the body when someone goes into shock?
Think of shock as like a state of collapse.
All right.
It's your cardiovascular system kind of waving the white flag saying it can't keep up anymore.
Oh, wow.
And this can actually happen for a number of reasons.
Like what? What kind of reasons?
So the most common one is called hypovolemic shock.
Okay.
And that's caused by blood or fluid loss.
Okay.
But there's also cardiogenic shock, where the heart itself is failing to pump effectively.
I see.
Then you have neurogenic shock, often caused by spinal cord injuries,
Okay.
where the body loses its ability to regulate blood vessel constriction.
Wow.
And finally, there's distributive shock, which includes things like anaphylactic shock from severe allergic reactions.
Okay, so a lot of different roads can lead to the same destination.
Exactly. And regardless of the cause, the ultimate consequence is the same: inadequate tissue perfusion.
Okay, and remind me what that means again.
That means your cells aren't getting the oxygen and nutrients they need,
Okay.
and waste products start to build up.
Oh.
It's like a city losing power and sanitation.
Oh, wow.
Things fall apart pretty quickly.
Yeah, I can see that.
Yeah,
So it's not just about blood loss, it's about the entire system kind of breaking down.
exactly. And this breakdown often happens in stages.
Okay.
The first stage, compensated shock, is like your body trying to put out a small fire.
Okay.
You might see things like restlessness, anxiety, or a rapid heart rate. These are early warning signs that something is wrong.
So those early signs are actually really important.
Oh, they're super important.
Like someone being unusually anxious or restless after an injury.
Exactly. They're your body's way of saying, hey, we need help here.
Wow.
But if the underlying problem isn't addressed, things can progress to decompensated shock.
Okay.
That's when the fire starts to spread.
Oh,
And you see things like a drop in blood pressure, confusion, and labored breathing.
Okay.
And then the final stage, irreversible shock, is when the fire is completely out of control.
Oh, gosh.
Unfortunately, at that point, organ damage is widespread,
Oh, wow.
and the chances of survival are very low.
So it's all about catching it early and acting quickly.
You got it.
Okay, so what are the first things someone should do if they suspect someone is in shock?
Okay, so first and foremost, call 911
Okay.
or your local emergency number.
Okay.
Then make sure the person's airway is open and they're breathing.
Okay.
If there's any external bleeding, control it with direct pressure.
Direct pressure.
Absolutely. And
Wow.
keep them lying flat to help improve blood flow to the vital organs.
Okay, so call for help, open the airway control bleeding, and lie them flat.
You got it.
Got it. What about IV fluids? Wouldn't that help to, like, restore blood volume?
So IV fluids are definitely part of the treatment for shock, but it's not as simple as just pumping fluids in.
Okay.
In fact, aggressive fluid resuscitation, especially in cases of hemorrhagic shock,
Okay.
can actually do more harm than good.
Really? I'm surprised to hear that.
Yeah, it can.
Why is that?
So think about what's happening in hemorrhagic shock.
Okay.
Your body is losing blood, and its ability to clot is compromised.
Okay.
If you flood the system with fluids, you can actually dilute the clotting factors,
Oh.
making the bleeding worse.
So it's like trying to put out a fire with gasoline.
That's a really good analogy.
Yeah.
It's a delicate balance.
I see.
The goal is to maintain adequate perfusion without making the bleeding worse.
Right.
That's why the concept of permissive hypotension has emerged.
Permissive hypotension.
Okay.
I've never heard of that.
Have you not?
No, tell me about it.
So it's a strategy where instead of trying to restore blood pressure to like normal levels immediately,
Okay.
doctors allow it to remain slightly lower
Okay.
for a period of time.
But wouldn't that deprive the organs of oxygen?
It's a calculated risk, but studies have shown that in certain cases, this approach can actually improve outcomes
Oh, wow.
because it gives the body time to form clots and reduces the risk of dislodging existing clots.
Okay.
Of course, permissive hypotension isn't appropriate for every patient,
Right.
and it requires careful monitoring by medical professionals.
So it's a more nuanced approach than just more fluids is always better.
Exactly. It's about understanding the complexities of the body's response to shock
Yeah.
and tailoring the treatment to the specific situation.
That makes sense. Okay. Now, I know we've talked about IV fluids in general.
Yeah.
But are there specific types of fluids that are used in shock?
That's a great question.
Thanks.
Solutions like dextrose and water, which are primarily used to provide energy and treat low blood sugar, aren't really effective in shock.
Okay, so what do they use instead?
So the go-to fluids for shock are crystalloids,
Crystalloids.
like normal saline or lactated ringer solution.
Okay.
They contain electrolytes, and help restore fluid balance.
Okay.
In some cases, doctors might also use colloids,
Okay.
which are solutions containing larger molecules that help draw fluid into the bloodstream.
So it's not just about giving fluids, it's about giving the right fluids.
Absolutely. It's all about understanding the nuances of fluid therapy.
Wow. This is all starting to make sense, but I feel like we've only just scratched the surface.
We have.
There's so much more to unpack here.
There is.
Okay, so where do we go from here?
Well, now let's dive deeper into the specific types of shock,
Okay.
starting with the most common one, hypovolemic shock.
All right, I'm ready for the next level.
Let's do it.
Let's do it.
All right.
Okay, so to recap, hypovolemic shock is basically when there's not enough blood circulating in the body.
You got it.
Okay.
Yeah. It's all about a reduction in that circulating blood volume, that vital fluid that keeps our bodies running.
Right, and that can happen for a bunch of reasons, right? Not just bleeding.
That is correct.
Okay, give me some examples.
So while hemorrhage or bleeding is the most common cause,
Okay.
you can also develop hypovolemic shock from severe dehydration,
Okay.
extensive burns, or even severe vomiting and diarrhea.
Wow, so even if you're not visibly losing blood, your body can still react as if you are.
Absolutely. It's all about fluid volume.
Right.
The body needs a certain amount to function.
Okay.
And if that volume drops too low, the heart can't do its job and the organs start to suffer.
That makes sense. Okay, let's start with hemorrhage since that's the most common culprit.
Yep.
What kind of situations are we talking about here?
Well, the usual suspects are traumatic injuries,
Okay.
car accidents, falls, gunshot wounds, stabbings, anything that can damage blood vessels.
Yeah.
But here's the thing.
What's that?
Even a seemingly minor injury can lead to significant blood loss if it involves a major artery.
Okay, that's scary.
Yeah.
Our source material mentioned that injuries to certain organs are particularly dangerous in terms of blood loss.
Yes.
What makes them so different?
So think of it like this. Some organs are like bustling city centers
Oh.
with tons of blood flow.
Yeah.
The heart, liver, spleen, and major blood vessels are all highly vascular.
Okay.
Damage to any of these can result in massive hemorrhage.
I see.
Yeah.
And what about blunt trauma where there's no visible bleeding?
That's where it gets tricky.
Okay.
Think about like a hard impact to the abdomen.
Okay.
You might not see blood,
Right.
but the force can rupture organs like the spleen or liver,
Oh.
leading to internal bleeding. That's really hard to detect.
So it's not just about what you see on the outside, it's about the mechanism of the injury.
Exactly.
Yeah.
You have to consider the bigger picture
Right.
and look for those subtle signs that we talked about earlier.
Right. Okay. Let's move on to dehydration. How can someone get so dehydrated that they develop hypovolemic shock?
So dehydration is all about losing body fluids.
Okay.
And it can happen in a surprising number of ways.
Really?
Yeah, the most obvious is not drinking enough,
Okay.
especially in hot weather or during exercise.
Okay.
But you can also get severely dehydrated from illnesses that cause fluid loss,
Oh.
like severe vomiting or diarrhea.
I see.
Your body is essentially being drained of fluids faster than you can replace them.
Okay. And what about burns? How do they fit into the picture?
So think of your skin as a protective barrier holding all those precious fluids in.
Okay.
When you have a severe burn, that barrier is damaged,
Right.
and fluids can leak out at an alarming rate.
Wow.
The larger the burn, the more fluid you lose.
So even though you're not losing blood, you're still losing vital fluids,
Exactly.
which leads to the same problem, hypovolemic shock.
Precisely. And the consequences are the same, too.
Right.
Inadequate tissue perfusion
Right.
and the potential for organ damage.
Okay, so how do we know if someone is developing hypovolemic shock?
Okay, so remember those amazing compensatory mechanisms we discussed?
Yeah.
They come into play here, too.
So the body is basically trying to put out the fire, even if it doesn't know what caused it.
Exactly.
Okay.
In the early stages, your body is fighting to maintain blood pressure and perfusion.
Yeah.
One of the first signs you'll notice is a rapid heart rate.
Okay.
Think of it as your heart trying to make up for the lost volume by pumping faster.
Okay.
And breathing becomes faster and shallower as your body tries to get more oxygen into the bloodstream.
It's like trying to take short, quick breaths while running a marathon.
You got it.
And those subtle signs we talked about, like anxiety and restlessness,
Yeah,
are those present in hypovolemic shock as well?
absolutely.
Okay.
The brain is very sensitive to changes in blood flow. So if it's not getting enough oxygen, it'll start sending out distress signals.
So if someone's injured or ill and they suddenly become anxious or restless,
Yeah.
that could be a red flag.
It's definitely a warning sign that shouldn't be ignored.
Wow. Okay, so as hypovolemic shock progresses, we see more obvious signs.
Yeah.
Like what kind of signs?
The skin will become cool and clammy.
Okay.
almost like you're touching a cold, wet cloth.
Okay.
Their lips and nail beds might turn bluish, indicating a lack of oxygen.
Okay, what about blood pressure? Is that a reliable indicator of hypovolemic shock?
Here's the thing.
Okay.
Falling blood pressure is a late sign of hypovolemic shock.
Oh.
By the time you see it, the body's already in serious trouble.
Oh, wow.
So it's not about waiting for the blood pressure to drop.
Hmm.
It's about recognizing those earlier signs, like the rapid heart rate and the changes in mental status.
So those are like the early warning system.
Exactly.
Okay, this is incredibly helpful. So let's say we recognize those signs.
Okay.
What can be done to treat hypovolemic shock?
It all comes down to two main goals.
Okay.
Addressing the underlying cause
Right.
and restoring adequate perfusion.
Okay.
If the cause is hemorrhage, right, the priority is to control the bleeding.
Okay.
Whether that's applying direct pressure surgery or other interventions.
I see.
And then we talked about fluid replacement earlier.
Nice.
So normal saline or lactated ringer solution are the fluids of choice.
What are they?
They help to replace those lost fluids and get the blood volume back up.
Okay.
In severe cases, blood transfusions might also be necessary.
Okay.
But remember, it's not just about pumping fluids in.
Right, we talked about that.
Exactly. It's about finding that balance between restoring volume and not overwhelming the system.
Okay, so control the bleeding, replace lost fluids carefully, and what else?
And keep the person warm.
Oh, right.
Remember the trauma triad of death?
Yeah,
Hypothermia is a major concern in shock.
right.
So blankets, warm environments, anything to help maintain body temperature is essential.
Okay, got it. So we've got control the bleeding, replace lost fluids, and keep them warm.
You got it.
3 key takeaways for treating hypovolemic shock.
You've summarized it perfectly.
Okay, I'm ready to tackle another type of shock.
All right. What's next on the agenda?
Let's delve into cardiogenic shock.
Excellent. Get ready to learn about the heart's incredible resilience and the challenges it faces when things go wrong.
I'm ready.
All right.
So to recap, cardiogenic shock is basically when the heart itself can't pump effectively.
Exactly.
Okay.
Imagine your heart is like the engine of your body.
Okay.
In cardiogenic shock, that engine is sputtering and struggling to keep things moving.
Oh, no.
Yeah, and this can happen for a bunch of reasons, right? We talked about heart attacks earlier.
Right.
But what else?
Yeah, what else can cause it?
So heart attacks or myocardial infarctions
Right.
are the most common culprits.
Okay.
A blockage in a coronary artery cuts off blood supply to the heart muscle,
Right.
damaging it and weakening its pumping ability.
So it's like a domino effect.
Exactly.
A heart attack weakens the heart, and then the weakened heart can't pump enough blood,
Correct.
leading to shock.
A vicious cycle that needs to be broken quickly.
Oh, gosh. Okay. But there are other causes too, right?
Yeah, there are.
Like what?
So certain heart conditions like valve problems can put extra strain on the heart.
I see.
What about arrhythmias?
Arrhythmias.
Yeah, those irregular heart rhythms we hear about.
Oh, yeah. Okay.
Those can disrupt the heart's pumping action too.
How so?
So some arrhythmias cause the heart to beat too fast or too slow,
Okay.
while others mess up the coordination of the heart chambers,
Okay.
making it inefficient at pumping blood.
Okay, so it's not just about a weak heart muscle. It's also about the rhythm and coordination being disrupted.
You got it. Now, believe it or not, even medications can sometimes play a role in cardiogenic shock.
Really? Which ones?
Some medications used to treat high blood pressure,
Okay.
like beta blockers,
Okay.
can sometimes suppress heart function too much,
Oh, no.
especially in people with already weakened hearts.
Wow.
It's a delicate balancing act.
So treating one problem can inadvertently contribute to another.
Exactly.
It's tricky.
It is. That's why it's so important to have regular checkups.
Right.
And be open with your doctor about any medications you're taking.
Good advice. Okay, so let's talk about how to spot cardiogenic shock.
Okay.
What are the signs?
Well, low blood pressure is a big one.
Okay.
The heart isn't pumping with enough force,
Okay.
so the pressure in the system drops.
But we know from our discussion of hypovolemic shock that low blood pressure is a late sign.
That's right.
So what else should we be looking for?
You're catching on quick.
Thanks.
So rapid heart rate is another common sign.
Okay.
The heart is trying to compensate for its weakened pumping ability by beating faster.
Okay.
Think of it like revving the engine to try and get more power.
So a rapid pulse could be a clue that something's wrong with the heart itself.
It's definitely a possibility, especially if it's accompanied by other symptoms.
Okay.
And just like with hypovolemic shock, rapid breathing is common as the body tries to get more oxygen.
Makes sense. What about shortness of breath?
That's another one to watch for,
Okay.
especially if it's worse when lying down. The weakened heart struggles to pump blood out of the lungs efficiently.
I see.
So fluid can build up,
Okay.
making it hard to breathe.
So it's not just the heart that's affected, it's the lungs too.
Exactly. Cardiogenic shock can have a ripple effect throughout the body.
Wow, okay. And like with the other types of shock, you might also see changes in mental status.
Absolutely.
Okay.
Like confusion, disorientation, or agitation.
Okay, so it's the brain saying, hey, I'm not getting enough oxygen here.
Exactly.
Okay, so we've got low blood pressure, rapid heart rate, rapid breathing, shortness of breath, and altered mental status.
Right.
Are there any other signs that are specific to cardiogenic shock?
There are a couple of key signs
Okay.
that can really help distinguish it.
Okay.
One is the presence of crackles in the lungs.
Crackles?
Yeah, have you ever heard of that?
No. What are those?
They're abnormal lung sounds
So-
that doctors can hear with a stethoscope.
Yeah.
Sounds like crackling or bubbling.
Okay.
And it indicates fluid buildup in the lungs.
Right, because the weakened heart can't pump blood out of the lungs efficiently.
Exactly.
So there's like a traffic jam in the lungs.
Perfect analogy.
Okay, I like that.
And this fluid buildup makes it even harder to breathe.
Right, okay. So crackles in the lungs is one telltale sign.
Okay.
And the other one is
Jugular vein distension.
jugular vein distension, or JVD.
Exactly.
Okay, break it down for me.
So think of it this way. The jugular veins in your neck are like pipelines carrying blood back to the heart.
Oh, yeah.
In cardiogenic shock, the right side of the heart can become overloaded
Okay,
because the left side isn't pumping effectively.
I see.
This causes blood to back up in the jugular veins, making them appear swollen.
So it's like a backup in the plumbing system.
Exactly. And this backup can extend all the way back to those jugular veins,
I see.
making them visibly distended.
Okay, so we've got crackles in the lungs and jugular vein distension as two telltale signs of cardiogenic shock.
You got it.
This is starting to feel like detective work.
It is.
Yeah.
Each sign and symptom is a clue.
Right. And it's all about putting them together to solve the puzzle.
Love that analogy. Okay, so we've got a handle on the signs and symptoms.
Okay.
Now, how do we treat cardiogenic shock?
Okay, so treating cardiogenic shock requires a multi-pronged approach,
Okay.
addressing the underlying heart problem,
Oh.
improving heart function, and supporting the body's vital organs.
Sounds intense.
It can be.
Where do we even begin?
Just like with any type of shock, the first priority is making sure the person's airway is open
Okay.
and they're breathing properly.
Makes sense.
Supplemental oxygen is usually provided to help boost those oxygen levels in the blood.
Okay, so oxygen therapy, and then I'm guessing medications also play a big role.
Absolutely. Medications are the workhorses of cardiogenic shock treatment.
Okay.
The specific ones used depend on the underlying cause and how severe the condition is.
Okay.
But there are a few common types.
Like what? What kind of medications?
So one type is called inotropic agents.
Inotropic agents. Yeah, they help to increase the force of the heart's contractions,
Okay.
making it pump more effectively. Think of them as giving the heart a little extra muscle.
So like a booster shot for the heart.
Exactly.
Okay.
They give it that extra oomph to pump blood more efficiently.
Makes sense.
Another type is vasopressors,
Okay.
which constrict blood vessels, raising blood pressure and improving blood flow to the vital organs.
So it's like tightening the hose to increase the pressure.
You got it.
I like these analogies.
And depending on the underlying cause, doctors might also use medications to break up blood clots
Okay.
or adjust dosages of other medications that might be contributing to the shock, like those beta blockers we talked about earlier.
So it's about finding the right balance of medications to support the heart without suppressing it too much.
Exactly. It's a delicate dance, and it requires careful monitoring and adjustments.
Okay, so we've got oxygen therapy and medications.
Right.
What else is in the cardiogenic shock toolkit?
There are a few other interventions that might come into play.
Okay, like what?
One is mechanical ventilation.
Mechanical ventilation.
Yeah.
Okay, I remember that from our deep dive on respiratory distress.
You do.
Yeah, that's when a machine helps the person breathe right.
That's right. In cardiogenic shock, the lungs can get overloaded with fluid,
Right.
making it difficult to breathe on their own.
Okay.
Mechanical ventilation helps to support breathing and improve oxygenation.
So it's not just about the heart, it's about giving the lungs a break too.
Exactly. Remember, cardiogenic shock affects multiple organ systems.
Right. Okay.
Another intervention you might hear about is an intra-aortic balloon pump, or IABP.
Okay, an IABP? That one sounds intense.
Hmm.
What in the world is an IABP?
So it's a device that's inserted into the aorta, the main artery leaving the heart.
Okay.
The IABP inflates and deflates in sync with the heartbeat,
Okay.
helping to improve blood flow to the coronary arteries and reduce the workload on the heart.
So it's like a little helper for the heart.
You could say that.
Okay.
It's a temporary measure to support the heart while it recovers.
Wow, this is all fascinating, but it sounds really complex.
It definitely is.
Ah.
Cardiogenic shock is a serious condition that requires specialized care.
Right.
But even having a basic understanding can be helpful, especially if you or a loved one is dealing with it.
Yeah, I agree. Okay, so let's recap.
Okay.
Treating cardiogenic shock involves supporting breathing,
Right.
administering medications to improve heart function and raise blood pressure,
Yes.
and possibly using mechanical ventilation or an IABP.
You got it.
And of course, treating the underlying cause like a heart attack is essential.
You're really getting the hang of this.
I'm starting to feel like a shock expert.
Well, don't jump ship to medical school just yet.
Okay.
But it is empowering to understand these conditions, isn't it?
It really is.
Yeah.
Okay, I'm ready for the next challenge.
Okay, you are.
Yeah. What other types of shock should we explore?
Let's talk about neurogenic shock.
Neurogenic shock.
This one really shows the connection between your nervous system and your cardiovascular system.
Yeah.
It's usually caused by spinal cord injuries, and it can be tricky to recognize.
Okay, I'm intrigued. Let's dive into neurogenic shock.
All right, get ready for a fascinating journey into the world of nerves and blood vessels.
I'm ready. So remind me again, what exactly is neurogenic shock?
It's all about a disruption in the nervous system's control over blood vessel constriction.
Okay, back up a second. How does our nervous system control our blood vessels?
Okay, so think of your nervous system as a vast communication network,
Okay.
sending signals throughout your body.
Uh-huh.
It can send signals to the muscles in your blood vessel walls, telling them to constrict or relax.
So that's how our bodies adapt to changes in position or activity level?
Yeah, or even temperature.
Whoa.
Exactly. It's a constant balancing act.
Right.
And the nervous system is the conductor.
I like that.
But in neurogenic shock, the conductor gets knocked out of commission,
Oh.
disrupting the whole orchestra.
And the most common reason for this is a spinal cord injury.
You got it. When the spinal cord is injured, those signals from the brain to the blood vessels
Okay.
can get interrupted or scrambled.
Oh, no.
Yeah, and this can lead to widespread vasodilation.
Vasodilation.
Basically, the blood vessels relax and widen too much.
And why is that a problem?
Think of it like expanding a water balloon without adding more water.
Okay.
The pressure inside drops, right?
Right.
The same thing happens in your circulatory system.
Right.
The blood vessels get too big for the amount of blood they contain, and the blood pressure drops.
So even though the person isn't actually losing blood, it's like their body is reacting as if they are because of this vasodilation.
You're absolutely right. It's called relative hypovolemia.
Relative hypovolemia.
Yeah.
Okay, so what makes neurogenic shock tricky to recognize?
So what makes it tricky is that it doesn't always present like the other types of shock.
Okay, in what way?
Well, you might not see the typical compensatory mechanisms,
Okay.
like a rapid heart rate and cool, clammy skin.
Okay.
In fact, the heart rate might actually be slower than normal,
Oh.
and the skin might be warm and dry.
That seems kind of counterintuitive.
It is.
Why wouldn't the body try to compensate by increasing the heart rate and constricting blood vessels?
It's because the problem isn't with the heart or blood volume directly.
Yeah.
It's with the nervous system's ability to regulate those things.
I see.
The signals just aren't getting through.
Wow.
So the body is stuck in a state of vasodilation.
Yeah.
And those classic compensatory mechanisms don't kick in as you'd expect.
So it's almost like the body's emergency response team is out of touch.
That's a great way to put it.
Yeah.
And this can make neurogenic shock harder to recognize, especially in the early stages.
Okay, so besides the slow heart rate and warm, dry skin,
Yeah.
what other signs and symptoms should we be looking for?
So low blood pressure is still a hallmark sign,
Okay.
along with dizziness, lightheadedness, and weakness.
Okay, and what about mental status? Is that affected in neurogenic shock?
Absolutely.
Right.
You might see anything from mild confusion to a complete loss of consciousness. Remember, the brain needs a constant supply of oxygen-rich blood.
Right.
And when that supply is compromised, things start to go haywire.
So even though the heart rate might be slow, the other signs and symptoms still indicate that something is seriously wrong.
Exactly. It's
Huh.
crucial not to be fooled by that slow heart rate.
Right. It's not a sign that everything's okay.
Not at all.
Okay, so we've got a handle on the signs and symptoms. Now, how do we treat neurogenic shock?
Okay.
Is it similar to the other types of shock?
There are some similarities, but there are also some important differences.
Okay, tell me more.
So the first priority, if there's a spinal cord injury,
Okay.
is to stabilize the spine
Okay.
to prevent further damage.
So we're talking about like immobilizing the person with a backboard and a neck collar.
Exactly.
Okay.
You want to keep that spine as still as possible to minimize the risk of further injury.
Got it.
Next, you focus on supporting breathing and circulation.
Okay.
Supplemental oxygen is typically provided, and if the blood pressure is dangerously low, IV fluids might be given.
Okay, to help boost the blood volume.
Exactly.
But we talked earlier about how aggressive fluid resuscitation can be harmful in some cases.
Right.
Does that apply to neurogenic shock too?
It's a bit more nuanced here.
Okay.
While excessive fluids aren't ideal,
Okay.
they can be helpful in the short term to support blood pressure.
Yep.
The key is to use fluids judiciously
Okay.
and monitor the person's response carefully.
So stabilizing the spine, supporting breathing and circulation.
Right.
What about treating the spinal cord injury itself?
So treating spinal cord injuries is a whole other deep dive.
Yeah, bet.
But it often involves a combination of surgery medications and rehabilitation.
Okay.
Surgery might be needed to relieve pressure on the spinal cord,
Okay.
or to stabilize the spine. Medications can help to reduce inflammation and swelling.
Okay. And what about rehabilitation?
Rehabilitation plays a crucial role in helping people regain function and adapt to life after a spinal cord injury. This can involve physical therapy, occupational therapy, and other therapies tailored to their individual needs.
So it's a long road to recovery.
It can be. Spinal cord injuries are complex,
Right.
but with the right care and support,
Yeah.
many people can make significant progress.
That's good to hear. Okay, so that's neurogenic shock in a nutshell.
Yes,
I'm starting to see how all these different types of shock are interconnected,
they are.
but yet each has its own unique challenges.
Exactly.
Okay, are we ready to tackle another type of shock?
You bet. Let's move on to anaphylactic shock.
Anaphylactic shock.
Yeah, the severe allergic reaction that can quickly become life-threatening.
Okay, I'm all ears. Bring on the anaphylaxis.
All right, anaphylactic shock is essentially your body's immune system going into overdrive.
Okay.
It's like a security system that mistakes a harmless visitor for a dangerous intruder
Oh.
and sets off all the alarms.
And we've talked about how the body reacts to stress.
Right.
But this is like a whole other level of reaction.
Absolutely. It's an extreme response to an allergen.
Right.
Something that normally wouldn't cause a problem,
Okay.
but in anaphylactic shock,
Yeah.
it triggers a cascade of events that can be life-threatening.
So what kind of things can trigger this extreme reaction?
Lots of things.
Give me some examples.
Foods, medications, insect stings,
Okay.
even latex.
Wow. Okay.
But some of the most common culprits are peanuts, tree nuts, shellfish, milk eggs, soy, and wheat.
For food allergy.
Exactly.
Okay. And what about medications? What kind of medications can cause this?
Penicillin and other antibiotics,
Okay.
aspirin, and NSAIDs.
Okay.
And certain chemotherapy drugs are all known to trigger anaphylactic shock in some people.
Okay. And for insect sins, we're talking about bees, wasps, hornets, that kind of thing.
Exactly.
Okay. So it's important to know your own allergies
Yeah,
and avoid contact with those triggers.
absolutely.
But even if you're careful, accidents happen.
Right.
So it's crucial to recognize the signs of anaphylaxis early
Yes.
and know how to respond. Okay, so let's talk about those signs. What should we be looking for?
So anaphylaxis tends to come on quickly
Okay.
within minutes or hours of
Yeah.
exposure to the allergen.
Right.
And the symptoms can vary,
Right.
but some common ones include skin reactions, like hives and itching.
So it's not just a little rash, it's more like a full-body allergic eruption.
That's a good way to put it. You might also see swelling of the face, lips, and tongue,
Okay.
which can be really scary.
Yeah.
You'll likely hear wheezing or see the person struggling to breathe.
Right, because those airways are constricting.
Exactly.
And of course, there's a drop in blood pressure, just like with the other types of shock.
That's right. That's a hallmark of shock, regardless of the cause.
Okay, this all sounds pretty serious. What should someone do if they suspect anaphylactic shock?
First and foremost, call 911.
Okay.
This is a true medical emergency,
Yeah.
and every second counts.
And while you're waiting for help to arrive.
If the person has an epinephrine auto-injector like an EpiPen, use it immediately.
Okay, I remember we touched on epinephrine earlier.
Yeah.
It's that fight or flight hormone.
Yeah.
But how does it help in anaphylaxis?
Epinephrine is a powerful medication that counteracts the effects of anaphylaxis.
Okay.
It constricts blood vessels to raise blood pressure,
Okay.
opens up the airways to improve breathing,
Okay.
and basically tells the immune system to chill out.
So it's like hitting the reset button on the allergic reaction?
Exactly. It can buy precious time while you wait for emergency responders.
That's awesome. Okay.
Yeah.
Call 911, administer epinephrine if available.
Yes.
What else can you do?
Help the person lie down and elevate their legs if possible.
Okay.
This can help improve blood flow to the vital organs.
Okay.
Also loosen any tight clothing and try to keep them calm and reassured.
Okay. Those all seem like simple but important steps.
They are.
So to recap,
Okay.
call 911,
Right.
use an EpiPen if you have one,
Yes.
and provide basic first aid while waiting for help to arrive.
You've got it. And remember, even if the person seems to recover after using an EpiPen, it's still crucial to seek medical attention.
Oh, really? Why is that? I would think that the EpiPen would take care of the problem.
So anaphylaxis can be sneaky.
Okay.
Sometimes symptoms return hours after the initial reaction.
Wow.
It's called a biphasic reaction.
Okay.
And it's important to be monitored by medical professionals to ensure the reaction is truly resolved.
So it's like the fire seems to be out, but there are still embers smoldering beneath the surface.
That's a great analogy. Now we've covered 3 major types of shock: hypovolemic, cardiogenic, and anaphylactic shock.
Right.
Are you ready for the grand finale?
Bring it on. What other shock secrets are you going to reveal?
Let's dive into septic shock.
Septic shock.
Yeah, the one that occurs when the body's response to an infection goes haywire.
Septic shock. That's one I've definitely heard of, but I don't really understand what makes it different from just a regular infection.
It's more than just a bad infection. It's a life-threatening condition where the body's own immune system turns against it.
So it's like the body's defense system goes rogue.
Exactly. Think of it as a wildfire spreading throughout the body,
Okay.
causing damage wherever it goes.
That sounds terrifying.
It can be.
So how does this happen? What causes septic shock?
It all starts with an infection,
Okay.
but not just a minor one.
Okay.
It's usually a severe infection that gets into the bloodstream,
Okay.
like a bacterial, fungal, or even viral infection gone wild.
So does that mean any infection has the potential to turn into septic shock?
Not necessarily.
Okay.
While any infection can potentially lead to sepsis,
Okay.
the risk is higher with certain types.
Okay. Like what?
Pneumonia,
Okay.
urinary tract infections,
Okay.
and skin infections are some of the usual suspects.
Okay. And what about people with weakened immune systems?
Yes,
Are they more vulnerable?
absolutely.
Yeah.
Their immune systems are already struggling. So they're more susceptible to developing septic shock if an infection takes hold.
Okay, so let's break this down. The infection triggers this massive inflammatory response
Yes.
that damages the body's own tissues and organs.
Right.
But how does that actually happen?
Okay, so when your body senses an infection,
Okay.
it releases chemicals to fight it off.
Okay.
These chemicals called cytokines trigger inflammation,
Okay.
which is usually a good thing.
Right.
It's part of the healing process.
Right.
But in septic shock, the inflammation goes overboard.
Oh.
Like a fire hose that's lost control.
So instead of helping, the inflammation actually starts to harm the body.
Exactly.
Right.
The excessive inflammation damages the lining of your blood vessels,
Okay.
making them leaky.
Oh.
Fluid leaks out of the bloodstream into the surrounding tissues,
Oh, yeah.
and boom, you've got a drop in blood pressure.
So we're back to that concept of relative hypovolemia,
That's right.
even though there's no actual blood loss.
Exactly. The blood vessels are too wide and leaky, so the effective blood volume decreases,
Okay.
and it doesn't stop there.
Oh, no. What else happens?
This uncontrolled inflammation can also disrupt blood clotting.
Oh, no. Not another domino effect.
I know it's bad. What happens when blood clotting goes haywire?
You can develop something called disseminated intravascular coagulation, or DIC for short.
DIC. Okay, that doesn't sound good at all. What exactly is going on there?
It's basically your clotting system going into overdrive.
Okay.
Tiny blood clots form throughout your bloodstream,
No.
blocking blood flow to vital organs and causing damage.
So it's like the body's clotting system is attacking itself.
It's a bit like that, a paradoxical situation where the body is both clotting too much and bleeding too much at the same time.
Wow. Okay, we've got leaky blood vessels,
Right.
low blood pressure, DIC. Anything else we need to add to this septic shock horror story?
Unfortunately, yes.
Oh, gosh. Okay, what else?
The inflammation can damage organs directly,
Oh.
leading to multiple organ dysfunction syndrome, or MODS. MODs. Okay, I'm starting to see a pattern here, all these scary acronyms. What's MODS all about?
It's a serious condition where multiple organs start to fail.
Okay.
This happens when the organs are deprived of oxygen and nutrients
Right.
due to the low blood pressure and the poor blood flow.
Okay.
And the inflammation itself can also directly damage those organs.
Wow, septic shock sounds incredibly dangerous.
It is. It's one of the leading causes of death in intensive care units worldwide.
Okay. I'm getting chills just thinking about it.
I know, it's scary stuff.
Yeah. So
Yeah.
how do you even begin to recognize septic shock? What are the warning signs?
It can be tricky in the early stages
Okay.
because the symptoms can be subtle
Okay.
and mimic other conditions.
Right.
But some common signs include fever,
Okay.
chills or rapid heart rate, rapid breathing,
Okay.
low blood pressure, and altered mental status.
Okay. Those sound a lot like the signs of other types of shock.
They do.
So how do you know it's septic shock?
The biggest clue is the presence of an infection. If someone has a known infection like pneumonia or a UTI,
Okay.
and they start showing signs of shock, septic shock is a major concern.
So if they already have an infection
Yes.
and then they start showing those signs.
Exactly.
Okay. And what about the skin? We talked about how skin temperature and appearance can vary depending on the type of shock.
Right.
What's the pattern with septic shock?
So in the early stages, the skin might be warm and flushed
Okay.
because of the widespread vasodilation.
Okay.
But as it progresses, the skin can become cool and mottled as blood flow decreases.
So the skin can provide clues, but it's not always a reliable indicator on its own.
Exactly.
Okay.
It's all about looking at the big picture, all the signs and symptoms together.
Okay, so we've got a handle on the signs and symptoms.
Okay?
Now, how do you tackle this beast? Is treating septic shock as complex as treating cardiogenic shock?
You bet it is.
Okay.
It's a three-pronged attack.
Okay.
Identifying and treating the infection,
Okay.
supporting the vital organs, and managing the inflammatory response.
Okay, step one, tackling the infection. How do you even know what kind of infection you're dealing with?
So doctors usually start with blood cultures
Okay.
to figure out what bacteria is causing the infection,
Okay.
and they'll often start broad-spectrum antibiotics
Okay.
that cover a wide range of possible culprits.
So it's like throwing a wide net to catch the infectious bad guys.
That's a great way to put it.
Yeah.
And once they get the blood culture results back, they can tailor the antibiotics to specifically target the bacteria causing the infection.
Okay, so antibiotics are crucial.
They are.
What about supporting the vital organs? Is that similar to what we talked about for the other types of shock?
There are definitely some similarities.
Okay.
Oxygen therapy, IV fluids,
Okay.
and medications to support blood pressure and heart function are all part of the game plan.
So we're back to that delicate balancing act of fluid management.
Exactly.
Right.
But in septic shock, managing the inflammatory response is also paramount.
Right. So how do you do that?
Okay.
It's not like you can just tell the inflammation to calm down.
No, you can't, unfortunately.
Right.
But there are medications that can help modulate the immune system
Okay.
and reduce inflammation.
Okay.
Corticosteroids, for example, can help dampen down that excessive inflammatory response.
So it's like putting out the wildfire that's raging through the body.
That's the idea.
Okay.
You want to control the inflammation and prevent further damage.
Okay. So antibiotics, supportive care, and inflammation management.
Right.
Those are the key pillars of septic shock treatment.
You've summed it up perfectly. Septic shock is a serious condition, but with prompt and aggressive treatment, many people can recover.
That's good to hear. Okay, so we've covered 4 major types of shock: hypovolemic,
Yes,
cardiogenic anaphylactic, and septic shock.
we did it.
My head is spinning with all this information.
I know it's a lot to take in,
It is.
but it's all about connecting the dots.
Right.
And you've done an amazing job of following along and asking great questions.
Oh, well, thank you. I feel like I could teach a class on shock.
Well, maybe not just yet,
Okay.
but you've definitely gained a solid understanding of these complex conditions.
I think so, too.
Yeah.
And that's what it's all about, right?
That's what it's all about.
Empowering yourself with knowledge
Mm.
so you can recognize danger and potentially save a life.
Exactly.
This has been an incredible deep dive. I feel like I've learned so much about how my body reacts in emergencies.
And remember, we've just scratched the surface.
Yeah, I
The
mean,
human body is full of surprises.
it is.
But the more we understand about how it works,
Yeah,
the better equipped we are to handle whatever life throws our way.
I agree. So for our listeners out there, what are the key takeaways you want them to remember?
So be aware of the signs and symptoms of bleeding and shock, both internal and external.
Okay.
Don't hesitate to seek medical attention if something seems off, especially with children.
And even if you're not a medical professional,
Mm-hmm.
there are things you can do to help while waiting for help to arrive.
Absolutely. Simple things like controlling external bleeding with direct pressure or
Right.
keeping someone warm can make a world of difference.
Great advice. This deep dive has truly been an eye-opener.
It has.
So for everyone listening out there, thanks for joining us on this deep dive into bleeding and shock.
It's been a pleasure.
We'll be back next time with another fascinating topic to explore. Until then, stay curious, stay informed, and stay safe. Okay, so we've explored all these different ways our bodies can go into shock,
We have.
but we haven't really talked about how our bodies try to fight back.
Yeah, it's true.
Can't all be bad news, right?
Of course not. The human body is incredibly resilient.
Okay, good.
It has all these amazing built-in mechanisms
Okay.
to try and maintain stability
Okay.
and protect those vital organs when shock sets in.
So it's not just giving up.
Oh, no, not at all.
It's trying to do something.
Think of it like a well-coordinated emergency response team springing into action.
Okay, I like that analogy. So,
Yeah.
so what's the first line of defense?
One of the key players is what we call the autonomic nervous system.
Yeah.
Remember, it's the part of our nervous system that we don't consciously control.
Okay, so things like breathing.
Yeah, things like breathing, heart rate, and digestion.
Right. And it has two branches. The sympathetic nervous system, which is all about fight or flight,
Yes,
and the parasympathetic nervous system, which is more about rest and digest.
you got it. And in shock, it's the sympathetic nervous system that takes charge.
Fight or
It's like a superhero
Uh,
swooping in to save the day.
Okay, I'm picturing a superhero at a cape. So what does this superhero actually do?
It releases a surge of adrenaline and noradrenaline,
Adrenaline.
also known as epinephrine and norepinephrine.
Right, okay.
These hormones are like messengers racing through the bloodstream
Okay.
and delivering urgent instructions to different parts of the body.
So it's like sending out a bat signal to call for backup.
Exactly. The message is loud and clear. We're in trouble. Take action.
Okay, I love it. So what happens first? What's the first thing that gets that message?
One of the first targets is the heart.
The heart, okay.
These hormones make the heart beat faster and stronger.
To try and like pump more blood?
Exactly.
Okay.
To compensate for whatever's causing the shock.
Right, to get more blood to the vital organs.
Precisely. It's like trying to keep the water flowing through a leaky hose
Okay.
by increasing the pressure.
And the sympathetic nervous system also targets those leaky blood vessels, right?
It does.
How so?
It causes the blood vessels in the skin muscles and digestive system to constrict,
Okay.
narrowing them to help redirect blood flow to the vital organs,
Oh, okay.
the brain, heart, and lungs.
So it's like prioritizing traffic flow.
Yes.
Making sure the most important vehicles get through the congestion.
You're getting it.
Okay.
The body is basically saying, we can sacrifice blood flow to the less essential areas
Okay.
to make sure the brain and heart stay online.
Wow. Our bodies are so smart.
I know, they're amazing.
What else does this superhero nervous system do?
It also triggers the release of hormones that help the body conserve fluid.
Okay.
For example, aldosterone tells the kidneys to reduce the amount of sodium and water excreted in the urine.
Okay, to hold on to those fluids.
Exactly.
Uh-huh.
It's like plugging those leaks and holding onto every precious drop of fluid.
Okay, so it's a brilliant strategy,
It is.
but it's not a permanent solution.
Unfortunately not.
What do you mean?
These compensatory mechanisms are like temporary fixes.
Okay.
They can buy the body some time.
Right.
But if the underlying cause of shock isn't addressed, they will eventually fail.
So it's like running on a backup generator.
Yeah.
You can keep the lights on for a while, but eventually you need to fix the main power source.
That's a perfect analogy.
Yeah.
And that's why getting medical attention as quickly as possible is so crucial.
Makes sense.
You know, we need to address that root cause of the shock
Right.
to give the body a chance to fully recover.
This has been an amazing deep dive.
It-
We've gone from the basics of the cardiovascular system
Yeah.
all the way to the incredible ways our bodies respond to shock.
We've covered a lot of ground.
I feel like I've learned so much.
Good, I'm glad.
Yeah, me too. So for our listeners out there,
Okay.
what are the key takeaways you want them to remember?
Be aware of the signs and symptoms of bleeding and shock, both internal and external.
Okay.
Don't hesitate to seek medical attention if something seems off,
Right.
especially with children.
And even if you're not a medical professional, there are things you can do to help
Yes,
while waiting for help to arrive.
absolutely. Simple things like controlling external bleeding with direct pressure
Right.
or keeping someone warm can make a world of difference.
Great advice.
Or try.
This deep dive has truly been an eye-opener.
It has been.
Well, thank you so much for joining us on this deep dive into bleeding and shock.
It's been my pleasure.
We'll be back next time with another fascinating topic to explore. Until then,
Hmm.
stay curious, stay informed, and stay safe. All right, diving in again. Today, the endocrine system.
Oh, a fascinating one.
Yeah, I'm excited for this one. We've got some dense medical textbook excerpts here.
Oh, excellent.
Luckily, our listeners are already pretty into this stuff.
Right, they're not starting from zero, that's for sure.
So we can really get into the nitty-gritty. We're going to focus on endocrine emergencies.
When hormones go haywire,
Exactly. Those moments when things go seriously wrong.
it's a bit like, knowing those warning lights on your car dashboard.
Oh, I like that.
You don't have to be a mechanic,
Right.
but understanding what means trouble can save you a major breakdown.
Absolutely.
Yeah.
Okay, before we get to the warning lights, though, let's just back up for a second.
Sure.
Endocrine glands versus exocrine glands.
Here's
What's the
it.
difference again?
So endocrine glands release hormones directly into the bloodstream.
Got it.
And those hormones affect things all over the body, whereas exocrine glands, they use ducts to send substances outside the body.
Yeah.
Like sweat or saliva.
So it's all about where those secretions end up,
Exactly.
inside or outside.
Inside or outside.
Okay. The source had this great mnemonic, exocrine equals XIT.
That's a good one.
Super helpful, right?
Yeah.
So those endocrine hormones,
Yes.
they're like, what, tiny messengers?
They're traveling through your blood,
Mm-hmm.
delivering instructions to different cells.
So how do they know which cells to talk to?
Well, imagine that each cell has a specific set of locks,
Okay.
and only certain hormones have the matching keys.
Interesting.
These are called receptors.
Okay.
And when a hormone binds to its receptor,
Yeah,
it triggers a specific action within that cell.
makes sense. So what happens if the message gets scrambled? Or, a cell gets the wrong instructions?
Well, that's where those feedback loops come in.
Okay, the feedback loops.
Yeah, think of it like a thermostat.
Okay.
If the temperature gets too high, it signals the AC to turn on, cool things down. Similarly, your body uses positive and negative feedback loops to maintain hormonal balance.
Gotcha. So give me an example of how those loops actually work.
All right, let's take childbirth.
Okay.
As labor begins, the hormone oxytocin stimulates contractions.
Okay.
And those contractions further stretch the cervix, which in turn signals the release of even more oxytocin.
Oh, wow.
So this escalating cycle, a positive feedback loop, continues until the baby is born.
So it's amplifying the change until a specific goal is reached.
Exactly.
What about negative feedback?
So negative feedback is about bringing things back to balance.
Okay.
When you're stressed, your adrenal glands release adrenaline, increasing your heart rate.
Right, getting you ready to fight or flee.
Exactly, prepping you for fight or flight. Once the stress passes, negative feedback kicks in,
Okay.
lowering adrenaline, bringing your body back to its resting state.
So endocrine emergencies are basically when those feedback loops malfunction,
You got it.
causing hormones to be overproduced or underproduced.
Exactly.
Okay, and this can happen for a variety of reasons. I mean, we're talking genetic factors, tumors,
Yep.
infections, even certain medications.
Right, it's a whole range of things.
Speaking of control systems, the source calls the hypothalamus and pituitary gland the master glands.
They really are.
Why do they get that title?
Well, the hypothalamus is like the CEO,
Okay,
constantly monitoring your internal environment,
right.
sending out directives.
Okay,
The pituitary gland is like the manager,
got it.
receiving those directives, relaying the orders to other endocrine glands throughout the body.
So they're calling the shots for things like growth,
Absolutely.
stress response, even reproduction.
Exactly. And one of the glands under their command is the thyroid,
Okay, the thyroid.
responsible for regulating your metabolism.
Right, with the hormone thyroxine.
That's it.
And here's where it gets really interesting for, those of us paying attention to what we eat.
Yes.
Thyroxine production requires iodine. Right. So what happens if you're not getting enough in your diet?
Well, iodine deficiency can lead to hypothyroidism,
Okay.
where the thyroid can't produce enough thyroxine. You might experience fatigue, weight gain, even difficulty concentrating.
Wow. So something as simple as not getting enough iodine
Right.
can have this ripple effect throughout the body.
It really can.
Now, the thyroid also produces calcitonin,
Yes.
which manages calcium levels. But there's another set of glands involved there, right?
You're thinking of the parathyroid glands.
Yes, the parathyroid glands.
They release parathyroid hormone, or PTH,
Okay.
which actually increases calcium levels when they dip too low.
Interesting.
It's a delicate dance between these two hormones to keep calcium in that sweet spot.
So even within the endocrine system, we've got these checks and balances going on.
We do, constantly.
What about the adrenals?
Ah, yes.
They seem to be all about that fight or flight response.
They're like your body's rapid response team.
I like that.
The adrenal cortex produces cortisol,
Yeah.
essential for managing stress,
Right.
regulating things like blood pressure, energy use.
Cortisol, the stress hormone we all love to hate.
Exactly.
Then there's the adrenal medulla,
Yes,
which releases adrenaline and noradrenaline,
it does.
giving you that surge of energy and focus when facing a perceived threat.
Exactly.
It's amazing how our bodies prioritize certain functions under stress,
It is, isn't it?
like shutting down digestion to divert energy elsewhere.
Exactly.
It makes you realize how chronic stress can really impact our overall health.
Oh, absolutely.
Now, the last gland we'll touch on today is the pancreas.
Okay.
And it's unique because it has both endocrine and exocrine functions.
That's right, a double-duty gland.
Right. It's involved in digestion and blood sugar regulation.
Yep.
Can you break that down for us?
So the pancreas releases digestive enzymes through ducts into your small intestine.
Okay.
That's the exocrine part.
Got it.
But it also produces insulin and glucagon, two hormones that control blood sugar levels.
Okay, so how do those two work together?
Well, insulin acts like a key, unlocking cells to allow glucose to enter and be used for energy.
Okay.
When blood sugar rises, say after a meal,
Mm-hmm.
insulin is released to lower it back down.
Okay.
Glucagon does the opposite.
All right.
When blood sugar drops too low, it signals the liver to release stored glucose back into the bloodstream.
So it's like a constant balancing act
It is.
to keep those blood sugar levels stable.
Yep,
Our source mentioned that glucagon can only do its job
right.
if the liver has enough glycogen stored up.
That's right.
What happens if it doesn't?
Well, think about that feeling of a sudden energy crash
Oh, yeah.
after a sugary snack,
Mm-hmm.
but no real meal.
Right.
You get a quick burst of energy as your blood sugar spikes, but then it plummets
Yeah.
because your body didn't have those long-lasting glycogen reserves to tap into.
Oh, that's happened to me before. It's like your body's saying, hey, I need more than just sugar here. Which brings us to diabetes.
Ah, yes.
Can you explain the difference between type 1 and type 2?
In type 1 diabetes, the pancreas doesn't produce insulin at all,
Okay.
often starting in childhood. It requires lifelong insulin injections to manage blood sugar.
Okay.
In type 2, the more common form,
Right.
the body either doesn't make enough insulin or becomes resistant to its effects,
Interesting.
often developing later in life.
And our source mentioned that over 3 million Canadians are living with diabetes,
Wow,
with even higher rates in men.
that's a lot of people.
That's a staggering number, which makes understanding these endocrine emergencies even more crucial.
It does, absolutely.
And one of the most serious is hypoglycemia,
Right, low blood sugar.
where glucose levels drop below 4 millimole. This can happen to anyone, but it's especially dangerous for people with diabetes.
Absolutely, it can be very serious.
Knowing that hypoglycemia can be so serious, what should we be looking out for? Are there any early warning signs that could help us prevent it from reaching that critical stage?
Absolutely. So you might see trembling, rapid heart rate, sweating, and intense hunger.
Okay.
But what's tricky is that these can be mistaken for intoxication.
Oh, wow. So someone might appear drunk when they're actually experiencing a medical emergency.
It's possible, yeah.
That's scary.
It is, which is why quick action is so important.
Right.
Treatment for hypoglycemia must be immediate.
The source mentioned a mnemonic, AEIOU tips,
Yes.
to assess altered mental status, but it didn't explain what those letters stand for. What can you tell us about that?
So AEIOU tips is a helpful way to remember potential causes of altered mental status. It stands for alcohol, epilepsy, insulin, overdose, uremia,
Uremia.
kidney problems, trauma, infection, psychiatric, and stroke.
Okay.
So remembering this mnemonic can help you quickly run through potential causes and get help faster.
Okay, so we've talked about low blood sugar,
Right.
but what about high blood sugar?
Okay.
What happens then?
So chronically high blood sugar or hyperglycemia
Hmm.
can be very dangerous as well.
Okay.
And it can progress to a condition called diabetic ketoacidosis,
Diabetic ketoacidosis,
or DKA,
DKA,
a potentially life-threatening situation.
DKA. That sounds serious.
It can be.
What's happening in the body when someone has DKA?
Basically, the body isn't getting the glucose it needs for energy.
Okay.
Because there isn't enough insulin to allow it into the cells.
Right.
So it starts breaking down fat for fuel instead,
Okay.
producing ketones as a byproduct.
Ketones.
The problem is ketones are acidic,
Ah, I see.
and their buildup in the blood disrupts the body's delicate pH balance.
Our source mentioned that hyperglycemia is also linked to worse outcomes after a stroke.
It is?
It's a reminder to take even seemingly mild symptoms seriously.
Absolutely.
And while we've been focusing on diabetes,
Right.
there are other endocrine emergencies related to different glands that we should be aware of as well.
There are definitely.
All right, that's a perfect segue into part 2 of our deep dive. We'll be back after a quick word from our sponsors.
Welcome back.
All right.
So we've laid the groundwork for understanding the endocrine system. Now it's time to explore some specific conditions that can arise when things go wrong.
Right, the emergency.
Exactly. Let's revisit the thyroid gland, the one responsible for metabolism.
Okay.
We talked about how iodine deficiency can lead to hypothyroidism.
Right.
But what happens when things get really serious? Our source mentions something called myxedema coma.
Myxedema coma. That sounds serious.
It is. It's like the extreme end of hypothyroidism.
Oh,
A
wow.
life-threatening condition where the body's metabolism slows to a crawl,
Oh, gosh.
impacting multiple organ systems.
So it's not just about feeling tired and sluggish.
No, it's far beyond that.
What kind of triggers can push someone into a myxedema coma?
Well, it can be a perfect storm of factors. Untreated hypothyroidism, exposure to extreme cold, infections, certain medications, even trauma or surgery.
So basically anything that puts significant stress on an already compromised system.
Exactly.
So what should we be watching for? Are the symptoms dramatically different from regular hypothyroidism?
Well, while fatigue, weight gain, dry skin are common in both, myxedema coma is characterized by a marked decline in mental status.
Okay.
You might see confusion, lethargy, even loss of consciousness. There can also be a drop in body temperature and blood pressure.
Wow. So it's a cascade of problems that can quickly become life-threatening. What about the opposite end of the spectrum, when the thyroid is overactive?
That's called hyperthyroidism.
Okay.
And in severe cases, it can lead to thyrotoxicosis,
Thyrotoxicosis.
where the body essentially goes into overdrive.
Thyrotoxicosis. That name sounds pretty intense. What's actually happening in the body when someone experiences this? How does it differ from a simple overactive thyroid?
Think of an overactive thyroid like a car engine, revving too high.
Okay, yeah.
Thyrotoxicosis is like that engine redlining, threatening to blow a gasket. It's a state of extreme metabolic acceleration that can lead to heart problems, fever, even delirium.
Okay, so what are the red flags? How would someone know if their overactive thyroid is tipping into dangerous territory?
Well, they might experience a racing heart, unexplained weight loss despite a big appetite, nervousness, tremors, sweating, and insomnia.
Okay.
Basically, everything speeds up and becomes exaggerated.
That sounds pretty exhausting. And our source mentions another scary-sounding term, thyroid storm. What exactly is that?
A thyroid storm is a rare but life-threatening complication of hyperthyroidism. Imagine all the symptoms of thyrotoxicosis, but amplified tenfold. It often comes on suddenly, triggered by things like infections, surgery, or even childbirth.
Oh, wow.
And the symptoms are even more extreme. You might see a very high fever, dangerously fast heart rate, severe agitation and confusion, even seizures.
Okay, so it's a true medical emergency,
It is.
requiring immediate attention. Wow, we're really seeing how delicate this balance is. Too much or too little thyroid hormone can have serious consequences.
Yeah.
Before we move on from the thyroid, what can you tell us about goiters?
So a goiter is simply an enlargement of the thyroid gland,
Okay.
often visible as a swelling in the neck. It can be caused by a variety of things,
Oh, sure.
from iodine deficiency to inflammation, or even tumors.
So a goiter itself isn't necessarily a problem,
Right.
but it could be a sign of an underlying thyroid issue.
Exactly. While many goiters are harmless, some can cause discomfort or difficulty swallowing if they press on surrounding structures in the neck.
Sure.
Others can be associated with either hypothyroidism or hyperthyroidism, so it's always best to get any unusual neck swelling checked out.
Good advice.
Oh.
Okay, let's shift gears and talk about the parathyroid glands. I remember they regulate calcium,
They do?
but what happens when they malfunction?
Well, if the parathyroid glands become overactive, they release too much parathyroid hormone, leading to hyperparathyroidism.
And too much PTH means?
Too much calcium in the blood,
Okay.
which might not sound like a big deal,
Right.
but it can lead to a range of problems. Fatigue, weakness, bone pain, kidney stones, even heart issues.
That doesn't sound good at all. What about the opposite? Hypoparathyroidism.
That's when you have too little parathyroid hormone,
Okay.
resulting in low calcium levels in the blood.
Okay, so instead of bones, stones, groans, and moans, we'd see a different set of problems.
Exactly. Low calcium can cause muscle cramps and spasms, tingling in the hands and feet, even seizures. It's a completely different set of warning lights to be aware of.
This is also fascinating. It really highlights how interconnected our bodies are
It is.
and how much we rely on these glands to function properly.
Yeah.
Are there any other conditions related to the parathyroid glands that we should be aware of?
Those are the main ones, but it's important to remember that any disruption in calcium balance can have cascading effects on other systems,
Okay.
like nerve function and muscle contraction.
Right, so even seemingly isolated problems can have wide-reaching consequences.
Exactly.
Well, we've covered a lot of ground on the thyroid and parathyroid glands. What's next on our endocrine adventure?
Let's move on to the adrenal glands,
Okay,
the powerhouses behind our stress response, and so much more.
perfect. We'll be right back to delve into the world of the adrenals. And we're back, ready to tackle those adrenal glands.
The grand finale of our endocrine tour.
They're kind of like the body's first responders, right?
That's a great way to put it, crucial for handling stress.
Yeah.
But they do a lot more than that, too.
Right, the cortex makes cortisol,
Yep.
and the medulla pumps out adrenaline, noradrenaline. We talked about adrenal insufficiency.
Mm-hmm.
When the cortex isn't making enough cortisol, that can be really bad.
It can.
What about the opposite, though? Too much cortisol, our source mentions Cushing syndrome.
Cushing syndrome, yeah. It's a fascinating one because it shows just how powerful cortisol's effects are all over the body.
So it's involved in blood pressure, metabolism, even the immune system.
All of that, yep. And when there's too much, it throws things way off balance.
What symptoms should make someone think, hang on, maybe this is Cushing's?
One of the most noticeable is weight gain,
Okay.
particularly around the belly and face.
Okay.
You might also see thinning skin, easy bruising, muscle weakness, high blood pressure. But it's not just physical.
Oh, interesting.
People with Cushing syndrome can have mood swings, get irritable easily, even have trouble concentrating.
Wow, it can really mess with your life.
Yeah.
What causes this overproduction of cortisol in the first place?
Few possibilities. Could be a tumor on the pituitary gland. Remember, that's the manager signaling to the adrenals.
Right.
Or a tumor on the adrenal gland itself. Even long-term use of corticosteroid medications like prednisone can do it.
So if you're experiencing those symptoms, definitely see a doctor.
Absolutely. Got to figure out the root cause.
Yeah, the adrenal medulla, the adrenaline part. Can things go wrong there too?
For sure. One that comes to mind is pheochromocytoma.
What now?
Pheochromocytoma. It's a tumor in the adrenal medulla.
Okay. Pheochromocytoma. And what's happening in the body with that?
Basically, it's like your fight or flight is stuck on.
Oh, yikes.
The tumor makes the medulla release way too much adrenaline, noradrenaline. So you get these persistent or sometimes sudden surges in blood pressure, rapid heart rate, sweating, headaches, intense anxiety.
Sounds awful. What would even trigger those surges?
It really depends. For some people, it's physical activity.
Oh, wow.
Even certain foods can set it off.
Really?
For others, it might be stress or just changing positions.
Like standing up.
Yeah, things like that. The key is figuring out your triggers and getting treatment.
So we've got adrenal insufficiency on one end,
Mm-hmm.
Cushing syndrome, pheochromocytomas on the other. Those adrenal glands walk a tightrope.
They do. And that highlights how important balance is for the whole endocrine system. These glands are working constantly to keep us healthy.
Makes you realize we need to take care of them.
We do.
But with all these things that can go wrong, it's a bit overwhelming.
Right.
What are some simple things we can do to support our hormonal health?
Well, the good news is a lot of it overlaps with general health advice.
Oh.
Eating a balanced diet,
Right.
regular exercise, managing stress, enough sleep, all those impact hormones positively.
It's like a holistic approach, mind and body.
Exactly. And knowledge is power. The more you understand your body, the better decisions you make.
This deep dive has been eye-opening for sure. Learned about how intricate the endocrine system is,
It is complex.
the problems that can happen, but also ways we can keep things balanced. Any last words for our listeners?
The biggest takeaway, I think, is our bodies are amazingly complex and resilient. Endocrine emergencies are serious, But knowing the signs, getting help quickly, that makes a huge difference. And taking care of yourself, those lifestyle choices can prevent problems in the first place.
Being proactive, in tune with our bodies. Well, thank you for guiding us through this endocrine world. I've learned a ton.
My pleasure. To our listeners, keep exploring, keep asking questions, keep taking good care of yourselves.
That's all for this episode of The Deep Dive. We'll be back soon with another fascinating topic. Until then, stay curious.
Welcome to another deep dive. Today we're going to be looking at two very important topics, hazmat and public health and infectious diseases.
Great.
We've got a stack of medical training materials here
Cool.
that we're going to be taking a look at and
Sounds good.
giving you all the need-to-know info.
Very valuable.
Let's start off with hazmat.
Okay.
Did you know that there are about 10,000 hazmat releases in Canada every year?
Wow, that's a lot.
Yeah, it's a lot.
Yep.
And 10% of those are related to transportation incidents.
Okay.
So that's a lot of spills and things like that. So first things first,
Okay.
how do you even recognize a hazmat situation?
Yeah, so some are obvious, like a tanker truck on its side leaking,
Right.
but others can be more subtle.
Oh, okay.
You have to keep an eye out for unusual clouds or smoke,
Right.
or leaks coming from vehicles or buildings, or even a strong acrid smell that seems out of place.
Although our sources do caution against relying on your sense of smell.
Absolutely right. If you can smell it, you're already exposed.
Right.
And if you see multiple people suddenly collapsing or having trouble breathing,
Yeah.
that's a major red flag.
Okay, so you've recognized the danger. What do you do?
The most important thing is to protect yourself.
Okay.
You want to stay uphill and upwind from the scene
Okay.
and be prepared to move if the wind shifts.
That makes sense.
Call 911
Right?
and give dispatch as much information as you can.
Yeah.
Location,
Yeah.
any identifying placards.
Speaking of placards,
Yeah.
can you talk about those for a minute?
Absolutely. Placards are a vital safety tool,
Right.
and they use a specific coding system to indicate what kind of hazardous material is involved.
Okay.
And that helps first responders prepare.
Right.
It also gives you an idea of how far away you need to be.
So there's a system for figuring out how dangerous the substance is.
There is, yeah.
Yeah.
The NFPA 704 system
Okay.
uses a diamond-shaped symbol
Okay.
with 4 colored sections
Okay.
representing health hazards. Fire hazard,
Okay.
reactivity, and special hazards like radiation.
Got it.
Each section has a number from 0 to 4, with 4 indicating the highest risk.
Are there resources available for the public to help people interpret these placards?
Absolutely. There are guides available online and even mobile apps
Oh.
that can help you decipher the information.
Okay, great.
And then for first responders, there's the Emergency Response Guidebook,
Got it.
which is a comprehensive resource
Cool.
that gives detailed information on how to handle various hazardous materials.
So even people without specialized training can have a basic understanding of the hazard.
Exactly.
Yeah.
It allows for a quicker, more informed response.
Now, dealing with some of these materials must require special gear.
You're right. That's where personal protective equipment comes in, or PPE.
All right.
And there are different levels of PPE,
Okay.
ranging from A to D, depending on the hazard level.
Can you give us a quick rundown?
Yeah, level A is the highest level of protection. It offers full body encapsulation
Okay.
and a self-contained breathing apparatus.
Got it.
So that's like what you might see in the movies
Right.
for the most dangerous situations.
Yeah.
Level D is your basic work uniform,
Okay.
minimal protection.
Right.
Levels B and C are somewhere in between.
Okay.
And interestingly,
Yeah.
most ambulances are only equipped with level C gear.
Oh, really? I would thought that they would at least have A.
It's a matter of balancing the level of risk with practicality and resources. It's important to remember that assessing a hazardous materials incident
Right.
and determining the appropriate PPE requires specific training and expertise.
Okay.
So even figuring out what PPE to wear
Yeah.
is a complex decision that should be left to trained professionals.
Yeah, that makes sense.
And that's why having trained hazardous materials teams is so important. They have the specialized equipment and knowledge
Right.
to assess the situation,
Okay.
identify the substances,
Right.
and establish safe zones.
Okay, now what happens if somebody comes into contact with the material?
So there are 2 types of contamination,
Okay.
primary and secondary.
Right.
Primary contamination is direct exposure to the substance.
Okay.
Well, secondary contamination happens when the hazard is transferred from someone or something that's already contaminated.
Got it.
And that's why decontamination is so crucial.
Can you expand on that a little bit?
Sure. It depends on the type of hazardous material.
Right.
But common methods include dilution with water,
Hmm.
absorption, using pads or towels,
Okay.
neutralization with chemicals,
Right.
and simply disposing of contaminated clothing.
Mm.
In emergencies, even hosing down a victim with large amounts of water might be necessary.
Wow. So it sounds like a very complex process.
It can be, and that's another reason why having trained professionals on scene is so critical.
Right.
They can determine the most effective and safe decontamination procedures.
Now, let's say someone is exposed to a hazardous material and needs medical attention.
Oh?
What are the special considerations for their treatment?
The first and most important thing is to protect yourself from secondary contamination.
Okay.
Then treatment focuses on minimizing further harm.
Mm.
You want to avoid invasive procedures, if possible.
Right?
Resources like Canutech,
Right.
which is Canada's National Emergency Response Center for Hazardous Materials Incidents,
Okay.
or poison control, can provide valuable guidance.
Right.
Transporting a potentially contaminated patient also requires extra precautions.
Okay, so handling a hazmat incident is a multifaceted process
It is.
that involves staying calm,
Right.
assessing the situation,
Yeah,
and taking appropriate steps to protect yourself and others.
absolutely.
Knowledge and preparedness are key.
Well said.
All right, so let's shift gears now
Okay.
and dive into the world of public health and infectious diseases.
Ready when you...
All right, so we talked about the potential dangers lurking in the environment, but now let's turn our attention to those threats that are often invisible to the naked eye. Right. Infectious diseases.
Those tiny invaders can certainly pack a punch.
They can.
Understanding how they work is crucial for protecting ourselves and our communities.
Okay, so let's start with the basics.
Sure.
How are these diseases spread?
There are several main routes of transmission.
Okay.
Some, like measles and the flu, spread through the air via tiny droplets released when someone coughs or sneezes.
Right.
Others, like the common cold,
Yeah.
can spread through direct or indirect contact with contaminated surfaces.
So like touching a doorknob that someone with a cold has recently touched?
Exactly.
Yeah.
And there are also diseases spread through contaminated food or water,
Right.
like certain types of hepatitis,
Mm-hmm.
and even some that are transmitted by insects or animals,
Okay.
such as Lyme disease and West Nile virus.
It's amazing how these tiny organisms have developed such diverse ways to spread. But luckily, our bodies have some pretty impressive defenses against these invaders.
Absolutely.
Yeah.
Our skin acts as a first line of defense, providing a physical barrier against pathogens.
Right.
Then we have mucous membranes in our respiratory and digestive tracts that trap those invaders.
Mm.
And of course, our immune system is a powerhouse
Mm.
with its specialized cells like B cells and T cells that work tirelessly to identify and destroy those pathogens.
It's fascinating how our bodies have these intricate defense mechanisms that we don't even have to think about.
It is.
But sometimes, despite our best efforts, those defenses are breached and we get sick.
Right.
What are some key things to understand about the cycle of infection?
Understanding this cycle helps us break the chain of transmission and prevent the spread of disease.
Mm.
We need to know things like the incubation period, the time between exposure and the onset of symptoms,
Okay.
when someone is most contagious,
Mm.
and how long the organism can survive outside a host.
So it's almost like detective work, tracing the path of the disease and figuring out how to stop it.
That's a great analogy. And that's where public health agencies come in.
Right.
They play a crucial role in collecting data, tracking outbreaks, and implementing strategies to control the spread of disease.
Now, what about those routine practices that healthcare providers use to protect themselves and others?
Those are essential.
Yeah.
Think hand hygiene,
Right.
using personal protective equipment like gloves and masks,
Hmm.
proper disposal of sharp objects,
Okay.
and thorough cleaning and disinfection of equipment and vehicles.
It all comes down to minimizing the opportunities for those pathogens to jump from one person to another.
Absolutely.
Okay, so we have a long list of specific diseases to cover,
We do,
ranging from those common childhood illnesses
right?
to more serious conditions.
Okay.
Where should we start?
Let's start with those childhood illnesses, some of which you may have experienced yourself.
Okay.
It's interesting to look at how our understanding and management of these diseases have evolved over time.
Measles, mumps, rubella. Yeah.
These were once considered almost rites of passage for kids.
They were incredibly common.
Right.
But thankfully, widespread vaccination has drastically reduced the incidence of these diseases.
It really is a testament to the power of vaccines in protecting public health.
It is.
But even though they're less common these days, it's still important to know what to look for.
Absolutely. Measles, also called rubeola, is highly contagious and spreads through the air.
Okay.
It typically starts with fever, cough, runny nose, and red, watery eyes,
Right.
followed by a distinctive rash that spreads from the head down the body.
What about mumps?
Mumps is characterized by swelling of the salivary glands, particularly the parotid glands, which are located on both sides of the face just below the ears. It can also cause complications like inflammation of the testicles in males, which can sometimes lead to infertility.
Oh, wow.
Yeah.
Definitely a good reason to get vaccinated.
Absolutely.
And rubella, also known as German measles,
Rubella is often milder than measles.
with symptoms like a low-grade fever, headache, and a rash.
Hmm.
However, it poses a serious risk to pregnant women,
Right.
as it can cause congenital rubella syndrome in the developing fetus, leading to birth defects, like hearing loss, heart defects, and intellectual disabilities.
That highlights the importance of vaccinations for not just individual protection, but also for safeguarding the health of future generations.
Exactly. It's about community immunity.
Right.
The more people who are vaccinated, the harder it is for these diseases to spread, which protects those who are unable to be vaccinated for medical reasons.
Okay, now what about chickenpox? It seems like every kid used to get it at some point.
Chickenpox or varicella is another highly contagious viral disease.
Okay.
It causes a fever and an itchy blister-like rash that appears all over the body.
Yeah.
While usually mild in children, it can be more severe in adults and can lead to complications like bacterial skin infections and pneumonia.
And we can't forget about shingles, which is caused by the same virus as chickenpox.
Right, shingles usually occurs later in life, often triggered by stress or a weakened immune system.
Right.
It causes a painful rash that typically wraps around one side of the torso, but can also affect the face and other areas.
It's amazing how a virus can lay dormant for years and then reappear in a completely different form.
It is.
Now, what about pertussis or whooping cough? I've heard that it's making a comeback in some areas.
Unfortunately, that's true. Pertussis is a bacterial infection that starts with cold-like symptoms, but progresses to severe coughing fits that can make it difficult to breathe.
Yeah.
Those coughing spells are often followed by a whooping sound as the person tries to catch their breath, hence the name.
Sounds pretty awful.
It can be quite debilitating, particularly for infants and young children.
Yeah.
The resurgence is likely due to waning immunity from vaccines and the bacteria's ability to adapt and become more resistant to antibiotics.
So it's important to stay up to date on vaccinations and be aware of the signs and symptoms of pertussis.
Absolutely.
All right, moving on to some more serious respiratory conditions. Let's talk about meningitis.
Meningitis is an inflammation of the membrane surrounding the brain and spinal cord.
Okay.
It can be caused by bacteria or viruses,
Right.
and both types can lead to symptoms like fever, headache, stiff neck, and sensitivity to light.
How can you tell the difference between bacterial and viral meningitis?
Bacterial meningitis is generally more severe and requires prompt treatment with antibiotics. It can progress rapidly and lead to serious complications like brain damage, hearing loss, and even death.
Oh, wow.
Viral meningitis, on the other hand, is usually milder
Okay.
and often resolves on its own.
So if you suspect meningitis, it's crucial to seek medical attention immediately.
Absolutely. Early diagnosis and treatment can make a huge difference in outcomes.
Now, what about tuberculosis or TB?
TB is a bacterial infection that primarily affects the lungs, but it can also spread to other parts of the body.
Right.
It's not as common as it once was, thanks to public health efforts and the development of effective antibiotics. But it's still a concern, particularly in certain populations, like those with weakened immune systems.
What are the typical signs of TB?
The hallmark symptom is a persistent cough that lasts for more than 3 weeks,
Okay.
often accompanied by coughing up blood or phlegm.
Right.
Other symptoms include fever, night sweats, fatigue, and unexplained weight loss.
It's a reminder that even though we've made progress in controlling many infectious diseases,
Right.
they can still pose a serious threat, especially if left untreated.
That's a great point. Vigilance and early detection are key.
Now let's discuss pneumonia, another common respiratory condition.
Pneumonia is an inflammation of the lungs that can be caused by bacteria, viruses, fungi, or even irritants like chemicals or smoke.
Okay.
It can range from mild to life-threatening.
Right.
And certain groups like older adults, young children, and those with underlying health conditions are at higher risk.
What are the typical signs and symptoms of pneumonia?
They can vary depending on the cause, but common symptoms include cough, fever, chills, shortness of breath, chest pain, and fatigue.
So it sounds like it can be difficult to distinguish from other respiratory infections.
It can be, and that's why it's important to see a doctor for proper diagnosis and treatment.
Yeah, we've talked about several serious respiratory infections,
Mhm.
but there are also many others that are less severe but still quite common, like bronchitis, bronchiolitis, laryngitis, and croup.
Right.
And of course, we can't forget about the common cold, which, while usually mild, can certainly make you feel miserable.
It's true. Those seemingly minor illnesses can disrupt our lives and remind us of the constant battle our bodies wage against these microscopic invaders.
Now let's move on to a different type of infection.
Okay.
Mononucleosis, often called mono, or the kissing disease.
Mono is caused by the Epstein-Barr virus, and it's known for causing extreme fatigue, sore throat, swollen lymph nodes, and a general feeling of being run down.
It's a common illness among teenagers and young adults, isn't it?
It is. The virus spreads through saliva,
Oh.
so close contact, like kissing or sharing drinks, can transmit it.
So the nickname kissing disease is quite fitting.
It is. And while it's usually not serious, mono can linger for weeks or even months, making it a real nuisance.
Yeah, and speaking of illnesses that can be a real drag, let's talk about influenza or the flu.
Influenza is a serious respiratory illness that causes thousands of hospitalizations and deaths each year in Canada.
Wow.
It's a viral infection that spreads rapidly, particularly during the winter months.
What are the key differences between the flu and the common cold?
Flu symptoms tend to come on suddenly and are usually more severe than cold symptoms.
Okay.
Fever, chills, muscle aches, headache, and fatigue are common with the flu, along with respiratory symptoms like cough and sore throat.
So if you're feeling like you've been hit by a truck, it's more likely to be the flu than a cold.
That's a good way to put it.
Yeah.
And while most people recover from the flu without complications,
Mm-hmm.
it can lead to serious problems like pneumonia, bronchitis, and even heart problems,
Oh, wow.
especially for those in high-risk groups.
So it's a reminder to not take the flu lightly. Now, are you ready to delve into the world of sexually transmitted diseases, or STDs?
Let's go for it. It's important to remember that STDs are common,
Okay.
and the more we know about them, the better equipped we are to protect ourselves and our partners.
Okay, let's start with gonorrhea.
Gonorrhea is a bacterial infection that's spread through sexual contact. It's particularly common in young people.
Okay.
Symptoms in men often include a burning sensation during urination and a pus-like discharge from the penis.
Right.
Women, however, may experience milder symptoms or none at all, which is why regular testing is so important.
Untreated gonorrhea can lead to serious complications, can't it?
It can. In women, it can cause pelvic inflammatory disease,
Right.
which can lead to infertility. In men, it can cause epididymitis, an inflammation of the tube that carries sperm.
Okay.
And in rare cases, gonorrhea can spread to the bloodstream and infect other parts of the body, like the joints, heart, or brain.
So it's definitely not something you want to ignore. Now, what about syphilis?
Syphilis is another bacterial infection that's been on the rise in recent years. It's also spread through sexual contact
Oh, yeah.
and progresses through different stages if left untreated.
Can you walk us through those stages?
Sure. The first stage usually involves a painless sore called a chancre
Okay.
that appears at the site of infection.
Hmm.
It may go unnoticed,
Yeah.
but even without treatment, it will heal on its own.
Right.
However, the infection remains in the body.
Okay.
The second stage often involves a rash that can appear anywhere on the body, along with flu-like symptoms like fever, headache, and sore throat.
Right.
These symptoms will also disappear without treatment, but the infection continues to progress.
So even if the symptoms go away on their own, it doesn't mean the infection is gone.
Exactly. Without treatment, syphilis can enter a latent stage
Okay.
where there are no noticeable symptoms. However, it can remain in the body for years
Oh.
and can eventually progress to the tertiary stage, which can cause serious damage to the heart, brain, nerves, and other organs.
That's a sobering reminder of the importance of seeking medical attention and getting tested if you think you may have been exposed to syphilis.
Absolutely.
Now let's talk about genital herpes, which is caused by a virus, right?
Yes. Genital herpes is caused by the herpes simplex virus.
Okay.
There are two types, HSV-1, which usually causes oral herpes or cold sores,
Right.
and HSV-2, which is the primary cause of genital herpes.
Okay.
However, both types can cause sores in either location.
So it's possible to get genital herpes from someone with a cold sore?
Yes, although it's less common than transmission from someone with genital herpes.
Okay, and what are the symptoms of genital herpes?
The hallmark symptom is the appearance of painful blisters or sores in the genital area.
Right.
The first outbreak is often the most severe,
Mm-mm.
but subsequent outbreaks can occur,
Okay.
triggered by things like stress illness or sun exposure.
So once you have the virus, you have it for life.
Unfortunately, there's no cure for herpes, but antiviral medications can help manage outbreaks and reduce the frequency and severity of symptoms.
Okay, now what about chlamydia? I've heard it's one of the most common STDs.
It is. Chlamydia is a bacterial infection that can cause a range of symptoms, but it's often asymptomatic, especially in women.
You might have it and not even know it.
That's right,
Yeah.
which is why regular testing is crucial.
Right.
If left untreated, chlamydia can lead to serious complications, particularly in women. It can cause pelvic inflammatory disease, which can damage the reproductive organs and lead to infertility or ectopic pregnancy.
So chlamydia is another example of an STD that might seem minor but can have long-term consequences if not caught early.
That's a great point. It underscores the importance of open communication with your partner, safe sex practices, and regular testing.
Okay, so we've covered a lot of ground here.
We have.
From those childhood illnesses that many of us have experienced
Okay.
to more serious conditions like meningitis and TB.
Hmm.
And we've even touched on the complexities of STDs.
Yeah.
But there are still many more infectious diseases to discuss.
Right.
From those pesky little critters like scabies and lice to more recent threats like antibiotic-resistant organisms and emerging diseases.
Absolutely. It's a vast and ever-changing landscape, and our exploration is far from over.
Well, I think that's a great place to pause for part 2 of our deep dive. We've given our listener plenty to ponder.
Definitely.
Welcome back to our deep dive into the world of hazardous materials and infectious diseases. We've covered a lot of ground already, but we still have a lot to explore.
Yeah, we've talked about recognizing and responding to hazmat incidents, and we've delved into the fascinating world of those tiny but mighty invaders, infectious diseases.
Right. And for our final stop on this deep dive, we're going behind the scenes, so to speak, to talk about a crucial aspect of infection control.
Okay.
Ambulance cleaning and disinfection.
It might not be the most glamorous topic, but it's absolutely essential for preventing the spread of those pesky pathogens and ensuring the safety of both patients and healthcare providers.
It's easy to overlook the importance of these seemingly routine procedures, but when you think about it, ambulances are on the front lines transporting patients with a wide range of conditions.
Exactly. They're constantly exposed to potentially infectious materials. So maintaining a clean and hygienic environment is critical. It's about breaking that chain of infection and minimizing the risk of those pathogens hitching a ride to the next patient.
So where do we even begin with this whole cleaning and disinfection process? It seems like a daunting task.
Well, the first step is understanding the different categories of equipment and the level of cleaning each requires. We can break it down into 3 main categories: critical, semi-critical, and non-critical.
Okay, let's break that down. What's considered critical equipment?
Critical equipment is anything that comes into direct contact with mucous membranes or sterile body tissues. Think of things like laryngoscopes, which are used to visualize the vocal cords, or endotracheal tubes, which are inserted into the trachea to help patients breathe. These items need to be sterilized after each use to eliminate all microorganisms.
Sterilization sounds pretty intense.
It is. Sterilization involves using high heat chemicals or radiation to kill all forms of microbial life, including those pesky bacterial spores, which are notoriously resistant to disinfection.
Wow, so that's for the critical stuff. What about semi-critical equipment?
Semi-critical equipment comes into contact with intact skin, but not mucous membranes. This includes things like stethoscopes, blood pressure cuffs, and even the stretcher itself. These items need to be thoroughly disinfected after each use, with a solution that's capable of killing viruses like hepatitis B, which are known to be particularly hardy.
And what about non-critical equipment, those things that don't directly touch the patient?
Non-critical equipment comes into contact with intact skin, but isn't directly used for patient care. Think door handles, seats, floors, control panels, all those surfaces that get touched frequently. These need to be cleaned with a hospital-grade disinfectant or a bleach and water solution to reduce the number of microorganisms.
Okay, so we've got the categories down. What are the specific cleaning routines that should be followed after every call?
The first rule is always wear appropriate personal protective equipment or PPE like gloves and eye protection when cleaning. It's about protecting yourself from potential exposure to those pathogens.
Safety first. What's next?
Then, it's all about a systematic approach to cleaning and disinfection. Remove any used linens and dispose of them properly in biohazard bags. Discard any disposable equipment like gloves and masks. Anything that can be reused needs to be thoroughly cleaned and disinfected according to the appropriate category. That includes things like backboards, oxygen masks, and any other equipment that was used during transport.
It seems like there are a lot of nooks and crannies to pay attention to.
There are. It's important not to overlook those high-touch surfaces like door handles, grab bars, and control panels, and any spills or bodily fluids should be cleaned up immediately using appropriate precautions and disinfectants.
And what about the stretcher? That seems like a prime spot for potential contamination.
You're right. The stretcher should be thoroughly cleaned with an approved germicidal or virucidal solution after each patient transport. A bleach and water mixture at a 1.100 dilution can also be used. It's important to follow the manufacturer's instructions for cleaning and disinfection to ensure effectiveness and to prevent damage to the stretcher's surface.
It's a reminder that even seemingly simple tasks like cleaning a stretcher require attention to detail and a commitment to following proper protocols.
Absolutely. It's all about maintaining a high standard of hygiene in an environment where infection control is paramount.
And it's not just about routine cleaning, right? If an ambulance transports a patient with a known or suspected infectious disease, additional precautions may be necessary.
You're absolutely right. In those cases, more specialized disinfection procedures might be required depending on the specific disease and its mode of transmission.
Can you give us an example?
Let's say an ambulance transports a patient with a respiratory illness, like tuberculosis, that spreads through the air. In that case, the ambulance might need to be thoroughly decontaminated, using a specialized fogging system that disperses a fine mist of disinfectant throughout the entire vehicle.
So it's not just about wiping things down in those situations.
No, sometimes a more comprehensive approach is needed to ensure that all potential pathogens have been eliminated. It's about minimizing the risk of transmission to subsequent patients and healthcare providers.
It sounds like there's a lot to consider when it comes to ambulance cleaning and disinfection. It's a multifaceted process that requires a systematic approach, attention to detail, and a commitment to following those established protocols.
Well said. It's not a task to be taken lightly, but it's a crucial part of maintaining a safe and healthy environment for everyone involved.
Well, we've covered a lot of ground in this deep dive. We've explored the hazards of hazardous materials, delved into the world of infectious diseases, and even ventured into the often overlooked but crucial realm of ambulance cleaning and disinfection.
It's been a whirlwind tour of knowledge.
It has. And hopefully our listener now feels better equipped to handle a hazardous materials incident, make informed decisions to protect themselves and others from infectious diseases, and even appreciate the importance of those unsung heroes who keep those ambulances sparkling clean.
Knowledge is power, and I hope this deep dive has empowered our listener to make informed choices for their health and safety.
Absolutely. But remember, this is just a starting point. There's a vast universe of information out there about these topics. So keep learning, keep asking questions, and stay curious.
And as we wrap up this deep dive, here's a final thought for you to ponder. Considering the increasing threat of antibiotic-resistant organisms, what actions can individuals and communities take to help slow down their spread?
That's a great question to leave our listener with. It challenges us to think about how our everyday actions can impact the bigger picture of public health.
Thanks for joining us on this deep dive. We hope you've enjoyed exploring these important topics with us.
Stay safe, stay informed, and keep learning.
Welcome to our deep dive. Today we're going on a journey to explore human development, all the way from, well, taking that first breath to later in life.
Yeah.
I'm so curious about all this stuff. You've sent some excerpts from medical textbooks about human development and neonatology. It's going to be fascinating to really dig into it.
It really is incredible. So many transformations.
I know. In those first few moments of life, like even a newborn's cry can change, like if they're hungry or if they're tired.
Oh, absolutely.
And toddlers, how do they have so much energy? Makes you wonder what's happening inside those little bodies, you know?
Well, in the first year alone, infants, especially newborns, or neonates as they're called medically, go through such dramatic changes. Like one of the biggest is switching from, well, relying on their mother's circulation to breathing all on their own.
Wow. Those tiny lungs are working so hard. I remember reading that newborns' lungs have fewer air sacs than adults do.
That's right, yeah.
So they must be working so hard to breathe.
Exactly, and it's not just the respiratory system. Their kidneys are maturing like crazy, and they're starting to build up their immune systems. And they even have a really unique way of regulating their blood pressure, too.
Oh, right. The textbook mentioned that a newborn's blood pressure is actually connected to their weight. How does that work?
Essentially, doctors use a formula to determine normal and low blood pressure in newborns based on their weight. It's based on the idea that as babies gain weight and their circulatory system develops, their blood pressure should go up too.
So as they grow, Their blood pressure kind of has to keep up.
Exactly. It's all about making sure that their tiny bodies are getting enough oxygen and nutrients to, support all that rapid growth.
That makes sense. But it's not all just physical growth, right? Infants are developing emotionally and socially too.
Definitely. Think about how a baby's cries become more distinct as they learn to communicate different needs. Hunger, discomfort, loneliness even. They're developing the basis for social interaction and learning to trust their caregivers.
It's like they're building relationships already.
Absolutely, yeah.
That makes me think about the trust versus mistrust stage of development I read about. How important it is for infants to have consistent care and responsiveness, to build that sense of security and confidence.
That's a core concept from Erik Erikson's theory of psychosocial development, and it highlights just how much those early interactions can shape an infant's well-being, emotionally and socially for years to come.
It makes you realize the huge responsibility parents and caregivers have, but also the incredible privilege. It's amazing to be part of shaping those early experiences.
Exactly. They're not just meeting those basic needs, they're actually laying the foundation for, well, a lifetime of healthy relationships and emotional development.
Speaking of growth and development, let's move on to toddlers and preschoolers between the ages of 1 and 5. It's amazing how much they change in just a few short years.
It's a remarkable transformation, going from taking those first, wobbly steps to suddenly running and jumping and climbing with what seems like endless energy.
And don't forget those why questions.
Oh, yeah.
It's like their brains are on overdrive, just trying to make sense of the world.
They're incredibly curious at this age, soaking up information and experiences. And all that exploring helps them develop essential motor skills, language, and even strengthens their immune systems.
And speaking of their immune systems, I was fascinated to learn that toddlers' lungs are actually growing rapidly during this stage.
Yeah.
But their respiratory muscles aren't strong enough yet for those, sustained deep breaths.
Yeah. It takes time for their little bodies to catch up. It's probably why they can run around like crazy for a bit and then suddenly just crash.
That makes so much sense. I always wonder why my toddlers had those bursts of energy and then they need to recharge.
Yeah.
And of course, then there's teething. Remember those sleepless nights?
Oh, yeah.
It's crazy how those tiny teeth can disrupt, everything.
Teething can definitely be a challenging phase for everyone, but it is a reminder that even what seem like small physical changes can have a big impact on a child's well-being. And this is also when social interaction becomes even more crucial.
Yeah, it's like they go from parallel play, where they're just kind of playing alongside each other, to really engaging with their peers, forming friendships and sharing and learning how to navigate those social situations.
Play becomes like their main way of learning about the world, developing social skills, problem solving, fostering their creativity. It's essential for their development.
And then before you know it, that school bell rings, and a whole new chapter begins the school-age years, 6 to 12.
This is when those permanent teeth finally start coming in, replacing all those baby teeth that cause so much trouble.
And their thinking starts to change, too. They go from just trying to avoid getting in trouble to actually wanting to please others and get their approval.
Right. They're developing a sense of what's right and wrong based on the rules and expectations of their family, school, society.
Like they're figuring out the rules of the game.
Exactly.
I remember reading about this as conventional reasoning. Is that right?
You got it. It's a big step in their moral development. And as they navigate this new social landscape, their sense of self starts to solidify too. Who they are, what they're good at, how they fit in.
That brings us to self-concept and self-esteem. This must be such a sensitive time for them. So much confidence, but also so many insecurities.
Absolutely. They're always comparing themselves to others, trying to figure out where they stand. It's a challenge, but it's also a huge opportunity for growth and self-discovery.
It's amazing how all these different aspects of development, physical, cognitive, emotional, social, they're all woven together.
It really is a complex and fascinating interplay, and as we'll see, it continues throughout the lifespan.
Well, speaking of complex and fascinating, let's move on to those, shall we say, turbulent teenage years, adolescence 13 to 18.
Buckle up. Hormones are surging, emotions are running high, and the quest for identity takes center stage.
Oh, I can only imagine the emotional roller coaster they're on.
Think about it. Their bodies are going through a huge transformation with puberty, and at the same time, they're wrestling with questions of independence, relationships, their place in the world.
It's no wonder the textbooks talked about an increased risk of, mental health struggles during this stage, like depression and anxiety.
It is a vulnerable time. It's so crucial for teenagers to have strong support systems, supportive relationships and access to resources if they need help navigating these challenges.
That makes open communication and understanding so important during these years.
Absolutely. They need to feel heard and validated and supported, even if they don't always show it.
And then from all that intensity, we move into early adulthood, 19 to 40.
Often a time for building careers, strengthening those close relationships, and, for many, starting families.
Like they've weathered the storm and are now setting out on their own.
Yeah. And while they actually reach their physical peak during this time, we also start to see the first subtle signs of aging.
Oh, you mean like those first few gray hairs we find? Or maybe feeling a bit stiff after, long day?
Those, and also things like the intervertebral discs in our spines, they start to settle.
So our spines are like compressing over time.
Exactly, yeah. And naturally, we gain some fat and lose a little muscle mass. It's all a natural part of the aging process.
Then before we know it, we're in middle adulthood, 41 to 60. I read that this can be a time of, reflection and reassessment.
It often is. Life goals can shift, kids might be moving out, health concerns might become more of a focus.
Plus, we've got those physical changes we can't ignore. Declining vision and hearing. And of course, for women, menopause is a major transition.
Yeah. Menopause brings a whole cascade of hormonal shifts. It can impact both their physical and emotional well-being.
The textbooks also mention some social and emotional challenges during this time, like increased loneliness, worries about finances, anxiety about retirement. Sounds like a lot to handle.
It can be a time of both fulfillment and challenge. Individuals might reevaluate their priorities, find new passions, or focus on, deepening those important relationships.
And then we enter late adulthood, 61 and beyond, the golden years.
Often seen as a time of wisdom and reflection, hopefully continued growth too.
Though the textbooks were pretty clear about the physiological changes that come with aging, especially for things like, our cardiovascular systems, our lung capacity, even brain function.
Our bodies do slow down, but that doesn't mean life stops being vibrant and meaningful. Maintaining those connections, staying active, and adapting to changes all contribute to a fulfilling life, even in those later years.
That terminal drop hypothesis really stuck with me. The idea that mental function tends to decline more rapidly in, like, the last 5 years of life. It's fascinating and a bit sobering at the same time.
It is. It reminds us of our mortality, but it also invites us to appreciate every stage of life and make the most of the time we have.
And for some, making the most of that time might involve exploring options like, assisted living communities, where they can receive some extra support while still maintaining a sense of independence.
Exactly. It's about finding the right balance for a comfortable and fulfilling life as we age.
So we've covered a lot of ground today. From infancy to late adulthood, exploring all the amazing transformations that happen throughout the human lifespan. But before we move on to part 2, let's take a little detour. Let's dive into the world of neonatology, where even the tiniest humans are facing those unique challenges and triumphs.
That's where we really see the resilience and adaptability of the human body, especially in those first few crucial hours and days.
Absolutely. Speaking of crucial moments, let's go back to that incredible transition from fetus to newborn. What happens in those first few moments after birth?
It's remarkable. For 9 months, a baby's getting oxygen and nutrients through the placenta. But once the umbilical cord is cut, their lungs have to take over that vital task of breathing.
It's amazing to think that those tiny lungs that have been basically dormant have to suddenly function on their own. I can see why the textbooks emphasized how important skilled care is during this time, especially for preemies or maybes born with other medical conditions.
Exactly. And that transition isn't always smooth. Sometimes there can be delays in a newborn's breathing, and that can lead to complications, like hypoxia,
Hypoxia.
which is just a lack of oxygen. And premature babies are especially at risk because their lungs might not be fully developed yet.
That makes sense.
Yeah.
What are some other things that can complicate that transition?
Oh, a number of things. Issues with the placenta during pregnancy, infections, congenital abnormalities. All these things can impact a newborn's ability to breathe effectively.
So what happens when a newborn struggles to breathe after birth?
That's where neonatal resuscitation comes in. A series of steps to support the baby's breathing and circulation to make sure they're getting enough oxygen.
Can you walk us through some of those steps?
Well, often the first step is as simple as drying the baby off and gently stimulating them. That can often encourage them to take that first breath. If that's not enough, then we might need to provide supplemental oxygen. or use a bag mask device to help them breathe.
I've seen those in hospitals. They look a bit intimidating.
They do, yeah.
But they can be life-saving for those babies who need that extra help. In the more serious situations, I've heard they might even need chest compressions.
That's right. Though we do use a special technique because, of course, their bones are still so delicate. It's a highly specialized skill that requires a lot of training and experience.
Wow, that's intense. It really highlights the expertise needed to care for these tiny humans.
It does, and we've only just scratched the surface of all the challenges and triumphs that can happen in those first few crucial hours and days.
Welcome back. I'm ready to go even deeper into this world of neonatology. It's fascinating to think about all the special care these tiny humans need.
It is, and it's a field that keeps evolving as we learn more about those unique challenges that newborns can face.
Yeah, in the last part, we talked about that critical transition from fetus to newborn and how those first few breaths can be tricky.
Right, and sometimes those breathing challenges, well, they can continue even after that initial transition.
The textbooks call that respiratory distress, right?
Exactly, it's just a general term.
Yeah.
Basically means a baby's having trouble breathing effectively.
I imagine that's pretty common, especially for preemies.
Yeah, prematurity is definitely a major risk factor. But there are others too. Infections, inhaling meconium during birth, congenital abnormalities like that diaphragmatic hernia we discussed.
Oh, right. The one where there's a hole in the diaphragm.
Exactly.
So those abdominal organs push up into the chest cavity.
Yeah, it's a serious condition, but thankfully surgical techniques have come a long way, so these babies have a much better chance of survival now.
And you mentioned meconium. That's the baby's first stool, right?
Yeah.
I remember reading that if a baby inhales that during birth, it can cause breathing problems.
It's true. It's called meconium aspiration syndrome. It can happen if a baby's under stress during labor. The meconium can irritate and block their airways.
Making it hard to breathe. So how do doctors know if a baby's in trouble? Like, are there any signs to watch out for?
We look for things like, rapid breathing, grunting sounds, a bluish tint to their skin, and retractions, which is where the skin between their ribs pulls in with each breath.
Oh, wow.
It's like their little bodies are working overtime to get air in.
Sounds scary. So what can doctors do to help when a baby's struggling like that?
The first thing is to make sure their airway is clear and give them supplemental oxygen if they need it. We might need to help clear their airways by suctioning.
I've heard about, in more serious cases, them needing to be intubated, where a tube is placed in their airway to help them breathe.
That's right. It's more invasive, but can be life-saving for those with severe respiratory distress. They might also need to be put on a ventilator.
A machine that breathes for them. Wow, it really makes you realize how vulnerable those tiny humans are. The textbook also mentioned apnea. What exactly is apnea?
Apnea is when a baby stops breathing for 20 seconds or more. It can be alarming for parents to see, but it's actually fairly common, especially in premature infants.
Why is that? Do their lungs just forget to work?
It's not that they forget, it's that their brainstem, which controls their breathing, is still maturing. Sometimes the signal just takes a little longer to get from the brain to the lungs.
Okay, so their systems are still catching up.
Right, and apnea can also be a sign of other problems too. Infections, heart issues, things like that. So it's really important to figure out the cause.
To address the root of the problem, so how is apnea treated? Is it something that usually resolves on its own?
Sometimes just gentle stimulation is enough, like a little nudge to remind their body to start breathing again. In other cases, they might need extra oxygen or a CPAP machine, which helps keep their airways open.
It sounds like there's a lot to monitor when it comes to a newborn's breathing. Speaking of monitoring, the textbook also emphasized how crucial temperature regulation is for these little ones. Why is that such a big deal?
Well, newborns, especially preemies, have a really hard time regulating their own body temperature. They lose heat so easily, and their little bodies haven't quite figured out how to generate enough heat to stay warm on their own.
Like little radiators that haven't been turned on yet?
That's a good way to put it. They are producing some heat, but not enough to keep up with what they're losing.
I remember bundling up my newborns in so many layers. But it sounds like there's more to it than just adding blankets.
You're right. Skin-to-skin contact with a parent, that's one of the best ways to help them regulate. It's like a natural incubator.
Makes sense. Warm, cozy, and secure.
Exactly. And of course, in hospitals, they use those incubators, those enclosed beds that can provide a controlled environment with the right temperature and humidity.
So keeping babies warm is super important, but what about the flip side? Like overheating? Can that be a
Yeah.
problem too?
Absolutely. Overheating can be just as dangerous. It can lead to dehydration and just make them uncomfortable in general.
So how do you know if a baby's too hot? Do they get fevers like we do?
Well, a fever in a newborn is very serious. It's a sign of an infection and needs immediate attention. But sometimes a baby might just be overdressed or in an environment that's too warm. So we check their temperature regularly.
And adjust their clothing and surroundings.
Exactly. It's about finding that sweet spot where they're comfortable and their temperature is stable.
What about feeding? That seems like another crucial aspect of neonatal care.
Oh, it's essential. It's how they get the energy and nutrients they need.
And everyone knows breast milk is best, right?
Breast milk is the ideal food, yes. It's full of antibodies to help protect them from infections, and it's easier for their little tummies to digest.
But sometimes, for whatever reason, breastfeeding isn't possible.
That's right.
So what happens then?
That's where formula comes in. There are many different types, and we can help parents choose the best one for their baby.
And how often are newborns feeding? I vaguely remember those round-the-clock feedings.
Oh, yeah. They typically need to eat every 2 to 3 hours, day and night. Their stomachs are tiny, so they need those frequent small meals.
It's no wonder new parents are always exhausted. Speaking of challenges, the textbooks also touched on birth injuries. It's hard to imagine anything going wrong during birth, but it sounds like it's something doctors have to be prepared for.
Unfortunately, yes. Sometimes things don't go perfectly during labor and delivery, and injuries can happen.
Earlier you mentioned caput succedaneum. Can you remind me what that is again?
Sure, it's basically just a swelling of the scalp that happens when the baby's head is pressed against the cervix during labor. It's just a collection of fluid under the skin.
It's like a big bump on their head.
Yeah, you could say that. It can look alarming, but it's usually harmless.
And what about cephalometoma? That one sounded a bit more serious.
Cephalometoma is a collection of blood, but under the periosteum. That's the membrane that covers the skull bones. So it takes a bit longer to heal than caput, and there's a small risk of infection.
But in most cases, it's still not a huge cause for concern.
Right. It usually goes away on its own. We just keep an eye on it to make sure there are no complications.
Are there any other common birth injuries, like to the limbs, for example?
One we see sometimes is a brachial plexus injury. This is damage to the nerves that control the arm and hand.
How does that happen?
It can happen if the baby's shoulder gets stuck during delivery, so their head is out, but the shoulder gets caught behind the mother's pubic bone. And that can stretch or tear those brachial plexus nerves, which run from the neck down to the arm.
Ouch. So what are the long-term effects of something like that?
It really depends on how severe the injury is. Some babies just have temporary weakness, others might have some paralysis.
So early intervention is key.
Absolutely. Early diagnosis and treatment, which might include things like physical therapy, splinting, even surgery, can make a big difference.
Wow, it's incredible how far our understanding of neonatal care has come.
It really is. We've made huge strides in improving outcomes for newborns, but there's always more to learn.
I'm feeling even more amazed by these little humans and how resilient their bodies are. But before we wrap up part 2 of our deep dive, I want to explore a bit more about some specific conditions that can affect newborns.
Okay, sounds good. Let's start with meconium aspiration syndrome. We touched on that a bit earlier.
Right, that's with a baby inhales meconium during labor or delivery, which can then cause breathing problems.
Exactly. Meconium is sticky, and it can really irritate a baby's airways, making it hard for them to get enough oxygen.
So what can doctors do to help a baby with that?
Well, if the baby's doing okay after birth, vigorous, crying, we might just suction out their mouth and nose to remove any meconium that's there. But if they're showing signs of respiratory distress, then they might need more intensive support.
Like what?
They might need extra oxygen, help breathing with a bag mask device, even intubation and mechanical ventilation.
Wow, okay. Another condition mentioned in the textbook was a diaphragmatic hernia. Can you remind me what that is and why it's so serious?
Sure, it's a birth defect where there's a hole in the diaphragm. That's the muscle that separates the chest cavity from the abdomen. This lets abdominal organs move up into the chest, and that puts pressure on the lungs, making it hard to breathe.
Sounds scary.
It is a serious condition, but thankfully surgical techniques have advanced, and now those babies have a much better chance of survival.
We've also talked about apnea, where a baby stops breathing for a while. You said prematurity is a common cause. But what are some other things that can trigger apnea in newborns?
Oh, various things. Infections, seizures, heart defects. Even reflux can cause it.
Wow. Sounds like doctors have to be real detectives, figuring out what's causing the apnea and how to best treat it.
You could say that. We have to consider all the possibilities and do tests to figure out the underlying cause. And of course, the treatment depends on what we find.
So it could be as simple as some stimulation to remind the baby to breathe, or more intensive like oxygen or that CPAP machine.
Exactly. It's about giving the right support based on that individual baby's needs.
Wow, we've covered a lot today.
Yeah.
From common newborn conditions to all sorts of specialized care techniques. Anything else you wanted to touch on before we wrap up part 2?
Oh, yes. There's one more condition that's pretty common, jaundice.
Oh, right. That's the one that makes the baby's skin and eyes look yellow.
Exactly. It's caused by a buildup of bilirubin in the blood. Bilirubin is a yellow pigment that's produced when red blood cells break down.
And is that serious? My baby's had a bit of jaundice, but it seemed to go away on its own.
Yeah, most cases are mild and do resolve on their own, but high levels can be harmful, especially to the baby's developing brain. So it's something we watch carefully.
So how do you treat it if it doesn't go away on its own?
One common treatment is phototherapy. We use special lights to help break down that bilirubin.
Oh, I've seen those in the hospital nurseries. They look like tanning beds, but for babies.
Huh, you're not wrong. The light converts the bilirubin into a form that's easier for the baby's body to get rid of.
Well, this has been an incredibly informative look at the world of neonatology. It's amazing how much goes into caring for these tiny humans and how much we've learned about their unique needs.
It's a field that's both challenging and so rewarding. To see these fragile newborns thrive, it's truly amazing.
I'm excited to hear more in the final part of our deep dive. Let's take a quick break and come back ready to explore even more fascinating insights into the world of human development. Welcome back to our final part. We've covered so much already, from those incredible transformations in infancy to the delicate world of neonatology.
It has been quite a journey, exploring all the things that shape our lives from the very beginning all the way to later life.
I know. It's amazing to think that we all started as these tiny, completely dependent newborns. And here we are now, navigating the complexities of adulthood.
It really is. And it shows how resilient and adaptable we are as humans, you know. We face challenges, we learn, we grow, and we keep going.
Speaking of challenges, I want to go back to those birth injuries for a minute. We talked about them a bit earlier, but I'm curious to hear more about, what kinds of injuries can happen and how they're treated.
Of course. We talked about how they can range from minor things that heal quickly to more serious ones that need special care. And thankfully, most babies go through labor and delivery just fine.
You mentioned a couple of those common head swellings, caput suxvadium and cephalometoma. Can you remind me what those are again and how they're different?
Sure. So caput suxadium is basically a swelling of the scalp, from pressure on the baby's head during labor. It's kind of a soft, squishy bump that can even go across those suture lines on the skull.
So like a temporary bruise or swelling from being squeezed through the birth canal.
Exactly. It usually fades away on its own in a few days. No treatment needed.
Okay, and cephalometoma. That one sounded a bit more serious because there's bleeding involved.
Right. Cephalometoma is a collection of blood, but it's between the skull bone and the periosteum, the membrane that covers the bone. So it appears as this firm bump, and it doesn't cross suture lines.
Oh, that's interesting. Why not? Does that have something to do with how the baby's skull is structured at birth?
Yeah, you're right. A newborn skull has several bony plates connected by flexible tissues called sutures. And those sutures allow the skull to kind of mold and change shape during birth, which is incredible. And with cephalometoma, the bleeding is actually contained within, the boundaries of one skull bone.
So it's like a little pocket of blood that's limited to one area.
Exactly. It usually takes a bit longer to resolve than caput, sometimes a few weeks or even months.
And are there any long-term effects?
In most cases, no. It just absorbs on its own over time. Sometimes, a small hardened lump might remain, but it's usually nothing to worry about.
Good to know.
Yeah.
But are there any potential complications to be aware of?
There's a slight risk of infection, so we watch those closely. And if needed, we treat with antibiotics. And we also watch for signs of jaundice because, the breakdown of those red blood cells in the hematoma, that can contribute to that bilirubin buildup.
Right, we talked about jaundice earlier. That's what makes the baby's skin and eyes look yellow.
Exactly. Something we keep a close eye on, especially with these little ones.
Okay, so we've got those head swellings covered. What about injuries to, other parts of the body? I know we were reading about brachial plexus injuries earlier.
Yes, those involve damage to the nerves that control the arm and hand.
Can you walk me through how that can happen during birth?
It can happen if there's difficulty delivering the baby's shoulder. So the head might be out, but the shoulder gets stuck behind the mother's pubic bone, and that can stretch or even tear those nerves. The brachial plexus nerves, they run from the neck down to the arm.
Oh, wow. That sounds really painful.
It can be, and the severity varies. Some babies just have weakness that goes away, but others might have some paralysis in the arm.
And what about long-term effects? Are there any?
It really depends, again, on how bad the injury was. Some babies recover fully, with time and physical therapy, but in more severe cases, there could be some lasting weakness or even disability.
Sounds like early intervention is really critical then.
Absolutely. Early diagnosis and treatment, things like physical therapy, splinting, or even surgery, can make a huge difference in helping these babies regain as much function as possible.
It's incredible to think about how fragile these newborns are, and yet how resilient their bodies are at the same time.
It is. And it also highlights just how important it is to have that skilled medical care during labor and delivery.
Yep.
Obstetricians, nurses, everyone is trained to look out for potential problems and to intervene quickly if needed.
It really makes you appreciate their work.
For sure. Bringing new life into the world, it's an amazing, complex process.
Well, we've been on quite the journey. From those first moments of life, through infancy, childhood, adolescence, even into adulthood. We explored the world of neonatology with all the challenges and triumphs that come with caring for those tiny humans, and all the amazing advancements that have been made.
It's been fascinating to look at the complexities and wonders of the human lifespan.
I'm definitely walking away with a deeper sense of awe and gratitude for this gift of life, and for all those intricate processes that make it possible.
It's a journey for all of us, full of challenges, triumphs, growth, and change, and it's a journey that connects us all, no matter our age or where we are in life.
I love that. Thank you for joining us on this deep dive into human development. We hope you learned something new today, and maybe even gained a new appreciation for the miracle of life in all its stages.
Absolutely. Until next time, keep exploring, keep learning, and keep marveling at the world around you. Hey everyone, and welcome to this deep dive. It's going to be all about female reproductive anatomy and obstetrics.
That's right.
We'll be taking all of our information from 2 medical textbooks.
Yes, one is all about gynecologic emergencies.
And the other one covers obstetrics.
Should be pretty interesting.
Yeah, so we're going to be uncovering some really fascinating things about this system. It's way more complex than most people even realize.
For sure.
Okay, so one more thing before we get started. I always love looking at the origins of words.
Right.
And did you know that the term pudendum,
Mm.
it refers to the external female genitalia, and it comes from the Latin for to be ashamed.
Oh, wow.
It's crazy, right?
Yeah, that is kind of ironic.
Like, why should we be ashamed of this vital part of the body?
Right, it really speaks to the historical context surrounding female anatomy.
Yeah, for sure. So let's forget about all that shame and get into the actual anatomy.
Okay.
We all know about the labia, but what do they actually do?
Well, the labia majora are the outer folds. Think of those as the bodyguards. They're covered in hair. They provide cushioning and protection for the more delicate inner parts.
So they're kind of like a first line of defense.
Exactly. And then you've got the labia minora.
The inner folds, right?
Yes, those are much more sensitive.
Gotcha. And of course, we can't forget about the clitoris.
Right.
I know it's not just about pleasure. It's got a pretty important structure, too.
Absolutely. It's packed with nerve endings.
Really?
More than any other part of the body, actually,
Yeah.
which is why it's so sensitive.
Mm.
Here's a fun fact.
Okay.
It's actually a lot larger than it appears.
Oh, really?
It extends internally as well.
That is definitely not something you learn in high school health class.
Nope.
Okay, what about the vestibule? It sounds kind of like an entryway.
It is basically the area that houses the openings for the urethra and the vagina.
Oh, okay.
But here's where it gets interesting.
Okay.
It also contains these tiny glands called Bartholin's glands.
Ah, I've heard of those.
They can cause some issues.
Yeah, they're the ones that can get blocked, right?
Yeah.
Exactly. They're responsible for lubrication during sex,
Okay.
but they can get blocked and form cysts.
And that's super painful, I've heard.
Yeah, they can be really painful.
So even these tiny little parts can have a big impact.
Right.
Speaking of big impacts, let's talk about menstruation.
Oh,
It's way more than just bleeding once a month. There's a whole symphony of hormones going on behind the scenes that most people don't realize.
yeah, it's a complex cycle.
So break it down for me.
So you've got estrogen and progesterone.
Uh-huh.
Those are produced by the ovaries, and they work together to thicken the uterine lining to prepare for a potential pregnancy.
So the body's always getting ready just in case.
Yeah, kind of like it's always prepping for the possibility of a baby.
What happens if the egg doesn't get fertilized?
Well, then the lining sheds, and that causes the bleeding that we know as a period.
Right, makes sense.
But here's something that most people don't know.
Okay.
During the follicular phase, that's when the egg is maturing.
Uh-huh.
One follicle will actually become dominant, and the others kind of fade away.
Oh, wow.
It's like a competition to see which egg gets released.
Survival of the fittest, even on a microscopic level.
Exactly.
Wow. Okay, so let's say an egg actually does get fertilized.
Right.
What happens? Then I know it implants in the uterus, but what does that actually look like?
Well, the fertilized egg, we call that a zygote.
Okay.
It starts dividing really rapidly and becomes a blastocyst.
Oh, what?
A blastocyst.
Okay.
Just imagine a tiny little ball of cells burrowing into the uterine lining.
So kind of like a seed planting itself in the ground.
That's a great analogy.
Okay.
And sometimes this implantation process can actually cause a little bit of bleeding.
Oh, really?
So someone might think that their period is starting, but it could actually be a sign that they're pregnant.
That is mind-blowing. There
Yeah.
are so many things that we just don't learn about our own bodies.
Right.
Now, what about the placenta? I know it's important, but I never really understood what it does.
Well, the placenta is like the ultimate multitasker.
Yep.
Think of it as the baby's lifeline. It provides everything that it needs to grow and thrive.
Okay.
It acts as the baby's lungs, liver, kidneys, and even its immune system,
All in one.
all rolled into one.
So it's basically doing the work of all these organs before the baby's organs are fully developed.
Exactly. And it also acts as a barrier.
Okay.
It filters out any harmful substances from the mother's blood.
Huh.
And it delivers nutrients and oxygen to the baby through the umbilical cord.
Speaking of the umbilical cord, I know it connects the baby to the placenta, but what's it made of?
Well, it's basically a superhighway of blood vessels.
Okay.
But here's a curious thing.
What's that?
It has 2 arteries and 1 vein.
Isn't it usually the other way around?
Yeah, usually it is in the body.
And why is that?
It's one of those anatomical quirks that scientists are still kind of scratching their heads about.
Interesting.
But it works.
Right. And another mind-blowing thing I think about fetal development is that the baby's blood actually bypasses the lungs completely. It gets all the oxygen it needs from the placenta.
Exactly.
I mean, that makes sense. The baby isn't breathing air yet. But how does the blood know to just skip the lungs?
Well, there are special shunts.
Shunts.
Yeah, they're like detours in the fetal circulatory system.
Okay.
They divert blood flow away from the lungs until birth.
Uh-huh.
And then when the baby takes its first breath,
Yeah.
those shunts close,
Yeah.
and then the blood starts flowing to the lungs like it's supposed to.
Wow. The body just knows what to do at each stage of development.
It really is amazing.
It is. What about the amniotic sac? It's filled with fluid, right? What's the purpose of that?
So the amniotic sac is like a cozy, weightless swimming pool for the baby.
Okay.
It cushions the baby from bumps and jolts.
So like a little shock absorber.
Yeah, and it allows for free movement, and it helps maintain a stable temperature.
So it's not just about protection. It's about creating this perfect environment for the baby to develop.
Exactly, and those first few weeks of pregnancy are super crucial.
Yeah. Why is that?
From week 4 to week 8, the baby's organs are forming really rapidly.
Mm-hmm.
Even seemingly harmless things can have a big impact.
Like what?
Oh, like certain medications, certain foods. That's why prenatal care is so important.
Especially in those early weeks.
Right.
Speaking of timing, how is the due date actually calculated? I know it's 40 weeks, but is that from conception?
It's actually calculated from the first day of the last menstrual period.
Oh, so it's not from conception.
No, it's not.
Yeah.
So it adds about 2 weeks to the actual gestational age, which is about 38 weeks.
So even though the baby isn't conceived until ovulation, the countdown starts from the beginning of the cycle.
Exactly. It's a way to standardize the calculation and make sure that everyone's on the same page.
That makes sense.
Yeah.
Well, this has been so interesting already. I'm learning so much.
Me too.
And we've got lots more to cover, so stay tuned.
Definitely. All right, so we're back.
We are back, and now we're going to be talking about
Pregnancy.
but specifically the things that can make pregnancy a little more complicated.
Yeah, there are some medical conditions that can have an impact.
Yeah, so we're going to go through some of these medical conditions
Right.
that can make pregnancy a little bit more challenging.
Absolutely.
So we're talking about things like substance abuse, heart disease, hypertension,
Nope.
seizures even.
It's crucial for women to have really open and honest conversations with their healthcare providers.
Yeah, so they can get that personalized support.
Exactly.
So let's start with substance abuse.
Okay.
Obviously a tough topic,
It is.
but a really important one.
It's something that we have to talk about.
Yeah, and I think sometimes people don't realize that anything a pregnant woman uses crosses the placenta,
Right. It can affect the baby.
and that can be anything.
Yeah, anything.
Like even things that people think are
harmless
Excellent.
can have a huge impact on a developing fetus.
Right, and the consequences can be really devastating.
Yeah, like what kind of consequences are we talking?
Well, it can lead to birth defects, developmental delays, and even something called neonatal abstinence syndrome.
Neonatal what?
Neonatal abstinence syndrome.
What is that?
So the baby is essentially going through withdrawal
Oh.
after birth because they've been exposed to those substances in the womb.
Oh, wow, that's so sad.
Yeah, it's heartbreaking. And it really highlights the need for compassionate care and support for these pregnant women who are struggling with substance abuse.
Yeah, for sure. Now, what about heart disease?
Okay, so pregnancy puts a lot of extra strain on the heart.
Yeah, because you're basically doing the work of two people at that point.
Right, so any pre-existing heart conditions need to be really carefully monitored.
And managed.
Yeah.
I mean, it's like asking your heart to run a marathon while you're carrying a backpack.
That's a great way to put it.
That's a lot of extra work.
It is. And the increased blood volume and cardiac output during pregnancy can actually worsen those
It
symptoms.
can increase the risk of complications.
Exactly. So it's not just about the baby's heart developing.
Right.
It's also about the mother's heart working overtime to support both of them.
Yeah, that's a good point. Okay, so another big concern, I think, during pregnancy is hypertension.
Right.
High blood pressure.
And there are different types of hypertension,
Okay.
each with its own set of risks.
So I'm guessing one of those is preeclampsia,
You got it.
which I've heard can be really dangerous.
It is a serious condition.
And when does it usually develop?
Usually after 20 weeks of pregnancy,
Okay.
it involves high blood pressure protein in the urine,
Yeah.
and it can even affect other organ function.
So it's not just about the blood pressure itself, it's the domino effect that it can have on other systems in the body.
You got it. Early detection is really key, and the treatment usually involves medication,
To lower blood pressure.
right, and sometimes magnesium sulfate to prevent seizures.
Speaking of seizures, those can be pretty scary for anyone, but especially during pregnancy.
Right.
What causes seizures during pregnancy?
Well, they can be caused by a variety of factors,
Okay.
including preeclampsia, epilepsy, or other underlying conditions.
And why are they so dangerous during pregnancy?
Well, seizures deprive the brain of oxygen,
Right.
and that can obviously harm both the mother and the baby.
So it's like a double whammy.
Yeah, they're both being affected at the same time.
So how are seizures treated during pregnancy?
Well, typically with medications.
But there are a lot of different seizure medications.
Right, the choice of medication is crucial.
Okay, so which ones are usually used?
Magnesium sulfate is often preferred
Okay.
because it's really effective at preventing seizures,
Uh-huh.
and it's generally considered to be safe for the baby.
So it's all about that balance, you
Yeah.
know? Treating the mother and protecting the baby.
Exactly.
Okay, let's talk about another condition
Okay,
that is pretty common during pregnancy.
right.
Diabetes.
All right.
We've already talked about gestational diabetes, which
Yeah.
develops during pregnancy. But what about women who have diabetes before they get pregnant?
Right, so pre-existing diabetes
Requires careful management.
throughout the entire pregnancy.
Why is that?
Well, it's all about keeping those blood sugar levels nice and stable
Okay.
to minimize the risk of complications.
For both the mother and the baby.
Exactly.
What kind of complications are we talking about?
Well, for the baby,
Okay.
there's an increased risk of birth defects, preterm labor, and even being born too large.
And that can obviously make delivery more difficult.
Yeah, and for the mother, there's a higher risk of preeclampsia,
Uh,
infections, and other pregnancy-related problems.
so it really affects every aspect of the pregnancy.
It does.
Wow. Okay, let's move on to respiratory issues now.
Okay.
So asthma is a common problem.
Right.
That can actually be made worse by pregnancy.
Uh-huh.
I mean, I can see how being pregnant could make it harder to breathe with all those hormonal changes
Right.
and the growing baby.
Especially on your diaphragm.
Yeah, exactly. So what can women with asthma do to manage that?
Well, it's important for them to work closely with their healthcare provider
Okay.
to manage their condition and to minimize the risk of those asthma attacks.
Because those attacks can be dangerous, right?
Absolutely. They're not just uncomfortable.
Yeah. Okay, and then there are some more serious respiratory conditions like cystic fibrosis, that's
Yeah.
a genetic disorder,
Uh-huh.
that can complicate pregnancy.
Really can.
I mean, I imagine pregnancy with cystic fibrosis would be incredibly challenging.
Yeah.
Given the impact that it has on the lungs.
Right. And it really highlights the importance of specialized care
Yeah.
and a multidisciplinary approach to managing those complex medical conditions during pregnancy.
That's a good point. Okay, now let's talk about something that is not life-threatening.
Okay.
But it can make pregnancy absolutely miserable.
Right.
Hyperemesis gravidarum.
Oh, yeah.
And it's way more than just morning sickness.
It is.
It's like morning sickness on steroids.
It's characterized by severe, persistent nausea and vomiting that can lead to dehydration, malnutrition, and even hospitalization in some cases.
Yeah, I've heard stories of women who are so sick they can't even keep water down.
Yeah.
It sounds awful.
It can be really debilitating.
So are there any treatments for it?
Thankfully, there are treatments.
Like what?
Intravenous fluids
Uh-huh.
and anti-nausea medications can provide some relief.
Okay, good to know. Now, what about kidney problems or renal disorders as they're called?
Right.
How do those affect pregnancy?
Well, pregnancy puts extra stress on the kidneys anyway.
Yeah, just in general.
Yeah, so any pre-existing kidney conditions can actually worsen.
Okay.
It also increases the risk of urinary tract infections,
Right.
which can be really painful
Yeah.
and potentially dangerous if they're not treated.
So it's like a double whammy for the kidneys, you know.
Yeah,
They're working harder and they're more susceptible to infection.
exactly.
Okay, and then you've got those inherited blood disorders like sickle cell disease,
Right.
which can also have serious implications during pregnancy.
Absolutely.
I know that sickle cell disease can cause a lot of pain and complications in general.
Uh.
So I imagine pregnancy would make those challenges even worse.
It really can. And it highlights the importance of preconception counseling.
For women with those genetic conditions.
Right, so they can discuss the potential risks and the management options.
Yeah, it's always good to be informed and prepared.
Absolutely.
Okay, so what about RH sensitization?
Okay.
I've heard that can be a problem in some pregnancies.
So RH sensitization occurs when a mother is RH negative
Okay.
and her baby is RH positive.
Uh-huh.
It's basically an immune response.
What does that mean?
So the mother's body sees the baby's blood as foreign,
Oh.
and it starts producing antibodies against it.
So it's like an internal battle going on?
It is, and those antibodies can cross the placenta
Oh,
and attack the baby's red blood cells.
that's not good.
Yeah, it can lead to anemia and other complications.
So what can be done about that?
Well, thankfully, there are treatments available
Okay.
to prevent RH sensitization from happening.
So how does that work?
Well, women need to be tested
Okay.
and then receive appropriate care.
Okay. Okay, good. Now let's talk about a common infection that a lot of pregnant women are screened for.
All right. Group B strep.
Yep. Group B strep is a type of bacteria that can be found in the vagina and the rectum.
Okay.
It's usually harmless to adults. It can be passed on to the baby during delivery.
And that's where the risk is.
That's where the risk is.
So it's not about the mother being sick. It's about the potential for the baby to get infected
Exactly.
during birth.
During a birth.
And those infections can be pretty serious, right?
Yeah, it can lead to pneumonia,
Uh-huh.
sepsis, and even meningitis in the newborn.
Oh, wow. That sounds scary.
Yeah.
But thankfully, they test for it during pregnancy.
Yes, routine screening is standard.
Okay.
And if a woman tests positive,
Yeah.
she'll get antibiotics during labor.
To prevent transmission to the baby.
Archaic.
So it's just a simple measure.
Right.
That can make a world of difference.
It really can.
Now, what about other infections,
Okay.
like viral or parasitic infections?
Those can be a concern too.
Yeah.
The timing of the infection is really important.
Okay.
So early exposure
During pregnancy.
can actually lead to developmental issues in the fetus,
Okay.
whereas later infections might
Yeah.
cause more specific problems,
Depending on the type.
depending on the type.
So it's like a race against time
Yeah,
with different consequences depending on when that infection actually occurs.
that's a great way to think about it.
Okay, and remember we were talking about epilepsy earlier.
Yes.
Well, pregnancy can actually have a really complex impact on seizure activity.
Yeah, it's not a one-size-fits-all situation.
Right.
Some women might have fewer seizures during pregnancy. Some might have more.
So how do you manage that?
Managing the epilepsy medication is really crucial.
Right.
Because some medications can actually harm the fetus.
Right.
So it's a delicate balancing act.
Yeah, it's all about weighing those risks and benefits and finding the best course of action.
For both the mother and the baby.
Exactly. Okay, now let's talk about another important gland, the thyroid.
Okay. I know thyroid disorders can affect anyone, but how do they play out during pregnancy?
Well, both hyperthyroidism,
Okay.
which is an overactive thyroid,
Uh-huh.
and hypothyroidism,
Underactive
underactive thyroid.
can pose risks during pregnancy. So what are the risks?
So with hyperthyroidism,
Okay.
it can lead to things like preterm labor, low birth weight,
Uh-huh.
whereas hypothyroidism, if
Yeah.
it's left untreated,
Uh-huh.
that can actually affect the baby's brain development.
Oh, wow. So it's not just about the mother feeling tired or sluggish.
it can actually have long-term consequences for the baby.
Exactly.
So managing these thyroid disorders
Is crucial.
for a healthy pregnancy.
Yes.
Okay, and finally, let's touch on a liver condition called cholestasis of pregnancy.
Okay.
Now, I've heard of that one. It causes really intense itching, right?
Yes, it's characterized by severe itching,
Okay.
usually on the hands and feet.
Uh-huh.
And it's caused by a buildup of bile acids in the liver.
Oh,
So while it's relatively harmless to the mother,
okay.
it can be really dangerous for the baby.
In what way?
It increases the risk of preterm birth and even stillbirth.
Oh, wow. So it's one of those conditions that's more about the baby's well-being than the mother's.
Yeah,
Wow, we've covered a lot of ground here. It's amazing to think about all the things that can potentially affect a pregnancy.
it is,
I mean, it really highlights the importance of prenatal care
for sure.
and having a strong support system.
Absolutely. And it's a testament to the resilience of the human body and its ability to adapt to these challenges.
It really is. All right, so we are back for the final part of our deep dive.
That's right.
We've gone over a lot.
Yeah, from the basics of anatomy to all the potential complications during pregnancy.
Exactly. And now we're going to talk about the main event, labor and delivery.
The culmination of this incredible journey, the moment everyone anticipates.
Okay, so let's break down what actually happens during a typical labor and delivery.
Okay.
Now, I know there are different stages. Can you walk us through those?
Of course. So labor is essentially a process of preparation and progress.
Okay.
So that first stage is all about getting the cervix ready for the baby to pass through.
Okay, so this is where those contractions come in, right?
Exactly. At first, the contractions are pretty mild
Okay.
and irregular, kind of like practice runs.
Like a warm-up.
Yeah, exactly. And then as labor progresses, they get stronger and more frequent.
And what's happening to the cervix during this time?
So the cervix has two major jobs during labor.
Okay.
First, it has to thin out,
Okay.
which we call effacement.
Effacement, what does that actually mean?
Imagine a thick rubber band
Okay.
becoming thinner and more stretched out.
Okay, I can kind of picture that.
And then the second job of the cervix
Yeah.
is that it needs to dilate or open up
Uh-huh.
to allow the baby to pass through.
Okay, so how big does it have to get?
Fully dilated is about 10 centimeters.
10 centimeters. Wow, that's pretty big.
It is. We actually use our fingers to measure this during those cervical checks.
Yeah. Wow. So the first stage ends when the cervix is fully dilated.
Yep. That's when we move into the second stage of labor,
Okay.
which is all about pushing.
This is the part that everyone pictures
Right.
when they imagine childbirth.
Exactly.
Yeah.
So the contractions now are super intense.
Yeah.
Really close together.
Uh-huh.
The woman feels an overwhelming urge to push.
So it's not just about the physical effort of pushing, but there's this primal instinct kicking in.
Absolutely. And with each push,
The baby moves further down,
further down the birth canal,
getting closer and closer.
closer to being born.
What a moment.
It is.
Okay, so then what happens after the baby is born?
There's still one more stage,
Hi.
the delivery of the placenta.
I guess the placenta's work is done at that point.
Pretty much it detaches from the uterine wall,
Okay.
and then it's delivered usually within 30 minutes after the baby arrives.
So it's kind of like the grand finale
It is.
of labor.
Yes.
Now, I know that not all births are the same. Some are quick, some are long, some are more complicated than others.
That's true. Every labor is unique.
And thankfully, we have so many options available today
We do.
to support women during childbirth,
Yeah?
like different birthing positions.
Yeah.
I've heard that some positions can actually make labor easier.
Yeah, there's been a growing movement towards more upright and active birthing positions.
Oh, instead
of lying flat on their backs,
right.
women can choose to stand, kneel squat,
Uh-huh.
or even give birth in a birthing pool.
I mean, I imagine those positions would make more sense, just anatomically speaking.
They do.
Yeah.
It can help align the baby with the birth canal
Uh-huh.
and use gravity to assist with the descent.
So it's not just about comfort, it's about working with the body's natural design.
Exactly.
And then there's also the use of doulas.
Yes.
Now, what exactly does a doula do?
So a doula provides continuous support during labor,
Okay.
emotional support, physical comfort measures,
Like what?
massage positioning,
Oh.
and they help advocate for the woman's birth preferences.
So it's like having a personal coach for childbirth.
Yeah, that's a great way to put it.
That sounds amazing.
It can be super helpful.
Now, while most deliveries are pretty straightforward,
Yeah.
there are times when complications do arise.
Right.
So let's talk about those. What are some of the things that can go wrong
Okay.
during labor and delivery?
One complication that can happen is shoulder dystocia.
Shoulder dystocia, what is that?
So that's where the baby's shoulder gets stuck,
Okay.
behind the mother's pubic bone after the head is delivered.
Oh, wow. That sounds really scary.
It can be.
So what happens then?
It requires really quick action by the medical team
Okay.
to kind of maneuver the baby and free the shoulder.
Uh-huh.
Thankfully, there are techniques that can help resolve this,
Okay, good.
but it can be a pretty tense situation.
I bet. Okay, what about breech presentations?
Okay, so breech presentation is when the baby is positioned to come out feet or bottom first
Okay.
instead of head first, which obviously makes vaginal delivery more challenging.
So what did they do in that situation?
It often requires a cesarean section
Okay.
for safety.
Okay, and then there's the dreaded prolapsed umbilical cord.
Yeah, that's when the cord comes out before the baby.
Right.
It's a true emergency
Yes.
because the cord can actually get compressed.
Right, and that cuts off the baby's oxygen supply.
Exactly.
So time is really of the essence.
It requires immediate intervention to relieve that pressure on the cord and deliver the baby as quickly as possible.
Wow, it sounds like every second counts.
It does.
Okay, what about preterm labor
So preterm labor, that's labor that begins before 37 weeks
of pregnancy?
of pregnancy,
Yeah.
and it can be triggered by all sorts of things.
Okay. And I imagine those babies face some additional challenges.
They do, because they're born too soon.
Right. Their organs might not be fully mature yet.
Exactly. And they might require specialized care in the NICU.
The neonatal intensive care unit.
Yeah.
Yeah, it's amazing how technology and medical advancements have helped improve the outcomes for premature babies.
It really is.
It is. Okay, now let's talk about multiple births.
Right.
Like twins, triplets.
They always bring that extra dose of excitement,
They do.
but they also come with increased risks.
I can imagine double the babies.
Double the babies, double the potential complications.
Yeah, like what?
Higher chance of preterm labor.
Okay.
And the babies tend to be smaller.
It's like a high-stakes juggling act, making sure that both of those babies are healthy
It is.
and thriving.
That's a great way to put it.
Now, we also need to talk about a more tragic possibility.
Okay.
Intrauterine and fetal death or stillbirth.
It's a heartbreaking loss for any family.
It really is. And I know that we can't always prevent these tragedies,
Right.
but we can offer support and resources.
To help those families navigate that difficult time.
Exactly. It's a reminder that even with all the advances in medicine, there are still things that we can't control. Okay, let's talk about some of the other complications that can occur during labor and delivery.
Okay, one thing we watch out for is meconium staining.
Meconium staining, what is that?
That's when the baby passes stool.
In the amniotic fluid.
Yeah.
Now, isn't that normal? I thought babies pooped in the womb all the time.
Well, it's not uncommon for babies to pass meconium before birth.
Okay.
But if it happens during labor, it can actually be a sign of fetal distress.
So it's like a red flag.
Exactly. And we monitor the baby very closely in those situations
Okay.
to make sure that they don't inhale the meconium, which could cause breathing problems.
So even something like poop
Right.
can be an indicator of the baby's well-being.
It can. And remember supine hypotensive syndrome
Yeah.
that we talked about earlier? It can also be a factor.
During labor and delivery?
Yes. If a woman is lying flat on her back,
Yeah.
the weight of the uterus can actually compress a major vein
Okay.
and reduce blood flow to the baby.
So that's why they encourage women to labor in different positions.
That's exactly why.
Right.
It's all about optimizing that blood flow and oxygen delivery to the baby.
Now, are there any other really serious complications
Yes.
that can happen during labor?
There are a few rare
Okay.
but potentially life-threatening events.
Okay. Like what?
One is uterine rupture.
Uterine rupture, that's when the uterus tears open.
That's exactly right.
Oh my gosh, that sounds incredibly dangerous.
It's more common in women who have had previous C-sections,
Uh-huh.
but it can happen in any pregnancy.
Yeah, I guess it just shows how much stress the uterus is under during labor.
Yeah, it does. And then there's
Okay.
uterine inversion.
Uterine inversion.
That's when the uterus turns inside out after delivery.
Oh my goodness, that sounds terrifying.
It's extremely rare,
But it can happen.
but it can happen,
Wow.
and it requires immediate medical attention to correct it.
Okay, so we've covered complications during labor. Are there any complications that can happen after the baby is born?
Yeah, so postpartum hemorrhage,
Postpartum hemorrhage.
that's excessive bleeding after delivery.
And that can be really scary
It can-
for a woman who has just given birth.
Yes, so it's important to monitor the bleeding closely
Okay.
after delivery and manage it if it becomes too much.
So what causes postpartum hemorrhage?
Well, there are a few different things.
Okay.
One of the most common is when The uterus doesn't contract properly after the placenta is delivered.
So the uterus needs a little help.
Yeah, kind of getting back to its normal size.
Right.
And then there's also the risk of pulmonary embolism.
What's that?
So that's a blood clot
Uh-huh.
that travels to the lungs.
Okay.
This is a serious complication that can happen after any surgery,
Okay.
but it's more common during pregnancy and postpartum,
So it's something to be aware of.
even after you've given birth.
Right.
Okay.
Okay. Now, before we wrap up, I think it's important to touch on trauma during pregnancy
Right.
because it's not just about the woman's injuries. It's about the potential impact on the baby, too.
Absolutely. So the enlarged uterus can actually protect the baby in early pregnancy,
Uh-huh.
but then it also makes the baby more vulnerable later on.
Right. So the uterus is kind of acting as both a shield and a target.
Yeah, that's a good way to put it. And all those physiological changes of pregnancy,
Like what?
like increased blood volume,
Very...
changes in breathing,
Okay.
can make the assessment and management of trauma more complicated.
So it adds like another layer of complexity
does.
to an already challenging situation.
Exactly. And it's crucial for those medical professionals
Right.
to be aware of these differences
Uh-huh.
and to prioritize the well-being
Of both the mother
and the baby.
and the baby. Well, I think we've covered just about everything there is to know about female reproductive anatomy and obstetrics.
It's been quite the whirlwind
It really has.
of information.
From the intricacies of hormones to the drama of childbirth.
It's amazing.
It really is. It's a system that never ceases to amaze me.
It's a testament to the power and resilience
Of the female body.
of the female body.
So as we wrap up this deep dive, I want to leave our listeners with a final thought-provoking question.
Okay, I like it.
Knowing how dramatically pregnancy alters a woman's physiology,
Uh-huh.
how might this knowledge influence future research on women's health in general, beyond just those reproductive years?
It's a great question.
It's something to ponder.
Absolutely.
So thank you for joining us on this deep dive
Okay.
into the incredible world of female reproductive anatomy and obstetrics.
It was fun.
We encourage you to keep learning and exploring this fascinating subject.
Yes.
Until next time.
Bye, everyone.
All right, get ready to dive deep today because we're tackling a topic that's both fascinating and super important: abdominal health.
It's a good one.
You guys have sent in a ton of research and articles about abdominal injuries and GI emergencies.
Yeah, there's a lot to cover.
It's a lot. We're talking blunt force trauma, internal bleeding, and basically everything that can go wrong with your stomach, intestines, and all the bits in between.
All the bits. That's a good way to put it.
Our mission today is to give you the knowledge to understand what's going on in there, but also, really importantly, how to recognize those warning signs and know what to do if there's a potential emergency.
Absolutely. Knowledge is power, right?
Exactly. Think of this as your crash course in abdominal health, but way more interesting than cracking open a textbook.
Way more fun. And you're definitely in the right place for that.
Absolutely. So to get started, I think it's helpful to have a visual.
Okay, I like visuals.
Imagine your abdomen as a bustling city,
A bustling city, okay.
packed with vital organs all working together. You've got your liver, your spleen, your stomach, intestines, all doing their jobs.
Yep.
But here's the thing. This city, unlike maybe some others, it lacks strong walls.
Oh, that's not good for a city.
Right. Unlike your heart and lungs, which are nicely protected by the rib cage, your abdomen is mostly soft tissue,
Interesting.
which makes it surprisingly vulnerable.
Yeah, you don't think about that.
No, not until something goes wrong. So it's a busy metropolis with essential services, but no real defenses.
That does make you realize how important it is to understand, the risks to this area.
For sure. And you mentioned the liver, spleen, stomach, intestines.
Mm.
Are those the main players in our abdominal city? What else is in there?
Well, like any city, the abdomen has different districts. You got downtown, which we call peritoneal space. That's where you find those orgies you mentioned. The liver, spleen, stomach, most of the intestines.
Okay, so those are like the big important skyscrapers.
Yeah.
Exactly, right in the center of it all. Then tucked away in the back, we've got the retroperitoneal space. That's more like the industrial zone, housing critical infrastructure like the aorta, the vena cava, kidneys, and pancreas.
Got it. So we've got downtown and the industrial zone.
Mm-hmm.
And lastly, we have the south end of our city, the pelvis.
Okay.
That's where the bladder and reproductive organs hang out.
So we've got our bustling city, different districts, all these important organs. But what's separating them? What keeps them from like bumping into each other all the time?
Right. Good question. That's where the peritoneum comes in. It's this thin, slippery membrane lining the abdominal cavity and covering most of the organs.
Okay.
Think of it like a silk sheet draped over everything. It allows the organs to slide around and move smoothly against each other.
Oh, so that's how they avoid all those fender benders.
Exactly. And then, to keep everything organized, we have the mesentery. It's a series of folds attaching the intestines to the abdominal wall, preventing them from getting tangled.
So the peritoneum is like the city's smooth, well-oiled infrastructure, and the mesentery is keeping everything nice and tidy.
Exactly.
But what happens when something disrupts this delicate balance? Let's talk about what can go wrong, starting with blunt trauma.
Right, blunt trauma. Imagine like a sudden earthquake shaking our city.
Oh, okay, so causing damage, but not necessarily breaking through the walls.
Right. Think of a car accident or falling from a height. Those kinds of forces can really do damage.
Yeah, it's scary to think about.
It can crush organs against the spine or tear them from their attachments.
It's like a demolition crew going through the city.
Kind of, yeah.
Wow.
But instead of wrecking balls, it's these invisible forces like shearing, crushing, and compression.
So even if you don't see external wounds, the internal damage from blunt trauma can be massive. It's like a hidden earthquake that only you feel the aftershocks of.
Exactly. And the type of damage, depends on the force and direction of the impact.
Oh, I see.
Shearing forces can tear organs like the liver or spleen. Crushing forces can rupture hollow organs like the intestines. And then there's compression, squeezing organs against the spine or pelvis, leading to internal bleeding.
Okay, so blunt trauma is like an earthquake. What about penetrating trauma? How is that different?
Well, if blunt trauma is an earthquake, penetrating trauma is more like a targeted missile strike.
Okay, a more direct hit.
Right. Sharp objects or projectiles piercing the abdominal wall and causing direct damage to whatever they hit. This could be a knife wound, a gunshot wound, or even something like broken glass from an accident.
So stab wounds versus gunshot wounds. Are there key differences in the type of damage they cause?
Absolutely. A stab wound is like a single focused attack. It damages the organ it directly hits. But a gunshot wound, that's like a cluster bomb. The bullet creates a wider path of destruction, potentially injuring multiple organs.
Wow.
Plus, bullets have much greater kinetic energy than a knife, which means more lateral damage, affecting tissues beyond the direct path of the bullet.
So it's not just what's directly hit. It's the shock waves and energy that ripple outwards, causing additional damage.
Right. And of course, the location of the wound plays a role in the severity. Hitting a major blood vessel like the aorta or vena cava can lead to massive internal bleeding.
And even if the injury doesn't seem life-threatening initially, there's always the risk of infection, right?
Absolutely, especially with penetrating trauma.
Right. Well, that brings us to something we touched on earlier, hemorrhage, the silent killer. We talked about internal bleeding from both blunt and penetrating trauma, but what makes it so dangerous?
The danger lies in its hidden nature. Unlike external bleeding, where you can see the blood loss, internal bleeding can be hard to detect. It's like a leak in a hidden pipe within our city walls. You might not know there's a problem until it's too late.
So it's a hidden threat that can escalate quickly if not addressed. And the signs might not be as obvious as a gaping wound.
Right. The early signs of internal bleeding can be really subtle. A slightly elevated heart rate, maybe some anxiety or restlessness. But as you lose more blood, the symptoms get more pronounced. Pale skin, cool, clammy hands, a drop in blood pressure.
So the body's trying to compensate for the blood loss, but eventually.
If it's not stopped, untreated hemorrhage leads to shock. The body's organs don't get enough oxygen and nutrients. This can cause organ damage and, in severe cases, death.
And on top of all of that, internal bleeding can be difficult to estimate, right? It's not like you can just look and see how much blood is gone.
You're right. It's not as straightforward as looking at a puddle on the floor. We have to rely on the mechanism of injury, vital signs, and physical exam findings to try and figure out how severe it is.
So it's like detective work, piecing together clues to determine the extent of the damage.
It really is.
Now, let's talk about what to do if you suspect someone has an abdominal injury. What are the key things to look for?
The most important thing is to consider the mechanism of injury. Has this person been in a car accident? Have they fallen from a height? Was there any forceful impact to the abdomen? If so, you need to be suspicious of an abdominal injury, even if there are no obvious external wounds.
So context is key. You can't just look at the person. You have to consider what happened leading up to this potential injury. What about more specific physical signs?
Well, think about what would happen if a building in our city was damaged. You might see cracks in the walls, debris falling, or even the entire structure starting to tilt. Similarly, with an abdominal injury, you might see bruising, swelling, or distension of the abdomen. You might also see abrasions, lacerations, or puncture wounds.
So we're looking for any signs of damage to the buildings in our abdominal city. What if the damage is more internal? Are there any clues we can get from the person themselves?
Absolutely. You'll want to ask about their pain. Where does it hurt? Does it radiate anywhere? Is it constant, or does it come and go? You'd also want to know if they've had any nausea, vomiting, or changes in their bowel habits.
So gathering intel from visual inspection and the patient's own report.
Exactly.
Something that really stood out to me is that you said 20% of patients with internal bleeding may have a normal abdominal exam.
It's true, which just highlights how tricky internal bleeding can be. Sometimes the bleeding is slow and subtle, especially if it's in the retroperitoneal space where there's more room for blood to accumulate before it causes problems.
So it's like a slow leak gradually filling up a basement in our city.
Exactly. And that's why it's so important to have a high index of suspicion, especially when the mechanism of injury makes abdominal trauma likely.
So even if they seem okay at first, if they've been in a situation where abdominal injury is possible, be extra cautious. Better to be safe than sorry. Now let's talk about what to do if we suspect someone has an abdominal injury. What are the priorities in terms of first aid and medical care?
Well, first and foremost, safety. Make sure the scene is safe for both you and the injured person.
Of course, safety first.
Then call 911 or your local emergency number immediately.
Okay, so call for help and then...
Then, while you're waiting, help them get into a comfortable position. If they're conscious and can swallow, give them small sips of water.
And no food or anything like that, right?
You're right. You want to avoid giving them anything to eat or drink if you suspect internal bleeding.
Makes sense.
Yeah.
What about other first aid measures? What if there's visible bleeding?
If you see external bleeding, apply direct pressure to the wound using a clean cloth or bandage. If you suspect a spinal injury, try to stabilize their head and neck.
But beyond that?
Honestly, it's best to leave any further medical interventions to the professionals.
So our role is stabilize the situation and get professional help ASAP. It's about knowing our limits and trusting the experts to do their thing. Now, before we move on to GI distress, there's one more thing I want to talk about, and it's kind of a dramatic one.
Okay.
Abdominal evisceration.
Oh, wow, yeah.
What exactly is that, and what should we do if we ever, God forbid, encounter it?
Abdominal evisceration is when internal organs protrude through an open wound in the abdominal wall.
So like a section of our city wall collapsing and exposing the buildings within.
Exactly. It's definitely a sight that can make anyone, even seasoned medical professionals, take a deep breath. But it's crucial to remain calm.
So what should we do? I've heard you shouldn't try to push the organs back in.
You've heard right. Definitely resist that urge. Instead, cover them with a clean, moist dressing or a clean cloth if that's all you have. Ideally, you'd use a sterile dressing soaked in saline solution, but if that's not available, use the cleanest material you can find and moisten it with clean water.
Okay, so we're basically creating a protective area over the exposed organs.
Exactly. Keep the person warm, reassure them, help is on the way, because this is a very serious injury that needs immediate surgery.
All right, so we've covered the more dramatic side of abdominal health, blunt force trauma, penetrating injuries, and the shocking scenario of abdominal evisceration.
It's a lot.
It is. Now, let's shift gears and talk about the more everyday GI issues that can affect our abdominal city. We've all had an upset stomach, but how do we know when it's something more serious than just a passing inconvenience?
That's where knowing the signs and symptoms becomes crucial. Just like with the trauma. It's like reading the warning signals in our city.
Okay, so let's learn how to decipher those warning signals. What are some common signs and symptoms that should make us pay attention?
Well, the most common symptom is pain. But pain is a pretty broad term. It's like saying there's a problem somewhere in our city, but not telling us what building is on fire,
Right.
So when it comes to abdominal pain, you have to be specific. Where is the pain? What does it feel like? Sharp, stabbing, cramping, burning? Is it constant or does it come and go?
So it's all about location, 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 just like with real estate.
Exactly. And the location can give us some clues about which organ is in trouble.
Can you give us some examples?
Sure, pain in the right upper quadrant just under your ribs could be a sign of cholecystitis. That's inflammation of the gallbladder.
Yeah.
Often caused by gallstones blocking the bile duct.
So if the gallbladder is like the city's waste management plant, a gallstone is like a garbage truck getting stuck, preventing things from flowing smoothly.
You got it. That blockage causes the pain and inflammation.
Okay, that makes sense. What about pain in other areas?
Pain in the lower right quadrant, especially if it starts around the belly button and moves, is a classic sign of appendicitis. The appendix is a little pouch attached to the large intestine, and when it gets inflamed, it can be very painful.
So the appendix is like a little side street that causes a major traffic jam when it gets blocked.
That's a great way to put it. And then there's pain that's more widespread and not really tied to one spot. That could be something like gastroenteritis, inflammation of the stomach and intestines, often from a virus or bacteria. Or it could be irritable bowel syndrome, or IBS, which is a chronic condition that affects the large intestine.
So those are more like conditions affecting the roads and highways rather than a specific building. What about other warning signals besides pain?
Vomiting is another one. It's the body's way of trying to expel something that's irritating it. Could be food poisoning, a virus, or even something more serious like a bowel obstruction.
So vomiting is like the city's emergency response team trying to clean up a hazardous spill.
Exactly. Then there's diarrhea, which is like a flash flood through the system. Infections, food intolerances, even stress can cause it.
Diarrhea as a plumbing problem. Is it just a matter of discomfort, or can it be more serious?
While it's often temporary, it can also be a sign of something worse, especially if it's severe or keeps coming back. One of the biggest concerns is dehydration.
Right, if our city's having a flash flood, the water supply can get depleted pretty quickly, and dehydration can be dangerous.
Absolutely, especially for older folks and young children. You might notice increased thirst, dry mouth, less urination, fatigue, dizziness, even confusion if it's really bad.
So it's like everyone in our city is getting sluggish and disoriented.
It's exactly.
Now, what about bleeding? We talked about internal bleeding from trauma, but can it also happen within the GI tract itself?
Oh, absolutely. Bleeding in the GI tract can be caused by lots of things, some minor, some life-threatening. Could be something as simple as hemorrhoids or something serious like a bleeding ulcer in the stomach.
So hemorrhoids are like a traffic jam in the city's outskirts, while a bleeding ulcer is like a burst pipe in a major building.
That's a great way to visualize it.
Both cause bleeding, but the severity is way different. How do you know if you're having GI bleeding?
The most obvious sign is blood in the stool or vomit, but sometimes it's so small you can't see it. You might notice black, tarry stools, which is a sign of digested blood, or you might have fatigue and shortness of breath from anemia, which is low red blood cell count from blood loss.
So it's like a slow leak, gradually draining the city's resources. What about changes in bowel habits? Can that be a sign of trouble?
Absolutely. Changes in bowel habits, like constipation, diarrhea, or a change in stool consistency, can signal a variety of GI conditions. Persistent constipation could mean a bowel obstruction. Frequent diarrhea could point to inflammatory bowel disease or IBD. And any big change in stool color, like black, Tory stools, or bright red blood, should always be checked out by a doctor.
Okay, so we've got pain, vomiting, diarrhea, bleeding, changes in bowel habits. Those are some big warning signs. But let's get even more specific. What are some of the actual GI conditions that can cause these symptoms, and how do they affect our abdominal city?
Well, we already mentioned cholecystitis, which is the inflamed gallbladder, and appendicitis, the inflamed appendix.
Right.
But there are a lot more conditions that can cause trouble in our abdominal city.
Let's take a quick tour of some of those trouble spots, starting with the esophagus, the highway that carries food from our mouth to our stomach. What kinds of problems can happen there?
One common condition is GERD, or gastroesophageal reflux disease. It's like having a faulty valve in the city's plumbing system, allowing stomach acid to back up into the esophagus.
So like a sewage backup.
Yeah, pretty much. It can cause heartburn and indigestion, and if it's not treated, it can lead to more serious problems like esophagitis, which is inflammation of the esophagus, or even Barrett's esophagus, a precancerous condition.
Okay, so we need to fix those plumbing problems before they get worse.
Exactly.
What about esophageal varices? I've heard those can be quite dangerous.
They can be. Esophageal varices are like weakened, bulging pipes in the lower part of the esophagus. They form when blood flow to the liver is blocked, often because of cirrhosis. This causes blood to back up into smaller veins, putting them under a lot of pressure.
So it's like a detour in our city's traffic, forcing more cars onto smaller, weaker roads. What makes those so dangerous?
Well, because those bulging veins are fragile, they can rupture. If that happens, it can cause massive bleeding in the esophagus, which is a life-threatening emergency.
Wow, that's scary. Let's move on to the stomach, the processing plant of our digestive system. What are some common conditions that affect this vital organ?
One of the most common is gastritis, which is inflammation of the stomach lining. It can be caused by things like bacterial infections, too much alcohol, and even some medications like aspirin or ibuprofen.
So gastritis is like a fire breaking out in the processing plant.
A good analogy. The most common symptom is a burning pain in the upper abdomen, often with nausea and vomiting. Treatment depends on the cause. If it's bacterial, you might need antibiotics. Lifestyle changes like avoiding alcohol and spicy foods are also important.
Okay, so gastritis is inflammation of the stomach lining. What about peptic ulcers? I know those can be really painful and even dangerous if they start to bleed.
You're right. Peptic ulcers are like craters that form in the lining of the stomach, or duodenum, which is the first part of the small intestine. They can be caused by an infection with a bacteria called H. pylori or by long-term use of certain painkillers.
So like acid rain eroding the walls of our buildings.
Exactly. The big worry is bleeding. If an ulcer erodes through a blood vessel, you can lose a lot of blood. This can lead to anemia, weakness, even shock.
Okay, so gastritis, ulcers, anything else that can go wrong in the stomach. What about something called gastroparesis? I've heard that can be really tough to deal with.
Gastroparesis is like a slowdown in the city's transportation system. It's when the stomach muscles don't contract normally and can't empty food into the small intestine. This can lead to nausea, vomiting, bloating, and feeling full even after a small meal.
So it's like the garbage trucks are on strike and trash is piling up everywhere.
A perfect visual. The exact cause isn't always clear, but it seems to be linked to nerve damage or problems with how the nerves function. Diabetes is a big risk factor because high blood sugar can damage those nerves that control stomach emptying. Treatment usually focuses on managing symptoms and addressing the root cause if they know what it is.
Okay, we've explored the esophagus and stomach. Now let's head to the small intestine, the absorption district of our city. What sorts of issues can pop up there?
Well, one is celiac disease. It's an autoimmune disorder where eating gluten triggers an immune response that damages the lining of the small intestine. And that, of course, makes it harder to absorb nutrients.
So it's like the city's residents are allergic to a certain type of food.
Yes. And when they eat it, it causes a huge inflammatory response, making it tough to get the nutrients they need. Symptoms can be all over the place: diarrhea, pain, bloating, fatigue, weight loss, even anemia.
Wow, that's a lot. How do they figure out if someone has it?
Usually involves blood tests as a biopsy of the small intestine. The only treatment for celiac disease is a strict gluten-free diet that lets the intestine heal and prevents more damage.
So we have to be mindful of food sensitivities that can cause chaos in our absorption district.
Yes.
What about Crohn's disease? I know that's a serious condition that can affect any part of the digestive tract, but it often involves the small intestine.
Right. You're right. Crohn's disease is like chronic unrest in our city. It's a type of inflammatory bowel disease, or IBD, and causes inflammation of the lining of the digestive tract, most often in the last part of the small intestine, the ileum.
So constant protests and roadblocks disrupting the flow of things and causing damage.
A good way to think about it. Symptoms depend on where the inflammation is and how bad it is, but can include abdominal pain, diarrhea, rectal bleeding, weight loss, and fatigue. There's no cure, but treatment can help manage symptoms, control the inflammation, and prevent complications.
So we need to keep those protests under control. Now let's move on to the large intestine, or colon, the waste disposal district of our city.
All right, let's head over there.
What are some common problems that can happen in this area?
One very common issue is diverticulosis. Think of it like weak spots in the city walls, where little pouches, called diverticula, form. These pouches usually don't cause any trouble, but they can get inflamed or infected, leading to a condition called diverticulitis.
So diverticula are like little potholes in our city walls, and when they get full of junk and bacteria, it causes a mini eruption.
Yeah, that's a good way to picture it.
What are the signs of diverticulitis?
The main ones are abdominal pain, usually on the left side, fever, and changes in bowel habits. Treatment usually involves antibiotics, rest, and a liquid diet.
So we need to keep those city walls strong and pothole-free.
Yes.
What about ulcerative colitis? I know that's another type of IBD, but it mainly affects the colon, right?
Exactly. Ulcerative colitis is like a wildfire ripping through the lining of the colon, causing ulcers and inflammation. It's a chronic condition that causes abdominal pain, diarrhea, rectal bleeding, and urgency.
It's like a firestorm in our waste disposal district.
Yep, causing a lot of damage. Like Crohn's disease, there's no cure, but treatments help manage symptoms and prevent complications.
We have to be vigilant about maintaining the health of our abdominal city.
We do. And speaking of vigilance, we can't forget about colorectal cancer. It's like a rogue development project in our city, growing out of control and potentially spreading. It's really important to get regular screenings, especially after age 50, to catch it early.
That's an important reminder. So we've covered most of the GI tract from top to bottom, but there's one last stop, the rectum and anus, the exit gates of our abdominal city.
Right, the final checkpoint.
What kinds of issues can happen there?
Hemorrhoids are one of the most common. Those are swollen blood vessels in the rectum or anus that can cause pain, itching, and bleeding.
So hemorrhoids are like traffic congestion at the exit gates, causing discomfort and delays.
You got it. They're often caused by straining during bowel movements, so a high-fiber diet and staying hydrated are key.
Okay, makes sense. Anything else we should know about?
We can't forget anal fissures, which are small tears in the lining of the anus.
Oh, ouch.
They often happen because of constipation or diarrhea, and they can be pretty painful and might bleed.
So cracks in the pavement at the exit gates.
Exactly. Maintaining regular bowel movements can really help prevent both hemorrhoids and fissures.
Right, keep that traffic flowing smoothly. Anything else to keep in mind?
While we're talking about the rectum and anus, we should mention anal cancer. It's not super common, but it can cause bleeding, pain, and changes in bowel habits. If you experience any of those, you definitely want to see a doctor to rule out anal cancer or other serious conditions.
Okay, so we've covered the whole GI tract from beginning to end.
We made it.
Our abdominal city is clearly a complex and delicate place, and any disruption, even a small one, can have a big impact. But I think we've equipped everyone with a good understanding of those warning signs, the common GI issues that can happen, and how they affect the parts of the system.
I think so too. The important thing is to remember your body is always sending you signals. If something feels off, don't wait. Go see a doctor. Early diagnosis and treatment can make a huge difference in managing GI conditions.
That's a great takeaway. It's about being proactive. Speaking of which, let's shift our focus to another crucial part of our abdominal city, the kidneys.
The kidneys, yes.
We'll be back after a short break to delve into these remarkable organs and how they filter waste, regulate fluids, and keep us running smoothly. Stay tuned. And we're back for part 2 of our abdominal health deep dive.
Round 2.
Exactly. Last time we explored our abdominal city
Our bustling city.
with all its working parts, but also its vulnerabilities, especially to those blunt and penetrating injuries.
Right, and that silent killer, internal bleeding.
Definitely a scary thought. But for this part, let's shift gears to the everyday discomforts, those potential emergencies that can happen in our GI system. We've all had an upset stomach.
Well, yeah.
But how do you know when it's something more serious, something that warrants a call to the doctor or even, 911?
That's a good question, and that's where being able to spot the signs and symptoms of GI distress comes in. It's like being able to read those warning signals in our abdominal city.
Okay, so let's put on our detective hats and learn how to decode those warning signals. What are we looking for?
Well, the most common symptom is pain. Yeah, but pain is pretty broad. It's like saying there's a problem in the city, but not telling us which building is on fire.
Right, right.
So we need to be specific. Where is the pain? What does it feel like? Is it sharp, stabbing, cramping, burning? Is it always there or does it come and go?
So location, location, location. Just like with real estate, but instead of beachfront property, we're talking organs.
Exactly. And the location of the pain gives us clues about which organ might be in trouble.
Okay, I like this. Give me some examples.
Okay, for example, pain in the right upper quadrant under the ribs could mean cholecystitis, inflammation of the gallbladder.
Oh, okay.
And that's often caused by gallstones blocking the bile duct, which is the pathway bile takes from the gallbladder to the small intestine.
So if we think back to our city analogy, the gallbladder is like the city's waste management plant.
Okay.
And a gallstone blocking the bile duct is like a garbage truck getting stuck in the alley,
Yes.
preventing things from flowing smoothly, which causes pain and inflammation.
You got it.
Okay, what about pain in other areas? What clues can that give us?
Well, if the pain is in the lower right quadrant, and particularly if it starts around the belly button and then moves, that's a pretty classic sign of appendicitis. The appendix is this little pouch attached to the large intestine, and when it gets inflamed, it can be super painful.
Okay, so the appendix is like a little side street off of the main thoroughfare of our intestines.
Right.
And when it gets blocked, it creates a huge traffic jam.
Exactly. And then you have pain that's more general, not in one specific spot. That can be harder to pin down, but could be things like gastroenteritis, which is inflammation of the stomach and intestines, often caused by a virus or bacteria. Or it could be irritable bowel syndrome, IBS, a chronic condition affecting the large intestine.
So those are more like conditions affecting the whole network, the roads and highways of our digestive system, rather than one specific building.
That's a good way to think about it.
Okay, so we've got pain. What are some other warning signs we need to watch out for?
Well, vomiting is another one.
Vomiting, okay.
Yeah, it's like the body's way of kicking something out, something that's irritating it.
Makes sense.
Could be food poisoning, a virus, or something more serious like a bowel obstruction.
Okay, so vomiting is like the city's emergency response team trying to clear out a hazardous spill, and we need to pay attention to what's being expelled.
Yes, exactly. Like, is there blood in it? Does it look like coffee grounds, which could indicate bleeding in the stomach? These are all details that you want to be sure to tell a doctor.
Right, those are really important clues.
They are. And then there's diarrhea, which is, like a flash flood rushing through the system. Lots of things can cause it: infections, food intolerances, even stress.
So diarrhea is like a major plumbing problem
Yeah,
where the pipes are overflowing and things are moving too quickly.
exactly. And while it's usually just a temporary inconvenience, it can be a sign of something more serious, especially if it's severe or persistent. And the biggest concern with diarrhea is dehydration.
That makes sense. If our city's experiencing a flash flood, the water supply gets depleted pretty quickly. Dehydration can be dangerous.
It can be, especially for the elderly and young children. Some things to watch for are increased thirst, dry mouth, decreased urination, fatigue, dizziness, and even confusion in severe cases.
So it's like our city's residents are getting sluggish and disoriented because they don't have enough water.
Mm.
What about bleeding? We've talked about internal bleeding from trauma, but can you have bleeding within the GI tract itself?
Or absolutely. GI bleeding can signal a whole range of conditions. Some are relatively benign, and some are life-threatening. It could be something as simple as hemorrhoids, which are swollen blood vessels in the rectum, or something as serious as a bleeding ulcer in the stomach.
So hemorrhoids are like a traffic jam on the outskirts of the city, while a bleeding ulcer is like a burst pipe in a major building.
Exactly.
Both cause bleeding, but the seriousness and potential consequences are very different.
Right.
How would someone know if they're having GI bleeding?
Well, the most obvious sign is blood in the stool or vomit. But sometimes the bleeding is so small that you can't see it with the naked eye. In those cases, you might notice your stool is black and tarry, which is digested blood. Or you might have fatigue and shortness of breath because of anemia, which is a low red blood cell count caused by blood loss.
So it's like a slow leak that's gradually draining the city's resources. What about changes in bowel habits? Can those be a sign of something more serious?
Definitely. Changes like constipation, diarrhea, a change in stool consistency can all point to various GI conditions. Persistent constipation, for instance, could be a sign of a bowel obstruction. Frequent diarrhea could be inflammatory bowel disease, or IBD. And any significant change in stool color, like black, tarry stools or bright red blood, should always be checked out by a doctor.
Okay, so we've got pain, vomiting, diarrhea, bleeding, and changes in bowel habits as major warning signs.
Those are the big ones.
Let's get into specifics. What are some of the actual GI conditions that can cause these symptoms?
Well, we've already talked about a couple: cholecystitis, the inflamed gallbladder, and appendicitis, the inflamed appendix.
Right.
But there's a whole host of other conditions that can wreak havoc in our abdominal city.
Let's take a tour, starting with the esophagus, the highway that carries food from our mouth to our stomach.
Okay, let's do it.
What kinds of problems can we run into there?
One common one is GERD, which stands for gastroesophageal reflux disease.
GERD.
Yeah, it's like a faulty valve in our city's plumbing system that lets stomach acid back up into the esophagus.
So a sewage backup in our main pipeline.
Pretty much. It can cause heartburn and indigestion. And if it's not treated, it can lead to bigger problems like esophagitis, which is inflammation of the esophagus, or even Barrett's esophagus, which is a precancerous condition.
So we got to fix those plumbing problems early.
We do.
What about esophageal varices? Those could be pretty dangerous, right?
They can be. Esophageal varices are like weakened, bulging pipes in the lower part of the esophagus. They happen when blood flow to the liver is blocked, often because of cirrhosis. This causes blood to back up into smaller veins, and that puts them under a lot of pressure.
So it's like a detour in our city's traffic flow, forcing more cars onto smaller, weaker roads. And what makes esophageal varices so dangerous?
Well, they're fragile and can rupture. And if that happens, it can cause massive bleeding in the esophagus, which is a life-threatening emergency.
Okay, let's move on to the stomach, the processing plant of our digestive system.
Okay, the stomach.
What are some common issues that can affect this vital organ?
One of the most common is gastritis. It's inflammation of the stomach lining. Lots of things can cause it, including bacterial infections, too much alcohol, even common medications like aspirin and ibuprofen.
So it's like a fire breaking out in our processing plant.
Exactly. The most common symptom is a burning pain in the upper abdomen, often with nausea and vomiting. How it's treated depends on what caused it. If it's a bacterial infection, you might need antibiotics. Lifestyle changes, like cutting back on alcohol and spicy foods, are important too.
So gastritis is inflammation of the stomach lining. What about peptic ulcers? Those can be pretty painful, and I know they can be dangerous if they bleed.
Yeah, you're right. Peptic ulcers are like craters in the lining of the stomach, or the duodenum, the first part of the small intestine.
Yeah.
They can be caused by an infection with the bacteria H. pylori, or by taking NSAID pain relievers, like ibuprofen and naproxen, for a long time.
So like acid rain eroding away at our buildings.
That's a good way to picture it. And the big concern with ulcers is the potential for bleeding. If an ulcer erodes through a blood vessel, it can cause significant blood loss, which can lead to anemia, weakness, and even shock.
Okay, we've covered gastritis, peptic ulcers. Is there anything else that can go wrong with the stomach? What about gastroparesis? I've heard that one can be pretty tough to live with.
Gastroparesis is like a slowdown in our city's transportation system.
Okay.
It's a condition that affects the stomach muscles and prevents them from contracting normally, so food can't empty into the small intestine the way it should.
Oh, I see.
This can lead to nausea, vomiting, bloating, and feeling full even after eating just a little bit.
So it's like those garbage trucks are on strike again and the trash is piling up.
Exactly. The exact cause isn't always clear, but it's thought to be related to damage to the nerves that control stomach emptying, or maybe a problem with how those nerves function. Diabetes is a common risk factor for gastroparesis because high blood sugar levels can damage those nerves. Treatment often focuses on managing the symptoms and addressing any underlying causes if they're known.
Okay, so we've explored the esophagus and the stomach. Let's move on to the small intestine, the absorption district of our abdominal city.
The small intestine, all right.
What are some of the problems that can pop up there?
Well, one condition that affects the small intestine is celiac disease. It's an autoimmune disorder that's triggered by eating gluten, a protein found in wheat, barley, and rye.
Yeah.
In people with celiac disease, when they consume gluten, it causes an immune reaction that damages the lining of the small intestine. This damage interferes with the absorption of nutrients.
So it's like the city's residents are allergic to a specific type of food.
Yes, and when they eat it, it causes a sort of inflammatory riot in the absorption district, making it hard to get the nutrients they need.
Oh, wow.
The symptoms vary a lot, but they can include diarrhea, abdominal pain, bloating, fatigue, weight loss, and even iron deficiency anemia.
So lots of potential problems.
Yeah. To diagnose celiac disease, doctors usually do blood tests and a biopsy of the small intestine. The only treatment is a strict gluten-free diet, which gives the small intestine a chance to heal and prevents further damage.
Okay, so we've got to be mindful of food sensitivities that can cause real havoc in our absorption district.
We do.
What about Crohn's disease? I know that's a serious condition that can affect any part of the digestive tract, but it often involves the small intestine, right?
You're right. Crohn's disease is like having this chronic state of unrest in our city. It's a type of inflammatory bowel disease, or IBD, that causes inflammation of the lining of the digestive tract. And the inflammation most commonly affects the last part of the small intestine, which is called the ileum.
So it's like there are constant protests and roadblocks happening, disrupting the flow of things and causing damage to the infrastructure.
That's a good way to think about it. The symptoms really vary depending on where the inflammation is and how severe it is, but they can include abdominal pain, diarrhea, rectal bleeding, weight loss, and fatigue. There's no cure for Crohn's disease, but the goal of treatment is to manage the symptoms, control the inflammation, and prevent complications.
So we need to keep those protests under control to keep our city functioning smoothly.
Exactly.
All right, let's move on to the large intestine, or colon, the waste disposal district of our city. What are some common issues that can happen there?
Okay, the large intestine. One of the most common conditions is diverticulosis.
Diverticulosis.
Yeah, it's like having these weak spots in the city walls where little pouches, called diverticula, form. Usually these pouches don't cause any problems,
Okay.
but they can become inflamed or infected, which leads to a condition called diverticulitis.
So diverticula are like little potholes in our city walls.
Yeah,
And when they fill up with debris and bacteria, it's like a mini explosion.
that's a great way to visualize it. The main symptoms of diverticulitis are abdominal pain, usually on the left side, fever, and changes in bowel habits. Treatment often involves antibiotics, rest, and a liquid diet.
So we need to keep those city walls strong and pothole-free.
Exactly.
What about ulcerative colitis? I know that's another type of IBD, but it mainly affects the colon, right?
That's right. Ulcerative colitis is like a wildfire spreading through the lining of the colon,
Okay.
causing ulcers and inflammation. It's a chronic condition that can cause abdominal pain, diarrhea, rectal bleeding, and urgency.
So it's like a firestorm raging through our waste disposal district, causing damage and disruption.
Exactly. Like Crohn's disease, there's no cure for ulcerative colitis, but the treatments focus on managing the symptoms and preventing those complications.
And of course, we can't forget about colorectal cancer. It's like a rogue development project in our city, growing uncontrollably and possibly spreading to other areas. It's so important to get regular screenings for colorectal cancer, especially after the age of 50, to catch it early when it's most treatable.
Yes, absolutely. Early detection is key.
So we've covered a lot of ground in our tour of the GI tract, from the esophagus to the stomach, small intestine, and large intestine. But there's one final stop on our journey, the rectum and anus, the exit gates of our abdominal city.
Right, the final stop.
What kinds of problems can happen in this area?
Well, one of the most common conditions is hemorrhoids. We touched on them a little earlier. They're swollen blood vessels in the rectum or anus.
Right.
They can cause pain, itching, and bleeding.
So hemorrhoids are like traffic congestion at the city's exit gates?
It's causing discomfort and delays.
And they're often caused by straining during bowel movements, which is why a high-fiber diet and good hydration are so important. You want to keep things moving smoothly.
Okay, so keep that traffic flowing. Anything else?
We also have anal fissures, which are little tears in the lining of the anus, often caused by constipation or diarrhea. These can be quite painful and might bleed.
So cracks in the pavement at the city's exit gates.
Exactly. And just like hemorrhoids, they're often related to bowel habits, so maintaining regular bowel movements can really help prevent them.
Right, consistency is key.
It is. And while we're on the topic of the rectum and anus, it's important to mention anal cancer. It's relatively rare, but it can cause bleeding, pain, and changes in bowel habits. It's important to see a doctor if you have any of these symptoms, just to rule out anal cancer or any other serious conditions.
Okay, so we finished our whirlwind tour of the GI tract from top to bottom.
We did it.
It's amazing how many things can go wrong in our abdominal city.
It's a complex system. It is. But now we've got a better understanding of those common warning signs of GI distress and the different conditions that can affect the various parts of the digestive system.
Definitely.
So remember, listeners, your body is constantly sending you signals. If something feels off, don't ignore it. Get it checked out. Early diagnosis and treatment can make a world of difference.
Absolutely, don't wait.
Now, speaking of being proactive, let's shift our focus to another vital part of our abdominal city, the kidneys. We'll explore these remarkable organs and how they keep our bodies clean and balanced in the next part of our deep dive. Stay tuned. And we're back for the final part of our journey into abdominal health.
The grand finale.
Exactly. We've explored this incredible city of organs, we've encountered the dangers of trauma, we've navigated the twists and turns of the GI tract.
Quite a journey.
It has been. But now we arrive at a crucial destination. The kidneys.
The kidneys.
These often overlooked but absolutely vital organs, the unsung heroes of our internal world.
You're so right. They're like the city's sophisticated filtration plant, constantly working to remove waste from the blood, regulate fluid balance, and just keep everything running smoothly.
Okay, I'm ready to give these bean-shaped wonders the attention they deserve. So we know they filter waste, but how exactly do they do that? Can you break it down for us?
Imagine the kidneys as this network of intricate filters and pipelines. Blood flows into the kidneys through the renal arteries, and then it enters these tiny filtering units called nephrons.
Nephrons. Okay, I vaguely remember those from biology class.
Right.
But how do they work?
Well, each nephron is like its own little processing plant, with a series of steps for filtering the blood. First, blood pressure forces fluid and small molecules from the blood into a cup-shaped structure called the glomerulus.
So it's like a sieve separating the good stuff from the bad.
Exactly. And then this filtered fluid, called filtrate, flows through these tiny tubes where essential things like water, glucose, and electrolytes get reabsorbed back into the bloodstream.
So it's not just removing waste, it's also about reclaiming valuable resources.
Exactly, like a recycling center built right into our filtration plant. The stuff that's left over, the waste products, along with excess water and electrolytes, become urine.
Okay.
And that flows out of the kidneys, through the ureters and into the bladder for storage.
So we've got our filtration plant with its sieves and pipelines, reclaiming valuable resources and sending the waste off for disposal. It's pretty remarkable. But as with any complex system, things can go wrong. What are some of those renal emergencies that can mess up this delicate balance?
Renal emergencies can range from infections to really serious conditions like kidney failure. Let's start with urinary tract infections, or UTIs. Those are like unwelcome visitors in our city, causing inflammation and discomfort.
UTIs, those are pretty common, right? And I've heard they're more common in women. Is that true?
Yeah, that's right. The female urethra, which is the tube that carries urine out of the body, is shorter than the male urethra. This makes it easier for bacteria to travel up into the bladder and cause an infection.
So even in our bodies, it's all about location, location, location. What about kidney stones? I've heard those are incredibly painful.
Oh, they can be. Kidney stones are like these crystal formations that form in our filtration plant. They can range in size, from tiny like a grain of sand to as big as a golf ball.
A golf ball?
Yeah, and they can cause excruciating pain as they try to pass through the urinary tract.
That's a scary thought. What causes them to form in the first place?
They form when there's an imbalance of certain substances in the urine, like calcium, oxalate, and uric acid. These can crystallize and clump together, forming stones that block the flow of urine.
So like mineral deposits building up in our city's pipes. Okay, what about acute kidney injury, or AKI? How is that different from kidney stones?
Acute kidney injury is like a sudden shutdown of the filtration plant.
Okay.
It can happen because of dehydration, infections, certain medications, even blockages in the urinary tract.
So it's like a power outage or a natural disaster that suddenly disrupts the kidney's ability to function.
Exactly. And then you have chronic kidney disease, or CKD, which is like a slow deterioration of the filtration plant. This is often due to underlying conditions like diabetes or high blood pressure.
So wear and tear on the city's infrastructure leading to a gradual decline in its ability to function. What happens when the kidneys just can't keep up anymore?
When the kidneys fail, waste products and fluids build up in the body, which can lead to all sorts of serious complications.
What are the treatment options when that happens?
So there are two main options: dialysis and kidney transplantation. Dialysis is like bringing in an external filtration system to do the job of the kidneys.
So like a mobile filtration unit to support our failing city.
Exactly. There are two types of dialysis: hemodialysis and peritoneal dialysis. In hemodialysis, the patient's blood is circulated through a machine that filters out the waste and excess fluids.
So like hooking the city up to a life support machine.
Yeah, good analogy. Then there's peritoneal dialysis, which uses the lining of the abdomen, called the peritoneum, as a natural filter. A special fluid is infused into the abdominal cavity, where it absorbs waste from the blood. Then the fluid is drained out, taking the toxins with it.
So it's like using a natural filtration system built right into the city walls.
Right.
That sounds a lot less invasive. What are the pros and cons of each type?
Well, hemodialysis is more efficient at removing waste products, but it requires going to a dialysis center several times a week, and each session can last for several hours.
So like scheduled maintenance for our city, but it's pretty time-consuming.
It is. Peritoneal dialysis, on the other hand, can be done at home, which gives patients more flexibility.
That's a big plus.
It is, but it requires daily exchanges of the dialysis fluid,
Yeah.
and there's a higher risk of infection.
So it's like a built-in system, but it needs constant upkeep. What about kidney transplantation? Is that a cure for kidney failure?
A kidney transplant offers the best chance of living a normal life again, but it's a major surgery, and there are potential risks and complications, of course.
So it's like getting a brand new filtration plant for our city, but it's a complex procedure. What determines if someone is eligible for a transplant?
Lots of things factor into that decision, including the patient's overall health, their age, their blood type, and the availability of a matching donor.
Right, it's complicated, but it's good to know there's hope for people with kidney failure. Now, we've talked about how the kidneys filter waste, but they also play a big role in maintaining the right amount of fluid in our bodies, right?
Absolutely. They're like the city's water management system, carefully controlling how much water stays in the body. They do this by adjusting the concentration of our urine.
Okay.
So when we're overhydrated, they get rid of more water. When we're dehydrated, they conserve water.
So they're like a dynamic dam, adjusting the flow to maintain a steady level.
Yes, perfect analogy. And on top of that, the kidneys regulate electrolytes, making sure we have the right amounts of sodium, potassium, and other minerals, which are crucial for things like nerve and muscle function.
So the kidneys are like multitasking masters.
They are.
Filtering waste, managing fluids, keeping our electrolytes in check. It's amazing how these relatively small organs play such a big role. But before we wrap up, I want to touch on one more thing. Genitourinary trauma.
Okay.
What kind of injuries can affect the kidneys, bladder, and other parts of the urinary system?
Genitourinary trauma can happen from either blunt or penetrating injuries, just like we talked about with abdominal trauma in general.
So our city's filtration plant and plumbing system can get damaged by an earthquake or a missile strike?
Exactly. Kidney injuries can range from minor bruising to severe tears, even rupture. Bladder injuries can cause leakage of urine. Urethral injuries can block the flow of urine.
Those are some serious plumbing problems.
Yeah.
What are the signs of genitourinary trauma, and what should someone do if they think they might have this kind of injury?
Some things to watch for are blood in the urine, pain or difficulty urinating, bruising or swelling in the flank or pelvic area, and any signs of shock. If you notice any of these, especially after a traumatic injury, it's crucial to get medical attention immediately.
So those are some major red flags.
They are. Early diagnosis and treatment can help prevent those complications and help preserve kidney function.
Well, we've covered a lot of ground today in our exploration of renal health, from the inner workings of the nephrons to those potential emergencies that can disrupt this delicate system. It's clear that the kidneys are essential for our overall health.
Absolutely. They really are. And it's important to be aware of what can go wrong and what to look out for.
So to our listeners, thank you for joining us on this deep dive into abdominal health.
It's been a pleasure.
We covered a lot, from the busy city of organs that make up our abdomen to the potential dangers of trauma and those common GI and renal emergencies that can occur. We hope you found this information helpful and maybe even a little bit empowering.
Knowledge is power.
It really is. Understanding our bodies better helps us take better care of ourselves. So stay curious, listen to your body, and don't hesitate to seek guidance from healthcare professionals when you need it.
And until next time, stay healthy and keep exploring.
And that's a wrap. We'll see you next time for another fascinating journey into the incredible world of the human body.
Welcome to another deep dive, everybody. Today, we're going to be taking a deep dive into the world of pharmacology,
Ooh, exciting.
with a special focus on medications used in emergency care.
That's a great topic.
We've got some really fascinating source material to work with.
Yeah.
A mix of introductory pharmacology stuff and then a guide to those critical meds that are used in emergency situations.
Perfect.
So get ready, because we're going to be going on a journey through time,
I love a good journey.
from ancient remedies to the huge billion-dollar pharmaceutical industry that we know today.
Wow. A lot to unpack there.
We'll also uncover the intricate regulations and approval processes
Yeah.
behind the very medications that save lives every day.
You know, it's really amazing how the quest to treat illness has just persisted throughout all of human history.
It really is.
And what we're going to discover is how dramatically our understanding and approach to treatment have just evolved over centuries.
Yeah, and our Intro to Farm Source really highlights this evolution.
Yeah.
It mentions ancient formularies with over 700 medications.
Can you believe that?
Can you believe that? It seems like our ancestors were just as determined to find cures as we are.
Oh, absolutely. But their knowledge of the human body and disease was really quite different.
Yeah.
So, for example, during the medieval period, illness was often seen as like a punishment from a higher power.
Oh, wow.
And so treatments focused on just alleviating symptoms
Yeah.
rather than addressing any underlying cause.
That makes sense,
Yeah.
given their limited understanding of things like bacteria and viruses.
Yeah, back then.
Yeah, back then.
Yeah.
It wasn't until much later in the 19th century that the pharmaceutical industry as we know it, really began to emerge.
Yeah.
This is when scientists started isolating and synthesizing potent medicinal compounds,
Yeah.
leading to the development of targeted therapies.
That shift from symptom management to targeted therapies.
Yeah,
That really marked a turning point in medical history.
it did.
Think about it.
Yeah,
We can now use medications to actually address the root cause of diseases,
yeah.
not just mask the symptoms. Right.
And that has had just a profound impact on human health and longevity.
No kidding.
It's incredible.
Speaking of modern medicine, let's talk about how medications are named.
Oh, yeah.
Turns out there's a whole system in place.
There is. It can seem a bit confusing at first,
Right.
but it's actually quite logical.
Oh, yeah, it's very logical.
Yeah.
Our source mentions 3 names for each drug.
Oh, right.
the chemical name,
Yeah.
which is usually a mouthful,
Yes.
the generic name,
Uh-huh.
and the trade name, which is the one we typically hear in like advertisements.
Yeah, that's the brand name, right?
That's the brand name.
Yeah, so the chemical name is like a really detailed blueprint of the drug's molecular structure,
I see.
while the generic name is a simpler, standardized name used by healthcare professionals.
Makes sense.
Yeah. And then the trade name is the brand name given by the pharmaceutical company that actually developed it.
Right.
And these medications don't just magically appear on pharmacy shelves.
No, they don't.
They go through a really rigorous approval process.
Absolutely. In Canada, the Health Products and Food Branch, or the HPFB,
Right.
plays a critical role in ensuring that all medications are safe and effective and are marketed truthfully.
Right.
So this whole approval process is incredibly thorough,
Yeah.
and it's designed to protect consumers like you and me.
That's good. I appreciate that.
Yeah.
It sounds like a really lengthy process, though.
It is.
So how long does it typically take for a new drug to actually get approved?
Well, on average, it takes about 9 years for a new drug to go from that initial research phase to approval.
Wow, 9 years.
That's almost a decade of testing and evaluation to ensure its safety and efficacy.
9 years. That seems like a long time,
It is.
especially for patients who are like waiting for new treatment options.
Right.
What contributes to that lengthy timeline?
Well, it's a multi-stage process,
Yeah.
and each stage is crucial for gathering evidence
Yeah,
and ensuring the drug is both safe and effective.
right.
So it starts with preclinical testing in the lab,
Okay.
followed by animal studies.
Got it.
And if the drug shows promise, it then moves on to human clinical trials.
Right, and our source mentions 4 phases of clinical trials.
There are...
Can you break down what happens in each phase?
Of course.
Okay.
So phase 1 trials involve a small number of healthy volunteers,
Okay.
and they focus on just evaluating the drug's safety profile, like the dosage range and how it's absorbed and metabolized by the body.
Okay.
So phase 2 trials then expand to include a larger group of patients
Uh-huh.
with the specific condition that the drug is intended to treat.
I see.
And these trials aim to determine the drug's effectiveness
Yeah.
and identify any potential side effects.
Got it. And so if a drug makes it through phases 1 and 2,
And it moves on to phase 3.
phase 3.
Yeah. And phase 3 trials are the largest and most comprehensive.
Wow.
They can involve thousands of patients
1,000.
across multiple study sites. These trials provide the most robust data on the drug's effectiveness and its long-term safety profile.
Oh, wow.
And if the drug successfully completes phase 3 trials, the pharmaceutical company can then submit an application to the HPFB for approval.
Oh, wow. And then there's phase 4.
Yes, phase 4 trials are conducted after the drug has been approved and is actually available on the market.
Wow.
And these trials involve ongoing monitoring to assess the drug's long-term effects
I see.
and identify any rare or delayed side effects that may not have been detected in earlier trials.
Wow. It's impressive how much goes into ensuring that the medications we use are safe and effective.
It is.
It really makes you appreciate the science and the regulatory processes behind it all.
It does, and
Yeah.
it really highlights the commitment to protecting public health.
Yeah, it really does.
Yeah,
Now, I'm curious about where these medications actually come from.
yeah,
Our source had this really interesting image showing a variety of sources,
right.
including animals, plants, and minerals.
Yeah, it's like a glimpse into the history of medicine.
Yeah, it does.
You know, for centuries, humans relied heavily on nature to provide healing compounds.
Yeah.
Many traditional remedies were derived from plants, animals, and even minerals.
Wow.
You know, think about aspirin, which originally came from willow bark, or morphine, which is derived from the opium poppy.
It's amazing how those ancient remedies have, like, paved the way for modern pharmaceuticals.
Oh, it is.
It really is.
And while we still utilize some natural sources, the pharmaceutical industry has evolved significantly.
It has.
Today, many medications are synthetic, meaning they're created in laboratories.
Wow.
And this allows for greater precision and control over the chemical composition and the dosage of medications.
And that shift towards synthetic medications has really revolutionized how we treat diseases.
It absolutely has.
Yeah.
It's allowed us to develop targeted therapies for such a wide range of conditions,
Yeah.
leading to just improved treatment outcomes and a better quality of life for countless people.
No kidding. It's pretty impressive.
Yeah.
But with all these powerful medications available, it's clear that regulation is essential.
It is.
Our source dives into Canadian regulation of pharmaceuticals and drug-related legislation.
Mm-hmm.
And it seems like a big focus is on protecting consumers.
You're absolutely right. Regulations are in place to ensure that medications are manufactured to a consistent standard,
Mm-hmm.
that their labeling is accurate, and that they're marketed responsibly.
Yeah.
So this helps to prevent false claims
Right.
and ensures that consumers are getting what they expect.
Right, and this source also mentions the Controlled Drugs and Substances Act of 1996.
Uh-huh.
Can you explain what that entails?
Yeah, so this act categorizes drugs based on their potential for abuse and dependence.
Oh, okay.
So think of it like a ranking system,
Yeah.
with Schedule 1 containing the most tightly controlled substances like heroin and cocaine,
Right.
and then Schedule 8 containing drugs with the lowest potential for abuse, like cough and cold medication.
Right.
So each schedule reflects the balance between a drug's medical usefulness and its potential for harm.
That makes sense.
Right.
Yeah.
So the goal is to ensure that those medications with a high potential for abuse are tightly controlled to prevent misuse and diversion.
That makes a lot of sense.
Yeah,
It's all about protecting public health and safety.
exactly. It's a balancing act
Yeah.
between ensuring access to medications for legitimate medical purposes and minimizing the risks associated with their misuse.
Now, let's shift our focus to the pre-hospital setting, where medications are often used in emergency situations.
Mm-hmm.
Our source really emphasizes the importance of safe and effective medication administration,
It is critical.
especially considering that these drugs can be both life-saving and life-endangering.
That's a crucial point. In emergency care, we're often dealing with time-sensitive situations
Yeah.
where accurate medication administration can make all the difference.
Absolutely.
It's why paramedics undergo such extensive training to ensure they have the knowledge and skills to handle these medications safely and effectively.
A lot of responsibility.
It is, but it's also incredibly rewarding,
Yeah.
Knowing that you have the ability to help someone in their time of need is a really powerful motivator.
Our source also mentions the Institute for Safe Medication Practices,
Yeah,
which has this list of error-prone abbreviations.
right.
Seems like even small mistakes can have really serious consequences when it comes to medication administration.
Absolutely. That's why clear communication and attention to detail are paramount.
Yeah.
We use standardized protocols and double-check everything to minimize that risk of errors.
Right. It's all about being vigilant
Yeah,
and prioritizing patient safety.
precisely. We're constantly striving to improve our practices
Yeah.
and ensure that we're providing the highest quality care possible.
Now let's dive into some specific medications that are commonly used in emergency scenarios,
Okay, sounds good.
starting with nitro or nitroglycerin.
Nitro. Fascinating drug. It's been used for decades to treat angina, which is chest pain caused by reduced blood flow to the heart.
Right. And our symptom relief ALS source explains that nitro is classified as a nitrate and an anti-anginal agent.
Mm-hmm.
It works by relaxing and widening blood vessels,
Yeah.
which improves blood flow to that heart muscle.
And it's incredibly fast-acting.
It is.
The effects can be felt within minutes,
Oh, wow.
providing rapid relief for patients experiencing chest pain.
But there are some situations where nitro is contraindicated,
Right.
meaning it shouldn't be used.
Correct.
For example, if a patient has recently taken a medication for erectile dysfunction,
Viagra.
like Viagra,
Right.
administering nitro could cause a dangerous drop in blood pressure.
That's a really important point. We always need to consider a patient's medication history before administering any new drug,
Yeah.
especially in emergency situations.
Yeah, absolutely.
Yeah.
So there's a lot to think about when it comes to using nitro safely and effectively.
Absolutely. It's a powerful medication
It is.
that can provide significant relief for patients with angina.
Yeah.
But it's just crucial to administer it appropriately
Yeah.
and monitor for potential side effects.
Absolutely.
Yeah.
Next up, let's talk about ASA, which is more commonly known as aspirin.
Aspirin, another workhorse medication that's been used for centuries.
Yeah.
It's an analgesic, antipyretic, anti-inflammatory, and antiplatelet agent.
Wow, that's a lot.
That means it can reduce pain, fever, inflammation, and prevent blood clots from forming.
Our source highlights its use in managing chest pain and potential heart attacks.
Right. Aspirin works by inhibiting the formation of thromboxane A2,
Okay.
which is a substance that promotes platelet aggregation,
Okay.
which is the clumping together of platelets to form a clot.
Right.
So by blocking this process, aspirin can help to prevent blood clots from forming in the artery,
Okay.
reducing the risk of heart attacks and strokes.
But like any medication, there are times when aspirin isn't appropriate. Yeah, for example, patients with active bleeding,
Right.
a recent stroke, or a history of aspirin sensitivity should avoid taking it.
Yeah, and it's also important to note that while aspirin is generally safe, High doses or long-term use can lead to side effects like stomach ulcers and gastrointestinal bleeding.
Oh, wow.
So it's always best to consult with a healthcare professional before taking aspirin regularly.
Now let's talk about oxygen,
Oxygen.
a vital element for life.
And a
Optimal therapy in many emergency situations.
Oh, yeah. Oxygen therapy is used to increase the amount of oxygen in the blood,
Yeah.
which is essential for organ function.
Right.
It's often administered through a nasal cannula or a face mask.
Seems pretty straightforward.
Yeah,
But our source mentions some nuances,
it does.
especially when it comes to patients with COPD
Right. That's chronic obstructive pulmonary disease.
or chronic obstructive pulmonary disease.
Right.
In those patients who often have difficulty breathing and retaining carbon dioxide,
Yeah.
we need to be cautious with oxygen administration.
Yeah, high concentrations of oxygen can actually suppress their respiratory drive,
Wow.
leading to further breathing problems.
So it's not as simple as just giving everyone as much oxygen as possible.
No, it's not.
We need to individualize oxygen therapy
Yeah,
based on the patient's specific needs and underlying conditions.
precisely.
And our source mentions a really interesting fact about oxygen.
Oh, what's that?
Prolonged exposure to high levels in neonates or newborns can actually cause blindness.
No, that's right.
It's called retrolental fibroplasia,
It is.
and it highlights the importance of careful monitoring when it comes to oxygen therapy.
It's a reminder that even those essential therapies can have unintended consequences if not administered appropriately.
Now let's move on to glucagon, a medication that's primarily used for treating hypoglycemia or low blood sugar.
Glucagon is a hormone that works by stimulating the liver to release stored glucose into the bloodstream.
Oh, wow.
So it's a life-saving treatment for severe hypoglycemia,
It is.
which can cause seizures, coma, and even death if not treated promptly.
It sounds like a critical medication for paramedics to have on hand.
Oh, absolutely. We often encounter patients with hypoglycemia in the field, especially those with diabetes who may have missed a meal or taken too much insulin.
Yeah, but glucagon isn't just for hypoglycemia, right?
That's right.
Our source mentions some other interesting uses for this medication.
It can also be used to treat beta blocker overdose and even help with esophageal obstruction.
Wow.
So it's a versatile medication with a few tricks up its sleeve.
Now let's talk about Ventolin, otherwise known as albuterol, a medication that's commonly used to treat bronchoconstriction or narrowing of the airways.
Ventolin is a type of bronchodilator that works by relaxing the muscles in the airways, allowing for easier breathing.
Right.
It's a mainstay treatment for asthma and other respiratory conditions that cause wheezing and shortness of breath.
Yeah, our source describes it as a sympathomimetic bronchodilator,
Yeah.
which sounds pretty complex.
It sounds complicated.
Yeah.
But it basically means that Ventolin mimics the effects of the sympathetic nervous system, which is responsible for the fight-or-flight response.
Right. Okay.
So one of the effects of the sympathetic nervous system is bronchodilation, or
Okay.
the widening of the airways.
So Ventolin essentially triggers the body's natural mechanism for opening up the airways.
Exactly. It's a quick and effective way to provide relief for patients who are struggling to breathe.
But, like any medication, Ventolin has potential side effects.
Right.
Our source mentions that it can cause tachycardia or rapid heartbeat,
Yeah.
tremors, and even anxiety in some patients.
That's why it's important to monitor patients closely after administering Ventolin and adjust the dosage as needed.
Now let's talk about epinephrine, a medication that's often described as a life-saving drug.
It is.
Yeah.
Epinephrine is a powerful medication that affects both alpha and beta receptors in the body,
Wow.
leading to this cascade of effects
Yeah.
that can be life-saving in emergency situations.
Yeah. Our source explains that it increases heart rate and the force of heart contractions, dilates the bronchioles, and constricts blood vessels.
That's right. Epinephrine is a go-to treatment for anaphylaxis,
Yeah.
which is a severe allergic reaction that can cause life-threatening airway constriction
Yeah.
and a drop in blood pressure.
And it's also used to treat severe asthma attacks and even cardiac arrest.
Exactly. It's a very versatile medication
Yeah.
that can be administered intravenously, intramuscularly, or even through an auto-injector like an EpiPen.
Wow.
But like any powerful medication, epinephrine comes with potential risks.
Of course.
So we need to be aware of potential side effects like tachycardia,
Yeah.
palpitations, anxiety, and even chest pain.
Wow.
So that's why it's crucial to administer epinephrine carefully and monitor patients closely for any adverse reactions.
Now let's shift gears and talk about some medications that are commonly used for pain management,
Okay.
starting with acetaminophen,
Acetaminophen.
which is more commonly known as Tylenol.
Or Tylenol, right?
Yes.
It's a widely used over-the-counter pain reliever and fever reducer.
Yeah.
It's generally considered safe when taken as directed, but it's important to be mindful of potential liver damage if taken in excessive amounts
Oh, wow.
or for prolonged periods.
Okay.
So our source describes it as an analgesic and antipyretic, meaning it reduces pain and fever,
Mhm.
but it doesn't have anti-inflammatory properties like some other pain relievers.
Right.
So acetaminophen works by blocking pain signals in the brain and reducing fever.
Mm-hmm.
And it's often used for mild to moderate pain relief
Mm.
and is a common ingredient in many cold and flu medications.
Right.
So ibuprofen is another popular pain reliever.
Ibuprofen.
Yeah, that's available over the counter.
Right.
And it's classified as an NSAID or a non-steroidal anti-inflammatory drug.
Okay.
So it works by reducing hormones that cause pain and swelling in the body.
Oh, I see.
Yeah, our source mentions that it's often used to treat headaches,
Uh-huh.
muscle aches, toothaches, and menstrual cramps.
Right.
And ibuprofen is also effective for reducing fever and relieving pain from arthritis and other inflammatory conditions.
But ibuprofen can cause side effects, right?
Yes, it can. Common side effects include heartburn, stomach upset, and nausea.
Yeah.
And in rare cases, ibuprofen can cause more serious side effects like ulcers or gastrointestinal bleeding.
Oh, wow.
So it's important to use ibuprofen cautiously,
Yeah.
especially if you have a history of stomach problems,
Right.
or if you're taking other medications that can increase the risk of bleeding.
Now let's talk about ketorolac,
Ketorolac
also known as Toradol,
or Toradol.
which is a powerful NSAID often used for more severe pain.
Yeah, ketorolac is similar to ibuprofen in its mechanism of action,
Okay.
but it's typically only available by prescription.
Gotcha.
It's often used for short-term pain management after surgery or for other moderate to severe pain conditions.
Yeah. Our source mentions that ketorolac has a higher risk of side effects compared to other NSAIDs, especially gastrointestinal bleeding.
That's right. Ketorolac should be used with caution.
Yeah.
And it's typically not recommended for long-term use.
Now, let's shift our focus to medications used for nausea and vomiting, starting with ondansetron, which is commonly known as Zofran.
Ondansetron is an antiemetic, meaning it prevents nausea and vomiting.
Right.
And it works by blocking serotonin receptors in the brain and gastrointestinal tract,
Okay.
which are involved in that vomiting reflex.
Yeah. Our source highlights its effectiveness in treating nausea and vomiting caused by chemotherapy,
Right.
radiation therapy, and surgery.
Yeah, it's also commonly used for nausea associated with migraines,
Oh, interesting.
gastroenteritis, and even motion sickness.
Right. But ondansetron isn't for everyone.
Right. There are certain situations where it should be avoided.
Yeah.
For instance, patients with a prolonged QT interval,
Okay.
which is a heart rhythm abnormality,
Yeah.
should not take ondansetron as it can increase the risk of serious heart problems.
And sometimes good old-fashioned diamond hydronate or gravel is the best choice for managing nausea and vomiting.
Yeah, diamond hydronate is an over-the-counter antihistamine
Okay.
that's commonly used for motion sickness. And it works by blocking the action of histamine, a chemical involved in the vomiting reflex.
Right, but it can cause drowsiness, right?
Yeah, drowsiness is a common side effect of diamond hydronate,
Right.
which is why it's often used to prevent or treat motion sickness during travel.
Yeah, now let's talk about a medication that's been making headlines lately, naloxone,
Naloxone,
also known as Narcan.
or Narcan.
Is a life-saving medication that's used to reverse the effects of opioid overdoses.
Yeah, it works by blocking opioid receptors in the brain,
Uh-huh.
effectively displacing opioids and reversing their effects, including respiratory depression, which can be fatal.
Wow, and our source describes it as a narcotic antagonist.
It
It
is.
sounds like a crucial tool in combating the opioid epidemic.
It absolutely is. Naloxone is now widely available without a prescription.
Oh, really?
Yeah.
Wow.
And it's been instrumental in saving countless lives.
Wow, that's great.
Yeah, bystanders, first responders, and even family members of people who use opioids are encouraged to carry naloxone and be prepared to administer it in case of an overdose.
It's incredible how accessible this life-saving medication has become.
It is.
Yeah.
It's a real testament to the importance of harm reduction strategies in addressing the opioid crisis.
Yeah, it really is.
Yeah.
Now, let's touch on a less common but potentially life-threatening condition. Adrenal crisis, also known as Addisonian crisis.
Adrenal crisis occurs when the adrenal glands, which sit on top of the kidneys, don't produce enough cortisol,
Right.
a hormone that's essential for regulating blood pressure,
Mm-hmm.
metabolism, and stress response.
Our source explains that patients with primary adrenal insufficiency, which is the most common cause of adrenal crisis,
Yeah,
often manage well with medication.
they do.
But during times of stress, their cortisol needs increase.
Right.
And without proper treatment, they can become critically ill.
Exactly. Adrenal crisis can be triggered by various factors,
Like what?
including illness, surgery, trauma, and even emotional stress.
Wow.
So symptoms can include severe fatigue, weakness, nausea, vomiting, abdominal pain,
Yeah.
low blood pressure, and even confusion.
It sounds like a really serious condition.
It is.
What's the treatment for adrenal crisis?
The mainstay treatment is hydrocortisone,
Okay.
which is a synthetic form of cortisol.
Okay.
It's typically administered intravenously or intramuscularly in emergency situations.
But hydrocortisone isn't a medication that paramedics typically carry, right?
That's correct. However,
Oh.
there are specific situations where paramedics might encounter a patient with adrenal crisis who has a pre-supplied vial of hydrocortisone.
Oh, okay.
Yeah.
And those are like,
So these situations would include severe hypoglycemia,
okay.
persistent gastrointestinal symptoms,
Mm-hmm.
syncope or fainting,
Oh,
high fever,
yeah,
altered level of consciousness, or significant tachycardia or hypotension.
I see.
So in these cases, the patient's condition may be so severe that prompt administration of hydrocortisone is warranted,
Right.
even before transport to the hospital.
Okay, so there are protocols in place to guide paramedics in these unusual situations.
Absolutely.
Yeah.
Our goal is to provide the best possible care to all patients, even in those rare cases where we encounter conditions that we don't typically treat in the field.
And our source mentions that patients treated with hydrocortisone for adrenal crisis require close monitoring
Uh-huh.
and should be transported to the hospital for further evaluation and management.
Right. Adrenal crisis can be a life-threatening condition. So prompt recognition treatment and transport to a hospital are essential.
Now let's shift our attention to intravenous or 5E therapy, a cornerstone of emergency care.
5E therapy involves administering fluids and medications directly into the bloodstream through a vein.
Right.
It's a rapid and effective way to deliver medications and fluids in emergency situations.
Our source highlights the importance of choosing the right 5E solution
Right.
based on the patient's needs.
Exactly.
It mentions isotonic crystalloids like normal saline and lactated Ringer's solution,
Uh-huh.
which are commonly used for fluid resuscitation in pre-hospital setting.
These solutions have a similar concentration of electrolytes as blood plasma.
I see.
So they help to restore fluid volume without causing significant shifts in electrolyte balance.
Yeah. The source also covers the various types of IV administration sets,
Yeah.
like microdrip and macrodrip sets,
Mm.
and the importance of using sterile technique when setting up and maintaining an IV line.
Oh, sterile technique is crucial to prevent infections,
Yeah.
which can be serious complications, especially in patients who are already ill or injured.
And choosing the appropriate IV site is another important consideration.
Absolutely. We look for veins that are straight, firm, and springy when palpated.
Okay.
And we want to avoid areas like joints,
Yeah.
edematous extremities, and sites with overlying cellulitis or other skin infections.
Right. It's all about minimizing the risk of complications and ensuring that the 5E is inserted safely and effectively.
Exactly.
Now, let's talk about some auxiliary medical directives, which are specific protocols that allow paramedics to provide certain treatments under defined circumstances.
Uh-huh.
First up, CPAP, or continuous positive airway pressure.
CPAP is a non-invasive ventilation technique
Okay.
that helps improve oxygenation in patients with conditions like acute pulmonary edema and COPD exacerbations. So it works by providing continuous positive pressure to the airways,
Right.
preventing them from collapsing and improving gas exchange.
But CPAP isn't appropriate for every respiratory distress situation, right?
That's correct. It's contraindicated in patients with asthma exacerbations,
Okay.
suspected pneumothorax, which is a collapsed lung,
Right.
unprotected or unstable airways,
Okay.
major trauma or burns to the head or torso, and those with tracheostomies.
Right. And it's also crucial to monitor patients closely while they're on CPAP,
Yeah,
as their blood pressure and oxygen saturation can fluctuate.
absolutely. We need to ensure that the CPAP is providing that desired benefit without causing any adverse effects.
Another auxiliary medical directive involves the use of supraglottic airways, which are devices that are inserted into the mouth to secure the airway and facilitate ventilation.
Supraglottic airways are often used when basic airway maneuvers like head tilt chin lift or jaw thrust aren't sufficient to maintain a patent airway.
Right.
And they're particularly useful for patients who are unconscious or who have a reduced level of consciousness.
But they're not without risks, right?
No, there are no contraindications include foreign body airway obstruction,
Oh,
known esophageal disease like varices,
right.
trauma to the oropharynx, and caustic congestion.
Okay.
So it's essential to confirm proper placement of a supraglottic airway.
Yeah.
And our source mentions that capnography, which measures carbon dioxide levels in exhaled breath, is the gold standard for verification.
Right. We need to ensure that the airway is in the right position to facilitate effective ventilation.
Precisely.
And if a patient with a supraglottic airway in place achieves return of spontaneous circulation, or ROSC,
Yeah.
the airway should be removed if...
It really is a dynamic field, and that's what makes it so fascinating. Speaking of fascinating, let's discuss a medication that's been generating a lot of buzz lately. Dexamethasone.
Oh, yes, dexamethasone.
It's a corticosteroid,
Yeah.
known for its potent anti-inflammatory effects.
I've heard about its use in treating respiratory conditions
Yeah.
like asthma and COPD exacerbations.
It can even be beneficial for patients with a history of smoking,
Oh, really?
which is interesting.
That is interesting.
What's intriguing about dexamethasone is its ability to work alongside other medications like salbutamol and epinephrine.
Oh, okay.
It doesn't replace these primary treatments,
Right.
but rather enhances their effectiveness.
So it's like a team player,
Yeah,
boosting the effectiveness of other medications.
exactly. And studies have shown that early administration of dexamethasone can actually improve patient outcomes.
Wow, that's great.
This not only benefits the patient directly, but can also reduce the strain on the healthcare system.
That's impressive. But I imagine there are specific criteria that need to be met before administering dexamethasone.
You're absolutely right.
Okay.
For instance, patients who are already on oral or parenteral steroids shouldn't receive dexamethasone.
Go.
So it's all about understanding the nuances and ensuring we're using these medications safely and appropriately.
Safety first, always.
Always.
Now, I know we've already touched on some pain management medications.
Yeah.
But are there any others that are commonly used in emergency care that we haven't discussed yet?
We talked about acetaminophen and ibuprofen, but let's delve into ketorolac,
Okay.
which goes by the brand name Toradol.
Oh, Corridol. I've heard of that one.
Yeah, it's a powerful NSAID typically used for moderate to severe pain.
Yeah, it's often given intramuscularly or
Yeah.
intravenously
Yeah,
when oral medications aren't an option.
you got it.
Yeah.
So if you think about the bigger picture,
Yeah,
what's crucial to remember about ketorolac is that while it's a stronger analgesic than ibuprofen,
Okay.
it also carries a higher risk of side effects.
Right.
Yeah.
Particularly gastrointestinal issues like ulcers and bleeding.
Exactly.
So it's reserved for situations where oral pain relievers aren't effective,
Right.
or the pain is severe enough to warrant a stronger medication.
Now, switching gears to nausea and vomiting, ondansetron, also known as Zofran, is often the go-to medication.
Yeah, I've heard of Zofran.
Yeah, it's highly effective in managing nausea stemming from various causes,
Yeah.
including chemotherapy, head trauma, and certain medications.
Ondansetron works by blocking those serotonin receptors in the brain and gut,
Yeah,
preventing the signals that trigger nausea and vomiting.
exactly.
It's like intercepting those signals before they can cause discomfort.
That's a great way to put it.
But we need to be aware of potential contraindications.
Right.
For example, patients with prolonged QT syndrome,
Yeah.
a heart rhythm disorder,
Uh-huh.
shouldn't receive ondansetron because it can worsen their condition.
Correct.
So even though it's effective, it's not a universal solution. Are there alternatives for those who can't take ondansetron?
Absolutely. Dimenhydrinate, better known as Grovel, can be a good alternative.
Oh, grovel.
It works through a combined antimuscarinic and antihistamine effect,
Okay.
making it useful for managing motion sickness and other types of nausea and vomiting.
Gravol. I've definitely used that for motion sickness before.
Yeah.
But I remember it making me quite drowsy.
Yeah.
Are there any situations where that drowsiness could be a problem?
You bring up a good point.
Yeah.
Drowsiness is a common side effect of dimenhydrinate,
Right.
and it can be particularly problematic for elderly patients as it may lead to confusion and other cognitive side effects.
So choosing the right antiemetic really depends on the individual patient and their specific needs.
Exactly.
Now let's shift our focus to a medication that plays a critical role in addressing the opioid epidemic, naloxone.
Naloxone, also known as Narcan,
Narcan, yeah.
is a true lifesaver when it comes to opioid overdoses. It's incredible how quickly it can reverse the effects of opioids, especially respiratory depression, which can be fatal.
How does it work? How does it work so fast?
What's truly remarkable about naloxone is how it works. It acts as an antagonist,
Okay.
competing with opioids for those receptor sites in the brain and body.
Right.
It essentially kicks the opioids off those receptors, reversing their effects.
So it's like a key that fits into the same lock as the opioids,
Yeah.
but doesn't activate the lock.
That's a great analogy.
Okay.
And because it's competing for those same receptor sites,
Yeah.
naloxone can actually displace opioids that are already bound, reversing their effects.
It sounds like a crucial tool for first responders.
It is.
Anyone who might encounter an opioid overdose.
Absolutely. Naloxone is increasingly available without a prescription,
Wow.
and many communities are making a concerted effort to distribute it widely.
That's great.
But naloxone is only a temporary fix.
Yeah.
Naloxone's effects wear off faster than many opioids.
Right.
So it's crucial to transport patients to the hospital for ongoing monitoring and treatment.
Okay.
Even if someone seems to be recovering after receiving naloxone,
Yeah.
they could relapse into an overdose state once the naloxone wears off.
I've also heard that reversing an opioid overdose with naloxone can trigger withdrawal symptoms,
Right.
which can be quite uncomfortable
Yes.
and even dangerous in some cases.
You're right. Reversing an opioid overdose can be a jarring experience for the patient.
Yeah.
They might experience nausea, vomiting, muscle aches, agitation, and even aggression.
Wow.
So it's crucial to be prepared to manage these potential complications and provide support to the patient.
Now, let's switch gears and talk about some specific medical directives that guide paramedic practice.
Okay, sounds good.
Can you explain what those are?
So medical directives provide a framework for paramedics to operate within,
Yeah.
outlining specific protocols and guidelines for various situations.
Right.
And they help to ensure that we're providing consistent, high-quality care to our patients, regardless of the circumstances.
So they're like a roadmap for decision-making in the field.
Exactly. They provide a structured approach to patient care.
Right.
Especially in those time-sensitive, high-pressure situations
Yeah.
where quick thinking and decisive action are essential.
Absolutely.
So our source mentions the IV and fluid therapy medical directive.
What does that entail?
So this directive provides guidelines for establishing and maintaining intravenous access
Yeah.
and administering fluids safely and effectively.
Right.
And it's all about ensuring we're providing the right fluids
Yeah.
at the right rate
Right.
based on the patient's age,
Okay.
clinical condition, and specific needs.
So it sounds like a foundational directive for paramedic practice,
Absolutely.
especially considering how often we use IV therapy in the field.
It's one of those core skills that every paramedic needs to master.
Yeah. And the directive also outlines situations where paramedics need to consult with a base hospital physician before proceeding with certain interventions.
Yes.
This helps to ensure that patients receive the most appropriate care, especially in complex or potentially high-risk situations.
Exactly.
So those consultations provide an opportunity for paramedics to discuss the case with a physician, get expert advice, and make sure they're on the right track.
It's a valuable safety net that can help to prevent complications and improve patient outcomes.
Our source mentions an example involving children with suspected diabetic ketoacidosis.
Right.
Can you explain why that situation would require a physician consultation?
Children with suspected diabetic ketoacidosis require careful fluid management
Right.
to avoid complications like cerebral edema,
Okay.
which is swelling in the brain.
Right.
And it's a potentially life-threatening complication that can occur if fluids are given too quickly.
Right.
So consulting with a physician allows paramedics to determine the safest and most effective fluid management strategy for each individual child.
So it's about getting that extra layer of expert guidance to ensure we're making the best decisions for our young patients.
Now let's talk about another important medical directive, the CPAP medical directive.
CPAP, or continuous positive airway pressure,
Yeah.
is a non-invasive ventilation technique that's really effective for managing certain respiratory conditions,
It is.
like acute pulmonary edema and COPD exacerbations.
It's become a staple in pre-hospital care for those conditions.
Yeah.
By providing that continuous positive pressure to the airways, CPAP helps prevent the alveoli,
Yeah, okay.
those tiny air sacs in the lungs, from collapsing,
Yeah.
improving gas exchange and making breathing easier.
But just like with any intervention, There are situations where CPAP isn't appropriate.
Right.
Can you elaborate on those?
CPAP is contraindicated in cases like asthma exacerbations,
Okay.
suspected pneumothorax, which is a collapsed lung,
Right.
unprotected airways, major trauma, and burns to the head or torso.
Okay.
So it's also not appropriate for patients who are unconscious or unable to protect their own airway.
Right. And even when it is appropriate, it's crucial to monitor patients closely while they're on CPAP.
Absolutely. Blood pressure and oxygen saturation can fluctuate during CPAP therapy.
Right.
So we need to be vigilant and make adjustments as needed.
Yeah.
We want to ensure we're providing the right level of support while minimizing the risk of complications.
Now, what about supraglottic airways?
Right.
Our source mentions a medical directive for those as well.
So the Supraglottic Airway Medical Directive outlines the guidelines for using these devices,
Oh,
which are inserted into the mouth to help manage the airway and facilitate ventilation,
Right.
especially when basic airway maneuvers aren't sufficient.
So they're like a backup plan when those basic maneuvers aren't enough to keep the airway open.
Exactly. And they're particularly helpful for unconscious or semi-conscious patients
Yeah.
who can't protect their own airways.
But just like with CPAP, there are specific contraindications for using supraglottic airways. What are some of those contraindications?
Well, for starters, they shouldn't be used if there's a foreign body obstructing the airway.
Oh, okay.
They're also contraindicated in cases of known esophageal disease.
Trauma to the mouth or throat and caustic ingestion.
Got it.
So carefully assessing the situation before using a supraglottic airway is essential.
And once a supraglottic airway is in place, confirming proper placement is absolutely crucial, right?
Absolutely.
Yeah.
We need to make sure it's in the right position to effectively ventilate the patient.
Right.
And the gold standard for verification is capnography,
Okay.
which measures carbon dioxide levels in exhaled breath.
Right.
So if we're seeing those carbon dioxide waveforms, we know the airway is in the right spot.
What happens if a patient with a supraglottic airway achieves ROSC,
Oh, yeah.
return of spontaneous circulation?
In that case, we need to be prepared to remove the airway promptly
Okay.
if their gag reflex returns or if they start to vomit.
Yeah.
So the return of these reflexes indicates that the patient is regaining consciousness
Yeah.
and may be able to protect their own airway.
Right.
So we don't want to risk them aspirating, which can lead to serious complications like pneumonia. Now let's talk about a unique situation that paramedics might encounter, an emergency involving a patient receiving home dialysis.
Right.
Our source mentions a specific medical directive for that.
That's right. The Home Dialysis Emergency Disconnect Medical Directive
Okay.
provides guidance for paramedics in safely disconnecting a patient from their dialysis machine
Right.
when transport to the hospital is necessary.
I imagine that's a delicate procedure that requires specialized knowledge.
Absolutely. It's not something we encounter every day, but it's important to be prepared.
Right.
Typically, paramedics are provided with an emergency disconnect kit
Okay.
and instructions to ensure a safe disconnection.
So the kit contains the necessary equipment and step-by-step instructions to guide you through the process.
Exactly.
It's reassuring to know that there are protocols in place for these less common but potentially life-saving situations.
Now let's shift our focus to another condition that paramedics may encounter, adrenal crisis, also known as Addisonian crisis. This involves a deficiency of cortisol, a vital hormone produced by the adrenal glands.
I remember from our earlier discussion that cortisol plays a key role in regulating blood pressure metabolism and the body's stress response.
You've got a great memory.
Thank you.
And when those adrenal glands aren't producing enough cortisol, it can lead to a cascade of problems,
Right.
resulting in adrenal crisis.
And our source explains that patients with primary adrenal insufficiency,
Uh-huh.
the most common cause of adrenal crisis,
Yeah,
often manage well with medication.
they do.
But during times of stress, their cortisol needs increase.
Yeah,
And without proper treatment, they can become critically ill.
exactly. And those stressors can be anything from an illness or infection to surgery, trauma, or even extreme emotional stress.
Wow.
So these events place an increased demand on the body for cortisol. And if the adrenal glands can't keep up, it can lead to adrenal crisis.
What are some of the signs and symptoms of adrenal crisis that paramedics should be aware of?
So the presentation can vary from person to person, but common symptoms include severe fatigue and weakness,
Okay.
nausea and vomiting, abdominal pain, low blood pressure, and even confusion or altered mental status.
Wow.
So in severe cases, adrenal crisis can lead to shock and even coma.
It sounds like a serious condition that requires prompt recognition and treatment.
Absolutely.
So what is the treatment for adrenal crisis?
So the cornerstone of treatment is hydrocortisone, a synthetic form of cortisol.
But we discussed earlier that paramedics don't typically carry hydrocortisone.
That's right. However, there are specific situations where paramedics might encounter a patient with adrenal crisis who has a pre-supplied vial of hydrocortisone.
Can you elaborate on those situations?
Yeah, these situations include severe hypoglycemia, persistent gastrointestinal symptoms, syncope, or fainting, high fever, altered level of consciousness, or significant tachycardia or hypotension.
Okay.
So in these cases, the patient's condition may be so severe that prompt administration of hydrocortisone is warranted,
Right.
even before transport to the hospital.
Right. And the medical directive provides guidance on how to administer hydrocortisone in these situations.
Precisely. The directive outlines the appropriate dosage, route of administration, and monitoring parameters
Yeah.
to ensure the medication is given safely and effectively.
It's remarkable how much knowledge and expertise paramedics need to have to handle these complex situations.
It's a constant learning process.
Yeah.
And we're always striving to expand our knowledge and skills to provide the best possible care to our patients.
Now, before we move on to the final part of our deep dive, let's revisit the components of a medication profile section from our Intro to Farm Source.
Okay.
It serves as a great reminder of all the information that goes into understanding and administering medications safely and effectively.
You're absolutely right. Each medication has its own unique profile, a comprehensive set of information that includes its classification mechanism of action indications, pharmacokinetics, side effects routes of administration dosages, contraindications, and special considerations.
It's a wealth of information that guides our practice and helps us make informed decisions about medication administration.
And it highlights the importance of continual learning.
Absolutely.
The world of pharmacology is constantly evolving with new medications, new research, and new guidelines emerging all the time.
Staying updated is crucial for ensuring we're providing the best possible care to our patients.
Now for the grand finale of our deep dive.
Okay.
Let's explore some real-world scenarios that put all of this knowledge into practice.
Okay, so let's jump into those real-world scenarios you mentioned. Let's imagine a situation where we're called to a soccer game for a 10-year-old child experiencing shortness of breath hives, nausea, and wheezing after a possible peanut exposure. What jumps out at you in this case?
The combination of respiratory distress, skin reactions, and potential allergen exposure points toward anaphylaxis. This is a serious allergic reaction that demands immediate intervention.
And epinephrine would be the first-line treatment in this situation, right? To counteract those life-threatening symptoms?
Exactly. Epinephrine is our go-to medication for anaphylaxis. Considering the child's age and weight, the appropriate dose would be 0.3 milligrams intramuscularly. That's typically administered using an auto-injector like an EpiPen.
Okay, so we've administered epinephrine, but what if the child continues to struggle to breathe? What would our next steps be?
That's a crucial question. If the child remains in respiratory distress despite the epinephrine, we might need to administer a second dose. Additionally, we definitely want to provide supplemental oxygen and closely monitor their vital signs, looking for any signs of improvement or deterioration.
It sounds like managing anaphylaxis can be quite dynamic, requiring ongoing assessment and adjustments to the treatment plan.
Absolutely. Each patient responds differently to treatment, and the situation can evolve rapidly. We need to be prepared to adapt our approach based on the patient's response.
Now let's shift gears to a different scenario. Imagine we're dispatched to a nursing home for a 79-year-old resident with a history of angina who's complaining of chest pain similar to what they've experienced before. Their blood pressure is 150/80 millimilli Hg, and their heart rate is 79 beats per minute. How would we approach this situation?
In this case, we'd want to start by assessing the patient carefully. We'd gather information about their symptoms, including the onset severity and any associated factors. We'd also obtain a 12-lead ECG to rule out a heart attack.
And since the patient has a history of angina, we'd want to consider administering nitroglycerin, right?
That's right. Nitroglycerin is a vasodilator, which means it helps to widen blood vessels. This improves blood flow to the heart muscle, which can alleviate chest pain associated with angina.
And based on their vital signs, nitroglycerin seems appropriate in this case. Their blood pressure isn't too low, and their heart rate is within a normal range.
You're absolutely right. We'd start with a dose of 0.4 milligrams of nitroglycerin sublingually, which means it's placed under the tongue and allowed to dissolve. Then we'd closely monitor their response, reassessing their symptoms and vital signs.
But let's say 5 minutes later, their blood pressure drops to 180 millimilli Hg, and their heart rate increases to 90 beats per minute. How would that change our approach?
That drop in blood pressure would definitely warrant caution. A significant decrease in blood pressure, especially a third of the initial reading, could make further nitroglycerin administration risky. In this situation, we'd hold off on giving any additional doses and focus on supporting their blood pressure. We might consider elevating their legs and closely monitoring their vital signs for any further deterioration.
It seems like managing a patient with chest pain requires a delicate balance between providing pain relief and ensuring their blood pressure remains stable.
You hit the nail on the head. It's a dynamic process that demands careful assessment and thoughtful decision-making.
Now, for a completely different scenario, let's imagine we're called to a scene where an 18-year-old football player is experiencing shortness of breath and wheezing after intense exercise during a heat wave. What are our initial thoughts?
In this situation, exercise-induced bronchospasm comes to mind. Especially with the wheezing, it suggests that his airways are constricted. Of course, we'd want to rule out other potential causes, but administering a bronchodilator like albuterol would be a reasonable first step to try to open up those airways.
Since he's 18, we could administer 800 micrograms of albuterol via an MDI or metered dose inhaler. We'd coach him to take slow, deep breaths after each puff to ensure the medication reaches deep into his lungs.
That's right. And while we're administering the albuterol, we'd also be assessing him for any signs of more serious respiratory distress, such as a rapid heart rate difficulty speaking or bluish tint to his skin. If those were present, we'd need to escalate our care and potentially transport him to the hospital.
It's all about staying vigilant and anticipating potential complications, even in situations that seem relatively straightforward.
Now let's say we encounter a 50-year-old patient with a history of congestive heart failure who's complaining of fever cough, chest congestion, and difficulty breathing. They have crackles in their lungs and swelling in their legs. Their blood pressure is 18,070 mmHg, and their heart rate is 110 beats per minute. They've already taken their husband's nitroglycerin, but it hasn't provided much relief. What are your thoughts on this case?
This sounds like a complex case with potential for complications. The elevated blood pressure, crackles, and swelling suggest fluid overload, which is common in heart failure exacerbations. It sounds like their heart isn't pumping effectively and fluid is backing up in their lungs and legs.
You're spot on, and the fact that they've already taken nitroglycerin adds another layer of complexity. While nitroglycerin can be helpful in heart failure, it can also lower blood pressure, so we need to be cautious.
So would we administer additional nitroglycerin in this case?
If they have an established IV line and their blood pressure remains elevated, we could consider administering 0.8 milligrams of nitroglycerin sublingually. But we'd need to monitor their blood pressure very closely to ensure it doesn't drop too low.
What if they don't have an IV line?
In that case, we'd hold off on further nitroglycerin and focus on providing supportive care. This might include supplemental oxygen, positioning them comfortably to help with their breathing, and potentially administering a diuretic if their blood pressure allows for it.
And we'd want to establish IV access en route to the hospital to allow for further interventions if needed.
Absolutely. Timely transport to the hospital is crucial in this situation.
Now imagine we're called to a scene where a 2-year-old child with a history of asthma is experiencing severe respiratory distress after being discharged from the hospital for pneumonia. They're unresponsive, have minimal breath sounds, and a rapid respiratory rate. Their heart rate is 150 beats per minute, and they have a history of a barking cough. They're also showing signs of cyanosis and are tripoding, which are all signs of severe respiratory distress. What are our priorities in this critical situation?
This sounds like a truly frightening situation for the parents and a critical case for us to manage. Our top priorities are ensuring adequate oxygenation and ventilation. We'd start with basic airway management, including supplemental oxygen and potentially bag valve mask ventilation if their breathing is inadequate. Given their history of asthma and the severity of their respiratory distress, we'd also administer epinephrine.
And what would be the appropriate dose of epinephrine for a 2-year-old?
Considering their age and the severity of their symptoms, we'd administer 0.15 milligrams of epinephrine intramuscularly. We'd also be prepared to assist their breathing and closely monitor their vital signs, looking for any signs of improvement or deterioration.
It sounds like managing a pediatric patient in respiratory distress requires a combination of quick thinking, precise medication administration, and constant reassessment.
You got it. It's a high-stakes situation that demands our full attention and expertise.
Now, shifting gears again, let's say we encounter an unconscious 44-year-old patient who's hypothermic, not breathing, and has barely detectable pulses. Their skin is cold and waxy, and their blood glucose is 3.9 millimole. What are our initial actions in this case?
Hypothermia adds a whole other layer of complexity to this situation. Our immediate priorities are addressing their lack of breathing and circulation. We'd start CPR, provide supplemental oxygen with positive pressure ventilation, and work to rewarm them as quickly and safely as possible.
And their low blood glucose suggests they might be hypoglycemic, which could be contributing to their altered level of consciousness.
Exactly. Administering glucagon would be a key intervention to address that hypoglycemia.
So we'd give 1 milligram of glucagon intramuscularly and continue to monitor their blood glucose levels.
And throughout this entire process, we'd be working closely with our team to ensure seamless care and transport to the hospital for further evaluation and treatment.
Okay, last scenario. Imagine we're treating a 16-year-old patient who's experiencing an alcohol overdose, is vomiting, and is having a seizure. Their blood glucose is 6.7 millimol. How would we manage this situation?
Seizures are always concerning, and in this case, the alcohol overdose adds another layer of complexity. Our first priority is to protect their airway, ensuring they're breathing adequately and doing what we can to stop the seizure activity.
So supplemental oxygen would be crucial, and we'd want to consider requesting advanced life support backup for potential medication administration to help stop the seizure.
You're absolutely right. And we'd also be monitoring their vital signs very closely, watching for any signs of respiratory distress or cardiovascular instability.
The normal blood glucose rules out hypoglycemia as a contributing factor to the seizure, but the vomiting and potential for aspiration would require careful airway management. We wouldn't want them to inhale any vomit, which could lead to serious complications.
These scenarios really highlight the diverse and often challenging situations paramedics encounter and how essential it is to have a solid understanding of pharmacology and those medical directives that guide our decision-making. It's about bringing together knowledge, critical thinking skills, and sound clinical judgment to provide the best possible care to our patients, no matter the challenge.
Absolutely. We've covered so much ground in this deep dive, from the history of medications to the complexities of safely and effectively administering them in emergency scenarios. I hope you've gained some valuable insights and a newfound appreciation for the power and responsibility we hold as healthcare providers.
I hope so too. The world of pharmacology is fascinating and it's constantly evolving. Continual learning and staying updated is essential for everyone involved in healthcare.
Thank you so much for joining us on this deep dive into pharmacology and emergency care. Until next time, stay curious and keep learning.
Welcome back, everybody, for another deep dive. This time we are going to be tackling a really important topic. It's one that unfortunately is pretty common: abuse and behavioral emergencies. And we've got a couple of chapters here, some dense medical textbook chapters we're going to get through.
You know, I think what's interesting about these chapters is that they really go beyond just defining the terms. They really try to explain sort of the why behind these issues and how they manifest in real-life situations, which I think can be really helpful for anyone, not just someone in the medical field.
Yeah, definitely. And so when we think about abuse, I think a lot of times people immediately, their mind jumps to like physical violence.
Yeah.
But the reality is it comes in so many forms, and these chapters really emphasize that. Emotional abuse, sexual abuse, and neglect, which I think sometimes can fly under the radar.
Yeah. And even when we talk about neglect, it's not always as straightforward as, withholding food or shelter. The chapters highlight this concept of passive neglect, which is really interesting, where, a caregiver may not be intentionally harming a child, but their actions or inactions are creating a dangerous environment. So, things like substance abuse by the caregiver, or even consistently failing to provide, emotional support and stability can have a profound impact on a child's well-being.
Yeah, it's heartbreaking to think about. And it makes me think about how vulnerable, kids are, especially younger children. The chapter actually mentions that younger children are at a much higher risk for fatal abuse and neglect.
Yeah, that's right. And I think it's a stark reminder that, abuse can happen anywhere, to anyone. It crosses all socioeconomic boundaries, all communities. This isn't something that only happens over there.
Exactly. And it kind of brings us to this idea of recognizing the warning signs. And I know, for medical professionals, there's actually a whole mnemonic, child abuse, to help them remember the red flags.
Yeah, it's a really helpful tool for them. But I think what's important for everyone to understand is that context is key. So, for example, one of the elements of that mnemonic is delay in seeking care. Now, sometimes that's a legitimate red flag. But imagine a single parent working 2 jobs who can't afford to miss work or doesn't have access to reliable transportation. Suddenly, that delay doesn't seem quite so suspicious. That's
a really good point. Yeah, it really highlights how important it is to look at the whole picture and not just jump to conclusions based on one isolated factor.
Exactly. And, while we're on the topic of recognizing abuse, we can't forget about our senior citizens. Elder abuse is sadly on the rise, and it often presents unique challenges.
Yeah, I imagine it's even harder to detect because the signs might be different than with child abuse.
Precisely. an older adult, might be more reluctant to report abuse because they're afraid of being placed in a nursing home or worried about getting their caregiver in trouble, especially if it's a family member. And then you have to factor in things like potential cognitive decline, which can make it even harder to identify what's happening.
Yeah, definitely. So we've talked about kind of these different phases of abuse. Now let's shift gears a little bit and dive into the world of behavioral emergencies. And I think it's important to remember that not every instance of unusual behavior is an emergency.
Right. We're really talking about situations where someone's behavior poses a clear and present danger to themselves or others. So think of someone who's become suicidal or homicidal or is experiencing a psychotic episode where they've lost touch with reality. Those are the kinds of situations that require immediate intervention.
Okay, so the chapters break down sort of the potential causes of abnormal behavior into 4 main categories. We've got biological factors, environmental factors, acute injury or illness, and substance-related issues.
Yeah, and I think what I find so fascinating here is how interconnected the mind and body are. These chapters really emphasize that. Physical illness can impact behavior and vice versa. It's really a holistic view. That challenges the idea that, we can treat mental and physical health as separate entities.
Yeah, absolutely. And it makes you wonder, how do professionals evaluate these situations? The chapter mentions this mnemonic COAST map, which sounds pretty intense.
Yeah, so it stands for consciousness, orientation,
Yeah.
activity, speech, thought, memory, affect, and mood.
Oh.
And perception. So by systematically assessing each of these areas, medical professionals can get a clearer picture of what's going on with the person. So for example, if someone is disoriented to time and place, or their speech is, rapid and pressured, it could indicate a more serious issue.
But it's not just about observing the behavior itself, but understanding the context and looking for these additional signs.
Exactly. Now let's talk about some common behavioral emergencies that we might even encounter in our own lives. Things like anxiety disorders, phobias, and panic disorder. These are surprisingly prevalent in our society.
Someone who suffers from panic attacks, and it's really debilitating for them, they describe it as this: sudden, intense wave of fear that just comes out of nowhere with physical symptoms like a racing heart, difficulty breathing. It sounds terrifying.
It absolutely can be. Yeah, it is more common than you might think. The chapter highlights a startling fact. Women are 67% more likely to be affected by panic disorder than men.
Wow. That's a huge difference. What do you think contributes to that? Is it biological? Societal?
Right.
A combination of factors.
It's a great question. And while the chapter doesn't delve into the specific reasons for this gender disparity, it does point at the importance of understanding how various factors, biological, environmental, and social, can contribute to the development of anxiety disorders. It's not always a simple answer.
Right.
It's often a complex interplay of things.
Yeah, definitely. So we've covered a lot of ground here, talking about, abuse, behavioral emergencies. And the thing is, a lot of these things overlap and influence each other.
Absolutely. It's all interconnected.
It is. But I think it's important for us to tease these things apart and try to understand them as best we can.
I agree. The more we understand, the better equipped we are to recognize these issues.
Yeah.
And potentially help ourselves or others.
Absolutely. Well, on that note, we're going to wrap up part 1 of this deep dive. We'll be back soon with part 2, where we'll continue exploring these topics in more depth. So stay tuned, and we'll see you then.
And speaking of anxiety disorders, it's important to understand. Post-traumatic stress disorder, or PTSD, it's a severe form of anxiety that can develop after someone experiences a traumatic event.
Like, what kind of events are we talking about?
Well, the chapter mentions things like military combat, terrorist attacks, car accidents, sexual assault. Essentially, any event that overwhelms a person's ability to cope can be a trigger for PTSD.
That makes sense. And I've heard that people with PTSD often relive the trauma through flashbacks and nightmares.
That's right. And those flashbacks can be so vivid and intense that the person feels like they're right back in that traumatic moment. It can make it incredibly difficult to move on and live a normal life.
So what can be done to help people who are struggling with PTSD?
Well, the chapter emphasizes the importance of creating a safe and supportive environment. So that can mean therapy, support groups, or even just having understanding friends and family. We're willing to listen without judgment.
Yeah, it sounds like feeling safe and supported is crucial for healing.
Absolutely. Now, this next section of the chapter really struck me. It talks about the dangers that paramedics and healthcare workers face when dealing with
potentially violent patients. It's a stark reminder that these professions aren't just physically demanding, they can be incredibly dangerous.
Yeah, that's something I hadn't really considered before. What kind of situations are particularly risky? Well, the chapter specifically mentions domestic violence calls as being among the most dangerous. Your emotions are running high. And there's often a history of violence between the individuals involved.
So it's not just about providing medical care, it's about assessing the situation and ensuring everyone's safety, including their own.
Exactly. And the chapter goes on to outline some specific risk factors to be aware of. Things like whether alcohol or drugs are involved, the presence of large crowds, or if there's already evidence of violence at the scene.
I imagine those factors can escalate a situation quickly.
They absolutely can. The chapter also points out, certain individuals who are statistically more likely to become violent, such as people who are intoxicated, experiencing drug withdrawal, or dealing with psychosis or delirium.
Okay, so let's say someone finds themselves in a situation, maybe a paramedic, maybe just a bystander, with a potentially violent patient. What are some things they can do to de-escalate the situation?
Well, the chapter really emphasizes the importance of verbal de-escalation techniques. So trying to calm the person down, speaking in a calm and reassuring voice, and validating their feelings can sometimes make a huge difference.
That makes sense. But I imagine there are also times when talking just isn't enough.
You're right. The chapter is very clear on that point. It stresses the importance of knowing when to retreat and call for backup. There's no shame in prioritizing your own safety. And sometimes removing yourself from a volatile situation is the best course of action.
So it's about recognizing the warning signs, using verbal de-escalation when possible, and knowing when to disengage and get help.
Precisely. And it's important to remember that. Paramedics, for example, are generally not supposed to physically restrain patients, unless it's absolutely necessary for safety. Restraint should always be a last resort.
That's really interesting. I never realized how much goes into handling these kinds of situations. It's not just about medical knowledge. It's about understanding human behavior, risk assessment, and de-escalation techniques.
It really is a complex
and
multifaceted field. And these chapters. Just scratch the surface of what's involved in responding to abuse and behavioral emergencies.
It's amazing how much we've learned just from these 2 chapters. We've covered so much ground, from the different types of abuse and their warning signs to the complexities of behavioral emergencies and the dangers first responders face.
And it's all knowledge that can be valuable to anyone, not just those in the medical field. Understanding these issues can help us be more informed, more compassionate, and potentially even save lives.
It's been a really eye-opening deep dive. I feel like I'm walking away with a much better understanding of these issues, and it makes me think about how I can apply this knowledge in my own life.
I think that's exactly the point. It's not just about absorbing the information. It's about how we use that information to make a positive impact, even in small ways.
So true. Okay, so let's do a quick recap of the key takeaways for our listeners. We learned that abuse isn't always physical. It can be emotional, sexual, or even neglect, which can be both active and passive. We also talked about how crucial it is to recognize those warning signs of abuse, especially when it comes to vulnerable populations like children and the elderly.
And we explored, the complexities of behavioral emergencies, understanding that they're not just about abnormal behavior, but situations where someone's actions pose a threat to themselves or others. We touched on the interconnectedness of mental and physical health, the importance of recognizing those risk factors for violence, and the techniques professionals use to de-escalate those potentially dangerous situations.
Wow, that is a lot. But it's incredibly valuable knowledge, and it can empower us to be more aware, more compassionate, and potentially even intervene in a helpful way if we encounter these situations in our own lives.
And that brings me to a final thought I want to leave our listeners with. Well, we've covered a lot of ground today. Remember, this is just the tip of the iceberg. There's always more to learn and explore when it comes to these complex issues.
Absolutely. So here's a question for everyone to ponder. How might this knowledge shift your perception of everyday interactions? Could it empower you to help someone in need, or even just approach challenging situations with more empathy and understanding?
It's something to reflect on. Sometimes just being aware can make a world of difference.
Well, that wraps up our deep dive into the world of abuse and behavioral emergencies. Thanks for joining us on this journey. It's been a privilege to learn alongside you.
Until next time, stay curious and keep those minds open.
Welcome to the deep dive. Today we're diving into a world that's both fascinating and intense.
Intense is right.
neurologic emergencies, and spinal injuries. We've got medical textbooks, training manuals,
Oh, yeah, the whole shebang.
ready to extract the need-to-know info, think life-saving tips, fascinating brain facts.
And a glimpse into how paramedics approach these really intense situations.
Ready to learn how to spot a stroke versus a seizure, or maybe you're curious about the weird things that can happen when your spinal cord gets injured.
Buckle up because things are about to get really interesting.
Okay, so first things first, why should we care so much about the nervous system? I mean, we all know it's important, but what makes it so vital in these emergency situations?
Well, the nervous system is like the body's internet, you know? It's the communication network that keeps everything running smoothly.
Okay, I'm with you.
When that network goes down, things can get chaotic really fast.
So we're not just talking about a broken bone here. We're talking about potentially losing the ability to breathe, move, or even react to danger.
Exactly. And what's really fascinating is that people with neurological issues are often much more vulnerable than we realize.
Oh, really?
They might not have the same reflexes that protect us from harm.
Okay.
Imagine not being able to pull your hand away from a hot stove.
Oh, wow. Yeah.
That's the level of risk we're talking about.
That's a powerful image.
It is.
So paramedics must have to be incredibly sharp when assessing these situations.
Oh, for sure.
They can't just slap on a bandage and call it a day, right?
Absolutely not. They have to be like detectives, piecing together clues to figure out what's going on inside the body.
Okay.
And one of the tools they use is this mnemonic called AEIOU tips.
AEIOU tips. Okay, I'm intrigued. Break that down for me. What does it stand for?
So it stands for alcohol, epilepsy, insulin, overdose. And it goes on from there.
Okay.
Basically, it helps them rule out these life-threatening conditions quickly.
So let's say someone is having a seizure. How would AEIU tips come into play?
Well, the E in AEIU tips stands for epilepsy. So right away, the paramedic is thinking about seizures as a possible cause for the person's condition.
Makes sense.
They'll check the person's medical history, look for any signs of a seizure, and use that information to guide their treatment.
So it's not just about memorizing a list of words.
No.
It's about using those words as a framework for quick thinking in a high-pressure situation.
Exactly. Now, speaking of seizures, one of the biggest challenges for paramedics is distinguishing between a stroke and a seizure.
Yeah, I can imagine.
They can look pretty similar to someone who isn't trained to spot the subtle differences.
Right, because both involve sudden changes in behavior or consciousness.
Right.
What are some key things that set them apart?
Well, with a stroke, you're looking for signs of one side of the body being affected.
Okay.
Think facial drooping, arm weakness, slurred speech. It's like one half of the brain's circuitry is suddenly offline.
And with a seizure, is it more about the whole body being affected?
Yes, you often see full body convulsions, stiffening, and sometimes even loss of bladder control.
Oh, gosh.
It's like an electrical storm in the brain disrupting everything.
So a stroke is more localized and a seizure is more widespread.
Right.
But are there different types of strokes and seizures? I've heard those terms thrown around.
Yeah, there are.
Okay.
So there are two main types of strokes, ischemic and hemorrhagic.
Okay.
Ischemic strokes are caused by a blockage in a blood vessel, like a clogged pipe. It's the most common type.
And what about hemorrhagic strokes?
Hemorrhagic strokes are caused by bleeding in the brain, like a burst pipe.
Got it.
It's less common, but often more severe.
Okay.
The key takeaway here is that time is brain. The faster we recognize and treat a stroke, the better the outcome.
So any sudden weakness, numbness, or difficulty speaking should be taken very seriously.
Absolutely. Now let's talk about seizures.
Okay.
They're not all as dramatic as the ones you see in movies.
Right.
There are also subtle seizures, like absence seizures, where a person might just stare blankly for a few seconds.
Those sound easy to miss.
They can be, especially in children. Parents might think their child is just daydreaming.
So what should we be looking for if we suspect someone is having a seizure?
Well, first, try to stay calm and keep yourself and others safe.
Okay.
Don't try to restrain the person or put anything in their mouth.
Got it.
Time the seizure, if possible, and note any specific movements or symptoms you observe. This will help the medical professionals later on.
So it's as much about observation as it is about action.
Exactly. Now, I know that sometimes people experience something that looks like a seizure, but it's not caused by abnormal brain activity.
Right.
Those are called psychogenic non-epileptic seizures, or PNES.
PNES. Okay.
They're often triggered by stress or trauma.
Okay.
And while they're not caused by the same electrical disturbances in the brain as epileptic seizures, they're still very real and distressing for the person experiencing them.
So it's not all in their head, so to speak.
Right.
It's just a different root cause. Interesting.
Yeah.
Okay, let's shift gears now and talk about spinal cord injuries. This is an area where I think a lot of people have misconceptions.
Yeah, there's definitely a lot of misinformation out there.
Okay.
One of the biggest things to understand is that the spinal cord isn't just one solid bone.
Oh, okay.
It's a bundle of nerves that runs through the spinal column, kind of like a delicate cable, carrying messages between the brain and the rest of the body.
So any damage to that cable can have a ripple effect throughout the entire system.
Exactly. And the higher up the injury, the more widespread the impact.
Right.
Think about it. A neck injury could affect breathing, arm and leg movement,
Wow.
even bladder and bowel control.
Okay, I'm starting to get a sense of the stakes here.
Yeah.
So what are the different ways the spinal cord can be injured? It's not just falls and car accidents, right?
You're right. It can happen in sports, during a simple fall, even from something like a diving accident.
Okay.
There are different types of spinal injuries depending on how the force is applied to the spine. We have flexion injuries, compression injuries, rotation injuries.
So like if you bend your neck too far forward, that's a flexion injury.
Right. And if you land on your head from a height, that's a compression injury.
Got it.
The important thing to remember is that even seemingly minor impacts can have a big impact on the spinal cord.
So it's not just about the bones being broken, it's about the potential damage to the nerves inside.
Exactly. And here's something a lot of people don't realize. You can have a spinal cord injury without a fracture.
Wait, really? How is that possible?
Well, the cord can be bruised, stretched, or even torn without any damage to the bone surrounding it.
Okay.
Think about a garden hose. You can kink it and restrict the flow of water without breaking the hose itself.
That's a great analogy. So how do paramedics know when to suspect a spinal injury? I imagine there are certain red flags they look for.
Absolutely. Things like a high-speed collision, a fall from a significant height, or even a diving accident where someone hits their head. Those are all automatic red flags.
So in those cases, it's better to err on the side of caution and assume there's a spinal injury until proven otherwise.
Exactly. Especially if the person is unconscious.
Right.
We can't afford to take any chances.
And what if the person is conscious? Are there specific signs and symptoms that point to a spinal injury?
Definitely. Things like pain or tenderness along the spine,
Okay.
numbness or tingling in the extremities, weakness or paralysis, even changes in bowel or bladder control. Those are all potential indicators.
So let's say a paramedic suspects a spinal injury.
Right.
What happens next? I've always heard about spinal motion restriction.
Yeah.
Is that where the backboard comes in?
Yes, the backboard is one tool we use.
Okay.
But it's important to remember that spinal motion restriction isn't just about strapping someone to a board.
Right.
It's about treating the entire spine, from the head to the pelvis, as one long bone.
Wow.
Any movement, even a slight twist or turn, could worsen the injury.
So they're basically immobilizing the entire body.
Essentially, yes. And it's a delicate process.
Yeah.
Paramedics have to work quickly and efficiently, all while ensuring the patient's airway is clear and their vital signs are stable.
Oh, wow.
It's a complex dance, and it requires a lot of skill and training.
So what's the deal with those backboards? I've heard they're not exactly comfortable.
You're right about that. While they're essential for stabilizing the spine during transport,
Right.
they can be quite uncomfortable, especially for longer periods. We try to make patients as comfortable as possible with padding,
Okay.
and by minimizing the time spent on the board.
It sounds like you're constantly weighing risks and benefits.
It is.
Immobilizing the spine to prevent further injury, but also trying to minimize discomfort.
It's a delicate balance, but the patient's well-being is always the top priority. And believe it or not, even something as simple as skin breakdown from prolonged pressure on the backboard is a concern.
That's incredible. So it's not just about the obvious trauma,
Yes.
it's about all these secondary considerations as well.
Exactly. It's all connected.
So what happens once a patient with a suspected spinal injury arrives at the hospital? What are the next steps?
Well, once they arrive, they'll undergo a thorough neurological assessment to determine the extent of the injury.
Okay.
This might involve imaging studies like X-rays, CT scans, or MRIs, as well as neurological exams to test their reflexes, strength, and sensation.
And then the treatment plan is tailored to the specific injury.
Precisely. Some spinal cord injuries can be treated with bracing or surgery, while others require long-term rehabilitation to help patients regain function and adapt to their new reality.
So it's not just about fixing the immediate problem.
Right.
It's about
supporting the patient through the entire recovery process.
Exactly. And that recovery process can be long and challenging, both physically and emotionally.
Okay, I think we've laid a really good foundation here.
Yeah.
But I'm curious to learn more about the long-term implications of spinal cord injuries. What are some of the potential complications that patients might face down the road?
That's a great question, and one that we'll delve into in more detail in the next part of our deep dive.
Welcome back to the deep dive. Before the break, we were talking about the immediate response to a suspected spinal injury.
Right, that initial stabilization.
Now let's dive into what happens after that initial crisis.
Okay.
What are some of the long-term challenges that people with spinal cord injuries might face?
So one of the biggest concerns is respiratory issues,
Okay,
because the spinal cord controls the muscles involved in breathing.
right.
An injury can significantly impair lung function.
So even if the initial injury is stabilized,
Uh-huh.
breathing problems can become a major issue down the road.
Exactly.
What else should we be aware of?
Another major risk is blood clots, specifically deep vein thrombosis, or DVT.
DVT. Okay,
Since many people with spinal cord injuries have limited mobility,
right.
blood clots can form in the legs and potentially travel to the lungs, causing a pulmonary embolism.
And a pulmonary embolism, that's a life-threatening situation, right?
Absolutely, it's a serious complication,
Right.
which is why preventative measures like compression stockings and blood thinners are so crucial.
Are there any other complications that are specific to spinal cord injuries? I know we talked about the potential for paralysis, but are there other things that might pop up later on?
There's a condition called autonomic dysreflexia,
Autonomic dysreflexia.
which can occur in people with injuries above the mid-chest level.
Okay.
It's basically a dangerous surge in blood pressure,
Okay.
triggered by something as simple as a full bladder or a wrinkled shirt.
Wait, so something as minor as a wrinkled shirt can cause a medical emergency?
Yes, it sounds strange,
Yeah.
but it's because the normal communication pathways between the brain and the body are disrupted.
Okay.
The body overreacts to a stimulus, and the blood pressure spikes.
So what are the signs of autonomic dysreflexia? What should people be watching for?
Things like a pounding headache, sweating, flushing, goosebumps, even a stuffy nose, those can all be warning signs.
Okay.
It's essential to recognize those symptoms and get medical help immediately,
Right.
because untreated autonomic dysreflexia can lead to stroke, seizures, or even death.
That's a stark reminder that the effects of a spinal cord injury can extend far beyond the initial trauma.
Absolutely, it's a lifelong journey, and it requires ongoing care and attention to manage these potential complications.
Okay, I want to switch gears a bit and talk about some other neurological conditions that, while not necessarily emergencies, can still have a big impact on people's lives.
Okay, sure.
Let's start with something that most of us have experienced at some point: headaches.
Yeah, everyone's had a headache.
Is there a way to tell if a headache is just a normal annoyance or a sign of something more serious?
Well, most headaches are benign,
Okay.
caused by things like stress, tension, or even caffeine withdrawal.
Right.
But there are some red flags that should always be taken seriously.
Like what should send us running to the doctor?
A sudden, severe headache that comes on like a thunderclap.
Okay.
That's never normal, especially if it's the worst headache you've ever had. That could be a sign of a brain aneurysm or a subarachnoid hemorrhage, which is bleeding in the space around the brain.
So if you have a headache that feels different from your usual headaches,
Right.
or if it's accompanied by other symptoms like nausea, vomiting, or vision changes, don't mess around. Get it checked out.
Exactly. It's always better to err on the side of caution when it comes to neurological symptoms.
Makes sense.
Now, another type of headache that can be particularly alarming is one that's accompanied by a stiff neck and fever.
Oh.
That could be a sign of meningitis, which is an infection of the membranes that surround the brain and spinal cord.
Meningitis, that's a serious infection, right?
Yes, it can be life-threatening if not treated promptly.
Okay.
So any headache with those accompanying symptoms warrants immediate medical attention.
Okay, let's talk about a different kind of pain. The kind that shoots through your face like a lightning bolt. I've heard those can be incredibly intense.
You're probably thinking of trigeminal neuralgia.
Trigeminal neuralgia, okay.
It's caused by irritation or compression of the trigeminal nerve, which is responsible for sensation in the face. It's often described as the most excruciating pain a human can experience.
Wow, that sounds awful.
It is.
And it can be triggered by the simplest things, right? Like eating or even touching your face.
Yes, even a gentle breeze or a brush of the hair can set off an attack.
Oh, wow.
Thankfully, there are treatments available, including medications and sometimes surgery, that can help manage the pain.
Okay, let's move on to a condition that, while not usually painful, can be quite startling. Bell's palsy, what exactly is going on there?
So Bell's palsy is a sudden weakness or paralysis of the muscles on one side of the face.
Okay.
It can look like you've had a stroke,
Oh, really?
but it's actually caused by inflammation or damage to the facial nerve.
So one day you're fine, and the next day you can't smile or close your eye on one side.
Right.
That must be terrifying.
They can be quite alarming, yes, but the good news is that it's usually temporary.
Okay.
Most people recover fully within a few weeks or months,
Okay.
though some may have lingering weakness or facial asymmetry.
So no known cause, but typically a good prognosis. That's reassuring. Now let's talk about a couple of conditions where the body's immune system goes haywire and attacks its own nerves. Multiple sclerosis, or MS, and Guillain-Barré syndrome.
Okay.
What are the key differences between these two?
Both MS and Guillain-Barré are autoimmune disorders,
Mm-hmm.
meaning the immune system mistakenly attacks healthy tissue.
Right.
In MS, the immune system attacks the protective covering of nerve fibers in the brain and spinal cord,
Okay.
causing a wide range of symptoms that can vary greatly from person to person.
So MS is a chronic progressive disease,
Right.
whereas Guillain-Barré is more of an acute temporary condition.
That's generally true.
Okay.
Guillain-Barré typically starts with weakness and tingling in the legs that spreads upward.
Okay.
In severe cases, it can cause paralysis and respiratory failure, requiring a ventilator.
So it can be quite serious, even life-threatening?
Yes, but the majority of people with Guillain-Barré make a full recovery with treatment.
Okay.
It's still a scary experience, though, to suddenly lose control of your muscles.
Okay. Let's shift gears now and talk about a couple of conditions that are becoming increasingly common as our population ages. Alzheimer's disease and Parkinson's disease.
Okay.
What are the hallmarks of each of these conditions?
Alzheimer's disease is a neurodegenerative disorder that primarily affects memory and cognitive function.
Right.
It's the most common cause of dementia, and it gradually robs people of their ability to remember, think clearly, and perform daily tasks.
It's a heartbreaking disease, both for the person who has it and for their loved ones.
It is, and sadly, there's no cure for Alzheimer's, though there are medications that can help manage some of the symptoms and potentially slow the progression of the disease.
And what about Parkinson's disease? What are the telltale signs?
Parkinson's is a movement disorder characterized by tremors, rigidity, slowness of movement, and difficulty with balance.
Okay.
It's caused by a loss of brain cells that produce dopamine, which is a neurotransmitter that helps control movement.
So it's not a cognitive decline like Alzheimer's. It's more about the physical ability to move.
Exactly. And like Alzheimer's, there's no cure for Parkinson's.
Okay.
But there are medications and therapies that can help manage the symptoms and improve quality of life.
Okay, we've covered a lot of different neurological conditions here.
We have.
From emergencies like strokes and seizures to chronic conditions like MS and Parkinson's.
It's a lot to take in.
Is there anything else you want to touch on before we wrap up?
I think we've given our listener a good overview of the complexities of the nervous system and the challenges that can arise when things go wrong.
Right.
But I would add this. Even if you don't have any of the conditions we've discussed, it's important to pay attention to your neurological health.
What do you mean by that? What should we be doing?
Simple things like getting enough sleep, managing stress, eating a healthy diet, and staying physically active.
Okay.
All of these things can contribute to a healthy nervous system.
So it's not just about avoiding injury or disease. It's about actively promoting neurological well-being.
Exactly. And if you do experience any unusual or persistent neurological symptoms, don't hesitate to seek medical advice.
Right.
Early detection and treatment can make a world of a difference.
Welcome back to the Deep Dive. We've been on quite a journey today, exploring the intricate world of the nervous system.
We have, from the brain to the spinal cord, covering those emergencies, chronic conditions.
The whole 9 yards.
The whole 9 yards, exactly.
So as we wrap up, I'm wondering what you think is the most important takeaway for our listener.
That's a good question.
What's the one thing they should remember from all this?
You know, I think the key takeaway is that the nervous system is really the foundation of our being. You know,
Okay.
it's what allows us to experience the world, connect with others,
Right.
and live a full and meaningful life.
And that means protecting it should be a top priority.
Absolutely. Whether it's wearing a helmet when biking, practicing safe lifting techniques, or being aware of the signs and symptoms of neurological problems.
Right.
We can all take steps to safeguard this precious system,
We've talked a lot about the big dramatic stuff.
right? This strokes, seizures, spinal cord injuries.
Exactly.
Yeah.
But what about those smaller everyday things? You know, those nagging headaches, that occasional tingling in our hands or feet.
Right.
Should we be concerned about those too?
That's a really insightful question. I think we often dismiss those little aches and pains as just part of life,
Yeah, we do.
but they can sometimes be our body's way of telling us that something is off.
So when should we listen to those whispers and seek professional advice?
It's all about knowing your own body
Okay.
and recognizing when something feels different.
Right.
If you have a headache that's more intense or lasts longer than usual,
Huh?
or if you experience any new or unusual neurological symptoms,
Right.
it's always a good idea to get it checked out.
So it's not about being a hypochondriac.
No.
It's about being attuned to our own internal signals.
Exactly. And remember, you know your body better than anyone. So don't be afraid to advocate for yourself and seek medical advice if something feels wrong.
What about those of us who don't have any specific neurological concerns right now?
Yeah.
What can we do to keep our nervous system healthy in the long run?
Well, the same things that are good for our overall health are also good for our nervous system.
Makes sense.
Things like eating a balanced diet, getting regular exercise, managing stress, and getting enough sleep.
Okay.
They all play a role in keeping our brains and nerves functioning optimally.
So it's not just about treating problems when they arise, it's about creating a lifestyle that supports neurological health.
Exactly. And I would add that staying intellectually engaged and socially connected is also important for brain health.
So reading, learning new things, spending time with loved ones, those are all good for our brains.
Absolutely. They help keep our minds sharp and our spirits high.
I think this deep dive has given us a lot to think about. From the dramatic to the mundane, it's clear that the nervous system is this complex
We did.
and a fascinating web that impacts every aspect of our lives.
It truly is. And as we continue to learn more about this incredible system, we'll undoubtedly discover even more ways to protect it and keep it healthy for years to come.
Absolutely. Well, thank you so much for guiding us through this deep dive today.
My pleasure.
It's been an enlightening journey.
Glad to hear it.
And to our listeners, thanks for joining us on the deep dive. We'll see you next time for another fascinating exploration.
All right, got those notes you sent over on pediatrics.
Mm.
I have to say, as soon as you hear pediatric, the whole call feels different, doesn't it?
Absolutely. Like everything you thought you knew about patient care, you have to hit reset.
Yeah, the source really drives that point home right away.
Mm-hmm.
Kids are not just tiny adults.
Right.
Their bodies, how they respond to illness, even how they feel pain.
Totally different.
All different.
And the differences can be really significant. Like, think about how big a child's head is compared to their body.
Oh, yeah.
It's way bigger proportionally than an adult, so they're so much more vulnerable to head injuries.
Oh, yeah. Just thinking about it makes me cringe. So let's say you show up on scene, you get a pediatric patient. What are some of the biggest things to think about right off the bat?
Well, communication is huge, but obviously that's going to be different depending on the kid's age, right?
Oh, yeah.
I've got your neonates who can't tell you anything, toddlers who might be scared or just not cooperative, and then teenagers who clam up the second their parents are in the room.
Oh, for sure. This source really breaks those developmental stages down
Yeah.
well
Yeah.
and gives some actually clever strategies for each one. I really like the TCLS mnemonic for assessing appearance in a nonverbal kid.
TCLS is great. Tone, interactiveness, consolability, look or gaze, and speech cry. It's like, I don't know, it's like cheat sheet to figure out how sick a kid is just by watching them.
Especially helpful when you can't get a good history from the kid themselves.
Exactly.
Now, how about the whole terrible twos thing? Is that really a thing?
Oh, the terrible twos are definitely a thing.
Okay.
Toddlers just don't have the same reasoning abilities.
Right.
So trying to reason with them is like,
Yeah.
forget about it.
Right.
The source was recommending things like distraction, you know, playing games to try to make the assessment less stressful.
For everyone.
Yeah, for everybody. Exactly.
Who wants to poke and prod a screaming toddler? Speaking of stressful, the source makes this interesting point about caregivers being like a second patient.
Oh, it's so true. You aren't just dealing with the sick kid.
Right.
You've got the adults there, and they're stressed out. They're scared, you know?
Yeah.
Yeah, maybe they feel guilty, or they're angry, or just plain terrified. It's a tough situation.
How do you even navigate that?
You got to stay calm, try to get them to help you if you can,
Okay.
but you also have to be ready to take charge if their emotions start getting in the way of the child's care. You have to be firm, but also compassionate, you know?
That sounds like walking a tightrope.
It can be.
So let's say everyone's calmed down a bit. You're ready to do your assessment.
Okay.
Where do you even begin with a kid?
I think one of the most useful tools we have is the Pediatric Assessment Triangle, the PAT.
Okay.
It gives you the snapshot of how sick a kid is just by focusing on three things: appearance, their work of breathing, and their circulation.
Okay, break that down for me. What are you actually looking for?
For appearance, we go back to that TI-CLS mnemonic, right? How's their muscle tone? Are they interactive? Can you console them? What about their gaze? And is their cry strong or weak?
So it's all those little cues that give you a sense of their mental status.
Exactly. Now, for work of breathing, we are looking for signs that they're having to work harder. Things like nasal flaring, retractions, where the skin sucks in around the ribs,
Oh, yeah.
or the collarbone. And grunting, believe it or not, they're actually trying to keep their tiny air sacs open.
Wow, amazing how those little bodies compensate.
Amazing, but it can also hide how sick they really are.
Oh,
So then we look at circulation specifically to the skin.
okay.
What color is it? Is it pale, mottled, or even blue? And capillary refill time. How long does it take for the color to come back after you press on a fingertip?
So if you're seeing those signs, that's a bad sign.
Yeah, that means their body is struggling to get oxygen and blood to where it needs to go.
And that's where things can go south really fast.
Exactly.
The source was pretty clear that kids compensate really well, and then, bam, they crash.
Right, especially when it comes to shock. Remember how we were saying how well they compensate?
Yeah.
Well, that makes shock extra tricky because you might not see the classic signs like low blood pressure until it's almost too late.
Like a ticking time bomb.
Yeah, pretty much. By the time their blood pressure drops, they are in serious trouble.
Oh, wow.
So we need to be hyper aware of those early clues: tachycardia, delayed cap refill, any change in mental status.
So what are some of the things that can cause shock in a kid?
Most common type is hypovolemic shock.
Ah.
Basically, they've lost fluid volume, whether it's bleeding, dehydration, or even severe vomiting and diarrhea.
Oh, right.
We also have to keep distributive shock in mind.
Okay.
That's when the blood vessels dilate and the blood pressure drops.
Okay.
That can be from things like sepsis or anaphylaxis.
Gotcha. And then there's obstructive shock, right?
Yeah, where something is actually physically blocking blood flow.
Right.
Things like a tension pneumothorax or a pulmonary embolism, but those are less common in kids.
Yeah.
And then, of course, there's cardiogenic shock. That's where the heart itself isn't pumping right.
Okay, so we've got hypovolemic, distributive, obstructive, and cardiogenic. All can look different and need different treatment.
Exactly, and that's why understanding those mechanisms is so important.
Yeah.
It lets us target our interventions the right way.
So we talked about the PAT, knowing shock early on, the different types we might see. What else should we be thinking about in our initial assessment?
Gotta consider those unique things about kids' anatomy that can make them more vulnerable.
Oh, right.
Like their airways.
Yeah, so much smaller and easily blocked.
Way smaller.
You've got that big tongue, and then for a while they're obligate nose breathers, right?
Exactly.
So even a little mucus can be a huge problem.
Huge problem. And chest walls are thinner, too.
Right.
So it's easier to hear lung sounds.
Yeah.
But it also means they're way more susceptible to chest trauma, like pulmonary contusions where the lung tissue gets bruised.
Okay. What about their bones?
Oh, yeah. Totally different from adult bones.
How so?
They have growth plates, areas where the tissue is still growing.
Right.
And those growth plates are actually weaker than the ligaments and tendons around them.
So that means fractures are more common than sprains in kids.
Way more common. So if you're looking at a musculoskeletal injury, you got to be super careful and consider a fracture, even if you don't see an obvious deformity.
It's amazing how much we take for granted when we're treating adults.
I know, right?
But I feel like we've just scratched the surface here.
There's so much more to unpack.
Yeah, there's croup, epiglottitis, asthma, meningitis, seizures, oh my. And then there's the really tough stuff like SUID and child abuse.
It's a lot.
It is. Let's take a breather. We'll be right back to dive into those topics.
Welcome back. So we just threw a ton of information your way about how kids are different.
We did.
But let's actually put those differences into practice and talk about specific pediatric emergencies.
All right, I'm ready. Let's start with respiratory emergencies. They seem to be pretty common in kids, right?
Oh, yeah, for sure. And the first thing you got to figure out is how bad is it, right?
Okay.
Is it respiratory distress, or has it progressed to respiratory failure, or even full-blown respiratory arrest?
Because those are three very different scenarios, each one needing a different level of care.
Totally. Okay, picture this. You roll up on scene, and there's a kid working hard to breathe. They have retractions, nasal flaring, maybe some grunting. Their oxygen saturation is okay for now, but they're definitely struggling. That's respiratory distress.
So they're not in immediate danger, but they need our help.
Right. So what we want to do is support them,
Okay.
give them some oxygen, try to calm them down to lessen how much oxygen they need, and just keep a close eye on them in case things get worse.
Makes sense. Now, what if they do get worse and it progresses to respiratory failure?
That's when it gets more serious. Their body just can't keep up anymore, so we start seeing hypoxia. Their blood oxygen levels drop, and they can't get rid of CO2, so it builds up.
Right.
They might get lethargic, have a weak cry, maybe even turn blue, cyanotic.
Okay, so that's a clear sign that they need more help that we can give them just by supporting their breathing.
Yeah, absolutely. We might have to help them breathe with a bag mask device, maybe even intubate them to protect their airway.
And then there's respiratory arrest,
Oh.
which is every parent's worst nightmare.
Yeah, it's terrifying, but the good news is that kids often respond well to resuscitation.
Oh, okay.
So there's hope, but we have to act fast.
So CPR, airway management, the whole 9 yards.
Everything, and quickly.
Yeah.
And speaking of airway management, let's talk about some techniques for keeping those tiny airways open.
All right, so beyond just positioning and suctioning, what else can we do?
Well, we have airway adjuncts like oropharyngeal and nasopharyngeal airways.
Right.
Basically, they help keep the tongue from blocking things up.
Okay.
The source has some really good pictures and step-by-step instructions on how to put them in safely and effectively.
Very helpful, especially for those who don't have a ton of pediatric experience.
Definitely.
What about oxygen? Are there different ways to deliver it to kids?
Yeah, definitely. Like for infants and really little kids who won't keep a mask on,
Right.
we can use the blow-by technique where you just hold the oxygen source near their face so they can breathe in more oxygen.
Gotcha. And if they can tolerate a mask, we can use a non-rebreather to deliver even more oxygen.
Exactly. It's all about picking the right tool for the job based on how old they are and what they need.
And then there's bag mask ventilation.
Right. Often the first step in actually taking over their breathing for them.
Right, where we're using the bag and mask to deliver breaths for the child.
Yeah. The source actually goes through the whole process step by step and points out common mistakes people make, like giving too much air or breathing for them too fast.
Yeah, you don't want to cause more problems.
Exactly. Got to be effective, but we don't want to cause things like gastric distension or even a pneumothorax.
Right, where air leaks into the space around the lungs.
Exactly. So it's a balance. Now, shifting gears a bit, let's talk about shock again. Remember how we said kids compensate well, then crash hard?
Oh yeah, like a ticking time bomb?
Right. And the source outlines those different types of shock: hypovolemic, distributive, obstructive, cardiogenic. It's so important to recognize which one it is.
Because the treatment is different.
Very different. So with hypovolemic, which is the most common in kids, our main intervention is fluid resuscitation.
Right.
We have to replace what they've lost, whether it's through an IV or even blood transfusions if it's really bad.
And for distributive shock, like from sepsis or anaphylaxis, we're looking at medications to constrict those blood vessels and get the blood pressure back up.
Exactly. And with obstructive, we have to find and fix whatever's blocking blood flow.
Right, like a tension pneumothorax that needs to be decompressed.
Yep. Or maybe a pericardial effusion that needs to be drained.
Okay.
And then cardiogenic shock is a whole other beast. That's where we need to support the heart itself, maybe with meds or even some kind of mechanical assistance.
Wow, so many different presentations and treatments. Speaking of things that can get your heart racing,
Oh, yeah.
dysrhythmias.
Those irregular heartbeats can be just as scary in kids as adults.
And just like with shock, recognizing it early is key.
Absolutely.
The problem is those signs and symptoms in kids, they can be pretty vague.
They really can.
Maybe they're just tired or irritable or vomiting. Could be chest pain, even abdominal pain.
It's really all over the place.
So we can't just rely on those classic symptoms we see in adults.
So the source really emphasized doing a quick pay and primary assessment.
Okay.
Make sure the airway and breathing are good, and then get an ECG or rhythm strip to see what's really going on with the heart.
Because once we know what we're dealing with,
Yeah.
then we can figure out the right treatment.
Exactly.
So what are some of the dysrhythmias we see in kids?
Bradycardia, a slow heart rate, is often because of hypoxia, so we got to focus on getting that oxygen level up.
Okay.
Tachycardia, or a fast heart rate, can be narrow or wide complex.
Ah.
And those wide complex ones, like ventricular tachycardia, those can be really dangerous.
So how do we treat those?
They mention antiarrhythmic meds like amiodarone, but if things are really unstable, we might have to do synchronized cardioversion.
Right, where you deliver a controlled shock to the heart to get it back into a normal rhythm.
Exactly. And of course, if they lose a pulse, we go straight into cardiac arrest mode and follow the pediatric protocols.
Full code. A good reminder that we have to be ready for anything and that these situations can change fast.
Oh, for sure. All right, let's take a step back from the life-threatening stuff for a minute.
Okay.
Talk about some conditions that might not be as dramatic, but we still need to know how to assess and manage them.
Okay, like what?
Well, fevers, super common in kids, right?
Yeah, definitely.
But it's not always an emergency. We got to know when to worry.
All right, so when should we be worried about a fever in a kid?
In babies under 2 months old, any fever is a red flag.
Oh, really?
Yeah, their immune system is still so immature, so a fever could mean a serious infection.
So those little ones need to see a doctor right away.
Absolutely. With older kids, we're looking for other symptoms that might clue us in that something's wrong.
Like what?
Vomiting, diarrhea, a headache, maybe neck pain or stiffness, a rash.
Okay, those all warrant a trip to the doctor.
Right, better safe than sorry. And of course, there's meningitis, which we talked about before.
Right.
Remember, it can be tough to tell the difference between viral and bacterial meningitis early on.
Yeah?
So we have to treat all suspected cases like it's bacterial until we know for sure.
Because bacterial meningitis is nothing to mess with.
Nope. Can cause brain damage or even death if it's not treated quickly and aggressively.
Let's talk about seizures.
Okay.
Another common pediatric emergency.
Yeah, and often scary.
So what are the key things to know about seizures in kids?
First, there are different types. We have generalized tonic-clonic seizures.
Right, those are the classic grand mal seizures, where they lose consciousness and their whole body jerks.
Exactly. Then there are absence seizures.
Okay.
Those are more subtle. Might just involve a brief lapse in awareness or staring off into space.
Right.
And then you have febrile seizures.
Which are specific to young kids and are usually triggered by a high fever.
Right. And even though most of them are benign and self-limiting.
Meaning they stop on their own without causing any lasting harm.
Right. But they're still scary to see.
Oh yeah, absolutely. So what do we do if we see a kid having a seizure?
First thing is safety.
Okay.
Protect them from injury, make sure their airway's open, and just provide supportive care. If it goes on too long, or if we see any problems with breathing, we have to intervene.
And we have to reassure the parents.
Oh, yeah.
Because they're freaking out.
Big time. So we stay calm, explain what we're doing, and let them know we're doing everything we can.
All right, so we've covered respiratory emergencies, shock, dysrhythmias, fever, meningitis, and seizures. Anything else on the pediatric emergency hit list?
Well, we can't forget about toxicology emergencies. Kids, especially toddlers, love to get into things they shouldn't.
Tell me about it. My nephew once tried to eat an entire tube of diaper rash cream.
Oh, my God.
It was a mess.
So when you think a kid's been poisoned, the history is everything.
Yeah.
We got to try to find out what they got into, how much, and when. That'll tell us what to do.
At our initial assessment, like always, is ABCs.
Airway, breathing, and circulation.
Got to make sure those are good before anything else.
Right. Then, depending on what it was and how the kid's doing, we might think about decontamination.
Like with activated charcoal?
Yeah, that's what they use in the ER when you've eaten something bad.
Right, it binds to the toxin in your stomach.
Exactly, and stops it from getting into the bloodstream.
Like a sponge for poison?
Pretty much. It's not perfect, but it can be really effective.
So we talked about accidental poisonings, but what about intentional ones, like child abuse?
Ugh, that's tough, but we can't ignore it.
Right.
The source gives some good advice on how to recognize the signs of abuse and neglect.
Okay, like what?
One thing is injuries that don't match up with the story you're getting.
Oh, okay.
Like if a little kid has a spiral fracture in their leg, but the parents say they just tripped and fell.
Yeah, it doesn't add up.
Nope. Or multiple bruises in different stages of healing.
Another red flag.
For sure. And any burns, especially those with specific patterns, we got to be concerned.
It's awful, but we have to protect these kids.
It's our responsibility. We need to be watchful, document everything carefully, and report any suspicions to the authorities.
No question.
Yeah.
Now, switching gears again, let's talk about trauma.
Okay.
Sadly, it's a leading cause of death and disability in children.
It is, and just like with everything else in pediatrics, their anatomy makes them more vulnerable.
Oh, for sure. They have less muscle mass and fat to cushion their organs.
Right.
So they're more likely to have internal injuries, even from what seems like minor trauma.
And their heads are bigger proportionally, so more head injuries.
Right. So what are the most common ways kids get injured?
Well, falls are huge for little kids,
Yeah.
especially toddlers who are just starting to walk and explore.
Right.
As they get older, we see more injuries from bikes, skateboards, scooters, and sports.
And of course, car accidents, which could be devastating.
Absolutely. And with any trauma patient, our focus is always ABCs, just like with any other emergency.
Right. Got to make sure their airways open, support their breathing, and control any bleeding.
Exactly. And what about spinal immobilization?
Yeah. Is that always necessary in kids?
It depends. If the mechanism was bad or if the child has any neurological problems, then yes, we need to immobilize.
Yeah.
But we also have to consider their age and size when picking the equipment.
Right. Don't want to use something that's too big or restrictive.
Exactly. Another thing to think about is where we're taking them.
Transport decisions.
Yeah, if it's a load and go situation, like they're really hurt,
Right.
got to get them to a trauma center, ASP.
Time is of the essence.
Absolutely. But if they're stable and the injuries aren't as bad, we can take our time a bit more,
Right.
get a better history, do a thorough exam, maybe even think about pain management.
That makes sense. Let's talk about burns.
Okay.
Another common pediatric injury that needs special care.
For sure. And the first thing with burns is scene safety.
Right. Got to make sure it's safe for us and the child.
Exactly. So let's say the scene is safe and we've got a kid with a burn. What do we do?
Well, we have to figure out how bad the burn is.
Right. We can use age-appropriate tools like the rule of nines or the rule of palms
Right.
to estimate what percentage of their body is burned.
Okay. And we have to keep child abuse in mind.
Always. Especially if the burn doesn't make sense with the story we're getting or if the child's too young to have gotten that burn on their own.
What about managing the burn itself?
We got to get rid of any clothing that's still burning, make sure their airway, breathing, and circulation are good, give them oxygen,
Oh.
maybe even think about intubation early on if we think they breathed in smoke.
And pain management is huge with burns.
Absolutely. Kids don't handle pain as well as adults, so we got to stay on top of that.
Yeah.
Cooling the burn with cool water is good,
Right.
but we should avoid putting on any creams or ointments. Our goal is to stabilize them and get them to a burn center.
Okay, so we covered respiratory emergencies, shock, dysrhythmias, fever, seizures, toxicology, child abuse, trauma, and burns.
Wow, that's a lot.
It feels like we just skimmed the surface of pediatric emergency.
I know, right? And there's so much more to learn, from specific conditions like croup and epiglottitis to caring for kids with special healthcare needs.
Like kids with tracheostomies or ventilators.
Exactly. It's a huge and complicated field.
It is, but also incredibly rewarding.
It really is. Knowing we can make a difference in the lives of these vulnerable little people.
That's what makes it all worthwhile.
I couldn't agree more. Let's take a quick break and come back to wrap up our pediatric deep dive.
All right, we're back for the final part of our pediatric deep dive. We've talked about how kids are different, those unique challenges, and some of the emergencies we see. But what about those kids who have ongoing medical needs?
You're right, that's a whole other area. The source talks about kids with technology dependence, like how important it is to understand their specific needs and be ready to handle any problems that might come up. You might run into kids with trachs, vents, feeding tubes, central lines, a whole world of equipment that can have issues.
So it's like, we're not just EMS, we're tech support too. But seriously, how can we be expected to know about all those devices?
You don't have to be an expert on everything. The source gives some basic guidelines for assessing and managing common problems, like a trach obstruction or a vent malfunction.
Okay, so it's more about being able to troubleshoot and provide care until we can get them to a higher level of care. And of course, we can't forget about the emotional side of things for these kids and their families.
Absolutely. Just like with any other pediatric patient, communication and empathy are key. We have to talk to them at their level, explain what we're doing, and reassure them that we're there to help. And we want to involve the caregivers as much as possible. They're often the experts on their kids' needs, so they can really help us out.
That makes sense, working as a team to give the best care possible. Now, before we wrap things up, I want to talk about something that's not talked about enough: mental health.
It's true. Just like kids get physically sick or injured, they can also have mental health struggles. And unfortunately, it's still something that people don't always take seriously.
The source talks about how mental health concerns are becoming more common in kids and teenagers, and stresses the importance of being compassionate and non-judgmental. These kids are hurting and need our help, just like any other patient.
And just like with any other emergency, our first priority is safety. We need to make sure everyone is safe, ourselves, the child, and anyone else around. Then it comes down to communication. Talking to the child calmly and reassuringly, letting them know we're there to listen and help.
Sometimes just having someone listen and understand how they're feeling can make a huge difference. What about situations where the child's behavior is getting worse and they're becoming a danger to themselves or others?
The source mentions that restraints might be necessary in those situations, but it should always be a last resort. And even when we have to use restraints, we need to keep talking to the child, explain what's happening, and watch them closely for any signs of distress.
It's about finding that balance between keeping everyone safe and treating the child with respect.
Okay, so we've covered a lot today, from the challenges of pediatric anatomy and physiology to how to assess and manage a whole bunch of emergencies.
And hopefully we've all gained a better understanding of how complex, but also how rewarding it is to work with children.
Absolutely. But before we sign off, I want to hit on one last but super important point: prevention.
Right. The source actually says that most pediatric injuries aren't accidents. They're predictable and preventable.
That's a big shift in thinking. It's not just reacting to emergencies, it's stopping them from happening in the first place.
Exactly. If we understand those common injury patterns and what puts kids at risk, we can work to make things safer for them and prevent these tragedies.
So what can we do to promote prevention? Well, we can start by teaching caregivers about basic safety stuff, like making sure car seats are installed correctly, practicing safe sleep for babies, and supervising kids based on their age.
Simple things that can make a big difference.
Huge difference. We can also advocate for safer playgrounds, bike helmets, and other things that prevent injuries.
It's about being proactive and making safety a priority.
Exactly. So as we wrap up this deep dive, remember that kids aren't just small adults. They have unique needs, and taking care of them takes special knowledge and skills.
But it also takes something more compassion, empathy, and a real desire to make a difference in their lives.
Couldn't have said it better myself. Keep learning, stay curious, and never stop fighting for what's best for all kids.
What stuck with you from this deep dive? Let us know on our social media. And remember, knowledge is most powerful when we share it.
Thanks for joining us on the deep dive.
All right, ready for another deep dive? Today, we're cracking open the world of paramedic medications.
Ooh, sounds intense.
It is. We've got these reference sheets from Health Sciences North Horizon Santé Nord.
Okay.
We're going to break down, like, the why, the what, and the how of all these powerful drugs paramedics use out in the field.
It's like a mobile pharmacy.
Exactly.
Wow.
But before we get too deep,
Yeah.
a quick disclaimer,
Of course.
just for informational purposes, not medical advice, just a glimpse behind the curtain.
I like it.
So let's start with something pretty familiar.
Okay.
Acetaminophen, right?
Yeah.
Tylenol.
Everyone knows Tylenol.
It's like a household staple.
For sure.
But did you know that it actually works on your central nervous system to, like, block pain signals?
Yeah, it's not just masking the pain, it's
Yeah.
going right to the source.
Wow.
And then for fever, it acts on the hypothalamus,
Uh-huh.
which is like your brain's internal thermostat.
Oh, interesting.
Helps your body cool down.
So there's a lot more going on than you think.
Right.
And here's another cool thing. Unlike some painkillers,
Yeah.
acetaminophen, it's easy on the stomach.
It is.
And it doesn't mess with blood clotting.
Very important.
That's pretty important.
But like all medications, there can be interactions.
Oh, right.
So, like with other drugs like warfarin, a blood thinner,
Okay.
and even food.
Food.
Yeah, it can slow down how fast it gets absorbed.
Huh. Interesting.
So timing is key.
So many things to think about.
Definitely.
Well, let's talk about another pain reliever.
Okay.
You know, one we all know, aspirin,
Aspirin, yeah.
salicylic acid, to be official.
Right.
But it's like the Swiss Army knife of medicines.
How so?
It does way more than just, like, you know, headache relief.
Oh, yeah. It tackles pain, fever.
Right.
And it's an anti-platelet agent.
Antiplatelet, what's that?
So imagine your platelets,
Okay.
the tiny cells that help your blood clot,
Yeah.
like little puzzle pieces, right? They fit together to stop bleeding.
I'm visualizing it.
Aspirin comes in and kind of changes the shape of those pieces, makes
Yeah.
it harder for them to stick together.
To form a clot.
Exactly.
Right.
And get this, that effect, it lasts for the entire lifespan of the platelet, like 5 to 7 days.
So aspirin is working in your blood for days.
Pretty much.
That's incredible.
It's amazing.
Makes you wonder if, like, the ancient Egyptians who used willow bark, where aspirin comes from,
Right?
if they even knew.
He probably had no clue.
It's so complex.
Right.
Speaking of simple remedies,
Okay.
dextrose in water.
Dextrose.
That's pretty basic, right?
Sugar water.
But in the hands of a paramedic,
Yeah.
it can be a lifesaver. Like, someone with dangerously low blood sugar.
Instant energy boost
Really?
right into the bloodstream.
Wow.
It raises those blood sugar levels fast.
That's amazing.
It can even help with seizures sometimes.
Seizures.
Yeah, if we don't know what's causing them.
Wow. So many uses.
But gotta be careful, right?
Oh, yeah. Too much, too fast.
Administering it too quickly can irritate the veins.
Okay.
Too much fluid, you overload the system.
That sounds bad.
It can be.
Anything else to keep in mind?
Oh yeah, if we suspect alcoholism or malnutrition, gotta give thiamine along with the dextrose.
Thiamine, why?
Prevents a serious brain disorder called Wernicke's encephalopathy.
Okay. Better safe than sorry.
Exactly.
So paramedics have to think about all this, like, on the fly.
All the time.
That's impressive.
It's part of the job.
They need those reference sheets, for sure.
Definitely.
Okay. What about something I think we've all used at some point? Diamond hydronate, or as most people know it, Gravol,
Ah, Gravol.
or nausea, vomiting,
Right.
But it's also used for vertigo.
That spinning, dizzy feeling.
Exactly.
Yeah, it's all about these things called H1 receptors.
Okay.
They play a role in allergic reactions and that motion sickness feeling.
Interesting.
Diamond hydronate blocks those receptors.
So it stops the world from spinning.
That's one way to put it.
But doesn't that mean it's blocking, like, all signals?
Well, yeah, some.
So what should we be careful about?
It also has what we call anticholinergic effects.
Okay.
It dries things out.
Right.
Dry mouth, for example.
Right.
And just like dextrose, gotta dilute it before giving it intravenously.
Okay, so dilute.
And go slow with the IV push.
Man, dilute and slow.
Important steps.
Speaking of antihistamines, let's talk about another one.
Okay.
Diphenhydramine, hydrochloride,
Yeah.
better known as Benadryl,
Benadryl, yeah, and another allergy fighter.
works in a similar way to dimenhydrinate.
It does.
Tell me more.
Well, it blocks histamine's effects on smooth muscles.
Smooth muscle.
They're like the ones lining your airways.
Right, right.
But it's not just those H1 receptors.
No.
It goes after other types of histamine receptors, too.
So it's like a broader approach,
You could say that.
but as we know, messing with the body's natural processes.
Yeah, there can be side effects, drowsiness, for one,
Okay.
and those anticholinergic effects, just like Gravol.
Right, the drying out.
Exactly.
Anything else paramedics need to know?
Oh, absolutely.
What's that?
Gotta dilute it with saline before giving it intravenously.
Dilute again.
Yep, prevents tissue damage around the injection site.
Another one to be careful with.
Definitely.
Okay, now for the big one.
Oh, yeah.
The one you always see in medical dramas.
Okay, I'm intrigued.
Epinephrine, or as they say dramatically, adrenaline.
Adrenaline, wow.
This is for, like, life-threatening allergic reactions.
Anaphylaxis. It's like hitting the emergency reset button on the body.
Wow, serious stuff.
It is.
So how does it work?
Works on multiple fronts, increases heart rate, and how strong the heart beats.
Okay.
Opens up the airways,
Wow.
and at higher doses constricts the blood vessels.
So it's like a triple whammy.
You could say that.
But a drug this powerful, it must have a lot of side effects.
There can be some anxiety, headaches,
Oh,
palpitations.
that sounds intense.
But in a life or death situation, those are secondary to saving the patient's life.
Of course.
Dosage is key.
Right.
Low dose for asthma, higher dose for anaphylaxis or cardiac arrest.
Same medication, different uses.
It's all about precision.
Fascinating.
Really highlights the skill of paramedics.
They have to make these decisions right there on the spot.
It's all about experience and judgment.
Okay, so we've talked about low blood sugar.
Mm-hmm.
What about when someone's blood sugar is dangerously high?
That's when we bring in glucagon.
Glucagon, okay.
It prompts the liver to release stored glucose.
So it lowers blood sugar.
Exactly.
It's like telling the liver, hey, we've got too much sugar here.
Right. Release some reserves.
I like that analogy.
And it's especially important for severe hypoglycemia.
When someone can't take sugar by mouth,
Like if they're unconscious,
makes sense.
but there's a catch.
Always a catch.
It won't work if the person's glycogen stores are depleted.
Glycogen stores.
Like if they've been starving.
Oh, okay.
It's a tool for specific situations.
So paramedics need a whole toolbox, basically.
That's a great way to put it.
Well, let's grab another tool from the toolbox.
All right, which one?
Ibuprofen.
Ibuprofen, yeah.
Another familiar face.
Everyone's taken ibuprofen.
It's an NSAID.
Right. Non-steroidal anti-inflammatory drug.
But how does it actually work?
It's all about prostaglandins.
Okay.
Those chemicals involved in inflammation and pain.
Yeah.
Ibuprofen blocks them.
Blocks them, so no pain.
It's like a mediator, calming things down.
At the site of the injury.
Exactly.
Very.
It also helps reduce fever, by the way.
Oh, right. Multi-purpose.
But like all medications, Gotta watch out for interactions.
Oh, of course. Like what?
Blood thinners, blood sugar regulators,
Okay.
and like all NSAs, it can have some GI side effects.
GI, like stomach issues?
Exactly.
Yeah, those are never fun.
Definitely not.
Okay, what about another NSAID?
Which one?
Ketorolac, also known as Toradol.
Ah, Toradol. Yeah, that's for moderate to severe pain.
More serious stuff.
Yeah, it is.
How is it given?
Usually by injection.
Injection, ouch, 4V,
Or IM.
intravenous, IM, intramuscular.
You got it.
Why injection?
Faster relief.
Straight to the source.
But that quick action, it comes with risks.
Like,
Serious GI side effects,
again, with the stomach issues.
especially with prolonged use.
Okay.
And their interactions with other medications.
Like what?
ACE inhibitors, diuretics.
Got it. So it's a powerful drug.
It is.
Definitely requires careful monitoring.
Absolutely.
Okay, let's talk about a drug that's been in the news a lot lately.
Okay.
Naloxone, also known as Narcan.
Narcan, right? The opioid overdose reversal drug.
It's literally saving lives.
It is.
It's amazing.
It really is.
So how does it work?
It binds to opioid receptors in the brain,
Okay.
blocking the effects of drugs like heroin or fentanyl.
Blocks them completely.
Imagine those receptors are like parking spots.
Parking spots.
And opioids are like cars trying to park there.
Okay, I'm following.
Naloxone comes in and blocks those spots.
So the opioids can't park,
Exactly.
so they can't have their effect.
You got it.
That's clever.
But dosing is crucial,
Why?
especially for someone who uses opioids regularly.
Oh.
It can trigger severe withdrawal symptoms.
So it's not a simple fix.
Not always.
Anything else to keep in mind?
The effects of naloxone, they're temporary.
Oh.
The opioid's effects can return once naloxone wears off.
So it's like a temporary reprieve
Exactly, by some time.
to get help.
Exactly.
Okay, imagine this. Someone clutching their chest. Classic signs of a heart attack.
Okay, scary stuff.
What do paramedics do?
Often the first line of defense is nitroglycerin.
Nitroglycerin, I've heard of that.
It's a vasodilator.
Vasodilator.
It relaxes and widens blood vessels,
Okay.
eases the workload on the heart, improves blood flow.
So it gives those blood vessels some breathing room.
Exactly.
That's a good way to put it.
It's used for angina,
Angina, that's chest pain, right?
from reduced blood flow to the heart muscle.
Okay.
Also used for pulmonary edema,
What's that?
fluid buildup in the lungs.
Got it. So nitroglycerin is pretty versatile.
It is.
But I bet there are things to watch out for.
Absolutely. Blood pressure is crucial.
Blood pressure, why?
Nitroglycerin can cause a sudden drop.
That's not good.
So we monitor closely.
Makes sense.
And there's another important detail.
What's that?
It can't be used in patients who recently took PDE5 inhibitors,
PDE5 inhibitors, like what?
like Viagra.
Oh,
The
interesting.
combination can cause dangerously low blood pressure.
Wow, so many things to consider.
It's all part of the job.
Paramedics have a tough job.
They do.
Okay, what about when you hear someone wheezing?
Wheeze.
That, like, constricted airway sound.
Right. It sounds like trouble.
What comes to mind?
Salbutamol.
Salbutamol or Ventolin.
Exactly.
Go-to for asthma, right?
And other respiratory conditions causing bronchospasm.
It's a bronchodilator, right?
It is.
Opens up those airways.
Makes breathing easier.
But messing with your breathing, isn't that risky?
There are some potential side effects. Increased heart rate, tremors.
Okay,
But those are usually mild and temporary.
good to know.
But here's an important point.
Okay.
In severe asthma attacks, where there's no wheezing,
No wheezing.
what we call a silent chest,
Oh, wow.
epinephrine might be needed instead.
So no wheezing doesn't mean things are okay.
Not always. It can be very serious.
Like a silent alarm.
Exactly. Even more dangerous.
Okay, let's move on to another medication.
Right.
Dexamethasone, also known as Decadron.
Decadron, right. A corticosteroid.
Corticosteroid, so an anti-inflammatory.
A powerful one.
What's it used for?
It's particularly effective for treating croup,
Croup, that's a respiratory condition, right?
common in young children.
Okay.
But it's not just for croup.
Ah,
Severe allergic reactions, asthma attacks,
right.
cerebral edema, that's swelling in the brain. And
Rita.
it can even be used as an antiemetic
Antiemetic, what's that?
to prevent nausea and vomiting with chemotherapy.
So many uses.
It's versatile.
But with great power comes great responsibility.
You could say that.
Any side effects?
It can have some, and there are interactions with other medications.
So careful consideration is needed.
Always.
Speaking of nausea and vomiting,
Yeah.
ondansetron, also known as Zofran,
Zofran, right, a powerful antiemetic.
used after surgery with chemotherapy.
Exactly.
So how does it work?
It blocks serotonin receptors in the brain and gut.
Okay.
Those receptors are involved in the vomiting reflex,
So it stops the vomiting signals,
like intercepting them before they reach their destination.
like a gatekeeper for your gut.
That's a good way to put it.
What's great about ondansetron?
It works quickly and lasts a long time.
Must be a relief for people dealing with nausea.
It is.
But are there any side effects?
There can be some headache, constipation,
Okay.
and it can interact with other medications.
So, as always, be aware of the risks.
Always.
Okay, last medication for this part of our deep dive.
All right, bring it on.
Let's move from nausea to childbirth.
Childbirth, wow.
Oxytocin, also known as pitocin.
Pitocin, yeah, crucial for labor and delivery.
It's like the conductor of the birthing process.
You'd say that.
So how does it work?
It stimulates uterine contractions
Uterine contractions, those are the powerful squeezes, right?
that help push the baby out.
Wow.
It can be used to induce labor, strengthen weak contractions,
Okay.
and control bleeding after delivery.
So many uses.
But it's a potent drug.
So there are risks.
Careful monitoring is essential.
Why?
It can cause strong contractions
Which could be dangerous.
for both the mother and the baby.
So finding that balance is crucial.
It is effectiveness and safety.
Paramedics really have their work cut out for them.
They do.
Well, that's the end of our medication rundown for this part of our deep dive.
Wow, we covered a lot of ground.
It's amazing how much goes into understanding these medications.
Right, and how paramedics use them in the field.
It's like they have a whole pharmacy in their heads,
They do.
ready to go at a moment's notice.
It's incredible.
But there's so much more to explore.
There is.
And in the next part of our deep dive,
Yeah,
we'll dig even deeper into some of these medications
sounds good.
and explore some of the challenges and considerations.
Looking forward to it.
Stay tuned.
Welcome back to our deep dive, into the world of paramedic medications.
It's like we've opened this treasure chest
Yeah,
of medical knowledge,
it really is.
and we're just getting started.
We've already covered some fascinating stuff, how these medications work,
Right?
why paramedics use them. But today,
Yeah.
let's shift gears a bit.
Okay.
Let's talk about some of the real-world considerations.
The practical stuff.
Exactly.
I like it.
Challenges paramedics face, when using these drugs in the field.
Out in the real world.
It's like taking our backstage pass
Yeah.
and getting a front row seat to the action,
I like that.
seeing how these medications play out
Yeah.
in real-life scenarios.
The high pressure situations, they're
That's right.
amazing. So let's revisit a couple of those medications we talked about.
Oh.
Remember acetaminophen
Yeah.
and aspirin,
Uh-huh.
both great for pain relief,
For sure.
but each, with its own quirks.
It's like choosing between two superheroes,
Okay.
each with their special powers
Yeah, I like that analogy.
and weaknesses.
So what are some of the key differences
Yeah.
paramedics need to keep in mind when, choosing between the two?
Well, remember aspirin's secret weapon,
Uh,
that antiplatelet effect.
right, preventing clots,
A game changer for preventing clots
especially in situations like a heart attack.
or a stroke,
It's like aspirin is like a silent guardian,
working behind the scenes.
keeping those blood vessels clear.
Absolutely.
But that same power, it can also be a drawback.
It's true.
Someone with a bleeding disorder
Yeah.
or a history of stomach ulcers.
Aspirin could be risky.
So it's about
Yeah.
weighing the benefits against the risks.
Exactly. That's where a paramedic's judgment comes in.
Their expertise.
They gotta assess the situation.
Look at the patient's medical history.
Make the best call with the information they have.
It's like they're playing medical detective.
Piecing together clues.
That's a great way to put it.
It is.
Now, what about dextrose in water?
Dextrose, yeah?
Lifesaver for low blood sugar.
For sure.
But remember those warnings.
Oh, and administering it too quickly.
Right. Too much, too fast.
You can overload the system.
What does that actually mean for the patient?
Imagine your circulatory system,
Okay.
like a network of highways.
Okay, highways.
And the fluid is traffic.
I'm visualizing it.
Fluid overload is like a massive traffic jam.
Oh, wow.
Congestion, strain on the heart and lungs.
So it's not just about getting the sugar in.
No.
It's about doing it safely.
Exactly. Paramedics are trained to monitor for that.
For signs of fluid overload,
Shortness of breath, swelling.
changes in heart rate,
They're like traffic controllers.
keeping things flowing smoothly.
Preventing any major pileups.
Another great analogy.
Well, let's shift gears again.
Okay.
Let's talk about a medication that's been really in the spotlight lately.
Okay.
Naloxone,
Nerd.
the hero of the opioid crisis.
It's saving so many lives.
It really is.
It's incredible.
But there are complexities.
Oh, yeah.
Misconceptions, even some controversy.
Like what?
Well, some people worry, right, that making naloxone widely available
Yeah.
might encourage drug use.
Like a sense of security.
Yeah, leading to riskier behavior.
It's an understandable concern.
It is.
But from what I've read,
Yeah.
the evidence doesn't really support that.
No, studies have shown the opposite.
Oh, really?
Naloxone access doesn't increase drug use.
Uh.
And in fact, it can lead to more people seeking treatment.
So it's not enabling drug use.
No, it's giving people a chance.
Like throwing someone a life preserver.
Exactly.
It doesn't condone the risky swimming.
But it helps them get back to shore.
That's a powerful image.
Saving lives has to be the priority.
Of course.
Naloxone gives people a second chance
To get help.
to address their addiction, rebuild their lives.
Compassion, harm reduction.
Powerful tools.
Okay, let's move on to nitroglycerin,
Nitroglycerin, yeah.
our trusty vasodilator.
For chest pain, heart issues.
Widens blood vessels.
Right.
But paramedics have to be mindful of
Blood pressures.
nitroglycerin can cause a sudden drop.
It can.
So how do they manage that
Constant monitoring.
of the patient's vital signs?
Looking for any red flags.
And if the blood pressure drops too low,
we might need to give fluids
or other medication,
to stabilize it.
like a balancing act,
Walk in a tightrope
trying to relieve the heart's workload.
without sending the blood pressure plummeting.
That takes skill.
It does.
Paramedics are constantly recalibrating,
Based on the patient's response,
making sure the medication is working.
without causing any harm.
It's impressive.
Now, speaking of delicate balances,
Okay.
oxytocin
Labor and delivery hormone
stimulates those contractions.
brings new life into the world.
But as we said before, it's potent.
Powerful stuff.
Careful monitoring is key.
Too much stimulation
Can be dangerous.
for both mom and baby.
Finding that sweet spot is crucial.
That balance between effectiveness and safety,
Exactly. Paramedics are trained to spot complications
like fetal distress,
or excessive bleeding.
and to act quickly,
They're the guardians of the delivery room.
ensuring a safe and smooth delivery.
A beautiful way to put it.
Now, before we wrap up this part of our deep dive,
Yeah.
I want to touch on something you mentioned earlier,
Yeah.
the evolving nature of medicine.
Is constantly changing.
Paramedics are always learning, adapting,
And keeping up with the latest advancements
like they're on the front line,
of medical innovation.
pushing the boundaries.
It's exciting.
We're seeing a shift towards more data-driven decisions.
Using technology, AI,
It's amazing how technology is transforming healthcare.
even in emergency situations.
But it's not just about technology.
No.
It's about expanding their scope of practice,
Right. Community paramedicine.
stepping into roles traditionally filled by nurses or doctors.
Providing care in the community.
It's a fantastic development.
It is.
Allows paramedics to use their skills
In new ways.
to address a wider range of health needs.
Chronic disease management, mental health support.
It's like taking that mobile pharmacy
Yeah.
and bringing it right to the community.
It has the potential to be transformative.
Improving outcomes,
Good.
reducing costs.
Alleviating strain on hospitals.
It's a win-win.
Absolutely.
So the future of paramedicine is bright.
Filled with possibilities.
And as we continue our deep dive,
yes.
we'll explore some of those possibilities
Yeah, wait.
and discuss how paramedics are shaping the future of healthcare.
It's going to be fascinating.
Stay tuned for part 3, where we'll wrap up our exploration of this amazing world.
Of paramedic medications.
It's a world full of wonder.
It is.
Welcome back to the deep dive. We've really gone deep into this world of paramedic medications.
Yeah, from those everyday, the everyday ones like Tylenol to those powerful ones.
Yeah.
Epinephrine, naloxone,
We've talked about how they work, why paramedics use them.
the balancing act.
Yeah, the risks, the benefits.
Matt, how paramedicine is changing.
It's really amazing to me.
It is fascinating.
Paramedics are more than just like first responders. right?
Absolutely.
They're like walking encyclopedias.
Medical knowledge on legs,
That's a good one.
ready for anything,
They really have to think on their feet,
all the time.
anticipate problems.
Know when to give a drug, when to hold back.
It's like they're
Yeah.
like master chefs.
Master chefs.
You know, they can whip up something amazing
Right?
with just a few ingredients.
I see what you mean.
They understand the potential of those medications, how to
Yeah.
use them in different ways.
To get different results.
So speaking of potential, the future of paramedicine,
Yeah, we've touched on it.
it's exciting.
It is.
So what does it look like?
Imagine
Yeah.
paramedics with portable diagnostic tools. Analyze blood, do ultrasounds, even DNA sequencing.
Like on the spot.
Right there in the ambulance.
It's like a mini hospital.
That's the idea.
Wow.
And those ambulances
yeah.
guided by AI.
AI.
Analyzing traffic data, patient vitals,
To get to the hospital faster.
and safer.
It's like sci-fi, but it's becoming reality.
It is.
It's about empowering paramedics.
To provide the best care possible.
More effective, more personalized.
Exactly.
And we can't forget about
Yeah.
expanding their scope of practice.
Community paramedicine.
Right. Filling those roles traditionally held by nurses, doctors.
Providing care in the community.
It's a big shift.
And it's so important.
Healthcare systems are facing so much strain.
Absolutely.
Paramedics can fill that gap
Provide accessible, affordable care.
where it's needed most.
It's about a more holistic approach.
They're becoming part of the community,
Trusted advisors.
pillars of support.
That's a beautiful thing.
Paramedics are so adaptable, so resilient.
They're not just responding to emergencies,
They're shaping the future of healthcare.
making it more equitable, more sustainable.
It's inspiring to see.
It is.
But as we wrap up our deep dive,
Yeah.
I want to shift the focus a bit.
Got it.
We've talked a lot about paramedics,
Their knowledge, their skills.
their challenges,
Mhm.
but what about the patient?
The patient. Right?
In all the excitement about, advancements,
Yeah.
we can't forget that healthcare is a partnership,
Provider and receiver.
two-way street.
Absolutely.
As patients,
Mm.
we have to advocate for ourselves,
Understand our own health.
ask questions, be involved,
It's crucial.
know about the medications we're taking.
The effects, the interactions.
Knowledge is power, right?
Absolutely.
The more we know,
The better decisions we can make.
it's like an instruction manual
Instruction manual.
for a complex gadget
You wouldn't just start pushing buttons.
without reading the manual first.
Our bodies are complex too.
We need to understand them
How they work, how they respond to
to
medications.
stay healthy.
It's not just about paramedics having all the answers
Right. It's about patients being active participants,
in their own health.
asking the right question.
As healthcare evolves,
Becomes more personalized.
data-driven,
This partnership becomes even more important,
we're all in this together.
navigating this complex world of health and well-being.
Absolutely.
And on that note,
Yeah.
I want to thank you, our listeners,
For joining us on this deep dive.
into the world of paramedic medications.
It's been a pleasure.
We hope you've learned something new.
Gained a new appreciation for paramedics.
They really are amazing.
They are.
But this is just the beginning.
Of your exploration.
Keep asking questions. Keep learning.
Keep advocating for your health.
Until next time, stay curious, stay informed.
And stay healthy.
We'll see you then. All right, let's jump into another deep dive. We're going to be looking at head, face, and musculoskeletal injuries today.
Sounds good.
And we've got some really interesting medical textbook excerpts that we're going to be looking at. We'll be looking at the anatomy, how things go wrong, and of course, what to do about it.
Right.
Our mission is to help you become fluent in injuries so you can better understand, medical discussions and make informed decisions.
Yeah.
So maybe you can even impress your doctor
Hopefully.
with your newfound knowledge. So it all starts with a solid understanding of how these systems work normally, right?
Yeah, that's a very good point. I mean, you got to know what normal is before you can figure out what abnormal is.
Right. You got to know the players before you can understand the game. So let's start with the MVP. Let's start with the brain.
The brain, yeah. It's a very delicate structure. It's very complex. It controls everything, and it needs a lot of protection. That's why we've got the skull. So the skull acts like a helmet, and it's got very specific designs to protect the brain.
And it's not just a solid shell.
It's not a solid shell. There are openings for very important connections.
Right.
And one of the most important ones is at the base of the skull. It's called the foramen magnum.
Oh, yeah.
And that's a large opening that allows the brainstem, which is the kind of the stalk of the brain, to connect to the spinal cord. So it's the information superhighway between the brain and the rest of the body.
That makes sense. Now let's move on to the face. And the face is more than just good looks.
Yeah, definitely.
I mean, it plays a vital role in our senses and everyday functions.
Yeah, we have 14 bones in the face.
Hmm.
And they work together to protect our delicate sensory organs like our eyes and our nose. They give us our unique features. They allow us to speak and eat, breathe.
I've always wondered about the eye sockets. I mean, they seem so vulnerable.
Yeah, the orbital floor, which makes up the eye socket, is very thin, surprisingly thin, and it's very susceptible to fractures. So, even a small impact can, potentially fracture the orbital floor and cause problems with vision and eye movement.
That's a good reminder that even seemingly small bones play a huge role.
Yeah.
So let's zoom out to the musculoskeletal system, and it really is the framework that lets us interact with the world.
Yeah, it's the ultimate support system. It allows us to move, it allows us to stand tall, it allows us to produce blood cells. We've got long bones in our limbs, short bones in our wrists and ankles, flat bones like our ribs and shoulder blades, irregular bones like our vertebrae. Each of them has a specific purpose, and they're shaped that way for a reason.
It's like a perfectly engineered puzzle.
It is.
And then there are the joints, the points where all this action happens.
Yeah, the joints. That's where two or more bones meet. And depending on what kind of joint it is, it dictates what kind of motion it allows. So some joints, like the ones in our skull, they don't move at all. They're fused, maximum protection. Some of them allow very limited motion, like between the ribs and the breastbone. But the real movers and shakers are the synovial joints, your knees, your elbows. They're the ones that allow us to move freely in all sorts of directions.
And those are probably the ones we injure most often.
They are, because of all that mobility.
Right, right. Now, I've heard of the bursa before, but I'm not really sure what it does.
Oh, yeah, the bursa. Those are fascinating. They're little tiny fluid-filled sacs.
Okay.
And they're positioned strategically between bones and tendons and muscles to kind of reduce the friction between them and allow them to glide over each other smoothly. So you can think of them as our own little tiny shock absorbers.
Oh, wow. So they're kind of like the unsung heroes of the musculoskeletal system.
They are, yeah.
What about muscles, tendons, and ligaments? Those are the ones that really make things happen, right?
Yeah, the muscles are the powerhouses. They generate the force to move. The tendons are the strong cables that attach muscles to bones. And the ligaments are the strong bands that connect bones to bones, providing stability.
So it's a complex interplay of all of these components to create, seamless movement.
Yeah.
But how does the brain actually communicate with all of these structures?
Well, that's the nervous system, right?
Right.
So we have networks of nerves like the brachial plexus in the upper limbs and the lumbar and lumbosacral plexuses in the lower limbs. And those carry the signals from the brain and the spinal cord to the muscles, telling them when to contract, how much to contract.
Wow, it's like a sophisticated communication system.
It is.
What happens when something disrupts those signals?
Well, then we start to see problems with movement, right? So weakness or paralysis even.
Yeah.
So understanding the nervous system is very important to understand how injuries can affect our ability to move.
Right. This is all really fascinating stuff. It's amazing to appreciate how much is going on behind the scenes to allow us to move freely and interact with the world.
Absolutely. But as with any complex system, things can go wrong.
Right. And that's where our deep dive takes a turn from, understanding how things work to understanding how things break.
Yeah, because understanding the mechanism of an injury, how an injury happened, gives us a roadmap, basically,
Right.
to predict what structures might be damaged. And it guides our assessment and treatment.
I'm ready to put on my detective hat and unravel the mysteries of injuries.
All right, let's do it.
Let's start with head and face trauma. Things that can happen with everyday bumps and falls or even more serious accidents.
Sure. So let's start with scalp lacerations.
Okay.
Those are cuts in the scalp. And even though they may not look that bad, they can bleed a lot.
Right.
Because the scalp has a very rich blood supply.
Yeah.
So basic first aid, knowing how to control bleeding can be very helpful.
Good point.
Yeah.
And what about those scary-sounding skull fractures?
Skull fractures, right.
Yeah. Are they all the same?
Well, no, there's different types. There are linear fractures, which are simple cracks in the skull. Then you have depressed fractures, where a portion of the skull is actually pushed inwards, which can compress the brain. And then you have open fractures, where the skull is broken and the brain is exposed.
Oh, wow.
That increases the risk of infection.
So those are pretty serious. What about basilar skull fractures? What makes those unique?
Basilar skull fractures, those involve the base of the skull, the bottom of the skull. And they can be tricky because the signs might be subtle, but they can have serious consequences.
Oh, like what?
Well, leakage of CSF, cerebrospinal fluid,
Okay.
damage to the cranial nerves.
So what should we be looking for?
So there's some classic signs. One is called raccoon eyes. It's bruising around the eyes. And the other one is battle sign, which is bruising behind the ear. And both of those can indicate a basilar skull fracture.
Okay. Noted. Now let's talk about traumatic brain injury, or TBI. It seems like, we hear about concussions all the time these days.
Yeah, concussions are a type of TBI, but there's more to it than that, right?
Right.
So TBI can be either a primary brain injury, which happens at the moment of impact, or a secondary brain injury, which happens later, and is usually due to swelling or bleeding inside the skull.
So it's not just the initial hit, it's what happens afterward.
Yeah.
What are some of the critical things to watch out for?
Well, one of the most important concepts to understand is intracranial pressure, ICP, and that's basically the pressure inside the skull.
If it gets too high, it compresses the brain. And that's bad news.
Right, right.
Then there's cerebral perfusion pressure, or CPP, and that's the pressure of the blood flow to the brain. So you need a good balance between the two. If you have high ICP, then you're going to have low CPP. And that means the brain is not getting enough blood flow, enough oxygen.
Yeah, so
Yeah.
it's not a good thing. And there are different types of brain injuries, right?
Yeah, we can categorize them as diffuse injuries, which affect a wider area of the brain, like a concussion, or a diffuse axonal injury, which is kind of a tearing of the brain fibers.
Okay.
And then there are focal injuries, which are more localized, like contusions, which are basically bruises on the brain
Oh, wow.
and hemorrhages, bleeding inside the skull.
So what about those dramatic epidural hematomas we see in medical dramas?
Oh, yeah. The epidural hematomas, those are very serious.
Yeah.
They usually involve arterial bleeding, which can cause rapid deterioration. And the classic sign is what we call lucid interval. That's where the person seems fine initially, but then rapidly deteriorates. So it's really a race against time to get them to surgery.
Wow, it's like a real-life medical thriller. Okay, let's move on to the rest of the body and talk about musculoskeletal mayhem. So what are the most important things to keep in mind when dealing with those types of injuries?
Well, first and foremost, remember the ABCs: airway, breathing, circulation.
Right?
A fracture can wait. A blocked airway cannot.
That's a good reminder.
So prioritize life-saving interventions.
So keep calm and assess the situation.
Exactly. So once you've done that, then you can focus on assessing the injury itself. And so let's break down some of the common musculoskeletal injuries that we might encounter.
Okay.
What's the difference between a fracture, a dislocation, a sprain, and a strain?
Right, those are good ones.
So a fracture is a break in the bone. There's open fractures where the bone breaks through the skin. And there's closed fractures where the bone is broken, but it stays under the skin. Dislocations are when a bone is forced out of its joint, so it's not in the joint anymore.
Right, right.
And that damages the ligaments, the tissues that support the joint.
Oh.
Sprains involve stretching or tearing of ligaments.
Okay,
And strains involve stretching or tearing of muscles or tendons.
gotcha. So fractures are bone breaks, dislocations are joint disruptions,
Right.
and sprains and strains involve soft tissues. What about some of the other common conditions like Achilles tendon rupture,
Oh, yeah.
tendinitis,
Uh-huh.
bursitis,
Bursitis, yep.
and arthritis?
Arthritis, yeah, those are all very common conditions.
Sure.
So Achilles tendon rupture is when the Achilles tendon, which connects the calf muscles to the heel bone, completely ruptures. So it can be a very debilitating injury, especially for athletes.
Yeah.
And tendinitis is inflammation of the tendons.
Okay.
Bursitis is inflammation of the bursa, those little fluid-filled sacs we talked about.
Oh, right, right.
And arthritis is inflammation of the joints.
Yeah. Okay. This is all incredibly helpful.
Right.
But now I really want to get to the practical stuff.
Yes.
You know, what to do when we actually encounter these injuries.
Right, because that's where the real empowerment comes in, right?
Exactly.
Knowing how to take action
Yes.
and potentially make a difference in someone's recovery.
So let's dive into the practical strategies for assessing and managing, head and face injuries, as well as those affecting the musculoskeletal system.
Let's do it.
Let's get practical.
Let's get practical.
Welcome back to our deep dive into the world of injuries. Now that we've got the basics down, let's talk about what to do when someone's actually been injured.
Right. The first thing is to make sure the scene is safe. You don't want to become another victim.
Right, safety first, always a good reminder. So let's say we're dealing with a potential head injury. What are some of the things that tell us, okay, this is serious, we need to call 911?
Well, the big one is loss of consciousness. Even if it's just for a few seconds, that's a serious sign.
Okay, so any loss of consciousness?
Yeah.
Call 911. What else?
Confusion, memory loss about the injury, a really bad headache that doesn't go away, nausea or vomiting.
Got it.
Slurred speech, weakness or numbness, seizures,
Okay.
unequal pupils, or if you see clear fluid draining from the ears or nose, those are all signs that something serious is going on.
That's a lot to remember. I guess it makes sense, though. Head injuries are nothing to mess around with.
No?
What about face injuries? Any special tips for those?
With face injuries, the first thing is to check the airway.
Right, breathing.
Make sure they can breathe. Swelling and bleeding can block the airway really quickly.
So make sure they can breathe.
Then what? Then you want to look for cuts, bruises, deformities. Check the eyes, ears, nose, and mouth for any signs of injury.
So basically, a head to toe. Well, I guess a head to chin in this case.
Exactly. Get as much information as you can so you know how to handle the injury.
Okay, speaking of handling the injury, What are the most important things to do in those first few minutes after a head or face injury?
The most important thing is to protect the cervical spine.
The neck.
Right, the neck. Keep the head and neck immobilized to prevent further injury to the spinal cord.
Got it.
Make sure the airway is open.
Right.
And if there's bleeding, control it with direct pressure.
So immobilize, airway bleeding, kind of like a mental checklist.
Exactly. Now, those nosebleeds that sometimes come with facial injuries,
Yeah, those can be pretty dramatic.
they can look scary, but they're usually not serious.
Okay.
Have the person sit upright, lean forward, and pinch the soft part of their nose for about 10 minutes. Okay? The leaning forward part is important. You want the blood to drain out the nostrils, not down the back of their throat.
That makes sense. You don't want them to choke or throw up. Okay, now, eye injuries. Those always make me cringe. What are some of the things you should absolutely not do if someone have an eye injury?
Never put any pressure on the eyeball itself, especially if there's something stuck in the eye.
Okay.
Don't try to remove it yourself. Just cover the eye with a clean dressing and get to a doctor.
Okay, so hands off. What if they get a chemical splash in their eye?
Oh, that's serious. You need to irrigate the eye with lots of water immediately.
Right away.
Right away. The sooner the better. At least 15 minutes longer if it's a strong chemical.
Got it. Time is critical. What about ear injuries? What if there's blood or fluid coming out of the ear after a head injury?
That could be a ruptured eardrum or even a skull fracture.
Yeah.
Again, don't put anything in the ear.
Got it.
Just cover it with a clean dressing and seek medical attention.
So just like eye injuries, the rule is, look, don't touch.
Exactly. Now, what if someone's ear gets completely torn off, like in a bad accident?
Oh gosh, that sounds awful. Is there anything you can even do in that situation?
Believe it or not, you can sometimes reattach a completely torn off ear. Wrap it in a clean, moist dressing, seal it in a plastic bag, put it in a cooler on top of ice water, and transport it to the hospital along with the person.
Really? That's amazing what they can do these days. Okay, let's switch gears and talk about musculoskeletal injuries. What are some of the general things to remember when assessing these types of injuries?
Always remember the ABCs.
Right. Airway, breathing, circulation.
Exactly. Life over limb. A blocked airway or uncontrolled bleeding is much more serious than a broken bone.
Good reminder. So once we've established that the person is stable, what's the best way to assess a musculoskeletal injury?
I use the acronym DSECAP BTLS.
DSEP BTLS?
It stands for deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling.
DSEP BTLS. I'm writing that down.
It's a systematic way to make sure you're checking everything.
Right. Like a built-in checklist.
Exactly. And don't forget about the 6 Ps. Pain, paralysis, paresthesias, pulselessness, pallor, and pressure.
Okay.
Any of those, especially together, could mean there's a serious problem.
Got it. So we've assessed the injury, and it's not life-threatening. What are some general things we can do to manage musculoskeletal injuries?
The goal is to reduce pain, prevent further injury, and control bleeding.
Okay.
So we might use over-the-counter pain relievers, ice packs, immobilize the injury with a splint, elevate the limb to reduce swelling, and use cold therapy to minimize inflammation.
You mentioned splinting. Are there any general guidelines for how to do that correctly?
Absolutely. First, always check PMS. Pulse, motor function, sensation before and after you splint. Make sure you control any bleeding before you splint. Immobilize the joints above and below the injury. Pad the splint well so it doesn't cause pressure sores.
Okay.
And never try to straighten out a deformed limb.
Got it.
And finally, check the splint regularly to make sure it's not too tight.
Those are all good tips. I'm feeling a lot more confident already. But we've only covered a fraction of what can go wrong with the musculoskeletal system, right?
Oh, absolutely. The human body is incredibly complex. There are tons of ways things can go wrong. So let's dive into some specific injuries, and I'll point out the key things you should know.
Let's do it. I'm ready for more.
All right. Let's start with the shoulder. Now, we already talked about fractures, but shoulder dislocations are also pretty common.
Why is that? Is it because the shoulder has such a wide range of motion?
Exactly. The shoulder joint is what we call a ball and socket joint. The head of the humerus, the upper arm bone, fits into a socket on the scapula. But the socket is pretty shallow, which allows for lots of movement, but it also makes the joint less stable.
So it's a trade-off flexibility for stability.
Right. And the most common way to dislocate a shoulder is to fall onto an outstretched arm, especially if the arm is rotated outward.
Ouch, I can imagine that hurts. So what does it look like if someone has dislocated their shoulder?
Well, it's usually pretty obvious. The shoulder looks out of place.
Oh.
And the person will be in a lot of pain and won't be able to move their arm very well.
So what do you do? Did you try to pop it back in?
I wouldn't recommend that. It's best to let a medical professional handle it. You could damage nerves and blood vessels if you don't know what you're doing.
Okay, so resist the urge to play doctor. What should you do while you're waiting for help to arrive?
Immobilize the arm using a sling and swath, and apply cold therapy to reduce swelling and pain.
Okay, got it. Let's move down to the elbow. What are some common elbow injuries besides dislocations?
One of the most common is a radial head fracture.
The radial head.
It's one of the bones in the forearm, and it's often fractured from a fall onto an outstretched hand.
And are elbow dislocations easy to spot?
Not always. They can be mistaken for a sprain, so any significant elbow injury should be checked out by a doctor.
Okay, I'm sensing a theme here. When in doubt, get it checked out.
Exactly. Better safe than sorry. What about forearm fractures? Those are pretty common, especially in kids.
Yeah.
They usually happen from a direct blow to the forearm or a fall onto an outstretched hand.
So the same way you can fracture the radial head, how do you manage a forearm fracture?
Immobilize it. You'll need a splint that goes from the elbow to the hand.
Okay. Now let's talk about wrist and hand injuries.
Yeah.
Those can be really problematic since we use our hands for everything.
You're right. Our hands are incredibly complex. Injuries to the wrist or hand can really impact our lives.
So what are some common wrist and hand injuries?
Wrist fractures are common, especially in older adults. And then there are all sorts of hand fractures, including the boxer's fracture.
Yes, the boxer's fracture.
Yeah.
Pretty obvious how that one got its name.
Yeah, it usually happens from punching a hard object. But hand injuries aren't always that straightforward. There's something called a mallet finger, which is an injury to the tendon that straightens the end of your finger.
So it's more than just a jammed finger.
Right. It means there's damage to the tendon, and it can happen from jamming your finger or catching it in a door.
Ouch, I've done that before. I'll have to be more careful. What about dislocated fingers?
Those are usually pretty easy to spot. The finger is bent at a weird angle.
Okay, let's move on to the lower extremities. We talked about pelvic fractures earlier. What are the key things to remember about those?
Pelvic fractures are serious injuries. They can cause a lot of bleeding, and they often happen from high-energy impacts, like car accidents or falls from heights.
Okay.
And they're classified based on how the injury happened.
So the way you get the injury determines what type of fracture it is. What are the different types?
There are lateral compression fractures, which happen from a side impact, posterior compression fractures, which happen from a head-on impact,
Yeah.
and vertical shear injuries, which happen from a force that's applied from above or below, like a fall from a height.
Those all sound pretty serious. How do you manage a pelvic fracture in the field?
The most important thing is to stabilize the pelvis and control the bleeding. You might use a pelvic binder or a sheet wrap, but you need to get the person to a trauma center as soon as possible.
So stabilize and transport. What about hip fractures? Those are really common in older adults, right?
Right, they often happen from a simple fall. As we get older, our bones get weaker, and the hip is a common place for fractures.
Why is that?
The hip joint bears a lot of our weight. Plus, osteoporosis, which weakens the bones, is more common in older adults.
So what are the signs of a hip fracture?
Pain in the hip or groin, inability to bear weight on the leg, and the leg might look shorter or rotated outward.
And how are hip fractures treated?
Usually with surgery. So in the field, we focus on pain management and immobilization.
Okay, stabilize and transport. Now what about femoral shaft fractures?
Those are fractures of the long bone in the thigh. They usually happen from high-energy trauma, like car accidents or falls.
So a lot of force is needed to break the femur.
Right, and because the femur has a rich blood supply, these fractures can cause a lot of bleeding.
So what do you look for with a femoral shaft fracture?
Severe pain, deformity of the thigh, swelling, bruising, maybe muscle spasms.
So what do you do?
Immobilize the fracture and control the bleeding. You'll probably need a traction splint to stabilize the fracture.
Okay. What about knee fractures?
Knee fractures can involve any of the bones in the knee joint, the femur, tibia, or patella. They usually happen from a direct blow to the knee or from landing hard on your feet.
What are the signs of a knee fracture?
Pain, swelling, tenderness around the knee, and trouble moving the knee or putting weight on the leg.
And how are they treated?
It depends on how bad the fracture is and where it's located. Some can be treated with a cast or brace, others need surgery.
We talked about knee dislocations earlier, how serious those can be. Anything else we should remember?
The most important thing is to check for a pulse below the dislocation.
Right, because that could mean the blood supply to the lower leg is cut off.
Exactly. If there's no pulse, that's a surgical emergency.
And if there is a pulse.
Immobilize the knee in the position you found it,
and get the person to a hospital right away.
Got it. Let's move down to the lower leg. What about tibia and fibula fractures?
Those are the two bones in the lower leg, and they're often fractured from a direct blow or a twisting force.
What should you look for?
Pain, swelling, tenderness in the lower leg, difficulty bearing weight. You might see deformity of the lower leg depending on how bad the fracture is.
And how are they treated?
Again, it depends on the severity and location. Some are treated with immobilization, others need surgery.
Ankle fractures are incredibly common too. What usually causes those?
Usually a twisting force like rolling your ankle,
What are the signs of a broken ankle?
pain, swelling, tenderness around the ankle, difficulty bearing weight on that foot.
And are all ankle fractures treated the same way?
Not necessarily. Some can be treated with a cast or brace, others need surgery.
What about fractures of the calcaneus, the heel bone?
Those are less common. They usually happen from high-energy impacts like falls from heights or car accidents.
Because the force travels up the leg and into the heel.
Exactly.
What are the signs of a calcaneus fracture?
Pain, swelling, and tenderness in the heel, and trouble putting weight on that foot.
And how are they treated?
It depends. Some can be treated with a cast or boot, others need surgery.
Okay, we've covered a lot of ground here. Let's switch gears and talk about joint injuries and dislocations. We talked about shoulder dislocations earlier. What are some other common joint dislocations?
Besides the shoulder, the elbow, fingers, hip, and knee are all susceptible to dislocations.
Okay, let's start with the elbow. What kind of dislocations happen there?
The most common is a posterior dislocation. That's where the bones in the forearm are displaced backward in relation to the upper arm bone,
And what usually causes that?
falling onto an outstretched hand with the elbow hyperextended.
Ouch. What does it look like?
Pain, swelling, deformity around the elbow. The person might not be able to move their elbow or feel anything in their hand.
So what do you do?
Immobilize the elbow and get them to a hospital. Don't try to put it back in place yourself.
Got it. What about finger dislocations?
Those are usually caused by a direct blow to the finger or by bending or twisting it forcefully.
So like a jammed finger gone wrong.
Right. And you can usually tell because the finger will be bent at an unnatural angle. There will be pain and swelling, too.
How do you treat a dislocated finger?
Usually a doctor can just pull on the finger to put the bones back in place. Then they'll splint it or tape it to support it while it heals.
Okay, that sounds fairly straightforward. Now, what about hip dislocations?
Those are less common than shoulder dislocations, but they're more serious because they can damage the blood vessels and nerves around the hip joint.
What causes a hip dislocation?
Usually a high-energy impact like a car accident or a fall from a height,
What are the signs?
severe pain in the hip, inability to move the leg, and the leg will be shortened and rotated inward.
So what should you do?
Immobilize the hip and get them to a hospital right away.
Okay, immobilize and transport. We talked about knee dislocations before, how those can be really serious too. What else should we remember?
Make sure you check for a pulse below the dislocation.
Right, right.
And immobilize the knee and get them to a hospital as quickly as possible.
Got it. This has been so helpful. I feel like I've learned so much.
I'm glad to hear that, but this is just the tip of the iceberg. There's always more to learn about injuries.
Well, folks, we're going to take a short break to let all this information sink in. When we come back, we'll go even deeper into the world of injury assessment and management. All right, welcome back to our deep dive. We've covered so much ground. We've talked about anatomy. We've talked about specific injuries. Now let's put it all together and really, equip ourselves to deal with these situations.
Right, because knowledge is power. The more you know about injuries, the better prepared you'll be to handle them.
Absolutely. So let's go back to head and face injuries for a minute. What are some things we need to think about when we're assessing these types of injuries?
Well, you have to be a good detective, right? Look for those subtle clues that might tell you there's something more serious going on. For example, delayed onset of symptoms.
Yeah, like what do you mean?
Someone might seem fine right after a head injury, but then hours or even days later, they start having headaches, dizziness, maybe they're confused.
So it's not always about what you see right away. You have to watch for changes over time.
Exactly. And sometimes the signs are very subtle. Changes in behavior like irritability, mood swings, trouble concentrating, those can be signs of a concussion.
Right, it's easy to dismiss those as just being tired or stressed, but they could be something more serious.
Exactly. So when in doubt, always err on the side of caution.
Okay, good advice. Now, what about skull fractures? How can you tell if someone might have one?
Well, sometimes it's pretty obvious, like if you see a deformity or bleeding from the ears or nose. But a lot of times the signs are more subtle,
Okay, like what?
like persistent headaches, especially if they get worse when lying down or bending over, or bruising behind the ears or around the eyes.
Okay, so subtle signs, but serious consequences.
Right. Now, facial injuries can be pretty scary because there's often a lot of bleeding.
Yeah, for sure.
But just like with any trauma, you always start with the ABCs. Airway, breathing, circulation.
Right, make sure they can breathe.
Exactly. And control any bleeding with direct pressure. Now, with eye injuries, the most important thing is to avoid putting any pressure on the eyeball.
Okay.
If there's something in the eye, don't try to take it out yourself. Just cover the eye with a clean dressing and get them to a doctor.
Got it. Hands off. What about chemical splashes in the eye?
That's a real emergency. You need to irrigate the eye with lots of water right away.
Right away, yeah.
The sooner you start rinsing, the better, at least 15 minutes, and even longer if it was a strong chemical.
Got it. Time is of the essence. What about ear injuries? If you see blood or fluid coming out of the ear after a head injury?
That could be a sign of a ruptured eardrum or a skull fracture, so don't put anything in the ear.
Okay.
Just cover it with a clean dressing and get them to a doctor.
So just like eye injuries, look, don't touch.
Right. What about if the ear gets completely torn off, like in a really bad accident?
Oh, that's a horrible thought, but I guess it happens. Is there anything you can do in that situation?
You'd be surprised, but you can sometimes reattach a torn off ear. You have to wrap it in a clean, moist dressing, seal it in a plastic bag, put it in a cooler on top of ice water, and then get it to the hospital with the person.
Wow, that's amazing. I had no idea. Okay, let's move on to musculoskeletal injuries. We've talked about a lot of specific injuries, but are there any general rules we should keep in mind when we're dealing with these types of injuries?
The most important thing is always to remember the ABCs.
Right. Airway, breathing, circulation.
Exactly. Because a blocked airway or uncontrolled bleeding is way more serious than a broken bone. Always prioritize life-saving measures first.
Right. The ABCs come first. So once you've made sure the person is stable, what's the best way to assess a musculoskeletal injury?
Remember DCAP BTLS?
Oh, yeah, DCAP BTLS.
Deformities, contusions, abrasions, punctures, penetrations, burns, tenderness, lacerations, and swelling. It's a good way to make sure you're checking everything. All right, our checklist. And then the 6 Ps: pain, paralysis, paresthesias, pulselessness, pallor, and pressure.
Exactly. Those are the red flags. Any of those, especially in combination, it means you need to get them to a doctor right away.
Okay, so we've assessed the injury. We've ruled out any life-threatening problems. What can we do to manage a musculoskeletal injury?
The main goals are to reduce pain, prevent further injury, and control any bleeding. So that might mean giving over-the-counter pain relievers, applying ice, immobilizing the injury with a splint, elevating the limb to reduce swelling, and using cold therapy to help with inflammation.
You mentioned splinting. Any tips for applying a splint correctly?
Always check PMS, pulse, motor function, sensation before and after you splint. Make sure you control any bleeding before you splint. Immobilize the joints above and below the injury, and pad the splint well so it doesn't rub. And don't try to straighten out a deformed limb. And finally, check the splint every so often to make sure it's not too tight.
That's all great information. I feel a lot more prepared now.
That's what we want. But remember, this is just a starting point. There's always more to learn about injuries.
That's so true. Well, folks, that's a wrap for our deep dive into the world of injuries. Thanks for joining us. We hope you learned some valuable information that you can use to stay safe and be prepared for the unexpected.
Exactly. Knowledge is power. So keep learning, keep asking questions, and be ready for whatever comes your way.
Until next time, stay curious, stay informed, and keep on diving deep.